Let us start. Let us discuss about medicine. I am Dr. Sandeep Sharma. I am both pediatric as well as medicine faculty. I take classes since last more than 10 years. I have been training students right from FMGE and EPG to all the way to super specialty. I have my super specialty programs running, residency courses running, and I try to simplify things the best I can. Here we are going to talk about medicine. Part 1, that is today, I will be touching upon 5 systems: pulmonology, GIT, hepatology, rheumatology, and nephrology. This will cover about 40 to 45% of the medicine today. Part 2, same time, 5 o'clock, we will be starting tomorrow. I will be covering CVS, neurology, endocrinology, hematology. Let us start with the first thing that we are going to take up, that is, we are going to start with pulmonology. Before we start with the discussion, what we are going to do, if you look at the papers of medicine, see, it is very important to understand the enemy before fighting the enemy. And the enemy, the examiners have evolved. If you look at the older MCQs, if you go through the old MCQs of FMG, 2018, 2019, 2020, you will find, and older than that, you will find a lot of one-liners were asked. Lot of exception-based questions were asked. Lot of, tables were asked. Now what examiner is doing is, even if they are asking a simple thing, they are making it into a case. Instead of asking what is the investigation of choice for pulmonary embolism, they are making a case scenario to see whether you can identify pulmonary embolism by the case or not, and then they are asking the investigation. When you will actually sit in the exam, in medicine, core medicine will be roughly about 15 to 20 questions. Don't be surprised. Core medicine will be 15 to 20. Why this number is so less? Because another 15 to 20 questions are integrated. Integrated means there is a component of pharmacology, there is a component of pathology, or it is a concept related to surgery. For example, esophageal disorders and GI, a lot of integration occurs across with surgery. If you have done only surgery and not medicine, you cannot solve those questions. If you have done only medicine and surgery, you have not done, you cannot solve. You need to have a recognition of both. So what I will try to do is, in the topics that we discuss, integration I will do. What we don't have is too much of time. So a few definitions, a few tables, you have to mug it up. I will tell you clearly, honestly, this is something you need to mug up. So you are supposed to mug up. What we need to discuss, what we need to write, we will write. And whatever important topic I discuss, I will tell you what all different ways it has been asked and what all different ways it can be asked as well. So this workbook, the content that we are discussing will be double of what is given in the book. What it means is, whatever I'm telling and speaking, that is also a content. It is just that you need to absorb it and write the technical points in your book. So what about annotated PDF? Yes, annotated PDF will be shared with the team and team will be forwarding it in the groups. If you can't find it sooner, so you're most welcome to reach out to me. What about other faculty members? Some other sessions also planned, or faculty members will try their best to take, but all sessions are standalone. Standalone means I will try to cover all the 9 systems of medicine the best possible I can in the limited time that we have available. You have to understand. Now, last thing before I start, sir, I have not done medicine. Would this be enough? My answer is, this will give you a fighting chance. You are leaving topics discussed here and doing something else, playing with fire. You do this, it's your day and you are an inherently hardworking smart student. You have a good chance in the exam, but end of the day, it is not one subject. It is how you are in all the 19 subjects that matter. Right? Let us start with pulmonology. So pulmonology, first of all, there are a few basics. Now there are some definitions you will find. These definitions, I will tell you first of all what is the meaning, simple language. The exam will be in English, so I'll be teaching in English. A few Hindi words I may use intermittently, but they will only be to exemplify or to explain a particular point. So it will not be an academic thing and you will not be missing out if you're not good in Hindi, but I will be teaching in English only, so you can be rest assured on that, right? So what is tidal volume? Tidal volume means whatever normal air is moving during inspiration and expiration. When you are breathing normally, not making an effort, you're solving an MCQ, you're thinking about something, watching a movie, eating food, or just sitting idle in your library. The volume which moves inside, outside, that is tidal volume. This topic which I'm discussing, it has hugely integrated with physiology. You may find questions in part paper B, you may find questions in paper A. So tidal volume is normal air moving inside and outside. I would advise keep looking at this table also. Why this table is important? Because what examiners will do, they have not asked this question in FMG, but I will be discussing the relevant NEET PG related points also, because you know that NEET PG type questions are being asked in FMG also. What I was telling you was that this particular table is important because NEET PG exam, older NEET PG exam, they put up this table and they said A, B, C, D, they mentioned it and they said identify the incorrect match of volume and the shown graph. So you had to pick up that tidal volume looks something like this. Above this, you have the inspiratory reserve volume. Below that, you have the expiratory reserve volume. This one, which cannot be breathed in or out, that is residual volume. If you combine all of them together, that is vital capacity. And if you include residual volume also, that is called as total lung capacity. One is definition. Second is how to identify in the table. You have to be mentally prepared. That is the first thing. Now, second thing is about FEV1 and FVC. FEV1 and FVC are the two values. Definition examiner will not ask. These are the two values which are asked in the exam. What is their importance? Because a patient comes to you. Suppose patient has a respiratory problem. You rule out infection. There is no infection in the patient. So what could be the respiratory problem? Patient could have asthma, COPD. Patient could have interstitial lung disease. Patient could have any respiratory problem, bronchiectasis or something. You do a spirometry. When you do spirometry, two values are obtained. One is FEV1 and second is FVC. FEV1 is volume of air which a person can exhale forcefully in the first second. So there is a machine known as spirometer which measures that. What is FVC? It is the total volume of air which can be exhaled after maximal expiration. What is the importance? Importance has been asked in the exam. Any patient comes to you with respiratory disorder, infection is not there. Take the ratio of FEV1 divided by FVC. When you find that FEV1 by FVC ratio is less than 0.7, it indicates patient is having obstructive lung disease. The patient is having obstructive lung disease. There is an obstruction in the airway. And whenever the patient has FEV1 by FVC ratio equal to or more than 0.7, what does it indicate? It indicates the patient is having a restrictive lung disease. Even in a normal patient, you will find FEV1 by FVC above 0.7, right? So, but if a disease is being thought of less than 0.7, earlier it used to be 0.8, it was revised a few years back. So now the cutoff used is 0.7. So less than 0.7 obstructive, equal to or more than 0.7 restrictive. Then you can get, examiner can ask you, what are the techniques you take to measure FEV1 and FVC? To measure FEV1 and FVC, we need the help of spirometry. But there is a problem. Spirometry cannot measure that gas which cannot be coming inside and outside. In other words, residual volume and total lung capacity cannot be measured like this. For that, we have another investigation known as whole body plethysmography, also simply known as plethysmography. Plethysmography has many subtypes, many techniques. Mainly it uses helium dilution technique, but those details will never be asked in your FMG exam. If it gets asked, it could be a physiology question, but certainly not a medicine question. So what are the name of the two techniques to measure that? Spirometry. But spirometry can measure everything except two things, the residual volume and TLC. For TLC and a residual volume, what do you need? You need body plethysmography. Okay. Moving further, we have this flow chart. Any patient comes to you, he has FEV1 by FVC ratio less than 0.7, that is less than 70%. You will suspect the patient is having a obstructive lung disease. Now, there are, broadly speaking, two types of obstructive lung diseases. One is reversible obstructive lung disease and second is non-reversible obstructive lung disease. Any obstructive lung disease, if you are suspecting, you give a trial of salbutamol. What is salbutamol? I'm writing in short. It is a short-acting beta agonist. We also call it as SABA. You give a trial of salbutamol in the patient. There will be two possibilities. The obstructive lung disease, the ratio improves. the ratio improves in the patient. If the ratio becomes better, that was a reversible disease. What does it indicate? The likely diagnosis in the patient. What is the answer? Yes, bronchial asthma. Bronchial asthma. However, if there is no improvement in the patient, if there is no improvement in the patient, you will suspect other diseases. It is a common mistake. We think that only COPD should be thought of. What is COPD? Chronic obstructive pulmonary disease. Other obstructive diseases like bronchiolitis will also have presentation like this, and bronchiectasis will also have presentation like this. So this will tell you that the underlying disease is not asthma, it is COPD, bronchiolitis or bronchiectasis. It will be helpful in ruling out the options in the MCQ. If the patient is having a normal to high FEV1 by FVC ratio, if it is equal to or more than 0.7, now it could be normal patient also, it could be restrictive lung disease also. In these patients, you will check for the absolute FVC value. FVC absolute value. If you find that FVC absolute value you need not remember, value varies according to age, gender and underlying condition of the patient. So check FVC for that age and that gender. If you find that the FVC value is normal, only the FEV1 by FVC ratio is more than 0.7, you would say patient is having no respiratory disease. No respiratory disease. It is a normal patient. But if you find that FVC is low, in these patients, you will suspect the patient is having what lung disease? Restrictive lung disease. So patient is having a restrictive lung disease. When you solve MCQs, simple MCQs as well as complicated MCQs, you can easily solve by keeping these topics in your mind, right? So no improvement, COPD, bronchiolitis, bronchiectasis with salbutamol, improvement, bronchial asthma. If it is high, more than 0.7, check for absolute value of FVC and decide whether it is a normal patient or there is restrictive lung disease in the patient. Now, let us do a table distinguishing between obstructive lung disease and restrictive lung disease, and we will be taking their examples also. What is the problem in obstructive lung disease? The problem in obstructive lung disease is air trap. Air is getting trapped. In bracket, you would write it is a flow problem. It is a flow problem. Flow cannot occur. Whereas restrictive lung disease, there is a expansion problem. There is a reduced expansion is the issue. Reduced expansion is the issue. In bracket, I'm writing these patients have a volume problem. Volume problem. Now try to think what will happen in the patient. In an obstructive lung disease, there is a obstruction, and it is not a complete obstruction, it is a partial obstruction. Now in between, although it is a rapid revision, but wherever needed, I will try to simplify concepts for you so that whenever you try to mug up also, it is also easy for you to do that. Because end of the day, we are going to become doctors, and I will use mnemonics, yes, but because it is medicine, so you can't have too much of mnemonics as much as in other subjects. So understand, obstructive lung disease means there is a partial obstruction in the airway. Okay, so what happens is inspiration can occur more easily, but during expiration, the airway tends to collapse around the obstruction. So what happens is with each breath, there is a trapping of air which is happening. So there is a expiratory flow problem, that is obstructive lung disease. What is restrictive? The lung cannot expand due to fibrosis or due to fibromuscular condition. And so the total capacity of the lung is reduced. That is called as restrictive lung disease. What are the examples? The examples of obstructive lung disease include COPD. For example, a particular COPD known as emphysema. It includes bronchial asthma, or simply I am writing as asthma. It includes bronchiolitis. It is an infectious condition. And it includes bronchiectasis. What about restrictive lung disease? Restrictive lung disease can have two varieties. First of all, there can be parenchymal disease, which are affecting the parenchyma of the lung. Parenchymal lung disease, the typical example for this is IPF, idiopathic pulmonary fibrosis. It also includes asbestosis, asbestosis. It also includes sarcoidosis. The second example for this, intermittently I'm having a look at your chat also. Second is extraparenchyma. Extraparenchyma. Outside the parenchyma. Extraparenchymal causes can be related due to chest wall. There can be due to chest wall causes. For example, kyphoscoliosis. Kyphoscoliosis. Or it can occur due to neuromuscular causes like MG. What is the full form of MG? I'm writing in short, myasthenia gravis. There is a huge list. List is there. You can always go through your detailed notes if you want. But we are discussing a summary of distinguishing between the two conditions. What about FEV1 by FVC ratio? I just told you it is less than 0.7 here. It is equal to or more than 0.7 here. What happens to fractional excretory flow between 25 to 75%? That becomes decreased because there is a flow problem, but it remains normal in restrictive lung disease. What about RV and TLC? Because air trapping is happening. So air trapping will cause TLC and RV to be high. Whereas restrictive lung disease, the lung cannot expand. So all types of volumes, including residual volume and TLC, will also be decreased. This particular point, dear friends, please highlight it. This particular point is your INI set MCQ 2021 November exam. You might be thinking, sir, INI set easy things are asked. Yes, FMG tough things are asked and INI set easy things are asked. And if something is a INI set or NEET PG top MCQ already, the chances of it getting repeated is more. Ask your seniors and those who have sit in the exam, they would know that questions do get asked. So RV TLC value has been asked once in the INI set. Don't worry, I'm not preparing you for INI set, but wherever the MCQ comes, we will be marking. What happens to diffusion capacity of lung for carbon monoxide? It is a test that we do. DLCO means diffusion capacity of lung for carbon monoxide. It remains normal in a patient with asthma, but it becomes reduced in a patient with emphysema. If you go by the old papers of FMG, you will find another MCQ asked on this. The only obstructive lung disease where DLCO becomes reduced is emphysema. It is decreased in emphysema, whereas it is decreased in patients with restrictive lung disease. Can asthma have rise in DLCO? Some patients it can, but those are exceptions. Vast majority, it remains normal for that patient. The only exception is if the patient is presenting with status asthmaticus, it can be slightly increased. So that is an exception, and that is why we will not be writing increases in asthma. What is the advice you would give to the patient? What is the advice you will give to the patient? Now, in a patient of obstructive lung disease, we will say breathe slowly and deeply. We ask the patient to breathe like this. This is the advice you give in obstructive lung disease. Restrictive lung disease, breathe fast and shallow whenever the distress worsens. So we will ask the patient to breathe like this. Why is it so? There are hemodynamics involved, not hemodynamics, there are aerodynamics which are involved, which we need not go into right now. But this is the advice that you would give, and it is mentioned in Harrison as well. Okay, so the topic is done. This table is extremely important. It is asked in the exam. Let's go to the next page and have a look at this flow volume curve. This flow volume curve, have a look at it. Whenever you look at this flow volume curve, always we start from this particular point. We start from this particular point. This is your starting point. This is your starting point, right? The segment which is on the lower side, minus side, that is the inspiratory segment. And the segment which is on the positive side is expiratory segment. Why the inspiratory segment is negative? Because as you are inspiring, the negative pressure is becoming more negative. So flow is written in minus value. Whenever flow is coming out, the sensors are detecting the flow coming out towards it. So it is always written as a positive segment. So remember, we start from here, then inspiration happens. When inspiration begins, the volume which is present in the lung at that point is the residual volume. Okay. Then inspiratory volume starts. This is the peak inspiration. Then inspiratory flow tends to fall. At the point at which maximum inspiration has been attained and no further inspiration can happen, this is the point where total lung capacity can be measured. Then the expiration starts. This is the peak expiratory flow point, and then the expiratory part ends and the new cycle of respiration begins. So what are the key points to know? First of all, it starts at point somewhere around 5.8 liter. The lower part is inspiratory, the upper part is expiratory. This point, what we measure is residual volume. This point, what we measure is total lung capacity. These are the normal things that you need to know. You can know abnormal only if you know the normal values first. Now, what are the abnormalities examiner can ask you? Examiner will give you, he will say, a patient with a lung disease underwent spirometry. Flow volume curve is as shown in the image. What is the likely diagnosis? By looking at the image, you have to tell. Now, in this photograph, you can see that this is the normal value. I'm labeling it also. So they will label in the exam. This is a normal. And this is a patient's flow volume. Now, what has happened to this? Two things you can see. Can you see that it has moved towards the left? Shift to left has happened, number one. Second, in the expiratory segment, there is a concavity which is getting produced like this. Concavity. So, I'm writing here, whenever you have a flow volume where there is shift to left as well as concavity getting produced in the expiratory segment, the patient is having obstructive lung disease. Obstructive lung disease. Right? What are the variations of this question? First of all, they can show this photograph and ask you diagnosis. Your answer will be obstructive lung disease. Whatever obstructive lung disease is given, you will mark it. Second, they will say obstructive lung disease was there. Curve is shown. After giving salbutamol, the curve shifted to right and became normal. What is your diagnosis? On giving salbutamol, the curve shifted back to right and became normal and the concavity disappeared. What is your diagnosis? If it doesn't change, then it should be other diseases like emphysema or COPD should be thought of, right? First thing. Second thing, look at this curve. This is a normal patient's curve. And this is the curve which has shifted to the right in the patient. Now remember, whenever there is a shift to right happening, or the overall dimension, overall size becomes narrow, overall size becomes narrow, the patient is having a restrictive lung disease. The patient is having a restrictive lung disease. Restrictive lung disease. Also, you need to know that whenever there is a shift to right, that will indicate a extra parenchymal variety, whereas in parenchymal, only the size will reduce in the patient. But again, examiner will not ask you to go so deep. So whenever there is a shift to right happening, or overall size becomes narrow because it is a volume curve. So overall volume is reducing, it will be a restrictive lung disease in the patient. And absolutely rightly said, these patients, because it becomes sharp like this, so some patients may have a beanie cap appearance. Beanie cap is plus minus. It is not always seen, but if the uppermost expiratory curve becomes pointed, that is called as beanie cap. I'm just highlighting here. Beanie cap may be plus minus. And tomorrow examiner can ask you as one liner, beanie cap on flow volume curve indicates which lung disease? It indicates a restrictive lung disease in the patient. Moving further, look at this curve. What is happening in this curve? In this curve, this upper one is the normal curve. And here you are finding this is the curve of the patient. I am highlighting in red. Originally it was red, but due to some formatting, the red color was lost. So the red colored one is the patient. Now what you can see in the patient, I am using the technical words also because there is a possibility tomorrow examiner may not show you the photograph. They will simply mention in the line and you have to imagine and tell the answer. So whenever in a flow volume curve, the inspiratory curve as well as expiratory curve are flattened symmetrically. They are flattening symmetrically. What does it indicate? If they are flattened symmetrically, that indicates fixed airway obstruction. It indicates fixed upper airway obstruction. Fixed upper airway obstruction. And the typical example for fixed upper airway obstruction is tracheal stenosis. Tracheal stenosis. Tracheal stenosis. What is the overall most common cause of tracheal stenosis? Most common cause of tracheal stenosis is prolonged intubation. MCQ point. So this is your medicine and anesthesia integrated and surgery integrated question. So prolonged intubation patient, after he has developed tracheal stenosis, what will happen? There will be a flattening of the curve. Flattening of the curve in these patients. Right? So next curve. Look at this next curve. What is happening? This is the curve of the, this is a normal curve. And this is a curve of the patient. I'm highlighting in the red. It has become a circular. So whenever examiner says circular flow volume curve, what does it indicate? Circular flow volume curve indicates neuromuscular weakness. Neuromuscular weakness. And neuromuscular weakness, what is the most common example? It will be seen in patients with myasthenia gravis. Absolutely right. Myasthenia gravis. Let us write NEET PG MCQ 2024. What is the most common HLA association of myasthenia gravis? It is HLA B8. That is your MCQ one-liner. Wherever possible, we will be incorporating all integrated MCQs at one place, because end of the day, what we want, MCQ should be right. Next thing, look at the next curve. Now in the next curve, what is happening? This red color curve is the curve of the patient. This is the curve of the patient. In this curve, what you can see is the upper part is normal, but only the inspiratory segment is flat. When only the inspiratory segment is flat, what does it indicate? It does not indicate fixed airway obstruction. Fixed में तो दोनों part affect होंगे. There will be variable airway obstruction. But which airway obstruction? Variable extrathoracic airway obstruction. Variable extrathoracic airway obstruction. Can you give an example? Can you give an example? Have you heard of croup patient? Laryngotracheobronchitis, right? Also caused by parainfluenza virus. That causes a variable extrathoracic airway obstruction. So all conditions which have stridor in them, remember, they all will present with this kind of flat curve. Only the inspiratory segment will be flattened in these patients. Okay. And finally, look at this curve. When this patient, what is happening? Only the expiratory curve, the upper one, the positive one, that is getting flattened. So if there is only expiratory segment getting flattened, only expiratory segment getting flattened, the patient is having variable intrathoracic airway obstruction. It will not occur in asthma. It will occur in some rare disorders where the tone of the bronchus changes with time. So there are some rare causes, you need not go into detail. Yeah, and all of these patients will be having wheeze on auscultation. They will be having increasing and decreasing wheezing on auscultation. So remember, if examiner says which curve is associated with stridor, this curve will be associated with stridor. And if they say which curve is associated with intermittent wheezing in the patient, this type of flattening of curve where the expiratory segment is flattened, that will be associated with wheezing. Absolutely right. Great. Kuti Padkini, Royal Khan is writing retrosternal goiter. Absolutely right. Great. See, you people have prepared so well. So you just need to trust your preparation. How long the class will go depends upon my ability to sit and your ability to sit and listen. At least till 10:15, 10:30 the class will go. There will be breaks in between, that I will let you know. Only 10 minutes break in between. Let us solve an MCQ. Look at the MCQ and give me your answer. FMG August 2020 MCQ. 60-year-old male patient is presented with complaints of dyspnea on climbing stairs. This flow volume curve is shown in red. As I said, this is the red curve. That is the patient. And his heart sounds and breath sounds are normal on auscultation. There is dyspnea on climbing stairs. What is the likely diagnosis? The overall dimension is reduced and it has slightly moved towards the right. What does it indicate? The patient is having, what is the answer? Restrictive extraparenchymal disease. Diffusion capacity of lung for carbon monoxide. Where does it increase? Where does it decrease? Now many of you asked me कि सर कोई इसका mnemonic बता दो, बहुत confusion रहता है. Diffusion capacity of lung for carbon monoxide has been asked in NEET PG once. It has been asked in old paper of FMGE once. So we have to do it. The mnemonic for DLCO increased. There is a mnemonic. Abhishek Sharma. I hope you all know Abhishek Sharma. He is the next big thing in our Indian cricket. Abhishek Sharma plays cricket. Easy to remember. The first words are the 4 important causes of rise in DLCO. A stands for alveolar hemorrhage. It is not anemia, alveolar hemorrhage. Do you know any disease where alveolar hemorrhage occurs? For example, there is a disease, you must have heard the name, good pasture syndrome. Good pasture syndrome. S stands for shunt. Which shunt? Left to right shunts. Left to right shunt example is ASD, VSD, PDA, etc. P stands for polycythemia. Polycythemia. Because more RBC mass, more hemoglobin will bind more carbon monoxide. So diffusion capacity of lung will increase. And C stands for congestive cardiac failure, also called as congestive heart failure. So this is the mnemonic for increase in DLCO. It's a simple one, but it covers all the points. There may be other causes also, but we are trying to cover the ones which are asked in the exam. And DLCO decreased. That simple way to remember mnemonic for this. VIP. जितने VIP लोग होते हैं वो हमेशा लेट आते हैं. VIP people are late. That is the mnemonic for DLCO. That is the mnemonic for DLCO being decreased. Let us write down what is the full form. V stands for Valsalva maneuver. I hope you all know what is Valsalva. You know, closing the 2 nostrils like this, and with a closed mouth, you try to push air through the eardrum. That is Valsalva maneuver. I, what does I stand for? It stands for interstitial lung disease. P, what does P stand for? It stands for pulmonary hypertension, also called as pulmonary arterial hypertension. I'm writing in short PAH. L stands for lung resection. Whenever lung volume loss happens or lung damage happens, overall volume loss, that can cause fall in DLCO. Then A stands for anemia in the patient. A also stands for a drug known as amiodarone. Amiodarone is a antiarrhythmic agent, but it also has thyroid side effects and it can cause fall in the DLCO. T stands for thromboembolism. You know there is a disease known as pulmonary thromboembolism we will be discussing today. And E stands for emphysema. E stands for emphysema. So this is the mnemonic. This is the list for you. Even if many of the things you might have read already, but if you keep adding these points to your notes, they will at least make it easy for you. There is a concept behind everything, but because the exam is less than 2 months away, we cannot afford, we have to cover a lot of ground. So diffusion capacity of lung for carbon monoxide. While reading, if you have any doubt, extra doubt in your mind, say to yourself, if it is relevant to the MCQ only, then I will ask, other I will not. But still, if you feel like, you are most welcome to reach out. Then we come to the GINA guidelines for asthma. What is GINA? Global Initiative Against Asthma. They give you standard guidelines which are mentioned in Harrison, and they are followed by all the standard places, including in India. Where is the latest update? 2025 latest update has come. So you are supposed to remember the latest guidelines. For the purpose of asthma, see, asthma diagnosis requires 2 things. Listen to me carefully, then we write and annotate the points. For the purpose of diagnosis of asthma, 2 things are needed and both should be present. 1, there should be some clinical feature suggesting asthma, and that feature should be variable. Variable means sometimes increasing, sometimes decreasing. Okay. Second, there should be abnormal spirometric value. I repeat, 2 things should be there. 1, there should be variable respiratory symptom. Second, there should be abnormal spirometric value. And when you talk about spirometric value, it should be expiratory value, which should be abnormal. If you have any one out of this and any one out of this, then you say patient is having asthma. Let us go into the details. So first thing to understand, it is diagnosed if both are present. First, history of typical variable respiratory symptoms. Wheezing should be there, or shortness of breath, or chest tightness, or cough. Any of them can be there. These symptoms should be variable in time and intensity, sometimes more, sometimes less. Worse at night or awakening the patient from sleep, or they should be triggered by some agent like viral infection, cold air, exercise, laughter, allergens. So at least one out of these symptoms has to be there. Wheeze, shortness of breath, chest tightness, and cough. And second, on spirometry, there should be confirmed variable expiratory airflow limitation, at least one or more of the following. What are the things we look out for? First of all, you check the positive bronchodilator responsiveness test. What we do is, first you check FEV1 or FVC. Okay, first you check. Then you give salbutamol, and after 20 minutes repeat the test. If now the FEV1 improves, you will call it as diagnostic of asthma. Okay, so how much it should increase? It should increase by equal to or more than 12%, or it should increase by equal to or more than 200 ml. It should increase by equal to more than 12% or equal to more than 200 values you have to mark up. Second, over a 2-week period, you check what is the peak expiratory flow in the morning and in the evening. This is difficult to do, but these days you have portable spirometric devices which can only check for PEFR value. So we ask the patient, do in the morning, do in the evening, 6 a.m., 6 p.m. and write in your diary. Now patient comes to you and he has a diary record of 2 weeks. If you find that there is a variability in twice daily PEFR, peak expiratory flow rate by equal to or more than 10%, then again it is a criteria. Third, you give inhaled corticosteroid and check FEV1 after 4 weeks. If FEV1 rises by 12% or peak expiratory flow rate rises by 20%, then it is a criteria. Fourth, you perform a bronchial challenge test. First of all, you do FEV1. Then you give methacholine or hypertonic saline or make the patient do exercise and check again. Now FEV1 falls. That is also a test for asthma. And finally, excess variation in lung function. FEV1 varies by equal to more than 15% or PEFR varies by equal to or more than 20% between 2 visits to the hospital. That is also diagnostic. Now you might be thinking, sir, why it is so tough? These are not tough, but it is just that we are not doing them and you have not attended the spirometric clinics right now, so you are finding it a bit tricky. Remember, spirometry is essential for asthma in age above 6 years or 7 years if available. Below 6 years, you cannot do spirometry. So in young children, diagnosis is made based upon symptoms alone plus improvement in symptoms with bronchodilator. Okay, but above 6 years of age and adults, it is spirometry which is the investigation of choice. Now, sometimes examiner asks you to distinguish between type 1 versus type 2 asthma. You need to understand that type 1 asthma is rare, whereas type 2 asthma is the one which is common. So when we talk about asthma, which is the variety we are talking about? Type 2 asthma. Type 1 asthma is the one in which there is a predominant neutrophilic infiltration of the bronchi. Type 2 asthma is the one in which there is eosinophilic infiltration of the airways. In type 1 variety, the IgE value is either normal or slightly increased. Whereas in type 2 asthma, the IgE value is significantly increased. The allergic one is the type 2 asthma. Type 1 variety, which will show no response, it will show poor response to steroids. Whereas type 2 variety will show good response to steroids. It will show good response to steroids. Now, why are we distinguishing between them? Because for type 2 asthma, new biomarkers have been updated, and this is a 2025 update. I'm putting a big star here. It could be a fresh MCQ. Not only here, but I have put it as an update for the NEET PG groups and for the INI set groups as well. It was not asked in this INI set, but doesn't matter. It has the likelihood of being asked. For the first time, guidelines say there are blood biomarkers or there are other biomarkers where spirometry is not needed, which will indicate asthma in the patient. But biomarker available for what? Only type 2 asthma. Two biomarkers are available. First of all, we can check FeNO value. What is FeNO? FeNO stands for fractional expiratory nitric oxide. This value is increased significantly in type 2 asthma, but it is a costly test not available. As an alternative, the guidelines say patient with variable respiratory symptom, if spirometry is not available and you find increased levels of blood eosinophils above the upper limit value for that age, that is also a marker and it can be a reason to start therapy for asthma even if spirometry is not available. Very, very important. Add it somewhere, see it again close to the exam. Going to the next topic, treatment of asthma. Latest update. This is again different. Now let me tell you, I have a bad habit. It's a bad habit for me professionally, but it's a good habit for all of you. The bad habit is I always make it a point that before my sessions, I go through what is there in all the platforms and all the videos and other places. Unfortunately, anything which has gone on already recorded or already printed cannot be changed. And so you need to remember this. This is the latest guidelines of asthma. They have simplified the guidelines. If you read the older guidelines, there was step 0, step 1, step 2, step 3, step 4, step 5. Now they have combined these steps together and they have simply said simplified therapy. What is the therapy that you will do? They say that any diagnosed patient with asthma, how would you start therapy? If the symptoms are less than 3 to 5 per week and overall lung function is normal, you will start AIR therapy. What is the full form of AIR? AIR stands for Airway. What is the full form? Anti-inflammatory reliever therapy is recommended. What is anti-inflammatory reliever? Earlier, what people were doing was they were giving salbutamol puff. Some people were adding inhaled corticosteroid. Some people were not giving salbutamol. Some were giving formoterol. And there was a lot of variation. Guidelines were not homogeneous. Now they have said any patient who, whenever he gets symptoms, he should take a puff of ICS formoterol. What is ICS? Inhaled corticosteroid combined with formoterol. I hope you know formoterol is a beta agonist. It is fast acting as well as long acting, right? So ICS formoterol, that is budesonide or beclomethasone, either of the two can be used combined with formoterol. That combination therapy is to be used. Suppose I am a asthma patient, whenever and I fall in this category, my normal lung function is there, symptoms are less than 3 to 5 per week. I get only twice a week. So whenever I get symptom, puff of ICS formoterol. That's it. Do I need to take anything daily? It is not needed. In fact, the older steps 1 and 2 have been combined here. So steps 1 as well as step 2 are combined in this particular step. It's a very important thing. You have to remember the latest guidelines. Second thing, if the symptoms are equal to or more than 5 times per week and waking the patient at night, or there is decreased lung function, you will use low dose MART daily. Now it is not SOS, it is not as needed daily use करना है. और क्या use करना है? AIR use नहीं करना, MART use करना है. तो आप पूछेंगे सर MART और AIR में फर्क क्या है? Subtle differences are there, dose difference is there, and how you are using it, that is different. So that is a practical thing. They will not ask MART use karna hai. What is the full form of MART? Maintenance and reliever therapy. जो स्टीरॉइड है वो काम करेगा मेंटेन करने का. स्टीरॉइड will act as a maintainer. Reliever of bronchoconstriction will be done by formoterol. तो यूज सेम करेंगे. क्या करेंगे? ICS formoterol. लेकिन डिफरेंस क्या है? यहां यूज कर रहे थे SOS. SOS मीन्स व्हेन इट इज नीडेड. यहां यूज करेंगे डेली बेसिस पे. एंड कौन सा यूज करेंगे? लो डोज मार्ट. इफ देर आर डेली सिम्टम्स, waking at night with decreased lung function, all three are present, or there has been a recent exacerbation which required hospital care, you will start medium dose MART daily. यूज वही करेंगे लेकिन उसका डोज जो है डेली बढ़ा देंगे, डबल कर देंगे. दैट इज कॉल्ड एज मीडियम डोज मार्ट. And if patient is still not improving on that, poor control is there, frequent exacerbations are there, three possibilities. Either you can consider adding LAMA. What is LAMA? Long acting muscarinic agonist. Long acting muscarinic agonist. Example, tiotropium. There are two drugs, iotropium and tiotropium. Tiotropium is the one which is longer acting and recommended according to GINA guidelines. Or you can give a trial of high dose MART. The problem with high dose MART is steroid also becomes high dose, and so there are some side effects. And third, you can consider biological agents. What is the role of oral steroids? Oral steroids can be given for a life-threatening episode, but they are not useful in the definite management in such patients. So what are the biological agents useful in asthma? Biological agents used in asthma. So what about considering biological agents? Yes, long-acting muscarinic antagonist. Really sorry, antagonist. It is tiotropium bromide. Biological agents useful in asthma. This is extremely important from exam perspective. Very, very important from exam perspective. And it is integration with your pharmacology as well. Pharmacology as well. Right? So biological agent क्या क्या है? देखो, anti-IgE. What is anti-IgE agent which is approved for use in asthma? Omalizumab. Second, anti-interleukin 4 receptor alpha. The agent is dupilumab. Third, anti-interleukin 5. We have mepolizumab. And fourth, anti-TSLP. What is TSLP? TSLP stands for thymic stromal lymphopoietin. It is involved in maintaining low-grade inflammation in the airway. So anti-TSLP, tezepelumab. Tezepelumab. Are there other antibodies? Yes, almost 11 monoclonal antibodies are there. But from exam perspective, what are the ones which are at least available in India? Approved by FDA, mentioned in GINA, available in India. These are the four important ones. Once you have remembered these four antibodies in asthma, you want to add more, most welcome to do it. But at least these four should not go wrong, right? And whenever, now there is always a view ki which one is to be used where. Generally, omalizumab is the first one which is started because number one, it is cheaper also, and secondly, it has maximum data safety available as well. But if they say that eosinophilia is very prominent, then sometimes we directly go over to dupilumab or mepolizumab as well. Now, these are complex guidelines. When you are solving MCQs in Q banks, particularly some custom modules where NEET PG and AIMS questions are added, you will find questions related to which one is to be preferred over what. Unlikely this will be asked in FMGE because the data for that is lacking and that data keeps on changing very frequently. So the new GINA guidelines are ambiguous on this. I'm telling the word ambiguous, and that is why examiner is unlikely to put fine details. These are useful in refractory asthma. Yes, they are useful in refractory asthma. Refractory asthma. Right. What is SAMTUS? It is not SAMTUS. It's a spelling bit. SAMTUS triad. SAMTUS triad is an PYQ NEET PG asked 3 years back. Three things which are a part of SAMTUS triad. What are these three things? First of all, these patients have asthma. Second, they have increased risk of developing nasal polyps. And thirdly, there is hypersensitivity, increased sensitivity to aspirin. If they don't use the word aspirin, non-steroidal anti-inflammatory drugs, they mention that will also be correct because cross-sensitivity is seen in these patients. So SAMTUS triad will be a triad of these three things, right? Good. Drugs useful in acute severe asthma exacerbation or status asthmaticus. Status asthmaticus is no longer called as status asthmaticus. We call it as drugs useful in acute severe asthma exacerbation. Exacerbation means worsening. So acute severe asthma exacerbation, what are the drugs which are useful? There was a question asked on this in INI set exam 2 years back. The question was, all of the following drugs are useful except, and it was a multiple correct option. So from exam perspective, you should know what are useful. Oxygen is useful. Steroids are useful. Two steroids are indicated for use. Either you can go for prednisolone or you can go for hydrocortisone. Third, you have salbutamol nebulization, which is useful. Ipratropium is useful. Tiotropium is generally preferred for maintenance therapy. Ipratropium is the one which is more useful for acute attack. Ipratropium is useful. In refractory cases, you can consider magnesium sulfate. You can consider IV theophylline, or you can consider IV aminophylline. Although they are seldom used, but these drugs at least can be useful. But where is no role of the drug? LABAs. LABAs is long-acting beta agonist. For example, salmeterol. They have no role. And montelukast, which is a oral drug. It is an oral drug which is useful in the maintenance therapy in exercise-induced asthma. It has no role in the management of any acute exacerbation in the patient. So salmeterol and montelukast. This is a previous year question that you need to remember from exam perspective. Let us talk about COPD. Now, COPD is chronic obstructive pulmonary disease. Two broad types are there, type A and type B. Type A varieties are the ones which are called as emphysema, where there is a permanent irreversible dilatation of the terminal of the alveoli and destruction of the alveolar wall. And second variety is type B, where there is chronic bronchitis. Emphysema patients are also called as pink puffers because cyanosis is not there, but these patients have a tendency to puff away. Both of them are associated with smoking. Emphysema is the one which is associated with more aggressive smoking. So pink puffers. Chronic bronchitis is the one where cyanosis is there, and these are the ones who are having blue bloaters. Emphysema patients always have wasting which is present. Wasting means loss of waste is there. And blue bloaters are the one where weight gain along with productive cough is the hallmark. These are the patients who are having productive cough as the hallmark. Now, this is the tracheobronchial tree. It has been shown. Two types of emphysema can be seen. First variety is the one in which the entire lobule of the alveolus becomes involved. It is called as panlobular emphysema. It is also known as pan-acinar emphysema. You can get a pathology MCQ. Panlobular or pan-acinar emphysema is seen in which condition? This is seen in patients with alpha-1 antitrypsin deficiency. But if the examiner says there is centrilobular emphysema, only the central part of lobuli, this particular part is getting dilated. But the terminal parts are still, relatively better off. This will be seen typically in patients with smoking associated disorders. These are the ones which are associated with smoking associated disorders, particularly COPD or emphysema. Let us move into the gold criteria for COPD classification of severity. Gold criteria is important. I am writing here. There was an MCQ asked on this in INI set November 25. INI set November 25, there was a question asked on this. So gold criteria says that there are 4 stages which are defined, and they are decided based upon FEV1 by FVC ratio, which is a mandatory criteria, and then predicted FEV1 percentage. You have to divide. 1 is mild, 2 is moderate, 3 is severe, 4 is very severe. FEV1 by FVC will be less than 0.7 in all of these patients. It will not be responding to bronchodilator. If the FEV1 percentage is more than 80%, that is mild COPD. If it is 50 to 80%, that is moderate COPD. If it is 30 to 50%, that is severe COPD. And if it is less than 30%, it is very severe COPD. Running short on time, just focus on these particular points. And what is the treatment of COPD as per the gold criteria? Now, this is something we need to understand. For the purpose of treatment, there are additional things that we do. We first check what is the MRC dyspnea grading. 4 grades of dyspnea are there. 1, 2, 3, 4. Right? Those dyspnea grades is a clinical thing. Then there is a score we calculate called as CAT score. And we see whether the CAT score is less than 10 or more than 10. And third, we see how many exacerbations or worsening has happened. Worsening can be of two types. One worsening where patient comes to OPD and goes back home. Second worsening where patient requires hospitalization for minimum 24 hours. Then you decide what is the class of COPD. Class A, dyspnea grade is 0 to 1, CAT score less than 10, 0 to 1 moderate exacerbation. Moderate exacerbation is the one which can be managed by the patient or which requires OPD visit but does not require hospitalization. These are the patients in whom the therapy of choice in these patients will be short-acting beta agonist, that is bronchodilator given as needed. As needed means whenever exacerbation happens, you give short-acting beta agonist. But it is seen that giving short-acting beta agonist, eventually side effects start coming or responsiveness to SABA tends to fall down. If the patient still stays in class A, you can switch over the patient to short-acting muscarinic antagonist. So ipratropium bromide can be started, but it will be given as needed. What about class B? When the dyspnea grade is 2 and above, CAT score is equal to or more than 10, these values examiner will mention in the question. But there is no hospitalization. This is class B. In class B, you have to give long-acting beta agonists, but they are given daily. They are given daily or regular is the word used for. So not SOS basis, long-acting beta agonist. Alternative in these patients is LAMA. LAMA example will be, I have given the example already, tiotropium bromide will be your example. Then we have class C, dyspnea grade 0 to 1, CAT score less than 10, and at least 2 or more moderate hospitalizations, moderate, not moderate hospitalization, it's a misprinting, moderate exacerbations, or at least one hospitalization. If at least one hospitalization has happened, but grade is less than 2 and CAT score is less than 10, that will be class C. In class C, you have to give long-acting muscarinic antagonist regularly. And class D, where everything is severe, dyspnea grade equal to or more than 2, CAT score equal to more than 10, 2 or more moderate exacerbations, exacerbation means worsening, or at least one hospitalization has happened. Treatment in these patients will be combining long-acting muscarinic agonist with LABA. Or you can consider inhaled corticosteroids with LABA. And if refractory patient is there is no response, which agent can be added? It's very, very important. And it is prominently mentioned in the New Nelson. Older Nelson, it was just mentioned as a footnote. New Nelson prominently mentioned refractory patients, you can consider adding azithromycin, oral azithromycin in these patients. Remember that azithromycin is a macrolide, but it is a very, very versatile agent. It not only has antibacterial action, it also has modest anti-inflammatory action. And in patients of COPD class D and severe cystic fibrosis with recurrent pneumonias, we are actually using azithromycin on a weekly basis. Either twice weekly, thrice weekly, बहुत तरह के regimes हैं, details will not be needed. So which antibiotic can be given for anti-inflammatory action in COPD and cystic fibrosis? What will be your answer? That is why I put a star. Azithromycin will be your answer. Right? Azithromycin is resistant in many people. The reason azithromycin resistance is high is because in India, we take azithromycin. Any sore throat, people take azithromycin. Any sore throat, people take azithromycin. Let me tell you a fact. Azithromycin resistance is not that common yet. It is that you are taking azithromycin for a wrong indication. That is the reason azithromycin doesn't work. You will learn it once you cross over to this side and start treating the patient. Then you understand that azithromycin is still a very, very good drug, but it is not a magic wand that, it's not Harry Potter. It's a wand that you just use like this and the patient gets correct. So azithromycin is the only agent which is antibiotic with anti-inflammatory action in respiratory tract. Remember this point, will be useful in the coming days. Moving further, we have some case scenarios to you. Let us talk about some case scenarios. Now we can pick up the speed. These are easy scenarios. First of all, examiner will say there is a patient with asthma or cystic fibrosis. He comes to you with productive cough. It can occur in asthma, cystic fibrosis, but there is brown sputum. First clue in the question, thick brown sputum and brown plugs are present. The patient has difficulty in breathing, and second clue in the question, raised immunoglobulin E. Asthma or cystic fibrosis, brown sputum, raised IgE, not responding to the conventional management. What is the likely diagnosis? The patient is likely suffering from a disease known as ABPA. What is ABPA? Allergic bronchopulmonary aspergillosis. This is an allergic reaction in response to aspergillus infection. So it is an allergic reaction. What is the cause? It is hypersensitivity to fungus. What is the name of the fungus? Aspergillus fumigatus. The name of the fungus is Aspergillus fumigatus. What is the cardinal diagnostic test? Put a MCQ here. Specific immunoglobulin E against Aspergillus. We don't check total IgE. We do a costly test known as Aspergillus specific IgE. It is not easily available, but this is considered the cardinal diagnostic test. In other words, you can call it as a gold standard investigation also. What happens to circulating levels of IgE? The total IgE levels are increased. They are more than 1000 international unit per ml. What will CT or chest X-ray show? Another MCQ. This is an MCQ asked in radiology part of FMGE PYQs. You will find CT or chest X-ray shows bronchiectasis. What type of bronchiectasis? Bronchiectasis means restriction of the wall of large bronchus. Central bronchiectasis is seen in these patients. Normally, it is peripheral bronchiectasis which is more common. But in asthma patient, cystic fibrosis patient, ABPA patient, what type of bronchiectasis is seen? Central bronchiectasis is seen. 3 types of questions you will ask. You will be asked, very, very important. If they ask you what is the treatment of choice in the patient, the treatment of choice is combination. See, it is an allergic reaction. You need to understand one thing. For treatment, when the patient is first diagnosed, you need to, number one, control the inflammation. For that, you need steroid. Plus, there will be aspergillus in the body. You have not used antifungal. So you have to use antifungal agents as well. But if the patient is not improving, then you will add omalizumab to control the inflammation because it is IgE mediated reaction. But for every worsening which is happening, you need not give antifungal because exacerbations can occur in the absence of active fungal infection also. Okay, so whatever I just said, you can listen to it again when you are listening to the video. Treatment of choice in these patients will be prednisolone, that is corticosteroids, combined with antifungal agents. What are the 2 antifungal agents of choice? The first line agent is always itraconazole. If itraconazole is not tolerated, you can go for voriconazole. Remember, fluconazole does not work in aspergillus. Fluconazole does not work in aspergillus. So either itraconazole or voriconazole is useful. Treatment of choice, steroids with antifungal. Refractory cases, what you will add? Omalizumab. And for exacerbations, that is worsening, what you will do? You will use only steroids. Why this point is important? Because there was an MCQ on this statement-based question. Not in FMG, it was asked in old AIMS paper, not INISET. AIMS before 2020, there was AIMS. It was not INISET. The INISET exam came by clubbing of the exam. So there was a question that a patient has been treated appropriately for ABPA. 1 year later comes to you with another acute exacerbation. Which of the following will be used? One of the option was steroids alone. One of the option was antifungals alone. Third was steroid with antifungal. Fourth was steroid, antifungal and biologicals. What is your answer? Steroids alone. Because exacerbations can occur in the absence of fungal pathogens also. This is the funda that you need to know. This is the funda I am telling you while discussing the topic. So first scenario is done. Second scenario. Respiratory infection or CVS condition is there, right? So patient will say there is a respiratory infection or there is a cardiovascular disease in the patient. Examiner will mention these words, decreased air entry is there. Air entry is reduced. And this is the most important point. I'm highlighting it here. Stony dull percussion note. Stony dull percussion note always indicates presence of fluid in the lungs. Remember that. Stony dull percussion note always indicates fluids. If you see chest X-ray, there will be blunting of the costophrenic angles because there is fluid getting accumulated in the costophrenic angle, and there is appearance of S-shaped Ellis curve. It is something which is more of a radiological described sign. We don't, pay much attention to it, but if they mention this word, the likely diagnosis in the patient is clearly pleural effusion. Pleural effusion. Right? So pleural effusion is the answer. Look at this table. Lights criteria for pleural effusion, very important. And there was a question asked on lights criteria indirectly in the recent. So based upon lights criteria, pleural effusion can be of two types: low protein and high protein. Low protein is called as transudative. High protein is called as exudative. How do we calculate? How do you say transudative versus exudative? We take the protein value, the ratio between the pleural protein divided by serum protein. If the pleural protein is less than 0.5 of the serum protein, that is transudative. If it is more than 0.5, it is exudative. Then we check for LDH value. If the LDH value is less than 0.6 of the serum fluid in the pleural space, then it is transudative. If the pleural LDH is more than 0.6 times, that is more than 60% of the serum value, that is exudative. Third, if you don't have a absolute value, if you see that pleural LDH is less than 2/3, equal to or less than, this word is missing here, equal to or less than 2/3 of the upper limit, then it is transudative. It is more than 2/3 of the upper limit of the normal value, then it is exudative. What are the common causes? Causes you need to remember. Multiple MCQs on this has been asked. Multiple MCQs have been asked on this. So transudative will be seen in systemic diseases like hypoalbuminemia, like cirrhosis, nephrotic syndrome, CCF, constrictive pericarditis. They will all have transudative effusion. On the other hand, exudative pleural effusion will be seen in autoimmune disease, for example, SLE, esophageal rupture, infections. Highlight this word, parapneumonic. This was the question which was asked. TB, fungal, empyema. What is empyema? Pus in the pleural cavity. Malignancy, pancreatitis, post-CABG, and pulmonary embolism. These all will have exudative pulmonary embolism. I'm writing in the bracket so that you don't miss it. And this is the photograph where they will show the photograph and ask you the diagnosis. Can you see that there is fluid, there is blunting of the costophrenic angle here? And what is S shape? It is a shape in which as you move from medial to lateral, the fluid level tends to rise. It reaches a peak over here, and then when you move posteriorly, it starts falling again. So it forms a S-like shape. That is called as the Ellis S-shaped curve. It is a more of a fancy word. It is something we do not pay attention in real life. If there is costophrenic angle getting obliterated like this, along with stony dull percussion note, the likely diagnosis is pleural effusion. Look at the MCQ. Treatment of pleural effusion depends upon the cause. Remember the word. Putting a treatment, I'm writing, mostly it depends upon treating the cause. Mostly you will treat the cause. However, in parapneumonic effusion, what is parapneumonic effusion? Due to pneumonia, fluid is accumulating. There is no separate treatment needed. Antibiotics for underlying pneumonia are good enough. No separate therapy is needed. But empyema, if it occurs, that will require IV antibiotics along with intercostal tube drainage. Intercostal tube drainage. So mostly it depends upon treating the cause of the patient. A patient with a history of pneumonia develops pleural effusion. So pneumonia with pleural effusion. What kind of pleural effusion it is? Parapneumonic. Parapneumonic is exudative or transudative? This is all you need to remember. Exudative. Right? If it is exudative, look at the options. Pleural protein ratio compared to serum less than 0.5? Wrong. It is more than 0.5. Pleural LDH less than 2/3 of serum LDH? Wrong. It is more than 2/3. Pleural LDH less than 0.6 of serum LDH? Wrong. It is more than 0.6. What is the odd one out? pH is not used to distinguish. An odd one out here is B, which is your correct answer. Many times you don't know the answer, but answer is reached by ruling out the options. So by ruling out the options, you can easily reach the correct answer. So if you have a question like this, don't panic. What is important is if a future question gets asked, you have to remember what are the causes of transudative and what are the causes of exudative pleural effusion. Let's move further. Next scenario, examiner will say there is a patient having hemopsis. What is hemopsis? There is bleeding in the sputum. Hematuria, that is, there is bleeding in the urine, and anti-GBM, anti-glomerular basement membrane antibodies are present. Whenever you have a diagnosis like presentation like this, patient is suffering from an autoimmune disease known as Goodpasture syndrome. In Goodpasture syndrome, what is the cause of hemopsis? It occurs due to alveolar hemorrhage. The cause in the patient is alveolar hemorrhage. Now, let us go one by one. What is the age and gender for Goodpasture syndrome? Now, there are two peaks of Goodpasture syndrome which are seen. One peak occurs in the mid adulthood and young adults, and second is the one which is seen in older age group. In the older age group, male and female are equally affected, but this is one autoimmune condition where males are slightly more affected compared to female, and it is 20 to 30 year, which is the common age group. And the risk is significantly more, or the bleeding in these patients is particularly triggered in smokers. So smoking does not cause Goodpasture syndrome, but smoking triggers acute complication or acute alveolar hemorrhage in the patient. So smoking in general is bad, but it is very bad in Goodpasture syndrome. So what is the most common auto antibody which is seen in these patients? There is IgG type of anti-GBM, anti-glomerular basement membrane antibody, which is seen. This anti-GBM antibody is directed against what? It is directed against alpha 3 NC1 domain of type 4 collagen. Alpha 3 NC1 domain of type 4 collagen. This particular point is also your MCQ. This is integrated with pathology part. Which antibody produces this disease? So these tables of antibodies is something you read in pathology also. If there is isolated renal involvement in Goodpasture syndrome, we don't call it as Goodpasture syndrome. The term anti-GBM disease is used in there. So when they say anti-GBM disease, these patients will not have alveolar hemorrhage. Now, what is the treatment of choice? Now, to remove, if the patient is presenting acutely, you need to start steroids and do plasmapheresis for the removal of these antibodies. So you will do plasmapheresis if the patient presents with severe disease with increased autoantibody titers. However, in general, for the attainment of remission, controlling the disease, the drugs, the therapy of choice, if they ask, you would write like this: we use a combination of choice. A combination of steroids, that is prednisolone, is combined with cyclophosphamide in these patients. So steroids along with cyclophosphamide are useful. Cyclophosphamide is not only an anti-cancer agent, it also has good immunosuppressive action, and in many vasculitis and many autoimmune diseases, cyclophosphamide is one of the frontline agents. So this is your Goodpasture syndrome. Let us move towards this disease. Next question. Examiner will say there is known infection patient, or there is respiratory disease or trauma, and there is dyspnea, that is sudden onset shortness of breath. Generally, it is sudden onset. So sudden onset shortness of breath will occur. There will be decreased air entry on one side. Decreased air entry on one side can be seen in pleural effusion also, but there will be unequal breath sounds. There, the important point was there will be stony dull percussion note. Here there is hyper resonant note in one affected side, and chest X-ray shows deep sulcus sign and loss of vascular markings on the affected side. What is deep sulcus sign? On the affected side, there will be a sign like this where air will be trapped, and this sign will produce a deep sulcus like appearance, and there will be complete absence of vascular markings in that particular segment. Whenever you have a presentation like this, what is the likely diagnosis? The patient is suffering from pneumothorax. Pneumothorax. Okay. Now, if there is, what is the treatment of pneumothorax? If it is, I'm giving the heading, if there is sudden onset pneumothorax or fall in SpO2, you should suspect the patient is having a variety of pneumothorax called as tension pneumothorax. Tension pneumothorax needs to be relieved as early as possible. And the immediate therapy of choice in these patients will be needle decompression. The first step in pneumothorax will be do needle decompression. Do needle decompression. Now the question arises, MCQ point. What is the site of doing needle decompression? Site of doing needle decompression. If it is a child, then you do needle decompression in second intercostal space in the mid-clavicular line. You do it in the second intercostal space in mid-clavicular line. But if it is an adult patient, you will do in the fifth intercostal space in the mid-axillary line. So be careful what is being mentioned. These are the standard guidelines for doing. After doing needle decompression, later you will put intercostal drainage tube insertion. But this site of putting needle is important, and already previous year question has been asked. It is integration between surgery, anesthesia and medicine. And pediatric part also I have mentioned. So child ke andar second intercostal space, make sure it is mid-clavicular line. In case of adult, it is the mid-axillary line where we put it in the fifth intercostal space. FMG July 25 MCQ. Options are not there. Question was something like this. This is the latest MCQ. After failed subclavian catheterization, when you are putting subclavian vein through here, there is always a possibility of hitting the apex of the lung. There is increased work of breathing, BP falls and pulse rises. What is the likely diagnosis? Likely diagnosis is pneumothorax in such a patient. So what needs to be done? Do urgent X-ray and consider needle decompression. Pneumothorax is a known complication of subclavian catheterization. Now it is predominantly a anesthesia topic integrated with medicine and surgery, of course. Pneumothorax is your answer. Okay. Next thing, examiner will say productive cough. Cough is more in the morning. Now cough is showing change with posture and change with diurnal variation. Productive cough more in the morning, yellowish sputum, and the sputum amount increases with change in posture. So something getting collected in a dilated space. Fever plus minus, another clue, clubbing of the digits. The patient is suffering from a disease known as bronchiectasis. So what is the likely diagnosis in patient? It is bronchiectasis. If you go through medicine MCQs of July 25, January 25, last 24 both exams and 23 both exam. In medicine, at least 5 to 6 questions are only based upon tell the likely diagnosis. It is just that every time examiner keeps, conjuring up new ways of asking you. So if you know the buzzwords, you can either reach the correct answer or you can rule out the option to reach the correct answer. And that is why these small boxes which I am discussing, you are supposed to remember every word of them, because many times easy question. It is just that you know the buzzword, you know the keyword, you know the answer. So bronchiectasis, what is bronchiectasis? It is definition, they will not ask, irreversible dilatation of the lower larger tracheobronchial tree, that is called as bronchiectasis. What is the investigation of choice? Investigation of choice is a previous year question. It is HRCT, high resolution CT scan of the chest. And what are the radiological signs which are seen in these patients? 3 types of radiological signs. It is a NEET PG MCQ. The question was, all of the following are radiological signs described in bronchiectasis except. So 3 signs were mentioned. You have to remember all the 3 signs. So first sign is tram track sign. It is not tram track calcification. Tram track sign. Tram track calcification is a feature of Sturge-Weber syndrome that we will discuss tomorrow. Kal aayega wo. Second is signet ring sign. Signet ring is seen in malaria also, and signet ring sign on radiology is seen on bronchiectasis. What is a signet ring? You have a ring like this, and then there is a, hira like this. Oh, hire wala anguthi. That is called as signet ring, right? So signet ring sign will be rings like sign, something like this. And third, there will be tree inward appearance. If you are already wearing a ring like this, you can have a look at it. If you are not wearing a ring like this, don't worry, your time will come. but not now after 17 January. So tree input appearance. So these are the three radiological signs described in bronchiectasis. What is the treatment in these patients? Treatment of bronchiectasis is treat the underlying cause. So generally it is infection. So you will use IV antibiotics. Harrison says these antibiotics should cover Pseudomonas and H. influenza. So generally we go for third generation cephalosporins. So most commonly we use third generation cephalosporins. Plus we allow more chest drainage to occur. So you give chest physiotherapy so that the mucus, the sputum which is collected in the dilated vessels, that can come out. The drainage of the chest improves, plus minus nebulization in the patient. And obviously, if it is due to underlying reason, you will be correcting the underlying cause. This is the treatment of. See, that is what I'm saying. If you go into radiology, there are so many radiological signs which have been described. The only thing is we can't remember everything. See, radiology makes sense only after you have done all the other 18 subjects. So I'm covering this particular point here because it was a previous year question. And these were the three options mentioned in the question. So the fourth one was your answer. So obviously there are more signs. So you are supposed to read radiology. But here I'm talking like a clinician. The most important things or the characteristic points are the ones I am discussing. And then we come to pneumonia. How pneumonia question will be asked to you. Examiner will say fever and cough is there. There is shortness of breath. Bronchial breathing will be the clue. And chest x-ray will show either lobar consolidation, in one lobe there is consolidation, or diffuse infiltrates are. Generally, lobar consolidation occurs in typical bacterial pneumonias, and infiltrates in both the lungs, hilar infiltrates. They can occur in bacterial causes, they can occur in viral causes, they can occur in some opportunistic pathogens as well. So fever, cough, bronchial breathing, consolidation or infiltrate, we are dealing with infection and inflammation of the lung parenchyma, that is pneumonia. The diagnosis is pneumonia. So this is pneumonia. Now let us talk about one-liners on pneumonia. Pneumonia is a sure topic in exam. If you go to pediatrics, IMNCI guideline of pneumonia, sure topic. If they don't ask there, you come to medicine, you have all the one-liners and you have criterias and you have treatments of pneumonia. So pneumonia, you do from pediatrics, you do from medicine, you go into the exam knowing that pneumonia something is going to be asked, right? So let us talk pneumonia, one-liners. Overall, most common cause of pneumonia is Streptococcus pneumoniae, also known as pneumococcus. What is the cause of nosocomial pneumonia? Most common cause is Staph aureus. Most common cause of pneumonia in COPD patient given in Harrison, Haemophilus influenzae. HIV, if they say overall most common cause, overall most common is different. Overall most common will be pneumococcus, that I will write separately. But if they say CD4 count related, CD4 count less than 500, these patients have a tendency to develop Mycobacterium tuberculosis infection. It will not be a true pneumonia, but it will mimic pneumonia-like presentation. CD4 count less than 200, patient will develop Pneumocystis jirovecii infection. Previously, it was called as Pneumocystis carinii. And CD4 count less than 50 cells per millimeter cube, it will be atypical mycobacteria. For example, MAC. What is the full form of MAC? Mycobacterium avium intracellulare. If question says lobar consolidation and bronchial breathing in AIDS patient, lobar consolidation will be typically produced by pneumococcus. And pneumococcus is also the common cause if CD4 count is not mentioned. Whatever the CD4 count, if they simply say most common cause of pneumonia in AIDS patient, where HIV positive patient already AIDS has developed. I hope you all know AIDS and HIV are not the same. HIV positive patient turns into AIDS, right? That subtle difference you'll be reading in microbiology. And if they say pneumonia with hyponatremia and diarrhea, hyponatremia means low sodium level, and diarrhea with pneumonia, always think of Legionella pneumophila as the likely pathogen. In these patients, the risk factor will be contaminated water conditioning or AC units, from where aerosols can spread into the closed room and spread Legionella pneumonia. And drug of choice in these patients, you can use either fluoroquinolones. These days, levofloxacin is very useful, or you can go for azithromycin. Fluoroquinolones or azithromycin. MCQ, CD4 count less than 50 is an MCQ. COPD is an MCQ. Overall, most common cause is an MCQ. So, the points done. Let us have a look at FMG January 23 MCQ and give me the answer. FMG January 23. Look at the question and give me the answer. HIV positive patient, pulmonary infection, CD4 count is less than 50 cells per millimeter cube. Sputum was positive for acid fast organism. Acid fast are mycobacterium. All mycobacteria are acid fast. They will stain with Zeal-Nielsen stain. So two clues: CD4 count less than 50, acid fast organism. Answer is B, Mycobacterium avium intracellulare. Mycobacterium avium intracellulare. Nosocomial pneumonia is hospital acquired pneumonia. Nosocomial pneumonia is hospital acquired pneumonia. Okay. Next, what is the predictor of mortality and where do you want to treat the patient? For that, we have a criteria known as CURB 65 criteria. CURB 65 criteria. NEET PG. Recently, it was asked. I said, recently it was asked. Would it be asked in FMG exam? You will tell me when we come for the recall. So, there is a CURB 65 criteria. It predicts mortality and it tells where you are supposed to treat the patient. Should you admit the patient? Should you treat on OPD basis? So, CURB 65, 5 components are there. CURB and 65, which is the age. C stands for confusion. So check for sensorium of the patient, whether he's oriented or disoriented. Second, you check for urea. Any urea value more than 7 millimoles per liter, that is a positive finding. You are giving a score of 1 each for if they are present. Then R, respiratory rate. If respiratory rate, it is not a newborn, it is not a child. So any adult with respiratory rate 30 per minute or more, give score of 1. Fast breathing will be there. B, BP abnormality. Either systolic BP is less or diastolic BP is less, or both, but you will take it as one value. Either systolic BP less than 90 or diastolic less than 60, 1 score. And age more than 65, 1 score. Then you calculate the total score. If the CURB 65 total score is 0 to 1, it is risk group 1, mortality is only 1.5%, low risk, you can give antibiotics at home. If the CURB 65 score is 2, risk group is 2, mortality is 9.2%, you have to decide if the patient is having any other comorbidity, counsel the patient's relatives, you feel that they are well off, but they live quite far away. So counsel them, get admitted, start antibiotic, later on we can discharge. But if the patient is very poor, no beds available, you will start with OPD care, but make sure that they are coming very frequently for the change of antibiotic. And if the score is between 3 to 5, there are scenario questions, tough scenario questions asked on this in INI-CT. So please spend some time in your local vernacular language, whatever it is, speak it out, discuss with your friend, or look at your mirror and talk to yourself and say it out what you are going to do. If it is total score 0 to 1, manage at home. Score 2, 9.2% mortality. So either ways it can go. But if it is 3 to 5, risk group 3, 30-day mortality without therapy is 22%, admission, and you have to manage as severe pneumonia. Okay, CURB 65 criteria 3 to 5 is the criteria for severe pneumonia. This is also an MCQ. When do you say severe pneumonia according to CURB 65? And I've put a small Q here. Which is better? Harrison says either of the two can be used, but CURB 65 is the one which is more commonly used. And this is the one on which questions are asked. PSI questions are generally not asked. And end of the day, Harrison also talks. Harrison says, more than the scoring systems, it also depends upon the assessment of the physician, which is actually true. Scoring system can only help you medically. Eventually, it is your clinical skill which will help you to decide what and where you want to treat the patient. So the question is, where do you want to treat the patient? For that, I have kept a lot of space. Why? Because I will be writing the updated Harrison guidelines. Updated Harrison 22nd edition guidelines. So I'll go slow, but this is an important point. So first of all, treatment of choice. If you are doing on OPD basis, you have, see, whether to decide OPD basis or not, we have already decided, right? CURB 65 criteria. If you are managing on OPD basis, first possibility, patient has no comorbidity. No comorbidity, only pneumonia is there. So what are the things you will do? You will use the patient, the first line therapy will be oral amoxicillin. You don't give amoxiclav, you give oral amoxicillin. Plus minus, you can consider combining either doxycycline or macrolide. Which macrolide do we use? Right in bracket azithromycin. You can combine one of the two with amoxicillin. What are the alternatives? This is the first line therapy. Alternative will be oral doxycycline alone, or you can go for oral azithromycin alone. Second possibility, if the patient has comorbidity. Comorbidity means there is some additional more problem. For example, there is uncontrolled diabetes also in pneumonia patient. Now there is a comorbidity or very severe hypertension in the patient. Or patient already had, some other recurrent infection or some hospitalization for some other event. Maybe he had appendix surgery some months back, some weeks back. So comorbidity is there. Now what you will do? You will treat on OPD basis. But in these patients, you will use oral amoxiclav. Now you will combine amoxicillin with clavulanate combination. Oral amoxiclav will be used. And you will combine it. Amoxiclav will be combined with either doxy or azithro because it is a comorbidity which is present. And second alternative, which is the one that we followed these days, you can use oral respiratory specific fluoroquinolones. Respiratory specific. What are the respiratory specific fluoroquinolones? You know the answer. It is either levofloxacin or moxifloxacin or going changes compared to what you might have read in your usual medicine notes. If you don't remember the usual medicine notes, this you have to remember. There is a possibility you may get question on this. So this is regarding the OPD basis treatment. Second is inpatient therapy or inpatient basis. Inpatient basis means you are admitting the patient. I'm writing in bracket hospitalized patient. In inpatient basis, if it is non-severe, you have admitted, but the patient is otherwise stable and there is no shock or any septicemia feature or other things. Non-severe patient, you will use beta-lactams. You can use either penicillins or cephalosporins. Generally, we use cephalosporins IV and they are combined with macrolides. Or you use fluoroquinolones alone, but you admit the patient and monitor in the hospital. If there is a patient with severe pneumonia and he's admitted in hospital, then you have to combine beta-lactams with fluoroquinolone. And if finally, last point, if the patient had any recent hospitalization in the last 2 or 3 months, or any recent hospitalization was there, you will add vancomycin. Or piperacillin tazobactam. Think and tell, why are we using vancomycin? Vancomycin is being added for MRSA cover and piperacillin tazobactam is being given for Pseudomonas cover. It is being given for Pseudomonas cover. You will now which one to add? That is a decision of the treating physician. Examiner will not ask you to choose. Right. So this is a summary. This is based upon 2 tables given in Harrison 22nd. Minor differences are there compared to the older Harrison. So it's a topic which is important and is being taught in the current NEET PG classes also, that this is a very important topic for the NEET PG exam. It is not only for NEET PG, it is also important for INSET. So I've kept empty space and I had to explain and write. So one-liners on pneumocystis jirovecii pneumonia. There are one-liners asked. First of all, pneumocystis jirovecii commonly causes infection in HIV positive patient. Something you already know. And what type of pneumonia it causes? It does not cause lobar pneumonia. It causes interstitial pneumonia. And when you do chest X-ray, there will be bilateral interstitial infiltrates present on the both sides. What will HRCT test show? HRCT test findings are important. These patients you will find diffuse ground glass opacities. Diffuse ground glass opacities. They are also written as GGOs. Remember that GGOs can occur in COVID-19 pneumonia also, but COVID-19 questions are being asked. Investigation of choice. Bronchoalveolar lavage fluid you take and apply GMS stain. GMS is a silver stain, gomorymethanamine silver stain. It will be positive for cyst. And if they ask you drug of choice, treatment के लिए भी prophylaxis के लिए भी same drug is useful, cotrimoxazole. It is a sulfonamide. Some they don't write cotrimoxazole, they write TMP SMX. That is the other name for cotrimoxazole. Trimethoprim sulfamethoxazole combination, that is called as cotrimoxazole. And next thing, last topic. After that, we will take the break. So just stay with me for the next 2 minutes. Okay. Examiner will give you this scenario: old age patient, bedridden patient, post-operative patient, sudden onset dyspnea. Sudden onset dyspnea can occur. See, you need to understand now. I'm summarizing as we are discussing. Sudden onset dyspnea with stony dull note, it will go in favor of rapidly developing pleural effusion. Sudden onset dyspnea in a patient where there is a history of asthma or allergies will indicate an acute exacerbation of asthma. Sudden onset dyspnea in a patient where there is resonant note happening and one side breath sound decreased, that will indicate pneumothorax. And if they say sudden onset dyspnea with tachycardia, pleuritic chest pain, and chest pain is worsening on inspiration, it indicates patient is developing pulmonary embolism or pulmonary thromboembolism. It typically occurs in old age patient, bedridden patient, post-operative patient, particularly total hip replacement patients. Fracture femur patients are more prone to develop this. The likely diagnosis in these patients, I'm putting it above, it is pulmonary thromboembolism. Pulmonary thromboembolism. Sometimes the word thrombo is not included. They use the word pulmonary embolism. They are the same disease. Don't get confused. Embolism, pulmonary thromboembolism, these words are synonymously used by the examiner. This is your old NEET PG MCQ. All of the following are seen in thromboembolism except pulmonary edema is not seen. You may get a simple one-liner. Pulmonary edema is not a feature of thromboembolism. Now, what are the risk factors? Important risk factors. First of all, it occurs in old age. Second, it occurs in prolonged immobilization, if the patient is immobilized for a long time. Third, it occurs in post-operative patients. What are the 2 surgeries in which the risk is more? Post-operative, if there is total hip replacement, the risk is more. You need to give prophylaxis. Second, any patient where invasive management of fracture neck of femur surgery has been done. Fracture neck femur surgery. You have higher chances of developing pulmonary embolism. Fourth, it can occur in nephrotic syndrome. Nephrotic syndrome is a procoagulant prothrombotic state. Fifth, it can occur in factor V Leiden mutation. It's some genetic cause of thromboembolism, can occur in young adults. It can also occur as a part of ABPA syndrome, antiphospholipid antibody syndrome. These are the important risk factors. Actual list, there are almost 15-20 causes. These are the important ones which examiner will be asking. So these patients will have first develop a deep vein thrombus, either in the calf veins or in the femoral vein, that will dislodge and then cause embolism. What is the screening test in these patients? Screening test is one-liner. Screening test in these patients is blood for D dimers. When you check blood for D dimers, these D dimer levels will be increased in the patient. But remember, D dimers can be increased in DIC also. So DIC can also have rising D dimer. So one possibility of D dimers is this patient, that is pulmonary embolism. If you do if you do ECG, what you will find? Most common ECG finding is tachycardia. What kind of tachycardia? Sinus tachycardia. No fibrillation, no flutter, just normal rhythm, but the rate is increased. But if they say characteristic ECG finding, there is a finding known as S1Q3T3 pattern. S1Q3T3 pattern. S1Q3T3 pattern is also known as McGinn-White sign. McGinn-White sign. McGinn-White sign. Good. Many of you have done it well. S1QT3 क्या होता है? There is a abnormal S wave in lead 1. There is abnormal Q wave in 3 and inverted T wave in lead 3. That is called as S1Q3T3 pattern. ये कैसा दिखता है? This is something I will show the photograph tomorrow also. And this is something I have discussed in my detailed videos. They are there on my YouTube channel link I showed. So you can go through it. I think video number 2 or video number 3, I have discussed the pattern. How does it look like? Because it's a rapid revision we are doing, ultra rapid revision. So just remember S1Q3T3 pattern. And examiner will give you other clues also along with the ECG strip if they put up a question. What will you find on chest X-ray in these patients? Now chest X-ray, look at this. 3 chest X-ray findings are important. Look at the first finding. Can you see in this patient, this consolidation has happened. It is a wedge-shaped demarcated area which has formed. This is called as Hampton's hump. Right? So what are the 3 signs? There will be Hampton's hump. This patient is having Hampton's hump. Hampton's hump. There will be a wedge-shaped demarcated consolidation in one of the segments of the lungs. Second will be watermark sign. Watermark sign. What will watermark sign show? Watermark sign indicates in the local area, the blood vessels will be less prominent. It is difficult to identify. You can just remember theoretically focal leukemia. And third will be Palla's sign. Palla's sign. What is Palla's sign? There will be enlarged descending right pulmonary artery. Enlarged descending right pulmonary artery. So in this photograph, this is a very characteristic photo. You can see a hump present. This is Hampton's hump which is present in this patient. Hampton's hump is present in this patient, right? Now, what will echocardiography show? Now, echocardiography shows a sign known as McConnell sign. But many people do not understand what is the meaning of McConnell sign. If the examiner writes in explanation, you will not be able to know that this was McConnell sign which is being taught. So when you do echocardiography, you will find that there is a right ventricular dysfunction. What kind of right ventricular dysfunction? You will find that there will be increased cardiac motion at apex of right ventricle, but decreased or absent motion in mid wall of the right ventricle. This abnormal motion of right ventricle is called as McConnell sign, and this is a feature of pulmonary thromboembolism. But what is the investigation of choice? Investigation of choice in none of these. It is CT, pulmonary angiography. It is also known as CT angiography or CTPA, CT pulmonary angiography. It is a one-liner question already asked in December 21. There was another question in 2023 exam of FMGE. I'm writing it here. Which is the investigation of choice to locate origin of thrombus in embolism? Then they are not asking to find the cause of embolism. They are asking you to find the location. And for that, you need to do ultrasound Doppler study. You need to do ultrasound Doppler study. So ultrasound Doppler will be needed in these patients to locate the origin of thrombus in embolism. You can just write. As you can see, I'm spending more time. The place where I'm spending more time, more chances of, more important, more chances of getting asked. If you just do the one-liners, I would not, be content, because who knows, the things we leave maybe. At least the important things we have to know. And gold standard investigation will be angiography. Gold standard investigation will be angiography. Now, what is the treatment that we do? Treatment is very simple. If examiner says that there is a pulmonary embolism patient where there is a small embolism or submassive embolism and there is normal BP, there is no hypotension, in these patients, you will start the patient on low molecular weight heparins. For example, the drug known as enoxaparin. Subcutaneously, you can start enoxaparin in these patients. But if there is a massive, there are radiological criteria for that and there are angiographic criteria for that. So they will mention it, massive is there. Massive pulmonary embolism or The systolic BP patient is less than 90 millimeters of mercury. Hypotension is happening. In these patients, you have to do thrombolysis. Good. And what agent will be used? Alteplase is the agent you will be using. And after thrombolysis, you will be putting the patient back on low molecular weight heparin. And thrombolysis has to be done within 12 hours of the onset of illness. Within 12 hours of the onset of illness. And finally, how can you do prophylaxis or prevention? Prophylaxis can be done by, in a high-risk patient, risk factors we have done, compression stockings should be used. Along with low-dose conventional heparin can be added in these patients. This is useful for prophylaxis. Let us solve an FMGE MCQ. 60-year-old bedridden patient develops sudden onset breathlessness and acute chest pain. What is the best investigation to make diagnosis? Bedridden patient, old age, sudden onset breathlessness, chest pain. It is not pneumothorax. It is not pleural effusion. It is not asthma exacerbation. What is the likely possibility? Acute pulmonary embolism. What? They are not saying screening investigation. Best to do make the diagnosis. They are saying best to make the diagnosis. CT pulmonary angiography which is used. Warfarin is used in high-risk patients, not in low-risk patients. If there is a previous history of pulmonary embolism, then warfarin can be used. Warfarin has a problem of bleeding. It is a more, kind of unsafe agent when bleeding tendencies are there, particularly in old age. So, see pulmonary angiography. Okay. So, let us start with the next case scenario. The case scenario is very important. And for some unknown reason, this topic has become relevant in all the exams, including the recent exam. There was a question, January 25 this year, there was a question asked on this topic. And similar questions have been asked, similar scenarios have been asked in the NEET PG exam as well. So the case scenario says, now look at the buzzwords, look at the keywords. There is progressive shortness of breath. It is not like sudden onset. It has started, it has a subacute kind of onset, but it is increasing. There is parasternal heave. Now, parasternal heave means there is likely right ventricle involvement that tends to produce a right-sided parasternal heave. It is more prominent on the right side. Loud S2, which is due to pulmonary component, plus minus right-sided S3, S4, plus minus features of congestive cardiac failure like hepatomegaly or raised ABP. What is the likely diagnosis? If the loud second heart sound, parasternal heave, shortness of breath, and right-sided sounds are abnormal, the likely diagnosis in the patient is PAH. What is PAH? Pulmonary arterial hypertension. It is not cor pulmonale, pulmonary arterial hypertension. See, cor pulmonale is a consequence of it. Cor pulmonale, we will be talking about it tomorrow when we discuss cardiology. You need to understand cor pulmonale and PAH are related, but they are not the same. They are related, I repeat, but they are not the same. What is cor pulmonale? We will discuss tomorrow. So, pulmonary arterial hypertension. Now, whenever you have a pulmonary arterial hypertension, we need to do a quick review, short review of this topic because some new drugs are also added in the Harrison 22nd edition. So, what is PAH? First of all, the definition says that we calculate the mean pulmonary artery pressure. Mean pulmonary artery pressure, it is also written as small m. If it is more than 20 millimeters of mercury, that is said to be pulmonary arterial hypertension. Earlier, it used to be more than 25, but now the cutoff used in Harrison, it was changed in the last Harrison itself, it is more than 20. There are, broadly speaking, two types of PAH. You can have pre-capillary causes and you can have post-capillary causes. Pre-capillary causes, the identifying factor of them, examiner will use the word transpulmonary gradient. There is a gradient we calculate on catheterization. The transpulmonary gradient will be more than 12 millimeters of mercury. That is pre-capillary PAH. It is typically seen in patients who are having idiopathic pulmonary hypertension. And most common cause of idiopathic pulmonary hypertension is gene mutation known as BMPR2 gene mutation. This gene mutation has been asked in the INI set exam already. BMPR2 gene mutation. Second is post-capillary PAH, where the transpulmonary gradient is less than 12 millimeters of mercury. And the cause of this will be typically seen in patients with mitral stenosis as well as patients with left ventricle failure. Due to back changes, post-capillary PAH will be produced. These causes, you need to remember, these causes are important and they are asked in the exam. Mitral stenosis is one of the favorite of FMG examiner, and we will be discussing this topic in detail tomorrow. It was asked in the July 25, it was asked in January 25, and it was asked in January 24 as well. So there is a good possibility you may get something on this tomorrow. We will be discussing it in details tomorrow. So remember, mitral stenosis is a common cause of pulmonary arterial hypertension, but it causes back pressure changes and so it causes post-capillary PAH. What happens to DLCO in these patients? DLCO in these patients will be reduced. What is the treatment that we are going to do in pulmonary arterial hypertension? Now, first of all, we have the first line. Wherever you possible, you have to treat the underlying cause. Treat the underlying cause. If there is a treatable cause, you will start with drug therapy. When you start with drug therapy, what are the agents which are approved for use? We have the first line agent. There are two first line agents which are available. First of all, we have the endothelin receptor antagonists. Endothelin receptor antagonists. Two types of drugs are available. We have bosentan, which is a non-selective endothelin receptor antagonist. It blocks both the endothelin receptor A as well as endothelin receptor B. And the second one is ambrisentan. Ambrisentan is a selective ETA blocker. It has less side effects and it is more specific for PAH patients. So two of these drugs are approved for use. Second class of drugs, they are very popular, easily available. You must have heard the name phosphodiesterase 5 inhibitor. Now this is also your pharmacology integration which is happening. So PDE5 inhibitors which are approved for use. One of them is a drug famous for its use in male erectile dysfunction, sildenafil. Another long form of that, which is actually preferred these days, is tadalafil. So sildenafil or tadalafil are the agents. Sorry, tadalafil are the agents which are used in as first line therapy. Can they be combined? They can be combined, but the problem is there is a possibility of fall in BP and there is a possibility of increased flushing happening. But many patients, you can combine them. In fact, some trials have shown that combining them reduces the overall mortality. If the first line agents fail, then you can go for second line agents. And the second line agent is prostanoid agent known as IV agent we use, intravenous form of epoprostenol. Epoprostenol can be used. It is a prostacyclin derivative. It is a pulmonary vasodilator and tends to reduce the pulmonary hypertension in the patient. Then we have the newer class of drugs which are available. What are the new drugs which have been approved for use? There is another big set of list of drugs. In fact, there are total about 12 to 13 drugs which can be used in selected patients, but not all of them are available in our country as well. So there are two new drugs that we need to know. First of all, we have a prostaglandin I2 binder and activator of prostaglandin I2, that is selexipag. This is a new drug. And second is activin signal blocker. Activin signal is involved in producing thickness of the pulmonary vessel. If you can block that signal, the pulmonary pressure tends to. So activin signal blocker, sotatercept can be used in these patients. So what are the 5 agents that you need to remember from exam perspective? Bosentan, ambrisentan, sildenafil or tadalafil, epoprostenol, selexipag and sotatercept. It will be a bit tricky when you read it initially. That is why I said you have to read it multiple times. But if you read it 3-4 times after and you do revision of that, eventually drug will be written there. All you need to do is identify and mark in the exam. So it is not going to be a theory paper, it is going to be a MCQ exam, so you just need to mark. Now have a look at the question and tell me the answer. FMG January 25 question. Female patient presented progressive shortness of breath, raised JVP, palpable liver, there is a systolic murmur and loud P2. So progressive shortness of breath, loud P2 and raised JVP, palpable liver, everything is fitting into which diagnosis? The patient is having a diagnosis of pulmonary arterial hypertension. Moving further, we have some scenarios from the recent exam. Look at the word. Examiner will say Homan sign, ECG changes, sudden onset of shortness of breath. What is the diagnosis? Deliberately, I have not put this scenario in the topic. Homan sign. What is Homan sign? When you press the calf muscle and you try to push the dorsally, when you press the calf muscle, push the foot of the patient dorsally, there is pain. That is called as Homan sign. Homan sign indicates deep vein thrombus. So Homan sign is an indicator of DVT. Plus ECG changes are there and sudden onset shortness of breath. What is the likely diagnosis? You know the answer. It is not a shortness of breath will not occur in DVT. The likely diagnosis is pulmonary embolism. And that is the answer. Homan sign indicates DVT is there, and now DVT is causing shortness of breath. That is pulmonary embolism. DVT itself will never cause shortness of breath, right? So pulmonary embolism is your answer. Good. Many of you answering it correctly. Then if the examiner says this was the question asked this year, July 25, petechiae sudden onset shortness of breath after fracture shaft of or road traffic accident. It is an orthopedic problem, what you call as fat embolism. Fat embolism. So don't confuse fat embolism with pulmonary embolism. Both of them are scenarios and both of them are frequently asked in the exam. Now, few words about primary ciliary dyskinesia. Primary ciliary dyskinesia is also known as Carter-Jenner syndrome. There is a triad of Carter-Jenner syndrome. What are the three things? Number one, these patients have situs inversus. Complete ulta ho jata hai. Normally, liver is on the right side, spleen is on the left side. This reverses, that is situs inversus. Plus, these patients have sinusitis. It is not one attack, it is recurrent attacks or chronic sinusitis. And thirdly, patient will have bronchiectasis. So three things occurring together: situs inversus, chronic sinusitis, bronchiectasis. That is the triad of primary ciliary dyskinesia, also called as Carter-Jenner syndrome. And what is the defect? The defect is, I'm putting an MCQ point, dynein arms. There is a dynein protein which is present in the arm of cilia. That is where the defect is. So dynein arm of cilia is the site of defect. And because cilia are defective, they cannot move properly. This condition is also known as immotile cilia syndrome. It is also known as immotile cilia syndrome. Immotile cilia syndrome. And also remember that Carter-Jenner syndrome is more severe in males. More severity is seen in males. And because cilia is absent, these patients will have infertility as well. Infertility tends to occur in the males. Immotile cilia, reduced motility of the sperms in these patients, right? So this is few words regarding the topic of Carter-Jenner syndrome. Then what are the three common types of ILD? Actually, ILD has it's a multiverse of its own. It has multiple types of diseases. We will not go into the details. Silicosis, asbestosis, then the rare other forms. They are all types of ILDs only. But here we are talking about three ILDs on which one-liner questions are asked in the exam. So three common types of ILD you should distinguish. One is idiopathic pulmonary fibrosis. Second is ILD seen in Sjogren syndrome or scleroderma. It is seen not only with Sjogren syndrome, you would write and scleroderma. Sjogren syndrome and scleroderma. And third will be ILD, which is also called as Hammond-Rich syndrome. So idiopathic pulmonary fibrosis, when you do biopsy of the lungs, you find a pattern known as UIP. What is the full form of UIP? UIP stands for usual interstitial pneumonitis. The treatment response in these patients is variable. They may improve with steroid, they may not improve with steroids. Second is ILD associated with Sjogren syndrome and scleroderma, that is ILD which is associated with connective tissue disorder. That when you do biopsy in these patients, it shows NSIP. What NSIP? The full form of NSIP is non-specific interstitial pneumonia, also called as non-specific interstitial pneumonitis. Non-specific interstitial pneumonitis. And these patients, the drug of choice is steroids. Plus, there is a new anti-fibrotic agent. It is commercially useful. And one of my relatives, there is a relative of mine, she got COVID and then post-COVID she got fibrosis. And we started a drug in that lady, that relative of mine, and she actually improved after 6 months. And it is a anti-fibrotic agent, slightly costly, but oral form it is available. It is nintedanib. Nintedanib is useful in patients. It's an anti-fibrotic agent useful in post-infection or post-tissue disorder, ILD, particularly if it is showing NSIP. So nintedanib is a pharmacology integration with medicine. And third is your Hamann-Rich syndrome. LIP can also occur. See, LIP can occur in Sjogren syndrome, but the more common ILD in connective tissue disorder is NSIP. More on this we will talk when we talk about connective tissue disorder. Now, biopsy shows Hamann-Rich syndrome shows acute interstitial pneumonitis. Acute interstitial pneumonitis. And acute interstitial pneumonitis is one condition which has a rapid acute fulminant course, and this is the variety which has a high mortality. So highest mortality in acute presentation in AIP patients. So these are the three types of ILDs on which MCQs are asked, so we are discussing them here. Let us move further and move into a topic which is one of the favorites again for FMG examiners. Examiner will make a case scenario. They will say either a smoker or a non-smoker. So smoking history is plus, but it is not minimum. So fever and hemopsis. Hemopsis means there is blood in the sputum. Weight loss is there, loss of appetite. Whenever weight loss and appetite loss happens, you should do something chronic, and malignancy should be a DD. Chest X-ray shows either mediastinal widening or collapse of the lungs. Collapse of the lungs. What is the likely diagnosis? We are suffering from carcinoma of the lung. Carcinoma of the lung is also known as bronchogenic carcinoma. It is also known as bronchogenic carcinoma. Now, it's an important topic. So, just like we spent some time talking about pulmonary hypertension, similarly, we will be spending some time talking about this disease. And we will do it in a high-yielding manner, so you can revise it also. So, if you have done, I'm changing it. What are the types of lung cancers? Now, broadly speaking, there are 4 varieties, but there is a classification of that as well. First variety is small cell cancer of the lung, SCLC. Small cell cancer of the lung is also known as oat cell carcinoma. So when they say oat cell carcinoma, some people are still fond of using the word oat cell, but the new nomenclature says the term oat cell should not be used. It is just a variant of small cell cancer only. So they are identical. So small cell cancer, also called as oat cell cancer of the lung. This is not very common. This comprises just about 15 to 25% of all lung cancers, but it is an aggressive tumor. And these patients have early brain metastasis. See, most of the lung cancers will metastasize to liver. Which is the variety which metastasizes to brain commonly? It is a Robbins related MCQ point, and it's a pathology MCQ, small cell cancer of the lung. Second category are the non-small cell cancer of the lungs. It includes 3 varieties. You have squamous cell carcinoma, you have adenocarcinoma, and you have large cell carcinoma. Large cell carcinoma. Squamous cell carcinoma as well as small cell carcinoma both tend to occur in smokers. Whereas adenocarcinoma is the one which is associated with a non-smoker. So if they say what is the most common tumor or brain or most common lung tumor, lung cancer in non-smokers, it is adenocarcinoma. This is the variety which is associated with asbestosis as well. Asbestosis is associated with increased risk of developing adenocarcinoma. It does not occur in the hilum, it tends to occur more in the peripheral region. Now, let us discuss the three common varieties. Large cell carcinoma will never be asked. It is more of a diagnosis of exclusion. So they will be asking you to distinguish between these three. They will be making a case scenario out of it and asking you what is the likely diagnosis. So let us go one by one. Small cancer of the lung. This is central in origin, central in location. Central means it occurs in hilum. Squamous cell carcinoma is also central, tends to occur in hilum. Whereas adenocarcinoma tends to occur in the peripheries. What is the frequency? As I said, it's seen in about 15 to 20% of the patients. Squamous cell carcinoma is second most common worldwide. This is the most common type in India, unfortunately. Adenocarcinoma is the most common worldwide. Common type worldwide as well as overall, if they mention and the word India is not there, the answer will be adenocarcinoma. Okay. Then what is the gender predilection? Small cell carcinoma, males are more commonly affected than female. Squamous cell carcinoma, males more commonly affected than female. Adenocarcinoma, females more commonly affected than males. Okay. So it's a stupid way to remember, but remember that both the cancers which are strongly associated with smoking are more common in male. You can remember like this, males smoke more. So males have small cell carcinoma more, squamous cell carcinoma more. Females, they smoke less, and females are, they are found on the periphery of the patriarchal society. So females are more commonly affected than males in adenocarcinoma. It's a stupid way, but at the end of the day, you need these generalizations to make you remember in the exam. Now, smoking association, strong association here, but it is absent in case of adenocarcinoma. What about the markers? When you do histological staining, small cell cancer of lung will have markers like chromogranin, which is positive, synaptophysin, which is positive, and plus minus NSE may be there. NSE is plus minus. What is NSE? Non-specific enolase. These are, now this is pathology integration, very, very important. Pathology integration happening. Squamous cell carcinoma will be having cytokeratin. Keratin is always present in the squamous cells, right? So chromogranin is also known as chromogranin A. Chromogranin has multiple subtypes. A and B are the two common subtypes. So chromogranin A positivity is small cell cancer. You can write chromogranin. Cytokeratin will be positive here. These patients will be having positivity for P40, P63 as well as P65 positivity. These are the tumor markers of squamous cell carcinoma of the lung. Adenocarcinoma unfortunately does not have many tumor markers, so most of them are having TTF1 positivity. TTF1 positivity. TTF1 stands for thyroid transcription factor number 1. Details I will not know. Now moving over, what will you find on microscopy? Small cell carcinoma, you will find small malignant cells. First of all, the size of the cells will be small. They will have increased basophilic staining. Especially in the endothelium of the vessels, in endothelial region. And this effect is called as Azzopardi effect. Squamous cell cancers will be having keratin pearl formation. So keratin pearl formation, and they will have whorl formation. Whorl means ऐसा वो बन जाता है fibrosis or keratin material का ऐसा whorl बन जाता है. Whorl is something like this. This is called as a whorl. So whorl formation will be common in squamous cell cancers. Whereas in adenocarcinoma, there will be butterfly pattern. So सबसे beautiful looking, not for the patient, but for the pathology is adenocarcinoma, butterfly pattern. It is also known as lepidic pattern. Butterflies जो होती हैं उनकी फैमिली का नाम ही लेपिडोप्टेरा है. Patera is not the right way to pronounce it, but I'm writing like this, saying like this so that you can remember it better. It is actually called as Lepidoptera. But P word silent होता है, तो हम लोग pronunciation में Lepidoptera कहते हैं उसको. So Lepidoptera is the technically speaking Lepidoptera is the genus of butterfly. So this is also called as lepidic pattern, beautiful butterfly pattern, right? Then which is the variety which is strongly associated with Horner syndrome? It is minus, it is minus, it is strongly present. Horner syndrome patient will have all the features like ptosis, meiosis, anhydrosis, etc. with loss of ciliospinal reflex. This is something you have read in anatomy and surgery also. Which is the variety which is associated with squamous cell carcinoma? It is adenocarcinoma which is associated. Now, paraneoplastic syndromes, you need to remember, they are rare in adenocarcinoma. They are common in squamous cell carcinoma. They are common in squamous cell carcinoma. They are rare in adenocarcinoma. In small cell cancer, the most common paraneoplastic syndrome is SIADH. SIADH. What is SIADH? Syndrome of inappropriate antidiuretic hormone synthesis. Second most common, they can also have Cushing syndrome. In case of squamous cell carcinoma, the most common paraneoplastic syndrome is hypercalcemia. Why hypercalcemia? Because these patients have increased PTHRP peptide formation. Parathyroid hormone related peptide. It works like parathyroid hormone, it is not the same. So it causes hypercalcemia. And adenocarcinoma generally does not have paraneoplastic syndrome. About 10 to 20% patients, however, 10 to 20% patients may have migratory thrombophlebitis. They may have migratory thrombophlebitis. Migratory thrombophlebitis is also known as Trousseau phenomena or Trousseau's disease. So migratory thrombophlebitis, it is not considered to be a true paraneoplastic syndrome, but it can occur in patients with adenocarcinoma. So these are the important summary, and this summary covers, let me tell you, this summary which I have just written, it covers every single MCQ asked on these distinguishing tumors in all the exams of FMG and NEET-PG. And most of the recent INSF also. It's a very important table. Mark it. You are supposed to go through it in the last week when you are doing revision, right? Go through it. It's a very important table. So I have written slowly while explaining. Now have a look at the FMG July 25 question and tell me the answer. A patient presented with cough and progressive weight loss since past 3 months. Biopsy of lung mass revealed chromogranin and synaptocin positivity. What is the likely paraneoplastic syndrome? First, you need to make the diagnosis. Cough, progressive weight loss, and lung mass. So it is likely cancer. Which cancer? Small cell cancer. And small cell, what is the most common paraneoplastic syndrome? SIADH is your likely answer. So SIADH is the possibility. Okay. Look at the next question. FMG January 25. Chronic smoker presented progressive shortness of breath. Spirometry revealed FeV1 of 60% and FeV1 by FVC of 0.6. It is less than normal. So what is the possibility that we are thinking of? ILD, silicosis and DIP, they all belong to the same degree. They are all restrictive lung diseases. This is a patient with low FeV1 by FVC. So likely answer in the question is C, that is COPD. Looks easy if you have done the topic. If you have done it superficially or don't have the precision, the same topic becomes tough. Although the topic, the disease is done, but there are a few points. Let us write a few points because it is a topic which is pediatric but also asked in medicine occasionally. Let us write down a few points related to cystic fibrosis. Cystic fibrosis. What is the dyad of cystic fibrosis? Dyad means two things which occur together. दो चीजें जो एक साथ होती. First of all, these patients have recurrent pneumonia. And second, these patients have malabsorption. Particularly malabsorption is seen. What is the gene of cystic fibrosis? CFTR gene. which is present on long arm of chromosome 7. So it is present on chromosome 7q. CFTR gene codes for a epithelial chloride channel. Chloride. What is the most common mutation which is seen in cystic fibrosis? It is delta F508 mutation. It is also written as phenylalanine 508 deletion, means there is deletion of phenylalanine residue on the 508 position. There is another name of this. This is called as class 2 mutation. So for future exam, you can remember the alternative names. If they ask second most common mutation, the answer is G551D. What is the screening test of choice? Screening test of choice. The screening test in these patients. Sweat chloride test. Yes, absolutely right. I can make out that most of you have done this topic well. If chloride level is equal to or more than 60 milliequivalent per liter, that is considered to be a positive test. But if they say screening test in neonate, you cannot do sweat chloride test in a newborn. You will do a blood test for IRT, which will be elevated. IRT is a abnormal form of trypsinogen which circulates in the blood of these patients. So immunoreactive trypsinogen will be your answer. In patients of cystic fibrosis, what is the cause of infertility? Infertility is more common in males compared to females. It is CAVD. CAVD stands for congenital absence of vas deferens. Congenital absence of vas deferens. It is just summary we are doing. I am quite sure you have read about it in pediatrics already. If not, you are supposed to read. So congenital absence of vas deferens. Then in these patients, what happens to chloride secretion? Remember, it's a ionized set MCQ. In respiratory tract, GIT and pancreas, the chloride secretion is decreased, whereas in sweat gland, the chloride secretion is increased. This is the MCQ recently asked in one of the ionized set exam. And what is the new class of agents which are available? The new agents which are available are CFTR modulators. CFTR modulators are the new class of agents which are approved for use in these patients. You have CFTR potentiators. The typical example is ivacaftor. And we have CFTR correctors. The example for this is lumacaftor, tezacaftor, lexacaftor. This may seem like this is important from MCQ point of view. It's the integration between pediatrics, medicine, and pharmacology. So if I zoom out, it's just a few points of cystic fibrosis, but it is important that you revise these points. Almost 70% of the points I have wrote are NEET PG or ionized set or FMGE actual previous year questions. I've just put them up in the form of a condition. See, pancreatitis is not common. It is more like a subacute or low-grade pancreatitis which occurs in these patients. This is the one which is responsible for eventually malabsorption, and in long-standing cases, diabetes can also occur in the patient. But predominantly, the cause of death is always pneumonia in cystic fibrosis. Right? So, dear friends, we are done with the respiratory system. Now, the GIT and hepatology part is relatively easy. It will be more scenario-based approach we will be taking, and there will be a lot of integration happening with the surgery part. So, I will not talk about the surgical details, but I will try to talk what bare minimum I feel you should know about the topic. Let us start with GIT. We'll be starting with esophagus first of all. So, esophageal disorders. What is dysphagia? First thing, approach to dysphagia. There is a flow chart we have to make, and this flow chart is very, very important. A lot of questions are asked from this flow chart. Dysphagia, one liner, it is considered the hallmark of esophageal disorders. So if somebody says, what is the hallmark of esophageal disease? It is dysphagia. What is dysphagia? Difficulty in swallowing is called as dysphagia. Suppose you are sitting in a OPD Patient comes to you and he says, I am having difficulty in swallowing. You ask him, is it difficulty in swallowing or is it pain in swallowing? Patient says, no pain, only difficulty in swallowing. So he has dysphagia. If pain is there, that is called as odynophagia. So dysphagia, if it is there, you will ask the patient again, is it to solids or is it to both solid and liquid? Patient says only to solid. So if there is dysphagia only to solids, the patient is having a structural cause of dysphagia. The patient is having a structural cause. A structure is there which is obstructing and causing dysphagia. If the patient says both solids and liquids I am having dysphagia, that will be motility cause of dysphagia. Motility cause of dysphagia. How structural cause causes dysphagia, motility cause causes dysphagia. This is something we have discussed in our face-to-face classes. In many of the ARISE centers, I have discussed that. But unfortunately, neither do we have the time, luxury of discussing the details. So simply remember dysphagia to solids alone, structural cause. Dysphagia to solids as well as liquids, motility cause. Then if it is structural cause, you ask the patient, when does it happen? Patient says occasionally, kabhi hota hai. उतना ही है कई सालों से. It is not increasing. So then you are dealing with benign disorders, structural disorders. Two possibility. First possibility, patient is having Zenker diverticulum. And second possibility, patient is having a ring known as Schatzki's ring. Schatzki's ring. If the patient says बढ़ता जा रहा है, patient is more than 60 years and there is significant weight loss present, the patient is likely to have carcinoma malignancy, carcinoma of esophagus, also called as esophageal cancer. If there is dysphagia to solid and liquid, regurgitation, GERD is present prominently all the time. Patient कहता है हर वक्त मुझे खाना ऊपर की तरफ आता फील होता है. Retrosternal chest pain is there mimicking angina. Patient has achalasia cardia. The likely diagnosis is achalasia cardia. And if the patient says regurgitation plus minus, इतना खट्टा डकार आता है, नहीं आता, कम आता है. But जब मैं तेजी से खाना खाता हूं तो बहुत छाती में दर्द होता है. When I try to eat fast, I have pain in my chest. The likely possibility is DES. What is DES? DES was previously called as diffuse esophageal spasm. Now it is called as distal esophageal spasm because it is the distal esophagus which is more affected, according to Harrison. पहले इसका नाम था diffuse esophageal spasm. Now it is distal esophageal spasm. Harrison 22nd में this is the change. So by looking at the buzzwords, keywords and the clinical finding, you can easily reach the correct answer. But we need to know the fine details. Some MCQ practice also we have to do. Let us move towards scenarios for diagnosis. So first possibility, examiner will say intermittent dysphagia to solid, halitosis. What is halitosis? Bad breath. Bad breath. A clue for all of you. Whenever you have to take a history of bad breath, never ask the patient himself. क्योंकि देखो अगर मुझे हेलिटोसिस है तो मुझे नहीं पता चलेगा. यू अंडरस्टैंड? जिसको बैड ब्रेथ होती है उसको नहीं पता होता है, दूसरे को पता होता है. तो ऑलवेज आस्क द स्पाउस और ऑलवेज आस्क द पार्टनर ऑफ द पर्सन हु इज अकम्पनिंग, क्या इनको बैड ब्रेथ है? वो बोलेंगे हाँ बहुत. द पेशेंट विल से नहीं 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 है. Who will you trust? The other person, because our nasal receptors, they tend to get accustomed to it. All those close-up and Colgate ads where they do like this, that is nonsense. You cannot come to know halitosis unless your mouth is stinking. Your mouth is really stinking, then to obviously you also will come to know. But generally, low-grade halitosis, it is the patient's attendant who will be telling you. So halitosis. Second thing, globus pharyngeus. It is also known as globus hystericus. There is a sensation of foreign body. Actually, yeah, like a sensation of foreign body sticking in the throat. That is called as globus pharyngeus. So intermittent dysphagia to solid, bad breath, sensation of things sticking in the throat. Likely diagnosis in the patient. Yes, many of you are answering it correctly. It is Zenker's diverticulum. The likely possibility is Zenker's diverticulum, also written as ZD. Now, let us do a quick rapid fire review. Zenker's diverticulum is a type of pulsion diverticulum. It's a type of pulsion diverticulum. Pulsion means something which forms due to pressure. Increased pressure inside the esophagus pushes a part of it through a weak area of the muscle that is called as pulsion diverticulum. It is also known as pseudo-diverticulum. Pseudo-diverticulum means there is no true muscle, only mucosa and submucosa are present. Only mucosa and submucosa. Remember, pseudo-diverticulum is Zenker's diverticulum. But Michel's diverticulum is true diverticulum because it has mucosa, submucosa, muscularis layer, they all are present. Okay. Now, what is the most common site? Zenker's diverticulum occurs through a triangle known as Killian's triangle. Killian's triangle is a triangular area present posteriorly in the inferior constrictor muscle. Inferior constrictor muscle. There are two types of muscles which are there. You have, if this is the neck, if you are seeing posteriorly, you will find that there are oblique fibers, and then you have the horizontal fibers. These fibers are cricopharyngeus fibers, these are the thyropharyngeus fibers, and this triangular space is present between them. This is called as the Killian's triangle. This is called as the Killian's triangle. And both thyropharyngeus and cricopharyngeus are the two parts of inferior constrictor muscle. This is also an MCQ. Okay, so it occurs most commonly through the Killian's triangle. What is the investigation of choice? You will do barium swallow. And when you do barium swallow, what you will find? You will find outpouching. This is also a spotter image. Can you see posteriorly there is a outpouching pouch formation where barium is going and it is getting located there. This is the typical photograph of Zenker's diverticulum. Remember this. Treatment of choice. There is no medical therapy, surgery. What is the best surgery that we do? According to Harrison, the best surgery is diverticulectomy. You cut the diverticulum and reinforce the cricopharyngeus muscle so that the gap becomes closed. We call it as cricopharyngeal myotomy. Alternative to this, we go through the oral route and pull out the not outside the body but pull out inside the throat only the diverticulum. So we call it as transoral endoscopic marsupialization. These are the two types of surgeries which can be done in the patient. Yes, various named surgeries have been given to them. Dolman's procedure, cricopharyngeal myotomy, and so on. So these are the two basic procedures that are mentioned in Harrison from medicine point of view. Surgical details you can always do from surgery. So when you are reading these topics in surgery, revise the medicine part. When you are revising medicine, revise the surgery part. It will make sure that the topic gets covered because you don't know from where the question is going to be framed. Next question, examiner will say intermittent dysphagia to solid. Barium swallow shows a circular ring or constriction in the distal esophagus at the squamo-columnar junction. Look at this photograph. There is a constriction like this. This also is an MCQ. If you have a presentation of this in the lower esophagus, there is a circular narrowing at squamo-columnar junction. The patient is having the diagnosis of Schatzki's ring. Schatzki's ring. देखो marsupialization का मतलब क्या होता है? You take out a hollow viscous and just evade it and make a knot upon itself. उसको कहते हैं marsupialization. How do I show? Like suppose there is a hollow thing, I take it out, I pull it out, then I evert it. Right? I evert it and then occlude the lumen using the structure itself. उसको कहते हैं marsupialization. What is Schatzki's ring? Intermittent dysphagia to solid, and there is a barium swallow showing a in the lower part. Schatzki's ring is also known as steakhouse syndrome. Steaks are a type of non-vegetarian food. India is a kebab country. Kebabs are more commonly taken, but steaks are more commonly preferred outside the India. So Schatzki's ring is not very common in India. It is more common in the Western world. And Schatzki's ring is more common in males compared to females, particularly in the age of 50 to 70 years. So it is more commonly in the older population. What is the treatment of Schatzki's ring? Treatment is very simple. Again, no role of medical therapy. You will do endoscopic dilatation. And if it fails, you will go in for surgery. The only good thing about this condition is it is not very common in India. So all examiner will ask you is diagnosis. Will you find? Photograph, age, what first line therapy? If it fails, what is to be done? Surgery is to be done. Only 4-5 points you need. Next page. We have a problematic topic. Carcinoma esophagus. How would the patient present? Old age, progressive dysphagia to solid, significant weight loss by the time patient presents. So patient is having carcinoma esophagus. When you do barium swallow, what will you find? Barium swallow shows, the word is important, irregular wing defect, producing a shouldering sign. Remember this word. People run after rat tail and bird beak. They forget the word irregular. Remember that in esophagus, when you do contrast study, regular defect is benign. Irregular defect is malignant. So if they say irregular defect, irregular bird beak, irregular rat tail, what should be your diagnosis? Carcinoma esophagus. If they say regular filling defect, if they say regular bird beak, the answer will be benign condition like achalasia cardia. So this word is important and we tend to ignore it, right? Irregular filling defect. Now, what are the signs which are described? Two types of signs are described. The first sign, if carcinoma esophagus occurs in the middle part of esophagus, it produces an appearance known as apple core appearance, as you can see in this photograph. This is the apple core appearance. Apple core appearance can be seen in carcinoma colorectal also, but in middle esophagus also it can be seen because there will be dilatation above, dilatation below, contrast material and irregularity in between. It is as if somebody has eaten apple only from the circumferential central part. That is apple core appearance. It will be seen in middle 1/3 of the esophagus. And the second variety, distal esophageal cancer, you will have dilatation and then irregular tail-like wing. This is called as the rat tail appearance. Rat tail appearance. Rat tail appearance tends to occur in the lower 1/3 of the esophagus. So, bird's beak is the word which was originally described for achalasia. But if they use the word irregular bird beak-like appearance, it can be indicative of carcinoma. We often keep running after bird beak rat tail. Let me put it very clear. Listen to me very carefully. If they say bird beak alone, achalasia. Rat tail alone, cancer. But if they use the word regular with any of them, the answer is achalasia. If they use the irregular with any of them, the answer will be cancer. If you just remember this funda, your answers will not go wrong. Unnecessary controversy gets created because we read a lot of random information. This is reliable information given in standard books. Just stick to it, right? So I repeat, if they simply write bird beak, achalasia. Simply write rat tail, cancer esophagus. Irregular word, cancer. Regular word, benign, like achalasia, right? There should be no controversy after this. Let's move further. So, what are the types of esophageal cancers? Upper 2/3 of esophagus, you have the squamous cell carcinoma. Squamous cell carcinoma. Whereas lower 1/3 you have adenocarcinoma. What are the risk factors for squamous cell carcinoma? The risk factors include smoking. Another risk factor is alcohol. Another risk factor is betel nut, also known as areca nut, also known as supari chewing, zuba kesari, pan parag, all these things, raj tree. If a person eats more, what cancer do they end up with? Squamous cell carcinoma. And excess ingestion of hot liquids. A person says to the vendor, squamous cell carcinoma, because Indians are more prone to have betel nut chewing and excess ingestion of hot liquid. This is the most common type in India. So in India, it is more commonly squamous cell carcinoma. And what are the other risk factors? It can occur in patients with Plummer-Vinson syndrome. You must have read about Plummer-Vinson. You will be reading in ENT also. These patients will have glossitis, esophageal web, anemia, etc. And lastly, it can be associated with chronic achalasia. Chronic achalasia cardia. These are the important risk factors. There are other also, but these are the important ones. Lower 1/3 you will have adenocarcinoma, which will be. Now this, what are the risk factors for adenocarcinoma of esophagus? It will be associated with obesity, high fat diet. It will be associated with processed food, all this ultra processed food that we eat, and it will be associated with GERD, so gastroesophageal reflux disease, which causes Barrett's esophagus. Which cancer will occur? Adenocarcinoma will occur in the patient. And because obesity, high fat, processed food is more common in the Western world, so United States, UK, what is the most common cancer of esophagus? It's adenocarcinoma. So answer will depend upon what options have been given to you, how the question has been framed for you. And if they ask in general, what is the most common site of cancer? Overall most common site in the Western world, it is lower esophagus. In India, it is middle 1/3 of the esophagus. So these are all the points which are overlapping, confusing. We are discussing at one single place. Right, let's move further. See, these are all kind of bland topics, but topics have to be done. The more topics we are covering, the more your revision is happening and more you are moving closer and closer to your goal. Now, moving to screening investigation. What is the screening investigation in carcinoma esophagus? It is always barium swallow. But if they ask investigation of choice, it will be endoscopy and biopsy. And if they ask you what is the staging investigation, the answer will be EUS. What is EUS? Endoscopic ultrasound. In fact, these are not separate. We put an ultrasound, we put an endoscope, and through that we take biopsy also, and we do ultrasonographic invasion, depth of invasion testing. So it helps in staging of the patient. What is the most common site of distant metastasis? Wrongly given in many of the older editions. It is not lung, it is liver, which is the most common site of distant metastasis. Liver, liver, liver. I repeat, liver. कहाँ भी लंग लिखा है उसको चेंज कर दो, लिवर है, right? If you read your notes and you find it is written lung, you are supposed to change it. अगला चीज ट्रीटमेंट. फिर मुझे पूछोगे सर उन्होंने ये बताया, मुझे पता है किसने क्या पढ़ाया, तब भी मैं कह रहा हूँ लिवर, तो मतलब राइट, आई टेक फुल रिस्पॉन्सिबिलिटी फॉर लिवर. It is the current, because some older books and older videos, there is lung also mentioned at a few places. So liver, there is no doubt about it. Coming to treatment part. Now, if the patient presents early, if there is early presentation, which is relatively rare, you will have to do surgery. What surgery you will do? You will do esophagectomy. And whenever you do esophagectomy, surgery integration, you will keep a cancer-free margin. You will free a cancer-free margin of equal to or more than 10 centimeter. Remember that when you are doing surgeries of cancer in gut or cancers in the colorectal region, or you do in the stomach, you keep a cancer-free margin of about 5 centimeter there. But in esophagus, you always keep a cancer-free margin of 10 centimeter. It is a NEET PG one-liner question. And if the patient presents late, you need to create a new esophagus afterwards. Late patient, you will have to use chemotherapy along with radiotherapy. The radiotherapy is called as EBRT. What is EBRT? External beam radiotherapy. You will be using external beam radiotherapy. External beam radiotherapy. There is a good regime for chemotherapy which is used. What is the currently followed best regime for these patients? Now we are integrating with surgery and pharmacology. Regime. What is flawed regime? चार चीजें हैं. F से हुआ 5 फ्लोरोयूरेसिल, साथ में हुआ L से हुआ ल्यूकोवोरिन, इट इज अ टाइप ऑफ फोलिक एसिड डेरिवेटिव. साथ में हुआ O से oxaliplatin, it is a platinum compound. Earlier we used to use cisplatin, but now Harrison's 22nd edition says oxaliplatin is more efficacious. It is a part of flawed regime. Plus taxanes. Taxane is a class of drugs. Example of that is docetaxel. Paclitaxel and docetaxel, two drugs are there. So this is the flawed regime. This is the best regime in these patients. So what is the new monoclonal antibody in carcinoma esophagus? It's a Harrison 22nd edition update. Harrison 22nd edition update. So new monoclonal antibody, there is a monoclonal antibody known as nivolumab. Nivolumab. Nivolumab is a PD-1 analog. PD-1 stands for a programmed death analog. What it does is, it activates apoptosis in many, it activates apoptosis in many cancer cells, in PD1 positive cancer cells. तो हम क्या करते हैं? See, in carcinoma esophagus, we first try to see what are the tumors, what are the patients who are PD1 tumor marker positive. If they're positive and money is available, it's a costly drug, we start nivolumab. It selectively kills only those cells which are cancer containing because they express PD1 on there. But not every cancer will improve, but those cancers where PD1 is positive on the cancer cell, it is a very useful monoclonal antibody. You can get a question on this. And lastly, what is the most important prognostic factor in carcinoma esophagus? It is depth of invasion. More is the depth of invasion, more worse is the prognosis in carcinoma esophagus. There are other risks like lymph node involvement, distant metastasis, etc. But it is the depth of invasion which is the most important prognostic factor. Next scenario, dysphagia to both solids and liquids. Very, very important. Liquids more than solids in long-standing cases. Regurgitation and heartburn are present. External chest pain mimicking angina is present. What is the likely diagnosis? What is the likely diagnosis? Patient is having achalasia cardia. Achalasia. देखो हम ना मोटिवेशन और भी कर सकते हैं, बातें और भी कर सकते हैं. So dysphagia to solid and liquid, liquid more than solid, and regurgitation, heartburn, chest pain present, achalasia cardia. Now, what is the mechanism of achalasia cardia? It is always an acquired disease. The mechanism is herpes simplex virus 1 infection triggers autoimmune reaction. This autoimmune reaction destroys ganglion cells in esophagus. उससे क्या होता है? When the peristaltic wave comes, the lower esophageal sphincter does not open. I'm putting like this: lower esophageal sphincter fails to relax. Weak waves, weak peristaltic waves, and that is achalasia cardia. Normally क्या होता है? Normally when you eat something, the ganglion cells, Ayurvedic plexus, mental plexus, they trigger peristalsis, and in response to that peristalsis, the lower esophageal sphincter relaxes. But in these patients, the ganglion cells are destroyed, so the waves which are produced, they are not sufficient to cause a relaxation of LES, and so there is a constricted LES that causes dysphagia, and the proximal esophagus becomes low, it becomes enlarged, it becomes dilated. That is achalasia cardia. When you do barium swallow, you will find a smooth filling defect. You will find smooth filling defect. Smooth filling defect. What about etoposide in esophageal cancer? So, barium swallow will produce a smooth filling defect. It is a benign condition. I told you benign conditions will have smooth filling defect, giving rise to bird's beak appearance. Beak's appearance or bird's beak sign in the distal esophagus. What is the investigation of choice or sensitive? See, the barium swallow is only for screening purpose. Investigation of choice will be high resolution manometry. It is high resolution manometry. What is the treatment of achalasia cardia? Treatment has three parts. First of all, you will be using drugs in the patient. Three class of drugs. Any one of the following can be used. Either you can use calcium channel blockers, for example, nifedipine, or you can use phosphodiesterase 5 inhibitors. I'm writing like this: PDE5 Is, that is PDE5 inhibitor, for example, sildenafil. Or you can use nitrates, glyceryl trinitrate, isosorbide mononitrate. But drugs का problem क्या है? They have to be taken 1 hour before each meal. Now try to think. Before every meal, you are taking a sildenafil, you are taking nifedipine. They have their own side effects also. They cause fallen BP, flushing, hypotension. And try to think like this. That, see, so difficult, no? It occurs in females, but can occur in males also. Male having sildenafil with every food. It's not logical. Male having, or male or female, both of them having nitrates with every meal. BP will fall suddenly. So these drugs are useful, but limited role in real world management. So more importantly, these days we go for local therapy. And what is local therapy? We give injection of botulinum toxin. Botulinum toxin, that is Botox injection. So injection of Botox. लेकिन Botox का इफेक्ट कितने टाइम तक रहता है? 6 month तक. Money cannot buy happiness, but money can buy Botox injection. Botox is not only useful for removing wrinkles, it is also useful for therapy of achalasia cardia, right? And if all else fails, we go for surgery. The best surgery in these patients is Heller's myotomy. It is also known as LES, lower esophageal sphincter myotomy. And there is a new surgery being done these days. Alternative to this is a surgery known as POEM procedure. POEM procedure. What is POEM procedure? Per oral endoscopic myotomy. They reduce the thickness of the lower esophageal sphincter, so the food which is coming by mechanical effect, they can still pass even if it does not relax totally, right? So this is the treatment. Treatment is important. I have not discussed details of treatment things, but here the treatment is important. FMG previous year question: which infection produces achalasia-like illness by causing destruction of the ganglion cells of the myenteric plexus? There is a disease known as Chagas disease, not Chagas, Chagas disease. It is caused by Trypanosoma cruzi. So infection which produces achalasia-like illness, Chagas disease. Let's move further. Easy things are coming your way now. Dysphagia to both solid and liquid. Retrosternal chest pain on eating quickly. Yeah. Have you ever been in that pani puri eating competition? Those stupidities have you done in your life? If you have not, you will still end up doing that. Don't think that that phase is over. So people go into golgappa eating competition. 4-5-6 खा लेते हैं, यहाँ पर फंस जाता है गले में. तो ऐसे पेन होता है फिर suddenly ऐसा लगता है मरने लगा हूँ. That is a variant of that. Pathological version of that is DES. What is DES? Distal esophageal spasm. It was previously known as diffuse esophageal spasm. So distal esophageal spasm, you will do these stupid activities. Just that right now is not the time. So don't do that. What you will end up with? You will end up with barium swallow showing corkscrew esophagus, also called as rosary bead esophagus. This particular photograph is a very, very important point, and it's a spotter image also which has been asked in the exam. Distal esophageal spasm, also called as diffuse esophageal spasm. So barium shows what? Corkscrew esophagus or rosary bead esophagus. क्या होता है इन patients के अंदर? Due to an unknown reason, it's the cause is unknown. When the patient tries to eat quickly, all different segments of esophagus, they contract together, and that produces spasm, pain, and a rosary bead appearance. This is distal esophageal spasm. Unfortunately, the treatment, there is no surgical therapy available for that. Drugs can be tried, but drugs can be tried similar to achalasia. But no specific therapy is available yet in these patients. And what is the differential diagnosis? The differential diagnosis is some which appear similar to this, but it is not same. Jackhammer esophagus. Jackhammer esophagus. It is also known as the nutcracker esophagus. Don't try to read too many details. It is a topic which you will be needing for your INI set exam when you will be preparing. Right? It's not needed for neurology. Next question. Examiner will say dysphagia with food impaction. गले में अटकता है खाना. History of atopy, allergies is there. One hypersensitivity, asthma, food allergy. GERD is there. Regurgitation is happening, and biopsy shows this is very, very characteristic. Biopsy shows equal to or more than 15 eosinophils per high power field. What are we looking at? The patient is likely suffering from EOE. What is EOE? Eosinophilic esophagitis. Eosinophilic esophagitis. When you do barium swallow and when you do endoscopy, this is what you will see. This is the barium swallow finding, and this is your endoscope finding. Endoscopic finding. So barium swallow and endoscopy, this appearance. Now normally when you look at the esophagus, it is a smooth tube. It is a smooth tube. There are no hastrations, no rings. When this like appearance appears, this is called a feline esophagus. Feline means cat. कैट के ईसोफेगस, बिल्ली के ईसोफेगस में रिंग्स होते हैं, सो फेलिन ईसोफेगस. इट इज ऑल्सो नोन एज ईसोफेजियल शिवर. It is also known as trachealization of esophagus. Trachealization of esophagus. Trachealization of esophagus. So feline esophagus is typically seen in eosinophilic esophagitis. What is the treatment that you do? GERD is very prominent in these patients, so you need to give PPI, and because it is an allergic reaction, so steroids need to be given. But which steroid is used? Locally acting steroid known as budesonide. This is the first line therapy. This is the first line therapy. But if this first line therapy fails, you go for second line therapy. And the second line agent, according to Harrison, is dupilumab. Dupilumab is not only anti-interleukin 4 or monoclonal antibody, it is also anti-interleukin 13 monoclonal antibody. And because interleukin 4, 5, and 13 are the three interleukins involved in eosinophilic esophagitis, this is efficacious. It's a costly agent, but it produces dramatic recovery. So, 6 monthly infusions may be needed in the patient. Don't write the therapies and drugs and all. Just remember the name of the drug. That is all examiner will be asking. Okay, so the topic is done. Let's come to some one-liners. Easy things and one Harrison update as well. So what is the investigation of choice for GERD? What is the investigation of choice for GERD? Investigation of choice is endoscopy and biopsy. Endoscopy and biopsy. What is the gold standard investigation in GERD? 24-hour esophageal. 24-hour esophageal monitoring. Esophageal pH monitoring. 24-hour esophageal pH monitoring. Now coming to treatment of GERD. First of all, first line therapy. First line therapy is always the most difficult thing to do. Lifestyle changes. लाइफस्टाइल चेंज सबसे मुश्किल काम है. गर्ड हो गया है तो पेशेंट को बोलोगे वेट कंट्रोल करो, डाइटरी चेंजेस करो. क्या डाइटरी चेंजेस? अवॉइड स्पाइसी फूड, उबला खाना खाना है, मसाले नहीं खाने. अवॉइड कैफिनेटेड बेवरेजेस, चाय कॉफी नहीं पीना. अवॉइड कार्बोनेटेड बेवरेजेस, रेड बुल, लिम्का, पेप्सी, कोक नहीं पीना. कहना आसान है, लोग मानते नहीं है. सो फर्स्ट लाइन इज लाइफस्टाइल चेंजेस, बट इट इज वेरी डिफिकल्ट टू फॉर द पेशेंट टू अडियर ऑल्सो, राइट. सेकेंड लाइन थेरेपी. सेकेंड लाइन थेरेपी. सेकेंड लाइन थेरेपी ड्रग्स. नाउ यहां पर आया हैरिसन का अपडेट. न्यू क्लास ऑफ ड्रग. अभी तक आपने क्या पढ़ा? पुराना हैरिसन क्या कहता था? इफ यू लुक एट योर ओन एग्जिस्टिंग नोट्स ऑल्सो, PIs, proton pump inhibitor, are the drug of choice? No. Harrison 22nd edition says there is a new class of drugs known as PCABs. What are PCABs? Potassium competitive acid blockers. According to Harrison, they are the drug of choice and most efficacious drug in GERD these days. Not for peptic ulcer, but for GERD. PCABs, what is the example of this drug? Vonoprazan. वोनोप्राजान. इसके और भी डेरिवेटिव हैं, सबके एंड में प्रजान आता है. तो प्रजान जहां पर भी आ जाए वो क्या है? पोटेशियम कॉम्पिटिटिव एसिड ब्लॉकर. फॉर्चुनेटली और अनफॉर्चुनेटली इंडिया में वोनाप्राजान मिलता है, सो इट इज नाउ अवेलेबल इन आवर कंट्री ऑल्सो. सो पोटेशियम कॉम्पिटिटिव एसिड ब्लॉकर, द फर्स्ट लाइन एजेंट. दे आर इरिवर्सिबल ब्लॉकर्स ऑफ hydrogen potassium ATPase pump, which is involved in acid production, and they are irreversible, immediately acting. PIs are relatively slow acting, so they are the favored agent. Second line drug after this, if not given in the option, then PPI. And PPI के अंदर भी Harris says new generation PPIs should be preferred. Example of a new generation PPI is tenetoprazole. Tenetoprazole is again irreversible PPI, faster acting PPI. If that is not in the option, then your answer will be H2 blockers like cimetidine, ranitidine, etc. Don't you think it is a topic waiting to be asked as a fresh question in pharmacology or medicine? Yes, it is. Please add it. What is GERD? GERD stands for gastroesophageal reflux disease. Somebody missed, so I've been writing there. GERD का full form होता है gastroesophageal reflux disease. खट्टा डकार ऊपर की तरफ आना खाने का, that is called GERD, right? We all have experienced it sometime or the other. That is reflux. If reflux is significant, it is causing Barrett's metaplasia, it is causing serious symptoms affecting quality of life, then we call it as GERD. Simple is reflux, bar bar ho disease kare, so that is GERD. That is the full form of GERD, right? This second line therapy fails, we go for third line therapy. Third line therapy is surgery. And what is the surgery that we perform in these patients? The surgery done in these patients is Nissan's fundoplication. Nissan's fundoplication. So Nissan's fundoplication is the surgery of choice. Yes, dear friends, we have done with the esophageal disorder. Let time to solve some MCQs. Let's solve some MCQs. A middle-aged female presented with difficulty in ingesting liquids more than solids. What is the most likely characteristic finding on barium swallow imaging? Liquids more than solids. Likely, and female patient, it is likely achalasia cardia. Achalasia में irregular नहीं होता, कौन सा होता है? Regular filling defect. This was a controversial question when it was asked in January 25. There are many versions of this question across the platforms, but I have my own collection of questions, and this was the question I know that which many of the students who actually sat and cleared also, they mentioned it. तो सर डाउट यही हो रहा था कि रैट टेल तो कैंसर में होता है. रेगुलर फीलिंग डिफेक्ट इज द क्लिंचिंग पॉइंट, सो ऑलवेज वॉच आउट फॉर रेगुलर फीलिंग डिफेक्ट. FMG July 23. 55-year-old male with difficulty in swallowing after a few bites of. तो डिफिकल्टी इन स्वेलोविंग का मतलब उसको डिस्फेजिया है, हैलिटोसिस, बैड ब्रेथ हो रहा है, एंड उसको निमोनिया विद कंसोलिडेशन भी हुआ है. निमोनिया क्यों होगा? समथिंग इनटू द पाउच which is getting aspirated when he's lying down. So everything fitting into Zenker's diverticulum. What is the type of Zenker's diverticulum? It is a type of pulsion diverticulum. Great, good. Most of you have answered it correctly. The answer is A, pulsion diverticulum. तो पहले वाले का आंसर C, second one the answer is A. You are doing fine. You are understanding. Let us continue the momentum. Next topic: Mallory-Wiestier versus Boerhaave syndrome. Mallory-Wiestier is more common. Boerhaave syndrome is rare. Mallory-Wiestier is superficial mucosal tears. Superficial mucosal tears in lower esophagus, particularly near the gastroesophageal junction. Gastroesophageal junction. So what is the learning point from here? Not just Mallory-Wiestier and Boerhaave, never do binge drinking. Ideally, no drinking, but at least never do binge drinking as well, if it is for party. So gastroesophageal junction. Another takeaway point, don't do nagging dance. Third takeaway point, never call your ex, even howsoever high you may be. So near gastroesophageal junction. What about Boerhaave syndrome? It is transmural. Transmural means throughout the thickness. So transmural rupture of lower esophagus. Transmural rupture of lower esophagus. And it typically occurs in the posterolateral aspect. Posterolateral aspect of esophagus. What are the risk factors? Risk factors for Mallory-Wiestier is alcoholic binge drinking. Have you heard the term? Nadeem sir must have taken your class already. Bulimia nervosa. Usually seen in adolescent girls, they eat a lot and then they vomit out. So bulimia nervosa is another risk factor. The risk factor here in Boerhaave syndrome is alcoholism and recent endoscopy done or instrument inserted into the esophagus. Mallory-Wiestier presents with painless hematemesis. Painless hematemesis. These patients have painful hematemesis. These patients also have a triad known as Mackler's triad. What is Mackler's triad? It is a previous year FMG MCQ also. Three things which occur together. There is persistent vomiting, there is severe pain, and there is subcutaneous emphysema, subcutaneous emphysema. What is the investigation of choice here? You will do endoscopy. Investigation of choice here, contrast, esophagogram. If that is not possible, you can go for CT also. CCT of the chest. CCT of the chest as well. What is the treatment here? Conservative. Fails, you go for PPI. Fails, you go for endoscopy. And what is the treatment here? Laparotomy has to be done along with shock management. Shock management. I hope the topic is clear and you have understood it nicely. There are many other signs. See, what we are doing is getting the answer correct or remembering the key points. Each topic you can expand as much as you want. But do we have the time and do we have the need for this? That is the only thing. No? So Mallory-Wiestier versus Boerhaave syndrome. Let's move further. Now we have summary of malabsorption disorders. Looking at the buzzwords, we have to look at the likely diagnosis, 2 points about it, and the treatment. Now, first scenario. So, summary of malabsorption disorder. So, onset between 6 months to 2 years. So, malabsorption starts in the first 2 years of life, can continue into adulthood. Poor weight gain, anemia, steatoria, fatty, bulky, sticky stool. HLA-DQ2 is positive. Sometimes HLA-DQ8 is also positive. But most commonly, HLA-DQ2 is positive. What is the likely diagnosis? Patient is suffering from celiac disease, also called as wheat allergy. The technical name for this is gluten sensitive enteropathy. Good. Gluten sensitive enteropathy. It was previously known as celiac sprue. Sprue word is no longer used. What are the associations? It is strongly associated with a skin condition known as dermatitis herpetiformis. It's a skin manifestation of celiac disease. Produces vesicles and bullae. It is associated with syndromes. 3 syndromes are associated: Down syndrome, Turner syndrome, and Williams syndrome. It is associated with type 1 diabetes mellitus and other autoimmune disease. It is also associated with selective IgA deficiency. It's a primary immunodeficiency which can occur in association. Associations are important. They have been asked in INI set as well as NEET PG exam. Both of them they have been asked. So you can get a repeat question in FMGE as well. What is the screening test? You do the blood test. What is the blood you do? Total IgA level in the blood along with IgA TTG. TTG stands for tissue transglutaminase. If that is not there, you can go for total IgA along with IgA EMA. What is EMA? Endomysial antigen. I'm writing on the side. TTG stands for tissue transglutaminase. Tissue transglutaminase. And it is Hamesha IgA antibody that we check. EMA stands for endomysial antibody. Endomysial antibody. Right. So ये है आपके antibodies. But what is the investigation choice? Investigation of choice is upper GI endoscopy and biopsy. Upper GI endoscopy and biopsy. Biopsy will show flattening of the villus and inflammation, lymphocytic infiltration in the gut epithelium. What is the treatment that you do in these patients? Lifelong gluten-free diet. If you are allergic to something, you have to avoid that diet. So no wheat-based products, gluten-containing products. What is the food to use? Rice is safe. Maize is safe. Buckwheat is safe. Buckwheat is not wheat. Quinoa is safe. Sorghum is a millet. It is safe. And chia seeds are safe. Tapioca, also known as sabudana, that is safe. And flax seeds, alsi kehte hain in North India, that is safe. What is the food to avoid? Bro. Bro should be avoided. What is bro? Barley should be avoided. Rye should be avoided. Oats should be avoided. And wheat should be avoided. All types of wheat, including semolina, suji, whole wheat, they all should be avoided. Dalia. So bro is to be avoided in these patients. This is something you already know. So this finishes our first malabsorption disorder summary. We have discussed in more details. More frequently asked, can occur in children, can occur in adults. That is celiac disease. Next question, next scenario. Let us have a look at the next scenario. Initial arthritis for 6 to 12 months. पहले पेशेंट को जब स्टार्ट होगा तो पहले 6 से 12 महीने तक इनिशियल आर्थराइटिस होगा. 12 महीने तक नहीं, 12 साल तक. इसको कट करो, ये मिस्टेक है. इनिशियली आर्थराइटिस विल बी फॉर 6 to 12 years, नॉट मंथ्स. 6 to 12 years. मंथ्स तो मिनिमम होता है, ईयर्स तक एक्सटेंड हो जाता है. फिर malabsorption start hota hai. This is the stage where the patient actually is treatable and comes to medical attention. And intestinal biopsy shows positive inclusions in the gut epithelium. What is the likely diagnosis? Yes, the likely diagnosis is Whipple's disease. So joint involvement, malabsorption, past positive finding in the gut epithelium, Whipple's disease. It's an infectious disease caused by a bacteria known as Prima Whipplei. Prophrima whipplei is the bacteria. It is a gram positive, pass positive, intracellular bacteria. Cell के अंदर रहता है. What are the later complications? Patient can develop CNS complication and CVS complication. CNS complication can be in the form of memory loss and aphasias. And CVS complication can be in the form of inflammation, carditis. Carditis, endocarditis, myocarditis, pericarditis, they all can occur, and some patient can develop arrhythmias as well. The treatment. Treatment is actually very difficult. So we will go by the 2025 update on the treatment. Now there has been a treatment update from the International Society for Gastroenterology, Hematology and Nutrition. So what they have suggested is there are two types of regimes you can follow for these patients. Whipple disease is a difficult disease. The only good thing about Whipple disease is that it is more common in the Western population. Why it is more common in the Western population and not in the Indian subcontinent, we don't know. One theory is we people get so much of commando training during our childhood. What is commando training? All kind of nonsense food we are eating, all kind of street food with so much of bacteria, viruses, parasites we are eating. Our gut epithelium is always in a upregulated state. And Whipple disease, even if the bacterial exposure occurs, it is not able to obtain or get entry into the body system. This is one theory. We don't even know whether it is true or not. So there is a good thing about something and there is a bad thing about something. The good thing about our system is these Western people come to our country, they get diarrhea next day. We go to all the countries, we don't get any diarrhea. Our immunity is very good. Right? So update says that it is difficult to eradicate them, but two types of regimes can be used. First regime is you use IV ceftriaxone. It is important. It is very, very important, and it is not there in most of the standard books. So you need to write it, whatever source you are preparing it from. First regime is you give IV ceftriaxone, and this is given for 2 weeks, followed by cotrimoxazole, which is given for 1 year. Second is you start with oral. Either of the two regimes can be used. You start with oral doxycycline and combine it with another oral drug known as hydroxychloroquine. And this combination is given for 1 year. So long-term therapy needs to be given in the patient. Okay, so two regimes are there. Let us go to the next disease. Onset of malabsorption. Diarrhea within 2 weeks of visit to tropical country. So it's an American word, but we have to live with it. So tropical sprue. Tropical sprue is the diagnosis. What is the hallmark? 100% patients are having folate deficiency. Can B12 deficiency occur? Yes, it can. But what is always present? Folate deficiency. And what is the treatment in these patients? Doxycycline और टेट्रासाइक्लिन. दोनों सेम क्लास के हैं, दोनों में से कुछ भी यूज कर सकते हैं ओरली, प्लस फोलेट सप्लीमेंट मिलीग्राम पर डे. Oral therapy is good enough for tropical sprue. Cause is not known. Generally, it is supposed to be some non-specific bacteria and it is according to the country. तो सिनेरियोस की बात हो रही है. देखो अभी सिनेरियो क्या पढ़े हम? 3 सिनेरियो पढ़े. लेट अस समराइज. ऐसा भागता नहीं चलेंगे, समझ के चलेंगे. सिनेरियो वाज childhood onset, steatorrhea, DQ2 positivity and certain foods causing problem in the patient, that is celiac disease. If they are saying ki arthritis followed by malabsorption followed by PAS positive bacteria on endoscopy and biopsy, Whipple disease. Malabsorption and diarrhea in 2 weeks of staying or visiting a tropical country, tropical sprue. Fourth scenario, malabsorption disorder due to reduced length of small intestine. Obviously, it will always be after disease or after a operation. So small intestine length becomes reduced. So malabsorption will occur because patient will not be able to absorb. So malabsorption disorder due to reduced length of small intestine. It is called as short bowel syndrome. Short bowel syndrome. Short bowel syndrome. If the small intestinal length becomes less than 200 centimeter, it causes malabsorption syndromes. Malabsorption symptoms appear. And if the small intestinal length becomes less than 100 centimeter, it causes complete intestinal failure. And so the patient will be TPN dependent lifelong. Patient will be TPN dependent. Now, what are the causes? We have one-liners here. Most common cause in newborns, there is a condition known as NEC. If you have done neonatology in pediatrics, you would know. I am being tempted to talk about it, but I can't because we are discussing medicine. So, NEC, necrotizing enterocolitis. Common cause are intestinal atrechias. Atresia means absence of lumen formation. Have you heard of duodenal atresia, jejunal atresia, ileal atresia? They all can cause. Most common cause in children is volvulus. It's a surgical emergency. Most common cause in adults, it is Crohn's disease. It's a type of inflammatory bowel disorder. Now, what are the drugs which are useful in these patients? There are two kinds of drugs. One is the drug which causes hyperplasia of the bile, and it helps in the increasing the absorptive surface area. There is a drug known as GLP-2 analog. The typical example of this drug is teduglutide. And second are anti-motility agents. By slowing down the gut motility, they allow more time so that absorption can occur better. So anti-motility agents, two of them are approved for use. Either you can use loperamide or you can use combination of diphenoxylate with atropine. Highlight this particular thing. Treatment is important. This is important. Treatment of short bowel syndrome is important. Next thing, patient will be having recurrent diarrhea and absorption, recurrent diarrhea and malabsorption, not absorption, recurrent diarrhea and malabsorption due to reflux of colonic content into ileum via the ileocecal wall. So ileocecal wall is leaky and it is not being able to keep the intestinal content separate from the colonic content. Backflow is happening, and from colon, bacteria is moving into the sterile region of small intestine. This is what you call as SIBO. What is SIBO? Small intestinal good. Small intestinal bacterial overgrowth. Small intestinal bacterial overgrowth. देखो, कभी सोचा है ऐसा कि हमारा जो स्टूल है जो कोलोन से आता है, कोलोन में इतना बैक्टीरिया है, स्मॉल इंटेस्टाइन में बैक्टीरिया नहीं है. Because ileocecal valve is very efficient. It does not allow the content of colon to go back. But if ileocecal valve is leaky due to some reason, whatever reason, sometimes no reason is found, then bacteria can periodically go inside and it will cause recurrent diarrhea and malabsorption, and that will cause small intestinal bacterial overgrowth. Now, in small intestinal bacterial overgrowth, you cannot repair ileocecal. So periodically you will have to use drugs like metronidazole with or without doxycycline. Multiple courses will be needed. And it is a disease which is actually very difficult to treat. And these days, a lot of endoscopic procedures are being done, but it is something beyond our exam level that we are preparing. So metronidazole with or without doxycycline. Yes, you rightly said rifaximin is being used in refractory cases. So refractory cases, we are giving a trial of rifaximin as well. Rifaximin acts locally and sterilizes the gut, so that can be used. But the first line therapy, according to Harrison, it is metronidazole with or without doxycycline. So Next scenario, examiner will say there is a patient with hypoproteinemia with edema, low serum albumin and globulin. So देखो ब्लड में एल्बुमिन नहीं, ग्लोबुलिन नहीं, लेकिन किडनी और लिवर से लॉस नहीं हो रहा, लिवर डिजीज नहीं है, रीनल डिजीज नहीं है, तो प्रोटीन का लॉस हो कहां से रहा है? स्टूल में हो रहा है. दैट कंडीशन इज नोन एज प्रोटीन लूजिंग एंटेरोपैथी. प्रोटीन लूजिंग एंटेरोपैथी. प्रोटीन लूजिंग एंटेरोपैथी. देखो इसके ऊपर इसका एक डिफरेंशियल डायग्नोसिस है, आई एम पुटिंग अ स्टार. एक होती है प्रोटीन लूजिंग गैस्ट्रोपैथी, व्हेन द लॉस हैपनिंग फ्रॉम द स्टमक. प्रोटीन लूजिंग गैस्ट्रोपैथी is seen in patients who are having Menetrier's disease. Menetrier's disease produces protein losing gastropathy. These patients will have hyperplastic mucosal folds, और इन patients में लॉस होगा स्टमक से, लेकिन यहां पर इंटेस्टाइन से लॉस हो रहा है. सो दिस इज प्रोटीन लूजिंग एंटेरोपैथी. नाउ इट इज नॉट अ सिंगल कंडीशन, इट इज अ एंड रिजल्ट ऑफ मल्टीपल डिजीजेस. क्रॉस डिजीज में हो सकता है, ट्रॉपिकल स्प्रू में हो सकता है, समटाइम्स लिम्फेटिक abnormalities can cause it. Investigation of choice, we check the stool for alpha 1 antitrypsin clearance. Stool for alpha 1 antitrypsin clearance, that is increased. More alpha 1 antitrypsin getting lost in stool is a marker that albumin and globulin are also getting lost in stool. So it's a test that we perform. How to perform the test will not be asked. Alpha 1 antitrypsin acts as a surrogate marker indicating कि प्रोटीन का लॉस हो रहा है into the stool. And what is the treatment? You treat the cause, plus you give increased high protein diet, and you add MCT, medium chain triglyceride oil, MCT oil in the food. It has been shown to improve the steatorrhea in the patient. Now there is a very interesting thing here. I'm putting a star, important point. There is a new test which is available for losing enteropathy. Many times alpha 1 antitrypsin clearance will not be possible or it will not be available. तो हम क्या करते हैं, ब्लड में चेक करते हैं लिम्फोसाइट काउंट. हमें ब्लड में मिलता है लिम्फोपिनिया with depletion of CD3 positive T cells. If this is found in the blood and patient is having malabsorption with hypoproteinemia, you should suspect which disease? Protein losing enteropathy. It is a new test which is available in these patients. MCT oil means medium chain triglyceride. Medium chain triglyceride. Medium chain triglyceride जो इनका absorption ज्यादा diffuse होता है, and even if intestine से नहीं absorb हो रहे, they can get absorbed from the colon, proximal colon as well. So medium triglycerides are always added in a patient with steatorrhea if you are suspecting it. Here steatorrhea is not obvious, it is just a component, so you will generally add MCT oil in the food. MCT is medium chain triglyceride oil. It's a health supplement. And then we have some one-liners, the one-liners. Specific or confirmatory investigation or investigation of choice for any malabsorption disorder. What is your answer? It is endoscopy and biopsy. Endoscopy and biopsy. Gold standard test for steatorrhea, one-liners. 72 hour fecal fat excretion. But सोच के देखो क्या यह practically possible है? 72 hour तक fecal fat excretion, right? That is the gold standard test for steatorrhea. Gold standard test for proximal small intestinal malabsorption, there is a test known as D-xylose test that we perform. And gold standard test for vitamin B12 malabsorption, again a test which is no longer done these days, it is Schilling test. Schilling's test. Schilling test may you give oral radiolabeled B12 and you find that there is less than 10% of radiolabeled B12 excreted after oral administration. After oral administration, it indicates likely malabsorption. Likely B12 malabsorption. It is not due to dietary deficiency, it is due to malabsorption of B12. So this is the interpretation, it is a topic. So let us continue with this if you can stay. FMG 2019. See, it is important because if we transfer it to the end of the discussion on 20th or 21st December, what will happen is you will have less time to revise also. So I want to finish off medicine early before that. FMG 2019 question is 3-year-old child presented with steatorrhea, weight loss and malabsorption features. What test shall be confirmatory to make the diagnosis? Which is the confirmatory test as well as investigation of choice? I've already told you. The answer is no. Confirmatory test. Look at the options. Look at the one-liners. The confirmatory is always small intestinal biopsy. Whether they ask 3-year-old child, whether they say 30-year-old man or woman, the answer will be same. Small intestinal biopsy will be confirmatory. It will be confirmatory in the patient. Okay. Let's move further. Talk about H. pylori. H. pylori is important bacteria. Questions are asked. And there was a question on H. pylori treatment in the July exam also, and likely to be asked in the upcoming exam as well. So what are the diseases which are associated with H. pylori? There is a list, and twice it has been asked in your FMG exam. First of all, H. pylori is associated with peptic ulcers. What kind of peptic ulcers? It is seen associated with 70% of duodenal ulcers and 50% of gastric ulcers. 50% of gastric ulcers. So it is associated with both duodenal and gastric, but the association with duodenal ulcer is more common. Secondly, it is associated with distal gastric adenocarcinoma. It increases the risk of stomach cancer of adenocarcinoma. Third, it increases the risk of developing GIT lymphomas. Fourth, it increases the risk of functional dyspepsia. What is functional dyspepsia? See, middle-aged adults often they will eat something and then they will have, abdominal distension. They will have belching, dakar aega. Then they will be, just putting some, massage on their tummy. Then they will be drinking Eno and they will be belching like, that kind of a thing. You must have seen middle-aged people do that. That is functional dyspepsia. There is no organic cause, but functional gas, belching, dyspepsia, indigestion, that is functional dyspepsia. And fifth, these patients will have functional abdominal pain. These are the important diseases which are associated with H. pylori. Now the question arises, what is not associated with H. pylori? Not associated with H. pylori is carcinoids. Carcinoids are not associated. It's a previous year question. Another MCQ, is there a protective or negative association? Protective or negative association of H. pylori? The answer is yes. What is protective or negative association? What it means is H. pylori prevents certain disease from happening, right? So what is protective or negative association? Two things. H. pylori protects against GERD, gastroesophageal reflux disease, and secondly, it protects against distal esophageal adenocarcinoma. It's a very, very interesting phenomenon that H. pylori causes stomach adenocancer, but it prevents esophageal adenocancer. I repeat, see here, H. pylori causes distal gastric adenocarcinoma, but H. pylori protects against esophageal adenocarcinoma. It's a very interesting thing, and obviously MCQ. It's not an MCQ in FMG exam, it's an MCQ of the old NEET PG question, can be asked in the FMG exam as well. Okay. Now, what is the treatment of H. pylori infection? We will go by what the Harrison 22nd edition update is saying. What we know so far. Traditionally, I'll write traditionally. Traditionally means what we normally do in H. pylori treatment. Traditionally, the first line therapy is called as triple therapy. Triple therapy. What is triple therapy? Either you use OCA or you use OCM drugs for 14 days. What is OCA or OCM? O stands for omeprazole. It is a proton pump inhibitor. C stands for clarithromycin. A stands for amoxicillin. Sometimes you don't use amoxicillin, you use M. M stands for metronidazole. So either OCA or OCM, either of the two, we use for 14 days. And second line, if first line therapy fails, then we go for second line therapy. Second line is called as quadruple therapy. quadruple therapy. What does quadruple therapy entail? Quadruple therapy will have OBMT, and it will also be given for 14 days. O is the same, B stands for bismuth compounds, and T stands for tetracycline. O and M we have already written. Now, quadruple therapy and triple therapy, these were the original therapies which were employed. However, now Harrison says, the new edition of Harrison says, in areas with more than 15% clarithromycin resistance, there are many countries in this world, including India, including many countries in Africa, where clarithromycin resistance is very high. In areas with more than 15% clarithromycin resistance, for example, India, OCA and OCM cannot be used. So what happens to the therapies? So in these areas, first line therapy becomes OBMT therapy. And what if the patient is resistant to OBMT or does not respond? Second line, there are two options which are available. Either you can go for levofloxacin based regimes, or you can go for rifabutin based regimes, and both of them will be combined with proton pump inhibitors. It is an exciting new thing. It is an exciting new thing. Already in the July 25 exam, before Harrison was released, this question had been asked. And now it has changed significantly the entire therapy for H. pylori. The biggest change in Harrison is H. pylori treatment. So there is a very good possibility something out of this will be asked in either FMG or NEET PG or INI set or maybe all of these exams. So this is something you need to know. Triple therapy is failing in our country and we are not supposed to use it, right? So this changes a lot. This changes things a lot. Details of levofloxacin and rifabutin they will not ask because it becomes too complicated. So there are big tables and flowcharts. You don't need to go into it. It's very, very important. Let us move to a star topic, inflammatory bowel disease. Inflammatory bowel disease is of two types. It's a integration. You read about it in pathology, you read about it in surgery, and you read in medicine. In fact, treatment is done by medicine people. So inflammatory bowel disease is of two types. We have Crohn's disease and we have ulcerative colitis. Crohn's disease can involve any part of gut starting from mouth till anus, but terminal IEM is commonly involved. Ulcerative colitis only involves the colon. So, first of all, what is the family history and twin concordance? Crohn's disease is strongly associated with positive family history and twin concordance. Ulcerative colitis association is not significant. Crohn's disease, the gene associated with familial Crohn's disease is NOD2 gene mutation. This is important, mentioned in both Robbins and Harrison. Smoking. Crohn's disease, the smoking increases the risk of Crohn's disease. But ulcerative colitis and smoking have a protective association, means smoking reduces the risk of getting ulcerative colitis. So should you smoke? No, because you will not get ulcerative colitis, but you will get Crohn's disease and you will get all the other types of lung cancers that we discussed. Appendicectomy has no effect on Crohn's disease, but appendicectomy has been shown to have a protective association. People in whom appendix has been removed, ulcerative colitis prevalence is less, but it is not reason significant enough that we do removal of appendix in every patient. It's just a finding. OCP use slightly increases the risk. Slightly increases the risk of Crohn's disease, but ulcerative colitis, there is no effect on ulcerative colitis related to OCP use. What is the most common antibody? It is ASCA. Details of these antibodies and full forms you will be reading separately also and in pathology also. The ulcerative colitis is associated with antibody known as p-ANCA, perinuclear anti-neutrophil cytoplasmic antibody. What is the site of involvement? It involves any part of the body from mouth to anus, but most commonly involves which part? terminal ileum. On the other hand, ulcerative colitis typically involves the colon. In colon, the most common site of involvement is rectum. The most common site of involvement is rectum. What are the lesions? Here you find discontinuous lesions because there are skip areas, also called as skip lesion. क्योंकि क्या होगा, थोड़ा सा पार्ट में अल्सर आएगा, फिर नॉर्मल, फिर अल्सर, फिर नॉर्मल, फिर अल्सर, फिर नॉर्मल. यहां पर कॉन्टिन्यूअस होता है. कॉन्टिन्यूअस मीन्स starts from the rectum and without any skip area goes all the way till whatever is the edge of the colon. Now the types of ulcers, here they are deep and focal ulcers. Here they are superficial ulcers. Is there gut wall thickening which is seen? Yes, it is present here. It is absent in ulcerative colitis. What about stricture, fistula and fissure? It is significantly present in Crohn's disease, but it is absent in ulcerative colitis. Malignancy risk, it is low in Crohn's disease, it is high in ulcerative colitis. How high? It is related to the age. So colonoscopy, regular colonoscopy is recommended every year after a certain period of ulcerative colitis has happened. The risk of malignancy is 2% in 10 years after diagnosis, and it rises to 8% in 20 years after diagnosis of ulcerative colitis. It is mentioned in Harrison. So as the age increases, the risk of malignancy in ulcerative colitis increases. What about extraintestinal manifestation? Extraintestinal manifestations can occur in Crohn's disease, but they are rare, but they are common in ulcerative colitis. What are the 3 common extraintestinal manifestations which can occur in ulcerative colitis? 3 ऐसी चीजें जो इंटेस्टाइन के बाहर हो रही है and which occur in ulcerative colitis. First of all, these patients have high risk of developing uveitis, particularly anterior uveitis, so they can develop blindness. Secondly, these patients have high risk of developing primary sclerosing cholangitis. Primary sclerosing cholangitis. इसमें जो आपकी large bile duct है, in that large bile duct sclerosis happens, thickening happens. उससे क्या होता है, पेशेंट में सिरोसिस हो जाता है, कॉन्जुगेटेड बिलिरुबिनेमिया हो जाता है और उसकी अनियन वॉल थिकनिंग हो जाती है. यू मस्ट हैव रेड इन सर्जरी एज वेल एज इन पैथोलॉजी. सो प्राइमरी स्क्लेरोसिंग कोलिंजाइटिस. Thirdly, these patients can develop pyoderma gangrenosum. Can erythema nodosum occur? Yes, it can. But more commonly what you find and on which question has also been asked is pyoderma gangrenosum. इसमें एक नॉन हीलिंग अल्सर बन जाता है आपके लेग के ऊपर. सो remember these 3 important words: uveitis, primary sclerosing cholangitis and pyoderma gangrenosum. However, the only extraintestinal manifestation which is more common in Crohn's disease than ulcerative colitis is ankylosing spondylitis. It is more common in Crohn's disease compared to ulcerative colitis. Microscopic examination. देखो Crohn's disease में क्या हो रहा है, आपके पूरी थिकनेस इन्वॉल्व हो रही है, तभी तो गट वॉल थिक होगा, तभी तो फटेगा और फिस्टुला करेगा. सो देयर इज ट्रांसम्यूरल इन्फ्लेमेशन. ट्रांसम्यूरल मींस थ्रू आउट द थिकनेस देयर इज इन्फ्लेमेशन and these patients will have serositis, सिरोसा का इन्फ्लेमेशन, and chronic inflammation से fibrosis of the gut हो जाएगा. और फाइब्रोसिस से ही एक रेडियोलॉजिकल साइन प्रोड्यूस होता है, उसका नाम है स्ट्रिंग साइन ऑफ कैंटर. So there will be narrowing due to fibrosis. It produces a sign known as string sign of Cantor. In case of ulcerative colitis, ये superficial रहेगा, म्यूकोजा में रहेगा, लेकिन सूडो पॉलिप बनाएगा. So there will be mucosal and submucosal inflammation. Mucosal and submucosal inflammation. And क्या करेगा ये? It will form pseudo polyps. Cryptitis, crypt का inflammation, crypts of Lieberkühn, and crypt abscess, neutrophil collection in the crypts, इसे कहते हैं crypt abscess. ये words हैं जिसको वॉच आउट करना है. इनफैक्ट हैरिसन कहता है कि जिन पेशेंट्स के अंदर बड़े बड़े सूडो पॉलिप बन जाएं, सूडो पॉलिप जो होते हैं ये इंक्रीज करते हैं कैंसर का रिस्क. सो दे कैन बी प्री कैंसरस ऑल्सो. दे कैन बी प्री कैंसरस एज वेल. And radiologically इसमें क्या दिखेगा? The appearance is called as lead pipe colon, lead pipe or hose pipe colon, lead pipe or hose pipe colon. Why? Because there will be loss of hostrations. हमेशा hostrations होते हैं, वो लॉस हो जाते हैं कोलॉन में अल्सरेटिव कोलाइटिस होने से, एंड कोलॉन जो है वो बहुत स्मूथ दिखती है. सो फोटोग्राफ्स यू मस्ट हैव सीन इन योर. नाउ व्हाट अबाउट द ट्रीटमेंट ऑफ आईबीडी? नाउ ट्रीटमेंट के लिए देयर इज अ टेबुलेटेड फॉर्म दैट विल बी राइटिंग इट, सो इट इज इजी फॉर अस टू रिमेंबर. नेक्स्ट, ट्रीटमेंट ऑफ आईबीडी. सबसे पहले फर्स्ट लाइन थेरेपी क्या है? क्रॉन्स डिजीज अगर माइल्ड टू मॉडरेट है तो हम यूज करेंगे ओरल या रेक्टल budesonide. What is budesonide? It is a corticosteroid. It acts locally, absorb नहीं होता. ओरल और रेक्टल budesonide ना, आइदर ओरल दे देते हैं, लेकिन अगर आपको लोअर एनस वाले रीजन में हो रहा है तो रेक्टल budesonide एनीमा भी दे सकते हैं. इफ दैट फेल्स in mild to moderate patient, then you go for oral prednisolone. Oral steroid will be indicated. If it is severe, then you have no choice but you use systemic steroid like prednisolone, and it is combined with either MMF or azathioprine. What is MMF? I am writing the full form above. MMF का full form है mycophenolate mofetil. It's a very interesting and good immunosuppressive agent which is available in India. Pehle it used to be costly, but now it is cheaper. The patent on this is gone, and now locally it is getting produced in India. So it has a, it's a good agent to use. So it is combined with prednisolone in these patients. What about ulcerative colitis? Ulcerative colitis के अंदर हम सबसे पहले 5 ASA agents का ट्रायल देते हैं. 5 ASA. ASA stands for amino salicylic acid. Amino salicylic acid agents. 5 ASA agents are employed. You can use them either orally or you can use them enema. What are the agents which are used? First agent is sulfasalazine. Second is mesalamine. And third is balsalamine. Either of these agents can be used. Either of these agents. ये तीनों एक क्लास के हैं, तीनों भाई हैं. So you can use one of them. And if ulcerative colitis is severe, then you have no choice, but you have to use steroids. So oral prednisolone will be used, plus minus MMF or azathioprine. So this is the treatment of mild to moderate. But if the Crohn's disease or ulcerative colitis are fulminant, severe, not getting controlled, very rapidly progressive, recurrent, बार-बार हो रहे हैं, the moment you cannot give steroids indefinitely, ना, non-responsive, respond ही नहीं कर रहे हैं, तो क्या यूज करेंगे? Biological agents. And which biological agents are useful in these patients? We go for anti-TNF alpha therapy. Traditionally speaking, हमारे 4 anti-TNF alpha agents हैं जो हम यूज करते हैं. So these agents, now if you look at the table of Harrison, it talks about 11 to 12 monoclonal antibodies and new drugs. सब के सब नहीं करने हैं, करेंगे नीट पीजी के लिए करेंगे. For FMG exam we will do only what the bare minimum you need to know, what are available in our country and what are actually clinically used. So there are 4 biological agents that you need to remember from exam perspective. So the first one, which is useful in both Crohn's disease and ulcerative colitis, is infliximab. So infliximab. Mild moderate का कैसे पता चलेगा? Clinically देंगे वो. Otherwise, there is a way to check for mild moderate. There are classifications known as Montreal classification. You can go for Montreal classification. It talks about extent, it talks about severity and so on. उससे करते हैं. But exam में जब MCQ आएगा तो they will mention mild या moderate या severe. So infliximab. Infliximab will be useful in both ulcerative colitis and Crohn's disease. दोनों में यूज करते हैं. Second is adalimumab. So adalimumab, it will be again useful in both ulcerative colitis and Crohn's disease. Third, we have certolizumab. You can remember C के साथ C. So it is useful only in Crohn's disease. So you can remember like this, C stays with C. And fourth is golimumab. Golimumab is useful only in ulcerative colitis. Apart from that, you will put a star and write what are the recent drugs which are being used. Recently, we are using two more drugs. There is a drug known as vedolizumab. Vedolizumab is useful in both ulcerative colitis and Crohn's disease. And second is a new class of drug known as ozanimod. Ozanimod. Ozanimod is a S1P1 receptor modulator. ये एक oral drug है. This is an oral drug which is effective in severe ulcerative colitis patient. So this is the Harrison update of new drug related to the what is important. This is based upon my reading and my perception of the drugs which are given. Let me tell you again, there are 11 drugs, biologicals. But if we write everything, we remember nothing. So we have to remember the more important ones and the ones which Harrison is also paying a lot of attention and which are actually available to us also. Otherwise, experimental things, there is no end, no point just remember, doing them for the sake of it. Hepatology is relatively easy in the beginning. So hepatology में सबसे पहला चीज जो इस पे questions are asked is scoring systems in hepatology. So if you have written, I'm changing. So in scoring systems, we have the first scoring system, that is the MELD score. What is MELD score? MELD score stands for Model for End Stage Liver Disease. This was one of the earliest score which was devised to help guide कि किस patient में prognosis अच्छा है, किस में खराब है, and which patient will require liver transplantation. It is used in the age group of 16 years and above. What are the components? Components are asked in exam. The mnemonic of component is CBI. So C stands for creatinine, B stands for bilirubin, and I stands for INR. What is INR? International Normalized Ratio. It's a marker of prothrombin time. Second is PELD score. It's a pediatric modification of MELD score. ये कई सालों के बाद आया. Modification of MELD score, it is used in the age group of 15 years and less. इसके component क्या है? देखो इसके component same नहीं है. The components are different. And these components are also asked in the exam. The mnemonic for this is a big apple. A big apple. A stands for age because ये बच्चों में हो रहा है. B stands for bilirubin. I stands for INR. G stands for growth failure. And last A, it stands for albumin. Now, interesting MCQ for you. Which of the following is a component of MELD score but not a component of PELD score? And one of the option was creatinine. That was the answer. So creatinine is a component of adult MELD score, but it is not a component of the pediatric end stage liver disease score, that is PELD score. Third, child pug score. Child pug score, also called as child pug Turcotte score. Child pug Turcotte score. देखो इसको ना अलग अलग नाम है. चाइल्ड स्कोर भी कहते हैं, चाइल्ड पग भी कहते हैं, चाइल्ड पग टर्कॉट भी कहते हैं. तीन लोगों ने मिलकर दिया था. तीनों का नाम आना चाहिए ना, लेकिन कई जगह पर सिंपल चाइल्ड पग स्कोर लिख देते. It is used to predict mortality and need for transplantation in CLD patients. What are the components? Now components can be remembered like this. Child pug score. एक child को क्या चाहिए? What does a child need? बच्चे को चाहिए an educated बाप. Child pug score में क्या चाहिए? An educated बाप. Baap is a Hindi word. Its a literal meaning is father. So A stands for albumin. E stands for encephalopathy. देखो कोई लॉजिक नहीं है, याद करना. ये कंपोनेंट है तो है, कैलकुलेट करना नहीं बोलेगा, कंपोनेंट पूछेगा एग्जामिनर. We will show discuss MCQs also. B stands for bilirubin. A stands for ascites. And P stands for prothrombin time. Prothrombin time. So these are the components of child pug score. Fourth, we have the Naser score, also called as Naser's prognostic index, and this is used in patients with Wilson's disease. What is Wilson disease? It is a disease of copper metabolism defect. Wilson disease, ATP7B gene mutation. Yaad aaya? These patients, they have increased copper levels. Increased copper levels occur in the liver. They occur in the eyes. In eyes, it produces KF ring, as well as sunflower cataract, and in the brain they can affect the basal ganglia. They can produce Parkinson-like disease. So this is Wilson disease, right? So this is I've written so that you remember this is Wilson disease which has been talked about. What are the components of Nazar's prognostic index? Components can be remembered by the mnemonic ABP. News channel bhi hai na ABP. Literally stands for Anand Bazar Patrika, but the name of the channel, the news channel is ABP. A stands for AST levels, that is SGOT levels. B stands for bilirubin levels. And P stands for prothrombin time. There is a new modification of this recently done, very important. It is missing in many of the textbooks. So modification kya hai? There is a Nazar's index has been expanded to call it as the New Wilson index. New Wilson index. New Wilson index was given by a person whose surname is Dhawan. So it is also known as Dhawan's index. No, it is not the Dhawan you are thinking of. It is not the same Dhawan, it's a different Dhawan. So New Wilson index or Dhawan's index, क्या होता है इसके अंदर? ABP. It's not Rajiv Dhawan actually, it's a different Dhawan. So ABP along with serum albumin and WBC count. So इसको कहते हैं Dhawan's index or New Wilson index. It is just a modification of Nazar's prognostic index. FMGE January 23. Select the correct combination regarding components of child pug score A, B, C और D. देखो बड़े सिंपल है. APTT तो किसी भी स्कोर का पार्ट नहीं है, तो A and B are ruled out. Globulin किसी का पार्ट नहीं है, ये C भी ruled out. तो बचा क्या? D is your answer. This is how you are supposed to mark in the exam. You should. That speed of marking is also important, and it develops the more MCQs you solve. तो थ्योरी अपनी जगह है, but please solve MCQs. It's a skill also which you develop. FMG June 22. Chronic alcoholic patient with splenomegaly presented with sudden onset hematemesis. Esophageal bleeding varices. Right, so B is your answer. याद कर लो. याद कर लो. I'm writing. Pain is always there. Pain is always there in scurvy. बिना पेन का स्कर्वी नहीं होता. पेन इज ऑलवेज देयर इन बोरहावे सिंड्रोम. पेन इज ऑलवेज देयर deep in heart of all MBBS doctors. So this pain is good. Let it motivate you. Remember, scurvy is always painful. Boerhaave syndrome always painful. They will mention the question with bone pain in scurvy. They will mention the question and painful hematemesis in Boerhaave syndrome. Let's move further. What is the first line therapy for upper GI bleeding due to varices? Now varices के साथ patient आया है upper GI bleeding के साथ. क्या करोगे? पहला चीज, after managing ABC, right? Manage ABC. What is ABC? Airway breathing circulation. If shock में आया है, तो you will manage shock. You will give fluids followed by blood transfusion. Followed by blood transfusion. And wherever you are giving blood transfusion, the target hemoglobin should always be between 7 to 9 gram per deciliter. कभी भी high नहीं करना, MCQ है. Because if you increase the hemoglobin beyond 9, it has, किसी का 9 है तो कम नहीं करना है, but बढ़ाना नहीं है by artificial transfusion, because it has been shown that it worsens bleeding due to paradoxical rise in portal pressure. तो portal hypertension worsen हो जाता है if you give high more blood transfusion. So only देना है जितना जरूरी है. And then you will start the patient. If you are suspecting portal hypertension, you will give IV terlipressin or IV octreotide. दोनों में से एक mention होगा. That will be given to the patient. And then do endoscopy. Now when you do endoscopy, what is the first line therapy that you will perform? In endoscopy, the first line therapy is endoscope EVL. What is EVL? Endoscopic वेरिसियल लाइगेशन. वेरिसेस को बंद करने की कोशिश करोगे. दिस पॉइंट विच आई एम राइटिंग, इट्स वेरी इंपॉर्टेंट. इट्स इंटीग्रेटेड बिटवीन सर्जरी एंड मेडिसिन. सो मेडिसिन सर्जरी इंटीग्रेशन इज. सो एंडोस्कोपियल वेरिसियल लाइगेशन बंद करने की कोशिश करेंगे. एंड ऑल्टरनेटिव टू दिस, Alternative to this is either band ligation, या तो बैंड लगाओगे या आप स्क्लेरोथेरेपी करोगे. Sclerotherapy means injection into the base of the bleeding vessel. If this fails, the second line therapy will be tamponade of the bleeding vessel. और उसके लिए एक ट्यूब यूज करते हैं, उसे कहते हैं सैंक्सटैकन ब्लैकमोर ट्यूब. सैंक्सटैकन ब्लैकमोर ट्यूब. स्टेप वाइज पूछता है एग्जामिनर. तो ये हो गया व्हाट इज द नेक्स्ट स्टेप इन मैनेजमेंट. In surgery, almost one third questions these days in FMG are what is the next step in management. So in surgery, particularly when you are preparing, keep that in your mind. And if that also fails, then third line therapy is always surgery. What is the surgery that we do in portal hypertension? TIPS procedure will be performed. So this is how you do management of upper GI bleed due to varices. Right? So yes, there was a question on this. That is why we are covering it here. It's a very, very important question. It has been asked multiple times in all the exam. So मैंने उस तरीके से लिखा है कि what if it is a medicine question, you can manage. If it is a surgical question, you can manage. Right? So now what they have done is there is a printing error during formatting. Drug of choice for prevention of variceal bleed. ये अलग topic है. Go to the अलग page. Drug of choice for prevention of variceal bleeding is beta blockers. So beta blockers like carvedilol और propranolol और nadolol. इन तीनों में से कोई भी एक can be given for prevention. Beta blockers do not have a role in treatment, but it's a one-liner question. For prevention of variceal bleed, what they do is they decrease the portal pressure and the rupture of the varices cannot happen. Then we have ascites. What is ascites? Free fluid in the peritoneal cavity. In ascites, we always calculate a gradient known as serum ascitic albumin gradient called as SAG. When you calculate SAG, this table comes in. This table is extremely important and often asked in the exam. If you calculate SAG, there will be two possibilities. Either there is high SAG, where the value of SAG is more than 1.1, or there will be low SAG that is less than 1.1. Let me explain in simple words so that you have an idea what I'm talking about. There is a patient of ascites, right? Ascites kya hai? Fluid in the peritoneal cavity. Generally, these patients will be having cirrhosis. Some of them will be having nephrotic syndrome, CCF, or some other reason. Now you need to find the cause. What do? You take out some fluid from the abdomen. You check the protein in it. Then you take the blood and check the protein in the blood. What protein? Albumin. So serum albumin minus ascitic fluid albumin, what value you get is SAG. What is SAG? Serum ascitic albumin gradient. Serum albumin minus ascitic fluid albumin, that is SAG. If the value is less than 1.1, it is low SAG. If it is more than 1.1, it is high SAG. Low SAG, there are 5 causes. Among them, these 3 causes are already asked in exam. Nephrotic syndrome, pancreatitis, TB. Ideally, all remember karna, ye teen nahi bhulna. If it is high SAG, you further see ascitic protein. If ascitic protein is less than 2.5, it is cirrhosis. If it is more than 2.5, it is cardiac cause like congestive heart failure or constrictive pericarditis. Sometimes it can occur due to IVC obstruction also. So if you are running short on time, तो ये जो point mention किए हैं ये गलत नहीं होने चाहिए. Ideally, the entire table is important. This table was important when I was a student. This table is important now, and this table will be important tomorrow when you will be teaching your juniors. And maybe when tomorrow your kids are doctors, then also this table will be important. So this is high SAG and questions. Multiple questions have been asked. In fact, January 25 there was a question in FMG, and last year January 24 also there was a question on FMG. So HBV serology, this is a table. Now ideally you should be remembering and mugging up this table. कि क्या positive और क्या negative तो क्या interpretation. But let me tell you, I have been a student and it is very difficult, almost impossible to remember and mug up this table. It is almost impossible. So what is the alternative way? Let's make a flowchart. This flowchart always works and we will try to practice it in the question also. Let's make a flowchart here, talking about how we actually approach the patient. So I am giving the heading Hepatitis B virus approach. approach for MCQ. And an MCQ will be something like this. There is a patient with hepatitis B virus. He's having his blood test or her blood test was done, HbSEA, IgGA, IgMA, and they will tell what is the likely diagnosis. This is how they will ask you. So how we are going to go? First thing is check for HbSAg level. What is HbSAg? HbSAg is the surface antigen of hepatitis B. There will be two possibilities. Either HbSAg is positive or HbSAg is negative. If it is positive, it indicates active infection. यानी कि hepatitis B active है body में. Okay. Now you see the antibody. There are two types of antibodies. If you find IgM anti-HBC, the patient is suffering from acute hepatitis B virus. The patient is having acute hepatitis B virus infection. And if the patient is having IgG anti-HBC, the patient is having chronic hepatitis B virus infection. Okay. But if the HbSAg is negative, there is no active infection. There is no active infection. Not active infection. अब क्या करेंगे? अब हम करेंगे तीन चीजें चेक. Three possibilities. First possibility, patient is having only anti-HbS positive. बाकी सब कुछ negative है. So the likely diagnosis in such a patient will be vaccinated patient, immunized patient, injection लगा है. He never got hepatitis B actually. Second, if the question says anti-HbS is positive, मेरे साथ साथ बनाओ. It is very useful and it comes like this. If anti-HbS is positive plus IgG anti-HBC is also positive. अगर आपके पास जगह कम है तो अगले पेज पे भी लिख सकते हो, अलग पेज पे भी. So answer will be hepatitis B हुआ but recovery हो गया less than 1 year. And third possibility, only IgG anti-HBC is positive. These patients will have remote recovery. Remote recovery का मतलब बहुत पहले इन्फेक्शन हुआ और रिकवर हो चुका है. कितना टाइम हो चुका है? Equal to more than 1 year. Equal to or more than 1 year. I'm zooming it. Equal to or more than 1 year. And also remember last point. If HbEAg is positive, that indicates high infectivity. And if HbE antigen is negative, that indicates low infectivity. You apply this rule and you will always reach the answer. If the table actually is tougher to remember because even if you read it multiple times, you will still forget it. But this flowchart, if you make it just 2 times also and just practice in the MCQs, most of your MCQs which are asked, you should be able to answer by this flowchart approach. And I've tried it, people have tried it, students have tried it, it works like a charm. Let us see if you can apply this approach in your MCQ or not. So what is the approach in MCQ? Look at this question, FMGE MCQ 2020. Look at this question. What is the likely diagnosis if a child has HbSAg negative, HbEAg negative, anti-HbS positive and IgG anti-HBC positive? See, you need to देखो HbSAg नेगेटिव है, इसका मतलब नो एक्टिव इन्फेक्शन. पहला ही स्टेप देखो, नो एक्टिव इन्फेक्शन, यानी कि एक्यूट भी नहीं हो सकता, क्रॉनिक भी नहीं हो सकता, तो बचा क्या? प्रीवियस HBV इन्फेक्शन. डी इज योर आंसर. If you see carefully, you will find that it fits into the previous HBV infection, but patient has recovered. You don't need to talk about recovery versus non-recovery in the patient. So recovery has happened less than 1 year. It was previous infection which has recovered. So if you just simply apply this logic and follow the chart, you will always reach a correct answer. Try it out. When you try it in MCQs, PYQs, question bank practice, mock exams, this will work. So this flowchart approach should be in a place where you can see it again and revise it in the last week also before the exam. right? Or you're traveling in the morning in the bus, cold time, you're going to give a test in between during travel, have a look at this chart because you may not get a question, right? But if you get a question, you should have that accuracy to get it right. So, topic is done. Then another topic on which questions are repeatedly asked. Inherited hyperbilirubinemias. What are inherited hyperbilirubinemias? They are inherited causes of jaundice. Now questions are asked on that, Dubin, Johnson, Rotor, etc. Let's form an approach. Examiner will say inherited hyperbilirubinemia. There are two possibilities. Either it is conjugated jaundice which is inherited or conjugated jaundice which is inherited. If it is unconjugated, those patients who have a neonatal presentation, only neonate they present, those are called as Crigler-Najjar syndrome. Crigler-Najjar syndrome. Crigler-Najjar syndrome is of two types, type 1 and type 2. One is incompatible with life, type 2 is compatible with life. One has high mortality, they all develop kernicterus, that is bilirubin-induced damage. They may or may not develop kernicterus. Another unconjugated jaundice which can present at any age including newborn period is Gilbert syndrome. Gilbert syndrome is entirely compatible with life. Then conjugated jaundice. Conjugated jaundice is of two types. So what about inherited causes of conjugated jaundice? Now if it is conjugated jaundice, there are two possibilities. First possibility, I am highlighting the word dark pigmented liver. And second possibility, there is a normal looking liver. If it is a dark pigmented liver and abnormal secretion into urine of coproporphyrinogens, there is a disease you will think of. We call it as Dubin-Johnson syndrome. Dubin-Johnson syndrome. Normal liver and no pigmentation in the liver, but similar presentation like Dubin-Johnson, that is Rotor syndrome. Dubin-Johnson syndrome is having gene mutation, ABCC gene mutation, which causes decreased MRP2 protein. This is your NEET PG MCQ. And these patients, there is a test that we do known as BSP dye test, bromosulfatholin dye test, which is abnormal. Rotor syndrome, there is another gene mutation, SLC01B1 and SLC01B3. These are the two genes which are mutated, both produce the same Rotor syndrome, and these patients, the bromosulfatholin dye test is. And remember that Dubin-Johnson and Rotor never occur. They are never seen in neonates. They have excellent outcome. They can be doctors. So let's focus on this. We are done. We are done. We are done with the topic. We are done with GI. We are done with pulmo. We are done with hepat. Let us start with the star topic of this session, that is systemic lupus erythematosus, SLE. SLE is an autoimmune disease, multi-organ damage due to autoantibodies and immune complexes. SLE is also simply called as lupus. If you have watched Dr. House MD, it's a popular web series. There is a favorite dialogue over there. His dialogue is, it's never lupus. When it MCQ's time, when it is rheumatology clinic time, it is generally lupus. Lupus means wolf. Just like wolf attacks the person and kills him, SLE also kills the patient. When wolf attacks someone, the wolf attacks the central part of the face. See, cat family, leopards, tigers and lions, they have a tendency to attack the neck of their prey. Wolves tend to attack, when they attack humans, they tend to attack the mid-face. These patients have malar rash occurring and then they eat up the person. So similarly, these are the reasons why the disease is called as lupus. This is what people say, how the name lupus came in. So what is it's an autoimmune disease. What is the age and gender? So age and gender in these patients, it is 30 to 50 years, middle-aged females. Females more common than males. And the ratio is 9:1. So 9 times more common in female, predominantly a female disease. What is the clinical picture? Number one, they will have constitutional symptoms like fever, weight loss, etc. Second, they will have cutaneous manifestation. What are the cutaneous manifestation? There are two types of cutaneous manifestation. First is chronic cutaneous manifestation and second is acute cutaneous manifestation. Acute cutaneous manifestation is known as malar rash. Look at this lady. She is having a rash in a butterfly distribution. Starts on the bridge of nose and like a butterfly spreads to the whole cheeks bilaterally. So it is erythematous, raised, scaly rash occurring in butterfly distribution. Butterfly distribution occurs on the nose as well as cheeks, and it always spares the nasolabial folds. These lines are never involved. It spares nasolabial folds. Malar rash is worsened by sun exposure, and this rash is the typical presentation in the patient. Remember, cutaneous involvement is the second most common organ which is involved. Chronic rash can occur in the form of DLE. What is DLE? Disc-like rash. We call it as discoid lupus erythematosus. And these are the patients who also have ulcers, nasal as well as oral ulcers, and they have alopecia. So loss of hair is common in the chronic variety of SLE. So two types of presentations are malar rash, which is acute, and chronic, which is discoid LE, where ulcers and alopecia are common along with disc-like lesion. Third is musculoskeletal involvement, and I am highlighting the word overall most common system involved, NEET PG one-liner MCQ. Overall most common system is musculoskeletal involvement. So it mostly occurs in the form of intermittent polyarthritis. This polyarthritis involves hands, wrist and knee joint. There is deformity, but no erosions are seen. There is deformity. So these patients will have intermittent polyarthritis. जॉइंट्स का इन्फ्लेमेशन होगा, डिफॉर्मिटी तो आएगी लेकिन इरोजन नहीं होगी. डिफॉर्मिंग नॉन इरोजिव आर्थराइटिस, इसे कहते हैं जैकूड्स आर्थ्रोपैथी. जैकूड्स आर्थ्रोपैथी. And what is the most serious involvement of kidneys? A serious involvement of SLE, it is a renal manifestation called as lupus nephritis. Lupus nephritis will require, it can be symptomatic or it can be asymptomatic. There are 6 classes which are described on renal biopsy. It is a pathology thing, so I will not go into the details. Remember, the most severe forms are class 4, followed by class 3 and class 6. Class 4 lupus nephritis is the one which is having wire loop lesions. And these patients have subendothelial deposits of immune complexes. So this is something which is asked in the pathology class as well. So what we have done so far, the patient is having constitutional symptom, the patient is having skin involvement, patient is having musculoskeletal, patient is having renal involvement as well. Among them, the serious manifestation is lupus nephritis. And before cyclophosphamide etc. came in, this used to be the cause of death. Right now, it is not the cause of death. Can other systems be involved? Yes, other systems can be involved. What are the other systems which can be involved? These patients can have hematological involvement. So these patients can have anemia as well as thrombocytopenia. And they can have lung involvement in the form of pleuritis. There is no pleural effusion, no pneumonia. Pleuritis is the most common SLE involvement in lungs. And this is a mid-year 2019 MCQ of FMGE exam. What is the most common lung involvement of SLE? It is pleuritis. How do you make the diagnosis of SLE? There is a criteria known as Euler ACR criteria. Look at this criteria. Don't be scared looking at this criteria. All this criteria tells you is that for any patient of SLE, what you need to know is that anti-nuclear antibody should be positive 1:80. This is considered to be the most important criteria. This is considered to be the entry criteria. Just like for entry into medical education, medical system in country, you need to crack FMG. Similarly, to be diagnosed as SLE, पहला चीज क्या करते हैं? ANA करते हैं. अगर ANA कम मिला या नेगेटिव मिला तो SLE नहीं है. अगर ANA 1:80 से ऊपर पॉजिटिव मिला तो that is entry criteria. Then you look at the other criteria. These are the criteria given and corresponding score is given. My suggestion to you, don't read this criteria in detail. आया भी तो याद नहीं रहे. तो हमें याद क्या करना है? Essential criteria for entry into diagnostic criteria is ANA. कितना? More than 1:80. Apart from that, if you look at clinical criteria, you look at immune criteria, take out the total score. You see कि क्या क्या चीज प्रेजेंट है. सपोज फीवर है तो यू गिव ए स्कोर ऑफ 2. साथ में ओरल अल्सर है, गिव ए स्कोर ऑफ 2. साथ में एंटी स्मिथ एंटीबॉडी है, गिव ए स्कोर ऑफ 6. कीप ऑन एडिंग. इफ द टोटल स्कोर is equal to or more than 10, it is sufficient to make a diagnosis of SLE. These criteria need not occur simultaneously, they can come one after the other. तो कम से कम एक clinical criteria, 10 points, and total score, the patient is having SLE. I repeat, listen to me. SLE के लिए criteria क्या करते हैं? ANA करते हैं. कितना? 1:80 and more. अगर है तो आगे चलो. आगे चलेंगे clinical and antibodies. दोनों चेक करेंगे. जो जो प्रेजेंट है उसको टिक करेंगे, फिर टोटल स्कोर निकालेंगे. इफ द टोटल स्कोर इज इक्वल टू और मोर देन 10, और कम से कम एक क्लिनिकल होना चाहिए. ऐसा नहीं कि सिर्फ एएनए से डायग्नोसिस ना दिए, इट शुड बी क्लिनिकल. यू मेक द डायग्नोसिस ऑफ एसएलई. नीड नॉट अकर साइमल्टेनियसली. सपोज देयर इज अ पेशेंट हु सेज एलोपेशिया पिछले साल हुआ था, अभी उसको अनीमिया हो रहा है, तो दोनों को क्राइटेरिया को कंसिडर करेंगे. And if the total score becomes equal to more than 10, it is SLE. The only thing important is ANA should be positive. Kitna? 1:80 and more in the patient. Right? This is ULAR ACR diagnostic criteria. We talked about ULAR ACR criteria, which was done. Now let us talk about the autoantibodies which are seen in SLE. That is a table which is asked in the exam. It's a very, very important table. And you will find this table being important not only in pediatric, in medicine, but also in pathology part. So multiple times questions have been asked. First of all, what is the autoantibody which is essential for diagnosis of SLE, which is the best screening test, high sensitivity but poor specificity. Poor specificity means it is not specific for SLE, it can occur in other conditions also. The name of the antibody is anti-nuclear antibody. Most specific antibody, it is anti-Smith antigen antibody. SM stands for Smith antigen. So anti-Smith or anti-Smith antigen antibody correlates. Which antibody correlates with disease activity? It is anti-double-stranded DNA. Anti-double-stranded DNA high titer indicates disease is active. Anti-double-stranded DNA low titers, it indicates that disease is under control. So when you are treating the patient, which antibody titer should be done on every follow-up visit? This is how question will be asked in NEET PG exam. It has already been asked. It can be asked in FMGE. See, you can remember simply correlates with disease activity, double-stranded DNA. But examiner will put question like this: which antibody needs to be checked on every follow-up visit to see response to therapy and whether the disease is active or quiescent? The answer will be anti-double-stranded DNA. Drug-induced SLE is a FMG MCQ. Anti-histone antibodies are commonly seen. So drug-induced SLE, anti-histone antibody. Now, which condition has strong association with lupus nephritis? So according to Harrison 22nd edition, strongest association with lupus nephritis is seen with anti-C1q antibody. Anti-C1q is a complement component against which autoantibody is formed, and about 85% association is seen with lupus nephritis in these patients. So anti-C1q is being used as a biomarker also in established patients of SLE. ABPA syndrome, producing recurrent abortion. You will be reading about ABPA syndrome in pathology also, in OBG class also. ABPA syndrome is associated with anti-beta-2 glycoprotein 1 antibodies. You can simply write anti-beta-2 glycoprotein antibody. It is also associated with LAC. What is LAC? Lupus anticoagulant. Lupus anticoagulant. Then neonatal SLE, what are the antibodies? Anti-Ro, anti-La. Anti-Ro, anti-La. Ro-La. बच्चा अब दुनिया में आया, SLE हो गया. सो रो ले बच्चे, हम ऐसा कहते हैं. तो रो ले नहीं है, रो ला है. सो रो एंड ला एंटीबॉडीज आर seen in neonatal SLE. ANA will be positive in all of them. Lupus cerebritis and seizures will be associated with anti-glutamate receptor, anti-GD2. In bracket I'm writing glutamate receptor antibodies. Glutamate receptor antibodies. I hope you know that from physiology that there are two types of neurotransmitters. inhibitory and excitatory. Glutamate is an excitatory neurotransmitter, and it is seen that anti-GD2 binds to glutamate receptor and activates it. And excitatory becomes active. What does it do? It causes seizures and inflammation in the brain. So anti-GD2 antibody. Depression and psychosis is associated with anti-neuronal antibody. Remember that cerebritis can have neuronal also, and psychosis patients can have GD2 also. But they are the ones which are specifically mentioned separately in the textbook. Autoimmune hemolytic anemia, you have anti-erythrocyte antibody. And finally, petechian thrombocytopenia are associated with antiplatelet antibody. You need to understand that not every patient will have all antibodies. These are the autoantibodies. And because different patients have different types of antibodies, so different manifestations of SLE are seen in the patient, right? So different types of manifestations you will be seeing in the patients. I am my own worst enemy. This disease is most applicable. This dialogue is most applicable in a patient of SLE. Now, one-liners, what is the most common pulmonary manifestation is SLE? It is pleuritis, that is inflammation of pleura, chest pain will be there. Most common cause of death, it is MI, myocardial infarction. Earlier, it used to be lupus nephritis. All these new standard textbooks say MI. Second common cause is infections. And third common cause is thrombosis. So in decreasing order, these are the three causes. The list has slightly changed in the recent years. So you can get a fresh MCQ on this. Fresh MCQ on this. What are the drugs causing SLE? There is a mnemonic of this known as SHIP. SHIPP. Sulfonamides, including Dapsone. Dapsone is a type of sulfonamide. Hydralazine, INH, that is isoniazid. It is an anti-tubercular drug. Procainamide, as well as penicillin. Penicillamine, not penicillin, penicillamine. That is D-penicillamine. Some books write phenytoin also as the list. It is actually a very long list, but these are the important drugs which have been asked, and this is pharmacology integration. Then if anti-Ro antilla is present in a pregnant lady, what will the baby develop? Suppose mother has anti-Ro antilla in mother can cross over and they can damage the AV node in the baby, leading to congenital heart block. Very, very important. Congenital heart block. And why congenital heart block occurs in SLE related pregnancy? Because there is damage to AV node. Remember, SA node is more resilient. AV node is the one which Bichara gets damaged in most of the autoantibody induced damage. So AV node damage will be occurring in these patients. All of them are one-liners and very, very important. This entire page, in fact, is full of previous year questions and possible future questions also. Let us go further, talk about the management of SLE. Now, management is huge, but we will try to simplify, and because it is a revision session, so I will try to write in a way that you can remember it better. First of all, every patient requires photo protection. So you need to apply sunscreen, you need to, cover the exposed parts, and sunscreen should be a good one, SPF 50 or so. And girls are better in photo protection compared to men. Now, girls will be, covering their face, covering their glove, they'll be wearing gloves. The typical, as I'm telling it to you, you can imagine, girls going on a scooty, covering their body well. If they're a SLE patient, they can manage themselves well. If a boy develops SLE, it is a big problem because men are very poor in photo protection. Even on a summery day, they will just wear a vest and shorts and go out into the sun. It is just nature which protects them because SLE is a disease of girls. But if it occurs in men, again, men have a lot of flares because men are very poor in photo protection. I'm not being gender specific. It is a praise for the girls that yes, girls are better in photo protection. So whether you are a man or a woman doesn't matter. In SLE, photo protection is very important because sunlight exposure triggers acute exacerbation, that is acute worsening in the patient. And second part will be immunosuppression. You need to suppress the body's own immune reaction against itself. Now, how you will do immunosuppression? Now, it is often very tempting to write prednisolone and hydroxychloroquine, but there is a proper way to write. So we will be writing in a way Harrison wants us to learn. And if you remember like this, you will never forget, and your future MCQs will also be correct. So let us assume the first condition is non-life-threatening SLE. Non-life-threatening means SLE is there, but there are no life-threatening feature. Can you give an example? For example, skin involvement. For example, joint involvement. So in these patients, what is the initial drug of choice? The drug of choice in these patients will be oral hydroxychloroquine.
oral hydroxychloroquine. I'm writing in short HCQ. That is given on a daily basis, regular basis, sometimes lifelong you need to give as a maintenance therapy. But for any flare, flare means any worsening, you will be adding oral prednisolone in these patients. The duration of prednisolone will depend how long the flare is, how long the worsening is. Flare means a worsening. And you will give prednisolone for about 1 to 2 weeks and then you taper and stop it. And if there is no response, if there is severe or non-responding, then there is a monoclonal antibody you can use in these patients. The name of the monoclonal antibody is belimumab. Belimumab inhibits B cell proliferation. It inhibits B cell proliferation. So it's a inhibitor of BAFF. There is a factor known as BAFF. It inhibits BAFF. It is a B cell proliferating factor which is inhibited by belimumab, right? Now, what if the patient is having life-threatening SLE? Second possibility, patient has life-threatening SLE. The example of a life-threatening SLE will be lupus nephritis. For example, lupus nephritis. What you will give in these patients? First of all, you need to induce remission, means response should come. So you will induce remission. The disease should come under control. फिर maintain करेंगे. तो remission के लिए क्या दोगे? You will use a combination of steroids. So you will use IV methylprednisolone in all of these patients. And bracket you would write add cyclophosphamide. When you will add cyclophosphamide? If there is severe renal involvement. For example, if there is class 3 or class 4 lupus nephritis. Remember I told you the severe forms are class 3 and class 4. So the biopsy findings I told you. So if that is there, you will add cyclophosphamide in these patients. But IV methylprednisolone will be given to induce remission plus minus cyclophosphamide. Two possibilities. If the remission comes, you will switch to oral prednisolone. And slowly you will taper it. And then you will switch the patient to hydroxychloroquine with azathioprine. What is azathioprine? It is another immunosuppressive agent. On the other hand, if there is no remission doesn't come, you will consider biological agents. Two biological agents you can consider. Either you can go for belimumab, the same drug we wrote above, or you can go for rituximab. Try to see the reason we are using it. There is a small concept behind it. Most of the problems in SLE are mediated by autoantibody. End of the day, they are antibody. Antibody is formed by plasma cell. Plasma cell are produced from B cell. So if you want to control the disease process, what antibody you will use? All those antibodies which target B cell specifically. Belimumab targets B cell and rituximab targets B cell because rituximab is anti-CD20 monoclonal antibody. It's a very small concept, will not be asked directly, but ideally when you are preparing for competitive exam, this is the way you should be preparing. So rituximab and belimumab are the ones that you will be using, right? So this covers the summary of what you need to know. This is easier to revise and it covers all the MCQs asked in any competitive exam in SLE in the last 10 years, whether it is NEET PG, FMG or INI-SET. They can be solved by this summary. This is not a perfect summary, but this covers the major aspects that you need to know as a rapid revision student in the last few weeks. Okay, so remember it, add it to your notes and please read it 2-3 times. ये पढ़ने में अच्छा लगता है, लेकिन you need precision because if a question will be asked, it will not be directly. They will make a scenario and ask you what next needs to be done. So SLE is done. Okay, let's move further. Now we move over to scenarios. Now we can increase the speed a bit. Now easier things will come. Next scenario, adult female, generally slightly older female, 50, 60, 70 years. She presents with symmetrical leather-like skin thickening. There is a scenario question based upon this asked in FMG. There is skin induration. There is contractures in the hands. And there is dysphagia or Raynaud's phenomena. What is Raynaud's phenomena? On exposure to cold, initially the fingers become pale. then they become blue, and then recovery happens, that is redness occurs. This phenomena is called as Raynaud's phenomena. And there is lung fibrosis or interstitial lung disease. Interesting thing to note, SLE does not have ILD. So if ILD is happening, it is not SLE that we are talking about. So if you have a presentation like this, the likely diagnosis in the patient is scleroderma. Scleroderma is an autoimmune disease where fibrosis, sclerosis of the tissues occurs. It is also known as systemic sclerosis. In short, it is written as SSC. These are the various names of the same condition, that is scleroderma. So if scleroderma occurs, what is the most common type of ILD occurring in scleroderma? It is NSIP. This is something I discussed with you yesterday also. Non-specific interstitial pneumonitis, full form, full name we have already written. What are the autoantibodies seen in scleroderma? Two types of autoantibodies are seen. See, scleroderma can be of two varieties. Either it is limited cutaneous. Limited cutaneous is the one which is affecting only the peripheries and head and neck, whereas diffuse cutaneous will be involving the entire body. Limited cutaneous scleroderma is associated with anti-centromere antibody. इसको याद करना पड़ेगा. There is no logic here. You have to muck it up. Diffuse cutaneous is associated with two types of antibodies. It is associated with anti-topoisomerase 70, anti-topoisomerase 70 antibody, also written as SCL70 antibody. And secondly, it is associated with anti-RNA polymerase 3. Anti-RNA polymerase 3 antibody. Anti-RNA polymerase 3 antibody. And what is the most common cause of death in scleroderma? The most common cause of death is ILD. That is why we are talking about ILD. Second common cause of death in these patients is PAH. ILD is interstitial lung disease. PAH is pulmonary arterial hypertension. Okay, so this is the cause of death. What about the treatment of scleroderma? Interesting thing to note, scleroderma is the only connective tissue disorder, autoimmune disease, where steroids do not have a role. I repeat, the only autoimmune connective tissue disorder where steroids do not have a role in management is scleroderma. So what do? We use other agents. So let us talk about the summary of treatment. Now in treatment of scleroderma, in bracket you would write steroids have limited to no role. And in fact, they should be avoided. Why? Steroids can trigger scleroderma renal crisis in these patients. What is scleroderma renal crisis? In these patients, there will be a rapid increase in BP. So malignant hypertension can occur along with fall in GFR, oligouria. So oliguria with massive rise in BP is called as scleroderma renal crisis, which can occur in steroid use in scleroderma. It's very, very important. So what are the therapies that you are going to use? First of all, the most efficacious agent in these patients is always cyclophosphamide. So most efficacious agent is cyclophosphamide. What are the other agents you can use if cyclophosphamide is not tolerated? Others which can be used, they include MMF, full form I told you yesterday, mycophenolate mofetil. You can use azathioprine. And you can also try methotrexate. And what is the biological agent which is useful in scleroderma? There is a biological agent by the name of tocilizumab. Tocilizumab is very important. It is a pharmacology MCQ asked 1 year back in NEET PG. Tocilizumab is anti-interleukin 6 receptor R. R word miss nahi karna, monoclonal antibody. And second part of therapy will be supportive therapy. तो supportive में हम क्या करेंगे? For Raynaud's phenomena, you will use calcium channel blockers. For example, nifedipine. For ILD, you will be giving antifibrotic agents. For example, nindatinib. I told you the name yesterday also. Nindatinib will be useful. And what if scleroderma renal crisis occurs? What if this crisis occurs? For scleroderma renal crisis, we can use ACE inhibitors. What are ACE inhibitors? Enalapril, captopril, lisinopril, etc. can be used in these patients. So this is the treatment of scleroderma. Interesting thing to note, no role of steroids in scleroderma. Right? Topic is done. Let's move further. 40-year-old woman presents with difficulty in eating due to persistently dry mouth. She also has a gritty sensation in eyes, dental caries, and enlarged lymph nodes. Dry eyes, dry mouth, lymphadenopathy. Which connective tissue disorder will you think of? It is not scleroderma, it is not SLE. Sjogren syndrome is what you will be thinking of. The patient is likely suffering from Sjogren syndrome. So, what is the summary? What are the key points you should remember? That whenever examiner makes a case scenario, the examiner will say 30 to 50-year female, dry eyes, dry mouth, and parotid swelling along with lymphadenopathy. The likely diagnosis in the patient is Sjogren syndrome. S is silent in these patients, so we call it as Sjogren syndrome. And dry eyes are also known as keratoconjunctivitis sicca. These patients have high risk of developing corneal ulcers. So sometimes they will use the word keratoconjunctivitis sicca. So which condition has primary Sjogren syndrome or dry eyes, dry mouth as the primary presenting problem? Among autoimmune diseases, it is Sjogren syndrome. What is the autoantibody? ANA is positive, but it is non-specific. I told you it is never specific. It can occur in multiple autoimmune conditions. Anti-Rho antibody can be seen, but it is anti-Rho 52 specific antibody and anti-La antibody. They are found to be more specific in such patients. They are more specific in such patients. What is the most common cause of death in Sjogren syndrome? It is lymphomas. Which type of lymphoma is common? Marginal zone. Marginal zone B-cell lymphoma. Lymphoma is the cause of death. Remember, which connective tissue disorder? Lymphomas are very common. Sjogren syndrome, they are very common. And it is the cause of death as well. Treatment in these patients. Treatment has two parts. First of all, you will do supportive immunosuppressive therapy, immunosuppression. For immunosuppression, your drug of choice will always be oral prednisolone. So steroids will be indicated. Other drugs, if steroids are not to be used, you can go for azathioprine. And because B cells are involved, B cell lymphomas are common. Which antibody will be useful? You tell me. Which autoantibody will be useful? I've already told you the funda behind it. Rituximab can also be used. Good. I hope you have understood the funda. Rituximab is anti-CD20. CD19, 20, 21, 22 are present on B cell. CD1 to 8 are present on T cell. Right? So rituximab will be useful. Apart from that, you will be giving symptomatic therapy, supportive therapy. As a part of supportive therapy, in the eyes, because dry eyes are there, you will put 0.3%, 0.5% methyl cellulose drops. Methyl cellulose drops. 0.5% methyl cellulose drops. And secondly, for dry mouth, you will be using an agent known as cevimeline. Or you can go for pilocarpine. Both of them increase saliva production. So cevimeline or pilocarpine, they are called as secretagogues. Secretagogues means they will be increasing the therapy. Why not belimumab? Data does not say. So when you say ki why not this drug, studies have not shown it to be effective. Simple thing, right? हम जनरलाइजेशन खुद बना सकते हैं, लेकिन ह्यूमन बॉडी जनरलाइजेशन से नहीं चलती. ह्यूमन बॉडी को ट्रीट अगर करना है तो हमें एविडेंस चाहिए. एसएलई अलग डिजीज है, स्क्लेरोडर्मा अलग डिजीज है, और जॉगरन सिंड्रोम अलग डिजीज है. तो कुछ डिजीजेस, कुछ ड्रग्स कॉमन होंगे, लेकिन उनका मैकेनिज्म ऑफ एक्शन एंड रिस्पॉन्स जो रहेगा वो अलग अलग रहेगा. ये क्वेश्चन मुझे एमबीबीएस में भी सुनने को मिलता है, एमडी में भी सुनने को मिलता है. सुपर स्पेशलिटी के स्टूडेंट्स होते हैं, वो भी पूछते हैं, सर ये ड्रग क्यों नहीं देंगे? इसका सिंपल सा रीजन है, जब स्टडी किया गया तो ड्रग इफेक्टिव नहीं पाया गया, इसलिए नहीं देंगे. In other words, if a drug is used, it has been found to be useful, benefits outweigh the risk, and safety data is available. As simple as this, right? This is the blanket statement. If you ask me 10 years later when you are doing super specialty, and I will have probably some gray hair at that time, you will ask me the same question, my answer to that time will also be the same. Okay? So this is the summary of Sjogren syndrome. Let's move further. Rheumatoid arthritis. Rheumatoid arthritis, name itself is saying arthritis, but it is an autoimmune disease. It is a chronic inflammatory disease characterized by a symmetric polyarthritis. Symmetric polyarthritis means both sides of the body joints are involved, and there are extra articular manifestations which are seen. Remember, extra articular manifestations are seen in 40% patients. So almost 40% patients have not only joint involvement, other organs also show inflammation. What is the most common HLA association in these patients? The most common HLA association is HLA-DR4 as well as HLA-DRW1. If you have to choose one, the strongest association has been found with HLA-DR4. HLA-DR4 followed by HLA-DRW1. Okay, so HLA-DR4 followed by HLA-DRW1. These are the HLA associations. Moving further, what are the autoantibodies that you will see? There are two types of autoantibodies you will find in rheumatoid arthritis. Most sensitive antibody of rheumatoid arthritis is anti-CCP. Anti-CCP. CCP stands for cyclic citrullinated peptide. Cyclic citrullinated peptide antibody. Anti-CCP antibody is the most sensitive antibody. It is seen in 85 to 90% patients. Less sensitive but still done is RF. What is RF? Rheumatoid factor. Rheumatoid factor is, the full form is rheumatoid factor. This is not specific for rheumatoid arthritis. It has a sensitivity of only about 70%. And rheumatoid factor क्या होता है? IgM antibody. It is IgM antibody against Fc portion of IgG. Antibody against antibody is called as rheumatoid factor. So these are the antibodies that you need to know. Anti-CCP, cyclic citrullinated peptide, is an antigen found on the inner surface of synovial membrane, and the antibodies against it mediate rheumatoid arthritis. What is the most common joint involved? Two joints are almost equally involved. You have the proximal interphalangeal joint, proximal IP joint, as well as metacarpophalangeal joint. But which joint is spared? Distal interphalangeal joint is generally spared. And most common tendon involved is flexor pollicis longus tendon. Flexor pollicis longus tendon. So flexor pollicis longus tendon is the most common tendon which is involved. Now, a lot of questions are asked, spotter images on the deformity produced and identifying it in rheumatoid arthritis. First of all, many patients look at this image, look at this page, and we will also have a look at the image side by side. So first deformity which occurs in rheumatoid arthritis is rheumatoid hand. There will be ulnar deviation of all the fingers. It is also called as ulnar hand or rheumatoid hand. So rheumatoid hand will look something like this. Can you see there is a ulnar deviation of all the fingers? They show like this. It is ulnar drift or rheumatoid hand seen in rheumatoid arthritis. Second feature will be hitchhiker thumb, also called as Z thumb deformity. What is hitchhiker? You have to ask for lift. How do you do? That is hitchhiker thumb. See, what happens in these patients is this is adducted thumb. This is abducted. So thumb is abducted and the distal part is hyperextended backwards like this. This is called as hitchhiker thumb. The distal part is going hyperextended. You need to understand the important aspect here. Arthritis does not involve DIP joint. I repeat, arthritis does not involve DIP, distal interphalangeal joint. But deformity can involve distal interphalangeal joint. Why deformity can occur if no arthritis? Because the tendons attached there can be involved. So it's a very interesting funda, and it is generally taught in medical colleges at MBBS level. I'm quite sure your medicine teacher would have told you this. If not, listen to this funda again. Which joint is not involved due to arthritis in rheumatoid arthritis? It is distal interphalangeal joint. But can deformity be produced here? Yes. The reason for deformity is not the joint involvement, but because of the other tendons and contractures and other things which are happening around this area. Okay. Okay, so these are two small little things that we can remember. Third is piano-key deformity. Piano-key deformity occurs on the ulnar aspect on dorsum. There will be tenosynovitis of extensor carpi ulnaris, which leads to prominence of the ulnar styloid process. Have a look here. This is piano-key deformity. Can you see this particular deformity? This particular ulnar styloid process area becomes unduly prominent. So keep these photos in your mind. First is ulnar drift or rheumatoid hand. Second is hitchhiker thumb. Thumb is abducted and distal part of the phalanx is hyperextended. It is going backwards. And third is piano-key deformity due to extensor carpi ulnaris involvement. Then fourth deformity is mallet finger. T is silent, mallet finger. Only flexion occurs at distal interphalangeal joint. This is mallet finger. Then we have swan neck deformity. Why do we call it as swan neck? Because the patient's fingers, the fingers of the patient look like a swan. To explain, it is looking like a swan. And that is why it is called as swan neck deformity. Swan neck deformity and boutonniere deformity are often mistaken by students when questions are asked. To remember the deformity in swan neck, you can remember the funda E pip F dip. Swan neck deformity is E pip F dip. So extension at proximal interphalangeal joint and flexion at distal interphalangeal joint. That is all you need to know. Reverse of this, reverse of swan neck deformity is boutonniere deformity. So my advice to you is only remember swan neck deformity. If boutonniere deformity gets asked, you reverse what we read in swan neck deformity. So now you will have extension at the distal interphalangeal joint and flexion at the proximal interphalangeal joint. That is called as boutonniere deformity, right? So these are the deformities which are produced. Photo can be asked, description can be asked, or close options can be asked. I'm putting a big star here. Very, very important. Even if you may know well, you are supposed to revise it close to the exam as well. So they are often asked in the exam. So this is your types of deformities. Now, I told you extra-articular manifestations, they can be seen in up to 40% of rheumatoid arthritis patients. What are the extra-articular manifestations? Patients can develop rheumatoid nodule. What are rheumatoid nodules? They are painless nodules which typically occur on extensor surfaces. So you can label extensor surfaces. Extensor surface क्या होते हैं? Back of the dorsum of the hand. They can occur on dorsal surface of the arm. They can occur on the elbow. They can occur on the shin bone, and they can occur on the back. So they will occur on the extensor surfaces. And it is considered to be the most common extra-articular feature. Second is secondary Sjogren syndrome. Primary Sjogren syndrome is a standalone disease. Can dry eye, dry mouth, mimicking Sjogren syndrome be produced in any other condition? Yes, it can be a feature of rheumatoid arthritis. So you can highlight secondary Sjogren syndrome. Reason is rheumatoid arthritis. What is the most common cause of death in rheumatoid arthritis? It is myocardial infarction. Inflammation happening in rest part of the body. Who's dying? Don't be like heart. Heart is a very fragile organ. Yes, it is important. And a lot of poetry has been written on heart. But let me tell you, heart is a very fragile organ. It's a very useless organ. Like it is useful, no, but useless in a very different way. Like, you say useless in the way that कुछ मतलब उसके अंदर resilience ही नहीं है. Think of liver. इतना डैमेज होता है उसके बाद भी रीजनरेट कर जाता है. What about heart? पोटेशियम 5.2 हुआ, अरिदमिया हुआ, डेड. SLE हुआ, what is the cause of death? Heart attack. Rheumatoid arthritis हुआ, what is the cause of death? MI. We will see many other conditions. Disease happening elsewhere. Who's dying? Heart. So when life makes you an internal organ, don't be like heart. Be like liver. Resilient, strong, adapting, and ability to regenerate. And transplantation also possible. Heart transplant, again, it's more of a theoretical thing. It does happen, but again, not as good and as popular and as possible as liver transplant, right? So most common cause of death in RA, MI. What is Felty syndrome? Felty syndrome is a triad of three things. It is a triad of three things. So Felty syndrome, what is Felty syndrome? It is a triad of three things. Rheumatoid arthritis, splenomegaly, and neutropenia. Splenomegaly and neutropenia. Which is more specific for RA? Anti-CCP is more specific. Not only sensitive, specific also CCP. Both sensitive and specific if they ask. It is anti-CCP. Okay. Management of rheumatoid arthritis. What is the management we are going to do? First of all, you will do pain relief. So for pain relief, what you will be giving? You can use non-steroidal anti-inflammatory drugs or aspirin. And you can also try, plus minus, you can try colchicine derivatives. Colchicine derivatives can be used. Second is disease-modifying anti-rheumatic drugs. DMARDs. What is DMARDs? DMARDs stands for disease-modifying anti-rheumatic drugs. The most commonly used drug is methotrexate. The most commonly used drug is methotrexate. If methotrexate fails or it is contraindicated, you go for hydroxychloroquine plus minus combined with leflunomide. This particular thing is important, and there is a case scenario asked in INI set exam. The case scenario was a patient with rheumatoid arthritis was started on methotrexate along with non-steroidal anti-inflammatory drugs, but there was inadequate response. What is the next step in management? One of the option was start biological agents. Another option was add hydroxychloroquine with leflunomide. That is your answer. Okay. So first you give a trial of the more easily available biological agents, then you move further. And third, if these also fail, if DMARDs are not working, severe rheumatoid arthritis, biological agents will be used. Now, what are the common biological agents which can be used? In these patients, you can go for anti-interleukin 1 drugs. For example, anakinra can be used. Second, you will go for anti-interleukin 6 R, that is receptor. Example, I just told you the drug, tocilizumab can be used. Tocilizumab can be used. Third, you can go for anti-TNF alpha. Typical example for that is infliximab, that can be used. And fourth, you can use anti-interleukin 17 alpha. The drug is ustekinumab. So if you see this condition, the biological agents we are using are different. Rituximab is not useful in these patients for the simple reason that B cell activation is not the primary disease process. It is just a bystander effect which is happening. And so you need to target the T cell mediated or interleukin 1, 2, and 17 alpha pathways. For that, we need these biological agents. So rituximab is not commonly used in patient of rheumatoid arthritis, right? And what about the role of steroids? You can write on the side, steroids are useful as bridge therapy. What is the meaning of bridge therapy? I'm not writing the detail. You just need to understand this funda. Bridge therapy means any DMARD if you start or biological agent you start, they take about 1 to 2 weeks for action to come. So what if the patient is having severe inflammation? So steroids are given for that temporary period in between, so that till the time of DMARDs and biological agents come into play, you can give some cover to the patient. And that is why steroids are not used regularly, but they are used as bridge therapy. तो जहां पर भी word मिले bridge therapy, we are talking about steroids, intermittently used, small period we are using till the effect of the actual drug we are targeting comes into play, right? That is how we are going to treat using steroids in these patients. Okay. Now, moving over to gout. Quick summary. Gout is associated with what underlying condition? It is a severe inflammatory condition of the joints of the foot, which is associated with underlying hyperuricemia. Hyperuricemia. So gout associated with underlying hyperuricemia. In hyperuricemia patients, due to a variety of reasons, sometimes triggers, sometimes unknown reason, there is deposition of MSU crystals in the joint. What are MSU? Monosodium urate crystals. Monosodium urate crystals. And how do they appear? These crystals appear as needle shaped. These words are important. There is an MCQ on this. Needle shaped, negatively birefringent. Needle shaped, negatively birefringent crystals in the synovial fluid. They are seen best by what? They are seen best by polarized microscopy. So on polarized microscopy, they are seen. So remember this funda that if there is a needle shaped, I'm just zooming out a bit. If there is needle shaped crystals, it is MSU crystals seen in gout patient. But if there are rhomboid crystals, then they are CPP crystals, calcium pyrophosphate crystal, indicating pseudo gout in the patient. So two types of MCQs can be asked. Needle-shaped crystals are monosodium urate, gout is the diagnosis. Rhomboid crystals in synovial fluid, rare disorder, pseudo-gout. These crystals are composed of calcium pyrophosphate. Calcium pyrophosphate. These are the crystals which are seen. What is the most common joint affected? The most common joint affected in these patients is the first metatarsophalangeal joint, first MTP joint. And the first MTP joint is swollen, that is called as podagra. There is severe pain. This pain is nocturnal in nature, and overlying skin is also inflamed, causing pseudocellulitis. Remember that gout is a condition which is more common in males compared to female. अभी तक हमने most of the conditions we have read today, SLE, rheumatoid arthritis, scleroderma, Sjogren syndrome, more common in female. This condition is more common in males, and it is a very, very painful condition, affects the first metatarsophalangeal joint in the patient. And recurrent attacks lead to permanent deformity and tophi deposition, leading to a sign known as Martel sign. So remember, Martel sign is not a sign of acute gout. It is a feature of chronic repeated episodes of gout in the patient. So deformity produced, bony erosions produced, and tophi deposition in the subcutaneous region is called as Martel sign. तो मार्टल साइन में पेन नहीं होता है. मार्टल साइन इज अ पेनलेस कंडीशन. Podagra is a painful condition. Remember the word podagra is acute gout. Martel sign is chronic gout. It is not a acute gout. Small little thing you need to remember. What is the treatment of gout? Treatment has two parts. First of all, you have to do the pain management. First, you have to do the pain management. For pain management, you have to avoid aspirin because aspirin can lead to deposition of more crystals in the joint. You can use endomethacin, that is non-steroidal anti-inflammatory drugs, plus minus colchicine derivatives, and very severe cases, you can use a short course of steroids also. You can use a short course of steroids also. Second is management of hyperuricemia. Management of hyperuricemia. Remember that management of hyperuricemia is always done after acute attack is over. क्योंकि अगर ये drugs, the drugs which are used to lower the uric acid level, if you start them early during the acute gout, actually the acute attack becomes more severe. So always started after the acute attack is over. Generally, it takes about 7 to 10 days. And after 7 to 10 days, the acute attack is over. Pain is gone. Now you start management of hyperuricemia. Now, for hyperuricemia management, there are two types of patients you can use. If the patient is overproducer of uric acid, then the drug of choice in these patients, in fact, the first line drug is always allopurinol. What is allopurinol? Allopurinol is a xanthine oxidase inhibitor. It is a xanthine oxidase inhibitor. And second line drug is generally febuxostat. Febuxostat. Remember that rasburicase is rarely used in hyperuricemia, and it is more commonly it is reserved for use in another condition known as tumor lysis syndrome. When you will be reading oncology, you will be reading about tumor lysis syndrome. वहां पे rasburicase use होता है. So first line agent is always allopurinol. Second line agent is febuxostat, right? And what if the patient is under excretor of uric acid? If patient is under excretor, some patients के अंदर the problem is the renal function is normal, but only uric acid is not getting excreted properly. In these patients, we will add a drug which prevents reabsorption and enhances renal excretion of uric acid. So the drug used in these patients is probenecid. It can be used orally, and oral probenecid is the drug which is used in these patients. And is there a new drug? I'm putting a star here. Harrison update, new IV drug to lower urate levels. To lower urate levels. It was recently approved for use. It is pegloticase. Pegloticase. What it does is it converts the uric acid into allantoin. This allantoin is water soluble and it is excreted from the body. It is excreted from the body. So pegloticase is the new drug which has been added. So you need to add this new drug in these patients. The topic is done. Gout topic is done. Let's move further. Ankylosing spondylitis. Now, ankylosing spondylitis is again a condition which is more common in males compared to females. So this is a condition which is associated with males compared to female. Strongest association of ankylosing spondylitis, it's a MCQ point already asked in FMG exam, HLA B27. Strong association is seen with HLA B27. Males are more commonly affected than female. Age of onset is generally 20 to 40 years. So age of onset is 20 to 40 years. Ankylosing spondylitis also associated with other associations of ankylosing spondylitis include psoriasis. There is a skin disease known as psoriasis. It is also associated with inflammatory bowel disorder. It is associated with uveitis. Rarely, it may be associated with aortic regurgitation as well. So these are the associations for ankylosing spondylitis. What will X-ray spine show? Various types of X-ray findings have been described. Initially, the patient presents with squaring of the vertebra. Later on, long-standing cases, the entire vertebral column becomes stiff. It produces the so-called bamboo spine. Photograph of bamboo spine you must have seen already in your radiology class, and you will be reading about it as well. Bamboo spine is a one-liner question of ankylosing spondylitis. Schober's test is a classical test done to check the stiffness of the spine, but these days it is no longer done because the test only checks the stiffness. It doesn't tell you the reason for stiffness of the lower back. But yes, you can say that historical test, I will write like this, historical test which was done for ankylosing spondylitis was modified Schober's test. Modified Schober's test. It only checks for the stiffness of the lower spine. Modified Schober's test is the one which is done. Now, what is the treatment in these patients? Treatment has two parts. First part will be, so treatment of choice in these patients, first of all, for pain relief, for analgesia, you will be giving non-steroidal anti-inflammatory agents and you will be combining it with physiotherapy. So physiotherapy targeting lower back will be needed. And second will be use of biological agents. Which biological agents can be used in these patients? TNF alpha inhibitors can be used. For example, TNF alpha inhibitor, I'm writing TNF alpha I. That is the short form of writing TNF alpha inhibitor. For example, infliximab can be used. And some patients benefit from anti-interleukin 17 antibodies, for example, ustekinumab. So ankylosing spondylitis is done. And then we come to sarcoidosis. There was a case scenario question asked in July 25 FMG exam. It was a very simple question actually. I will summarize in the end. So case question scenario asked in July 25 medicine part. It was a case scenario, 3-line long question which was asked in medicine this time. So what is sarcoidosis? Sarcoidosis is a granulomatous condition. It is an inflammatory condition where non-caseating granulomas form in various organs. The cause is not clear. Many theories have been given and many triggers have been identified. So sarcoidosis क्या है? Granuloma formation in the tissue. These are non-caseating granulomas, and these non-caseating granulomas have the ability to synthesize vitamin D. And this vitamin D, because it is on the higher side, it has a tendency to cause hypercalcemia. Hypercalcemia. The question asked in July 25 was something like this. I have not written here. Listen to the question. There is a middle-aged patient who's having some lesions in the body. He has features of hypercalcemia, but no exogenous cause is identified and parathyroid hormone levels are normal. Which of the following condition can produce this picture? One of the option was sarcoidosis. All the other three options were not the answer. One of them was parathyroid adenoma. Obviously, that will be ruled out because parathyroid hormone levels are not. So the answer, logical answer in the question was sarcoidosis. All you need to know is one granulomatous inflammation where vitamin D is produced by the granuloma cells and leading to hypercalcemia, that is sarcoidosis. What is the most common infectious trigger of sarcoidosis? The most common infectious trigger of sarcoidosis is Propionibacterium acnes. Propionibacterium acnes. Earlier, we used to think that Propionibacterium acnes only causes acne in adolescent. This is true, but this is also a wolf hiding in the garb of a sheep. भेड़ की खाल में भेड़िया. We now know that Propionibacterium acnes in adults can be a trigger of sarcoidosis in predisposed individuals. It's a very important point, can be asked as a fresh MCQ, and Harrison gives a lot of time talking about how and the mechanisms which are involved in this. Clinical manifestations. Let's go one by one. Most common involvement is lung involvement. There will be hilar lymphadenopathy at both the hilum of the lungs, and that will obstruct the bronchus. These patients will have cough and dyspnea. This occurs due to hilar lymph node enlargement. Skin involvement is seen in 24% patients. These patients can have two types of skin manifestation. Either they can have erythema nodosum. This is a dermatological condition I'm quite sure you will be reading in derma class. Or they can have lupus pernio. These are purple papules, purple colored papules occurring on the face. Remember the funda. Lupus is SLE. Lupus pernio is sarcoidosis. Right? Lupus pernio is sarcoidosis. Don't get confused. Lupus vulgaris is tuberculosis. You'll be reading about all these in the upcoming sessions as well. So erythema nodosum, lupus pernio are the skin manifestation of sarcoidosis. Third, parotid gland can have granuloma formation, so it can get enlarged, and palsy occurs of seventh cranial nerve. Which nerve passes through the parotid gland, dividing into its branches? It is seventh cranial nerve. So facial palsy can occur. What are the investigations? Twice MCQs have been asked. So there will be hypercalcemia and raised levels of enzyme known as ACE. What is ACE? Angiotensin converting enzyme. It does not play a role in the disease, but it acts as a marker. Its levels are increased in the blood. Right? And chest X-ray shows what? Look at this photograph. Can you see that there is bilateral hilar lymph node enlargement? This part and this part. This is lymph node enlargement which is happening. So there is bilateral hilar LAP. LAP is lymphadenopathy. And these patients, you find there is eggshell calcification. So what you find in the patient is eggshell calcification. Eggshell calcification. And what will HRCT test show? HRCT test will show the presence of a sign known as galaxy sign. Look at this. This is the part where granuloma is there and a lot of calcification is happening. If I zoom it, it is looking something like a galaxy. So this is the so-called galaxy sign. This particular thing is called as galaxy sign. It is seen on HRCT chest. What is the test we do? Bronchoalveolar lavage fluid analysis. And bronchoalveolar lavage fluid analysis will show CD4 cell by CD8 cell ratio. It will be more than 3.5:1. And there is an MCQ asked on this as well. So you put some fluid through bronchoscope and then take it out and you check the CD4 by CD8 ratio. It is more than 3.5:1 in these patients. Yes, Garland sign has also been described. And what is the investigation of choice? It is tissue biopsy. Which tissue is taken? Lymph node biopsy is generally taken. And that will show granulomas. And these granulomas, non-gazetting granulomas, will have vitamin D producing cells. What is the treatment? Drug of choice in all these patients. is oral prednisolone, that is corticosteroid. What are the second line agents you can use? You can go for hydroxychloroquine and you can go for methotrexate. And in refractory patients, you can go for infliximab. Okay, some of you are asking me about gallium scan. Gallium scan as well as Queens test. Queens test. They both have been described in sarcoidosis, but they are less commonly done clinically these days. They are less commonly done. They are the scans which have been described. They are the tests which have been described, but they are not very commonly done these days, and that is why we are not talking about it. Okay, so the topic is done. Sarcoidosis is done. So dermatomyositis, what are the things that you need to know? Dermatomyositis, first of all, which gender it will be more common? It will be more common in females compared to males. So female more compared to males. And the peak age for dermatomyositis, what is the peak age of Samantha? It is about 36 or 37. So peak age is again the same. It is 30 to 50 years. So more common in females compared to males. So dermatomyositis, it is an autoimmune inflammatory disorder predominantly affecting muscles and skin. Now, what is the skin involvement? 5 types of skin involvement is seen. First of all, these patients can have purple colored rash on the upper eyelid. We call it as heliotrope rash. Some patients can develop these scaly lesions on the knuckles. They are called as Gottron papule. Some patients can have photosensitivity and erythema on the sun exposed parts. What are the sun exposed parts? This neck region and this V region which is forming in the front, so we call it as V sign. In the back, this erythema is there, so we call it as shawl sign. And some patients can develop small dilated vessel and occasional ulcer around them. These are nail bed telangiectasia. Photograph as well as these lesions. You need to remember the name and you need to. So skin involvement is seen in 99 to 100% patients, and this is considered the hallmark of dermatomyositis. Second is muscle involvement, which is seen in about 90% patients. So both occur together, so we call it as dermatomyositis, but out of the two, which is more common and generally the presenting part, it is skin involvement. What about muscle involvement? It typically involves the proximal muscles symmetrically. So there will be muscle weakness along with raised CK enzyme in the blood. Plus, many patients can have Gower sign positive as well. I hope you know that Gower sign has been described for Duchenne's muscular dystrophy. Can it occur in some other condition? Yes, it can occur in dermatomyositis as well. So symmetrical muscle weakness. I hope you know that these muscles and the hip muscles are proximal, finger muscles are distal. So proximal muscles are involved. That means they have difficulty in raising their hand above the head and they have difficulty in climbing up and down the stairs. What are the complications which can occur? Interstitial lung disease can occur and carcinoma ovary can occur in the patient. Carcinoma ovary can occur in the patient, right? What are the investigations that you will do? First of all, the serum CK will be elevated in 70 to 80% patients. ANA is positive but non-specific. Specific autoantibodies. 3 autoantibody names you need to remember. Anti-MDA5 is positive. Second is anti-MI2 is positive. And third is anti-TIF. They are the specific antibodies found in these patients. What about anti-Jo1 antibody? There is another antibody known as anti-Jo1. It is rare, but seen. Anti-Jo1 antibody, Jo1, JO1. It is rare, but seen if patient has mechanic hands. What are mechanic hands? Rough hands, calluses, scaly lesions in the hand are called as mechanic hand. So this is something you can remember for future exams also. It's a very, very interesting and important thing. Right, it is there in your notes also. And what about gold standard investigation? It is always muscle biopsy. What is the treatment that you will do? Now, treatment in these patients, drug of choice is always corticosteroids, oral prednisolone. Second line drug, the two M's you can use. Either you can go for methotrexate or you can go for MMF. What is MMF? Mycophenolate mofetil. And if it is refractory, you can either use biological agents. For example, rituximab can be useful here, or you can give a trial of IVIG. What is IVIG? Intravenous immunoglobulin. The only autoimmune disease in which IVIG is useful is dermatomyositis. It's very, very important, and IVIG has been given in many refractory patients with good efficacy. It's a mixture of antibodies. It's a blood product. It is commercially available. It has immunomodulatory properties. So trial of IVIG can be given in these patients. So this finishes our discussion of dermatomyositis. And we move into the small but important world of vasculitis. It's a big world of its own, but we are keeping it small and discussing only the relevant parts because there is a huge overlap with pathology. I will discuss some relevant parts of pathology, but my focus will remain on the clinical aspects, that is medicine. So what is vasculitis? Vasculitis refers to inflammation of the vessel wall, that is called as vasculitis. Vasculitis can be primary or it can be secondary. The primary vasculitis is the one where no cause is found, and primary vasculitis is divided according to the size of the vessel. So if you have large vessel vasculitis, then we have medium vessel vasculitis, small vessel vasculitis, and variable vessel vasculitis. So let's discuss some examples. Large vessel vasculitis will be involving the aorta and its branches. So large vessel vasculitis, aorta and its branches are involved. So two example, Takayasu and giant cell arteritis. Takayasu arteritis and giant cell arteritis. Medium vessel vasculitis includes visceral and muscular arteries. It includes PAN and it includes Kawasaki disease. Kawasaki disease. Refractory means something which is not responding to first and second line therapy. Usual therapy, something does not respond, we use the word refractory. Third is small vessel vasculitis. Small vessel vasculitis will involve small vessels like arteriole, venule, and capillary. It is of two subtypes. You can have immune complex associated vasculitis. The typical example is HSP, Hanoch-Schönlein purpura. It's a pediatric vasculitis. And second is ANCA associated small vessel vasculitis. Example is GPA, MPA. Details of this full form we will be writing separately. And finally, we have variable vessel vasculitis. The example for this is Behcet syndrome, also known as Behcet's disease. Behcet syndrome or Behcet disease. Now, can there be secondary vasculitis? Yes, a huge list of causes is there. Two are important and they are asked in the exam. Both of them are NEET PG and INICET MCQs. So I'm putting Qs on top of them. Hepatitis B, chronic hepatitis B virus is associated with which vasculitis? PAN, polyarteritis nodosa. Polyarteritis nodosa. And hairy cell leukemia, it's a malignancy which can lead to which vasculitis? Again, polyarteritis nodosa. Remember, PAN can be primary vasculitis, PAN can be secondary. If it is secondary, what are the two causes? Chronic hepatitis B virus, you can write like this, chronic hepatitis B virus, and malignancy. Which malignancy? Hairy cell leukemia is the malignancy. Let us discuss this in a scenario format, one by one. So first of all, we'll be starting with first scenario. Only the important scenarios I'm discussing. Scenarios which have not been asked in NEET PG or FMG, I am excluding them. The reason is very clear. We don't have the time. If you have time, more scenarios, more topics you should read. But these are the ones which have been asked in the previous year topics. So let us look at the first scenario. Examiner will say age more than 50 years, fever, high ESR and CRP. So something inflammatory. एक तरफ का unilateral severe headache will occur. There will be pain in the scalp. Even the overlying scalp will be painful. Claudication of jaw and tongue will occur. Very, very important. What is claudication? Pain on exertion is called as claudication. It is like angina. When you do exertion, you have chest pain. That is angina. So angina like pain in the calf muscle, in the skeletal muscle, in the smooth muscle, in jaw, in tongue, that is called as claudication. What it means is if somebody chews a lot, speaks a lot, there will be pain in the jaw and in the tongue. You take rest for some time, you take Maun Vrat for some time, the pain goes away. This is a very important phenomena. So claudication of jaw and tongue. And there will be, when you palpate, there will be a tender cord-like तार के जैसा vessel will be palpable on one side where the pain is happening. This is a patient of temporal arteritis. This is a patient of temporal arteritis. Temporal arteritis, right? Also known as, yes, giant cell arteritis. Giant cell arteritis. And what is the most common vessel involved? It is superficial temporal artery. Superficial temporal artery. Apart from that, it can involve the other branches of ECA. What is ECA? External carotid artery. Other branches of external carotid artery can be involved. There is a risk of developing blindness in these patients if involves the ophthalmic artery, because many of these branches of ophthalmic artery are end branches to the retina. And what is the treatment that we give? It requires biopsy. You will do biopsy, you will find inflammation and giant cell formation in the biopsy sample. Treatment in these patients. Drug of choice is prednisolone. Prednisolone. You can give a trial of methotrexate in them. The biological agent which is approved for use is tocilizumab. The biological agent which is approved for use is tocilizumab. Right, so this is the first scenario in vasculitis. Let's move further. Second scenario in vasculitis, age 30 to 50 year, female more than male. It is a younger age slightly. Loss of radial pulse or femoral pulse means a large vessel is getting occluded, and claudication occurs on arm and leg. Remember the keywords. This is very, very important. Claudication, see, headache and claudication of jaw and tongue is giant cell arteritis. It is temporal arteritis. Claudication of arm and leg means when you move the arm or when you move the leg, there is pain. You take rest, it goes away. And radial pulse and femoral pulse are missing on the affected side. It indicates a large vessel is getting obstructed. Subclavian arteries are getting obstructed. Aortic branches are getting affected. This is a patient with, what is the diagnosis? Yes, it is Takayasu arteritis. Takayasu arteritis, also known as aortoarteritis, because it involves the large aortic branches. It is also known as pulseless disease. Pulseless disease. What is the most common vessel involved? It most commonly involves the subclavian artery. Second, commonly, it involves the common carotid arteries. And thirdly, it can involve the descending aorta itself. This is the list based upon the table given in Harrison. What is the treatment? Obviously, the treatment will be steroids. And many patients, if the complete occlusion happens, you need to perform bypass surgery as well. So let's move further. Third scenario. This scenario is one of the favorites of FMG as well as NEET PG as well as INI set exam. So till you keep giving exam, this scenario and variations of this scenario will keep getting asked. Age 30 to 50 year, female more than male, granuloma formation is always there, and triad of three things. Upper respiratory involvement, for example, sinusitis, nasal polyp, otitis media, recurrent sore throat, upper respiratory involvement. Lower respiratory will also be involved. So pneumonia-like involvement, hemopsis, decreased SpO2, lower respiratory involvement. And third will be kidney involvement, glomerulonephritis, in bracket I'm writing acute nephritic syndrome. Acute nephritic syndrome. If you have a presentation like this, the patient is likely having GPA. What is GPA? It is granulomatosis with polyangiitis. Granulomatosis with polyangiitis. So granuloma formation will always occur. It was previously known as Wegener's granulomatosis, but this term is not used anymore because later on it was found that Wegener was a person who was involved in Nazi activities. Like, this is the theory, and so the name was changed. This is the more popular theory. The actual thing is they just changed the nomenclature of entire vasculitis. And so this was the new name given. And these patients, not all, but some patients can have, if you look at their oral cavity involvement, oral finding, you will find strawberry gingivitis. So strawberry gingivitis or strawberry gums will be seen in granulomatosis with polyangiitis. Which is the most common autoantibody involved? It is C-ANCA, which is found in a lot of these patients. C-ANCA positivity, MCQ. C-ANCA is also known as anti-PR3, proteinase 3 ANCA. This is the other name for these patients. So C-ANCA means cytoplasmic anti-neutrophil cytoplasmic antibody. It is also known as anti-PR3 ANCA, is the alternative name. Very, very important. And what is the treatment? What is the treatment in these patients? First line therapy. For induction of therapy, we start the patient on steroids with cyclophosphamide. Steroids with cyclophosphamide. Alternatively, if the patient is not responding, you can go for rituximab directly as well. And then for maintenance, see, maintenance के लिए steroid नहीं देंगे. You will be shifting the patient to MMF. You can shift the patient to azathioprine. They can use singly or in combination, or you can go for 6 monthly rituximab also. 6 monthly rituximab can also be tried in these patients. So there are a lot of questions asked on this, and some tricky questions are also asked. If you're active on the Telegram group, there was a ionized style question, modified ionized question on this particular thing I had posted some days back, and there is also an audio explanation. So once this class will be done, just have a look at that question and see if you can answer it correctly or not, right? So this is GPA, granulomatosis with polyangiitis. Now remember the important thing. If they say upper respiratory, lower respiratory and renal involvement, GPA. If they say no upper respiratory, no granuloma, but lower respiratory with nephritis, then it will go in favor of MPA, that is microscopic polyangiitis. So 30-year-old female presented with recurrent episodes. Now see the question, read the question. Recurrent epistaxis, rhinorrhea. So recurrent epistaxis and rhinorrhea, what does it indicate? Upper respiratory involvement. There is hemopsis with cavitary lesions in lungs, lower respiratory involvement. And what is the third thing we are seeing? Intermittent passage of cola-colored urine. Cola-colored urine is gross hematuria, renal involvement. So what is the likely diagnosis? 30 to 50-year female, triad completed. This is GPA. What antibody will help you in diagnosis? The answer is C-ANCA. C-ANCA. Okay, next question. Age 30 to 50-year, female more common than male. Now see the interesting thing. It is like GPA, but upper respiratory not involved, granuloma not seen. What is seen? Lower respiratory involvement in the form of hemopsis due to alveolar hemorrhage and glomerulonephritis. What do we call it as? We call it as quasi-immune glomerulonephritis. This is the picture fitting into MPA. What is MPA? Microscopic polyangiitis. Microscopic polyangiitis. So microscopic polyangiitis. What is the autoantibody seen in these patients? It is P-ANCA which is seen. P-ANCA which is seen. P-ANCA is perinuclear ANCA. It is also known as myeloperoxidase. These are the alternative names for the same autoantibody. ऐसा ना हो कि tomorrow they repeat the question and the name is changed, so you are unable to identify it. Why not GPA? Why not GPA? Because there is no granuloma and no upper respiratory involvement. Upper respiratory involvement in GPA is seen in 95 to 100% patients. Remember this. Upper respiratory is never involved in microscopic polyangiitis. And so you can easily rule it out. Treatment, good thing. Same for GPA. So whatever we did there is applicable here as well. Right? Let's go further. So age 30 to 50-year, female more than male. Now, asthma is there, eosinophilia is there. Granuloma formation is there and neuropathy is there. So small vessel vasculitis, where asthma is there, allergies are there, so eosinophilia will occur. Granuloma formation similar to GPA, but nerve involvement, which was not seen in the other two varieties. Which small vessel vasculitis has allergic tendencies with neuropathy along with vasculitis. It is EGPA. What is EGPA? Eosinophilia. Or eosinophilic granulomatosis with polyangiitis. With polyangiitis. What is the older name? It was also known as Churg-Strauss syndrome. Churg-Strauss syndrome. Autoantibody, here also P ANCA. So people will say, sir, how do we distinguish? Do biopsy. If you find granuloma, it was EGPA. If there is no granuloma, and then it goes in favor of MPA. If there is asthma and raised eosinophil, EGPA. If there is no asthma, no eosinophilia, but nephritis is there, it goes in favor of MPA. This is how you distinguish between them. I'll summarize. Treatment, again, is steroids. Treatment in these patients is steroids. Okay. So let us quickly revise here. Unilateral headache, cord-like palpable tender lesion, pain on movement in jaw and tongue. We call it as jaw and tongue claudication. Risk of blindness. What are we dealing with? Temporal arteritis. Okay. Superficial temporal artery is involved. If they say one side our pulse is missing, radial pulse or femoral pulse is missing, patient is having other constitutional symptoms and fever, etc. And patient is also having claudication of the limbs. The answer will be Takayasu arteritis. It will involve the subclavian artery and other aortic branches. If the question says small vessel vasculitis, look at the pattern. Triad of upper respiratory, lower respiratory, and renal involvement, it is GPA. Granuloma, always there. C ANCA is the antibody. P ANCA is positive in the other two variants. If there is GPA-like presentation, but no granuloma, no upper respiratory tract involvement, it is MPA. And if there is asthma with neuropathy, but renal involvement is plus minus, it is EGPA or Churg-Strauss syndrome. And our pharmacology one-liner, that Churg-Strauss syndrome can also be a side effect of a drug. It's a NEET PG pharmacology MCQ. Have you heard the drug Montelukast? So it is a side effect of Montelukast in some patients. So it's a pharmacology integration that we are doing. Right? Topic is done. Let's solve some MCQs. Rapid fire MCQs. NEET PG 24. 45-year-old male presented with fatigue, hemopsis, current HB8. Actually, this question came here, but bronchoalveolar lavage is red in color, serum creatinine 1.7. Biopsy revealed paucity of immune complexes. So there is lower respiratory tract involvement and glomerulonephritis in a middle-aged person. It can occur in males also, although females are more commonly affected. What are we dealing with? The patient is likely having microscopic polyangiitis. Why it is not Goodpasture syndrome? Goodpasture syndrome will have anti-glomerular basement membrane antibody and immune complex will be present there. Right? This is the topic we will discuss in a few minutes from now. So microscopic polyangiitis, C is your answer. FMG January 23. Female presented with difficulty in standing up from sitting position and combing her hair. There is proximal muscle weakness. She also has violaceous rash around the upper eyelids bilaterally. This was the typical rash occurring in dermatomyositis. What is the likely diagnosis? Postmenopausal female, knee pain, joint aspiration revealed. See, now people will say, sir, knee mein ho raha hai. Knee can sometimes be. Although first metatarsophalangeal joint is most commonly involved, the important thing you have to look for, needle-shaped, negatively birefringent crystals in polarized microscopy. What is the likely diagnosis? These are MSU crystal. So what is the patient having? Gout is the diagnosis. Right, good. FMG January 23. 60-year-old male patient presented with throbbing unilateral headache, nodular thickening along the temporal artery, giant cells, granulomatous vasculitis present. What is the diagnosis? What is the diagnosis? This is temporal arteritis in the patient. Questions are looking easy because we have just done the topic. If you don't revise, the same questions will become tough in the actual exam. 30-year-old woman presented with slowly progressive dysphagia since past 1 year, no weight loss but has thickened leather-like skin and oral mucosa with hypertension. There is reduced exercise capacity due to lung fibrosis. So fibrosis happening, dysphagia happening, leather-like skin texture. What is it fitting into? Scleroderma is the likely possibility. So if you look at the buzzwords, keywords, read them well. These are all actual questions. So it is not that we are doing randomly. These are the previous year topics that I have selected for discussion in all these sessions. Just a sprinkling of NEET PG questions, just a sprinkling of updates of Harrison we are at. Okay, topic is done, system is done. Let us move into nephrology. Now, nephrology, less questions are asked from medicine directly. More questions are generally asked from pathology part. So pathology is more important in nephrology. But here some scenarios and some flowchart based approaches we will be forming. Let us start with nephrology. First of all, examiner will say there will be a case presentation which will be made. There is a spelling mistake here. They will say edema is present, but not on the entire body, face or around the orbit of the eye. So patient will come to you and he will say, when I'm getting up in the morning, I am finding my face is becoming puffy. The puffiness initially started around the orbit. It is more in the morning hours and it is gradually increasing. And my entire body, I feel it is becoming heavy. So this is edema starting from the face involving the entire body. And when he passes urine, urine is abnormally frothy. When you check urine protein is very high. Normally, you and me, we have zero protein. Okay, urine protein is negligible. In some patients, it can be 1 plus or 2 plus. We call it as mild. But if it is 3 plus or 4 plus, it is severe proteinuria, massive proteinuria. So edema on face, frothy urine, massive proteinuria. What is the likely diagnosis? You know the answer, absolutely right. We are dealing with nephrotic syndrome. Nephrotic syndrome. Let us do a rapid fire review of the clinical aspects of nephrotic syndrome. Now, nephrotic syndrome, what is the three important characteristics? What are the three important characteristics of nephrotic syndrome? First, these patients have massive proteinuria. Massive proteinuria. Second, these patients have edema. Edema typically occurs on the face or periorbital region. Later, it involves the entire body also. If you don't treat, obviously entire body will be involved. And thirdly, these patients will have hypoalbuminemia. What is hypoalbuminemia? Decreased serum albumin. These patients, they may or may not have two other characteristics. They may or may not have hyperlipidemia. Hyperlipidemia means the serum cholesterol in these patients, it is more than 200 milligram per deciliter. And they may or may not have hypercoagulability of blood. What is hypercoagulability of blood? They have increased risk of thrombosis. So these are the interesting things, important things related to nephrotic syndrome that you should know. Nephrotic syndrome, if you try to see, it is broadly of two types. We have primary nephrotic syndrome, also known as idiopathic nephrotic syndrome, where no cause is found. Idiopathic means just bad luck, it happened. And second is secondary nephrotic syndrome. It is secondary to something. Secondary can be drug induced, it can be SLE induced, it can be due to hepatitis B, hepatitis C, HIV, TB, UTI, anything can cause secondary nephrotic syndrome. Primary or idiopathic nephrotic syndrome is more common in children compared to adults, whereas secondary nephrotic syndrome is more common in adults compared to children. Primary or idiopathic nephrotic syndrome, there is generally no hematuria. There is no hematuria or hypertension. These patients have nephrotic with hematuria and hypertension. Primary, when you do biopsy of the kidney, if it is a child, you will find a disease known as minimal change disease. Why do we call it as minimal change? Because light microscopy is normal. Only on electron microscopy you find effacement of food process of photocyte. MCQs are asked in FMGE from pathology part and people jump and mark wrongly. देखो दो तरह के questions आएंगे. Two types of questions will be asked. If they say what is the light microscopic appearance, you will say normal glomerular, no change. That is why the name is minimal change. But when you do electron microscopy, changes will be present, and that is effacement of food process of podocyte. And if it is an adult, With primary nephrotic syndrome, the patient is likely to have FSGS, focal segmental glomerulosclerosis is the common biopsy finding you will see in these patients. Okay. What is about secondary nephrotic syndrome? The biopsy findings vary according to underlying cause. They vary according to underlying cause. What is the treatment in these patients? What is the response to therapy? Primary form shows good response to steroids. Secondary form shows variable response to steroids. Variable response means steroid response may come or it may not come. In primary nephrotic syndrome, the serum C3 level is always normal because C3 is not involved. Complement mediated damage is not happening. Here, serum C3 can be normal depending upon the cause, or it may be decreased. So some patients can have complement activation. Here you find selective proteinuria to be present. Selective proteinuria means only albumin is getting filtered. Albuminuria is happening. Here you find non-selective proteinuria to be present. This looks like a very simple flowchart to you, but trust me, this entire page, at least 4 to 5 previous year questions I have covered here. Statement based also, one-liner also, case scenario based also. If you will be solving your MCQs, pathology questions will also be solved. I'm not teaching pathology, but pathology questions in this will also be solved based upon this table. It's very, very important, right? What is the most common type of nephrotic syndrome in children? For quick revision, idiopathic, also called as primary form. Most common biopsy finding in childhood nephrotic syndrome, minimal change disease. I hope you know that minimal change disease is also known as null disease and lipoid nephrosis. These are the other names of the same condition. Most common type of nephrotic syndrome in adults, secondary nephrotic syndrome. If you do biopsy in nephrotic syndrome in adult, which pattern will be found? FSGS will be found. FSGS can occur in primary also in adults. It can occur in secondary also in adults. This is a FMGE MCQ. Which is the most common type of disease seen in age more than 60 year producing nephrotic or lymphoma leukemia patient developing nephrotic? Membranous nephropathy. Membranous nephropathy. What is the most common antibody? Very, very important. Potential MCQ. Which is the most common antibody which produces nephrotic syndrome in adults? There is an antibody known as anti-PLA2, phospholipase A2 antibody. It produces primary membranous glomerulonephritis. Very, very important. What is the most common nephrotic syndrome which is associated with hepatitis B virus? It is membranous nephropathy. But which is the most common variety associated with hepatitis C virus? MPGN. What is MPGN? Membranoproliferative glomerulonephritis. And most common associated with HIV, FSGS. Many of these points are Robbins points as well. And you will find them in FMG in the pathology part as well. Steroid resistance. Some patients will not respond to steroid. How do you define steroid resistance? MCQ. If you have given steroids daily in full dose for equal to or more than 6 weeks in children and equal to or more than 4 weeks in adults, we call it as steroid resistant nephrotic syndrome. Remember, the time to define nephrotic syndrome resistance is different in children, different in adults. What is the drug of choice in steroid resistant nephrotic syndrome? There are drugs known as calcineurin inhibitors. In calcineurin inhibitors, tacrolimus is the preferred agent. If not an option, your second answer will be cyclosporin. So pharmacology. Cyclophosphamide does not work in steroid resistant. Steroid resistant, only one drug works, calcineurin inhibitor. Cyclophosphamide, again I repeat, does not work in steroid resistant nephrotic syndrome. It's a common mistake you will find in many of the guidebooks and some of the free material roaming around on Telegram. Something which is free is not always correct, and something which is free is not always bad. There is always that middle ground. You need to be a bit skeptic sometimes. 18-year-old patient with an ASARCA is having proteinuria of 4.5 grams per day. Hyperlipidemia, hypoalbuminemia, recommended first line treatment. So massive proteinuria, hyperlipidemia, hypoalbuminemia, NSRCA means entire body is involved. It is nephrotic syndrome. What is the first line therapy in nephrotic syndrome? A, B, C, or D? The first line therapy is always prednisolone. Cyclophosphamide is not given. It is in the initial part. It is only given if steroid is not working, or more commonly, it is given when steroid is causing side effects, right? If resistance word is used, then you have to go for calcineurin inhibitor. Okay, that is the important thing you need to. So topic is done. Next scenario, it's again an easy topic. Cola colored urine, examiner will say it, or dark colored urine or gross hematuria. Cola colored, dark colored urine is indicating gross hematuria. There is periorbital edema, but it is not as prominent as nephrotic. Urine protein is it is there, but it is not massive. RBCs are present and oliguria hypertension are present. So remember, proteinuria, hematuria with oliguria, that is acute nephritic syndrome. Acute nephritic syndrome. Sometimes it is also known as glomerulonephritis. These two terms are interchangeably used. Glomerulonephritis. Acute nephritic syndrome or glomerulonephritis. Okay, when you do microscopy in these patients, urine microscopy, you will find RBC cast and dysmorphic RBCs. देखो अगर RBCs, if urine is red and there is hematuria, you need to see where the RBC is coming from. If RBC cast and dysmorphic RBCs are present, then it indicates glomerular origin of hematuria, and that will indicate acute nephritic syndrome. Okay, now acute nephritic syndrome, it is often triggered by infection. It is often triggered by infection. Membranous nephropathy is nephritic or nephrotic? Membranous nephropathy is nephrotic syndrome. Can it cause nephritic picture? Rarely, but it is generally considered to be nephrotic syndrome, right? So often triggered by infection, nephritic syndrome. Now, two types of cases you need to remember. Suppose a patient had infection, it can be skin infection or respiratory infection, and 1 to 5 days later, there is onset of the disease. The answer will be different. And if it occurs 1 to 3 weeks of sore throat and 2 to 6 weeks of pyoderma, the infection started. The onset, if it occurs like this, the answer will be different. If infection occurs and 1 to 5 days later nephritic syndrome starts, the likely diagnosis is IgA nephropathy. And if onset occurs about more than a week later, then it is post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis. IgA nephropathy will show mesangial deposits of immunoglobulin A, mesangial IgA deposits, whereas post-streptococcal glomerulonephritis will show subepithelial deposits. These deposits are called as humps. Can subendothelial deposit also occur? They can, but humps are typically produced due to subepithelial deposits. Both of them resolve with time, and post-streptococcal nephritis especially has a relatively better outcome. With supportive therapy alone, the patient will recover. Then next MCQ, rapid loss of renal function, AKI or oliguria happening. So rapid loss of renal function is happening. Biopsy shows crescent formation. This is the clinching clue. And electron microscopy shows rupture of glomerular basement membrane and proliferation of parietal membrane. My suggestion, when you are doing revision, ये जो बाकी के words mentioned है, even if you have known the answer, these words are important because you never know. In the actual exam, examiner may miss out the keyword, but he may mention other words. So all these words I have mentioned in this entire workbook, especially the ones in boxes, every single word is important. If you have a presentation like this, patient is likely having RPGN. RPGN. It is not MPGN, RPGN. What is RPGN? Rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis. It is also known as, yes, correct. It is Correct, Radha. Correct, Swami. It is crescentic glomerulonephritis. Other name is crescentic glomerulonephritis. Now, what are the types of RPGN? Now, these types are generally asked in pathology, but we will do a quick review here based upon what Harrison says. There are three types of RPGN which are described. The first variety is type 1 RPGN. It is also known as anti-GBM disease. Remember, I told you that if good pasture syndrome does not have lung involvement, only renal involvement, that is called as anti-GBM disease. So it is also, its another name is type 1 RPGN. Then we have type 2 variety. Type 2 variety is called as immune complex RPGN. So immune complexes are involved. And type 3 is called as quasi-immune RPGN. Quasi-immune means there is no immune complexes which are present. What are the conditions included here? This is seen in good pasture syndrome. This condition is seen in SLE, Hanoch-Schönlein purpura, and post-infectious glomerulonephritis. And type 3 variety, I told you, it occurs in MPA as well as GPA. In type 1 variety, there will be linear IgG and C3 deposits on the glomerular basement membrane. In type 2 variety, lumpy bumpy deposits will be present. Lumpy bumpy granular deposits will be seen. And in type 3, no immune deposits are seen. That is why the name is quasi-immune. No C3, no complement is getting activated in these patients. So this is based upon the table given in Harrison. It's important and they can help indirectly also if you get an MCQ on this. For those who are looking at their watch, when we will take the break, we will take the break. Don't worry. We are going fine without compromising any of the content we have planned. And we are also to the almost the last 5 pages of the class. So just a few more minutes and we will finish. So gross hematuria, cola colored urine, right? So hematuria is happening. There is mild to moderate proteinuria. Sensory neural deafness. So deafness is there and eyes are showing abnormality. Anterior lenticonus, anterior deformity of the lens of the eye. So eye involvement, ear involvement, and kidney involvement. This is a patient who's suffering from Alport syndrome. So what is the likely diagnosis? It is an inherited disorder known as Alport syndrome. So the diagnosis in the patient is Alport syndrome. What is the inheritance? X-linked inheritance is seen. This X-linked inheritance, it cannot be put directly into dominant versus recessive, and there are reasons for it. That is why Harrison and Robbins' new editions don't use the word dominant or recessive. They simply say X-linked inheritance is seen. It can occur sometimes in females also. Second common is autosomal recessive inheritance. Third common is autosomal dominant inheritance. If X-linked inheritance is involved, which is the most common gene it is involved? COL4A5 gene. COL4A5 gene means type 4 collagen is abnormal, alpha 5 chain is abnormal in these patients. Autosomal recessive, what is the gene involved? COL4A3 gene. And autosomal dominant inheritance, COL4A4 gene is involved. They all have abnormalities in which collagen? They have abnormalities in type 4 collagen. What will renal biopsy show? Renal biopsy shows basket weave appearance. Basket weave GBM. Why? Because there will be alternate thickening and thinning of glomerular basement membrane. That is, and this is a one-liner MCQ already in the previous year questions. Basket weave appearance. What is the drug of choice? First line agents are ACE inhibitors. They reduce proteinuria and control hypertension, which generally occurs in these patients. But there is a new drug which is available now. MCQ, potential MCQ. There is a drugs known as SGLT2 inhibitors. These drugs are more famously used for diabetes, type 2 diabetes, but they are useful in these patients also. There are two types of drugs where SGLT2 inhibitors are useful. Two types of drugs. One is canagliflozin, and second is rapagliflozin. So flozins are the agents which are useful here. So canagliflozin and rapagliflozin. Very, very important. SGLT2 inhibitors are useful in CKD, Alport syndrome, and also useful in FSGS patients. This is mentioned in New Harrison. It is a potential MCQ point. SGLT2 inhibitors are useful in all these conditions. So it's very, very important. I'm highlighting it here. Diagnosis everyone will make. These are the things. Pharmacology also, you can get a question on this. Next scenario. It's an easy one. We are on to AKI and CKD. In other words, we are on to the last two topics of nephrology. Don't try to run away. Acute kidney injury, previously called as acute renal failure. Rapid deterioration in renal function is acute kidney injury. Any one of the following, if it is present, we call it as AKI. First, if the rise in serum creatinine is equal to or more than 0.3 milligram per deciliter within 48 hours. That is first parameter. Second, if the serum creatinine is raised equal to or more than 1.5 times from baseline within 7 days, that is also acute kidney injury. And if there is a fall in urine output, that is oliguria, less than 0.5 ml per kg per hour for 6 hours or more, that is also a criteria. These are the criteria to define AKI. Any one out of these three criteria is fulfilled, we say नॉन डायबिटिक में तो हाइपोग्लाइसीमिया हो जाएगा, नो डॉक हाइपोग्लाइसीमिया नहीं होगा. And for that, you need to read the pharmacology of these drugs. We use them in low doses. And देखो हाइपोग्लाइसीमिया वही होता है जहां पर they are actually affecting the gluconeogenesis or similar conditions. Canagliflozins don't work like that. And that is why I would advise you read at least 2 hours only one topic, oral hypoglycemic drugs. It's very important and directly or indirectly asked in all competitive exams. So acute kidney injury, this is how you diagnose. Now, there is a classification known as KDIGO classification that we follow. KDIGO classification divides it into 3 stages, stage 1, 2, and 3, and 2 criteria are used, serum creatinine and urine output. So what is stage 1 acute kidney injury? If the serum creatinine rise is equal to or more than 0.3 milligram per deciliter, or it is between 1.5 to 1.9 times from baseline, you call it as stage 1. If it is between 2 to 2.9 times the baseline from the baseline value will be different for every patient. You need not remember the baseline value. And stage 3, if it is increased equal to or more than 3 times from baseline, or there is increase in serum creatinine, absolute value is equal to or more than 4 milligram per deciliter, or there is need for RRT. What is RRT? Renal replacement therapy, which is the technical name for dialysis. Or if the patient is having GFR, we write E, estimated GFR. There are formulas to calculate that. That is less than 35. Then we say serum creatinine stage 3. Stage 3 has 4 criteria. Common mistake we make, we remember only 1 or 2 criteria. Examiner knows this. Tomorrow he may put a question. Which of the following not compatible with stage 3 AKI, and we will be in a soup. So you have to remember them precisely. What about urine output? Urine output is easy to remember. Any urine output less than 0.5 ml per kg per hour for 6 to 12 hours, it is stage 1. So less than 0.5 ml per kg per hour for 6 to 12 hours. If the urine output is less than 0.5 ml per kg per hour for more than 12 hours, that will be stage 2. That will be stage 2. And third, stage 3, if it is less than 0.3 ml per kg per hour for equal to or more than 24 hours, or the patient is anuric for 12 hours, you call it as stage 3. Now, what are the types of AKI? Types of AKI. Types of AKI, there are 3 types of AKI depending upon the cause. Pre-renal, where the renal blood flow is compromised. Intrinsic renal, where the kidney damage to the parenchyma is happening. And post-renal, where obstruction is not causing urine to be go out of the body. So, what are the types of AKI? 3 varieties are there: pre-renal, renal, and post-renal. Pre-renal, the pathophysiology here is decreased renal blood flow. It occurs due to decreased renal blood flow. Pathophysiology here is renal parenchymal damage. Renal parenchymal damage. For example, ATN, acute tubular necrosis. And post-renal acute kidney injury, there will be obstruction to urine flow. That causes post-renal AKI. So some examples we will be writing. It's a long list, but we will only discuss the important points here. So pre-renal acute kidney injury will occur in dehydration or diarrhea. It will occur in patients with burns. It will occur in patients with shock. It will occur in patients with congestive cardiac failure, CCF. Renal acute kidney injury will occur in patients with ATN. ATN is acute tubular necrosis. You'll read about this in pathology. It will occur in glomerulonephritis. It will occur in drugs. It will occur with SLE. It will occur with prolonged pre-renal acute kidney injury. Prolonged pre-renal injury leads to renal acute kidney injury. And post-renal will occur due to stones in the urinary tract. It will occur due to strictures. It occurs due to BPH, benign prostatic hyperplasia. It occurs due to cervical cancer. And it can occur due to retroperitoneal fibrosis, a thing you read about in surgery class. Retroperitoneal fibrosis. Right. So, what is the treatment in pre-renal acute kidney injury? IV fluid bolus. Either normal saline or ringer lactate works like a charm. Here, treatment in these patients is treat the underlying cause. Underlying cause is treated. Plus, you give supportive therapy. And what is the treatment here? Catheterization to relieve the obstruction. Catheterization to relieve the obstruction. Catheterization to relieve the obstruction in the patient. And then there is a table on which question was asked in this FMG July 25. A lot of times people ask, see, जो मैंने causes लिखे हैं ये bare minimum causes हैं. These are just examples I'm writing. If you start reading, there will be about 25 to 30 causes for each. But you can't remember everything. Do eat what you can digest, read what you can revise, and what is relevant for the exam. Okay, so PYT, pre-renal versus renal acute kidney injury, Harrison table, you will write in bracket, question asked in July 25 FMG exam. There was a question asked on this. So look at these findings. It's a table you are supposed to mug up. How do you distinguish between pre-renal and oliguric acute renal injury or oliguric acute renal failure? In bracket, you will write renal, intrinsic renal. Many times you will find in your textbooks where they include the third one also, obstructive AKI also. If you have time, you can read that also. But I would suggest that close to the exam, when you have limited time, remove the third one. Only focus on these two. You have a higher chance of getting the answer correct. And in fact, Harrison does not even talk about obstructive cause much. So pre-renal versus intrinsic renal, how you are going to distinguish. The most important parameter is this parameter on which question was asked. Fractional excretion of sodium. How do you calculate? There is a formula for this given at the bottom. Urine sodium into plasma creatinine divided by plasma sodium into urine creatinine multiplied by 100. And if it is less than 1%, it is pre-renal acute kidney injury. If it is more than 2%, it is intrinsic renal acute kidney injury. Other are the values you are supposed to mug up, but this particular point is the most important thing on which question has been asked already. And let me tell you a historical fact. This has been asked not only now in FMG, it was asked in NEET PG when I was a student, when it was not called as NEET PG. The term NEET PG came in 2017. Before that, we had AIPGME. Same question, same examiner, name keeps on changing. So tomorrow, if National Board of Examination name changes, do you think they will change? They will not change. Similarly, the organizations remain the same, just the name change happens. So fractional excretion of sodium is the most important thing, and there was a question asked in my time as well. Whether I got it, I don't remember what was the question, which means that generally it was the correct answer. If you mark something wrong in actual paper, you will remember it lifelong. Let's go further. How to calculate GFR? There are numerical questions which are asked on this, and sometimes simple one-liner variations also asked on this. Schwartz formula was asked 2 times in the recent papers, once in NEET PG, once in INI set. It has not been asked in FMG. Can it be asked in FMG? The only logical reason is yes, they can repeat it and put it there. So Schwartz formula says, if you have to calculate GFR, we call it as eGFR, the formula is K multiplied by height taken in centimeter, divided by serum creatinine, that is milligram per deciliter. And K is a constant. The value of K is 0.413. This is the formula. You have remembered a lot of formulas in your school time. Again, some time to remember the formula. This is the first formula. But in adults, we don't follow this formula. Adults, we follow Cockcroft-Gault formula. And this formula says that for calculating GFR, for calculating eGFR, you will be using this formula. Children are simple, adults are complex, so formula becomes complex. 140 minus age, whatever is the age in years, multiplied by weight, divided by serum creatinine, multiplied by 72. This is the estimated GFR in males. What about females? Bracket you would write in female patient. You multiply this, whatever result you get, by 0.85. Because females have slightly lower value compared to males. End of the day, there is no logic here. You have to mug it up. Now, what about CKD? CKD stands for chronic kidney disease, where the estimated GFR is progressively going low. We call it as CKD. So, what is the staging of CKD? Look at this staging of CKD. Staging of CKD will tell you that any patient who's having estimated GFR 90 or higher, it is stage 1. If it is between 60 to 89, GFR ml per minute per 1.373 meter square, that unit will be written in the MCQ, stage 2. 3A 45 to 59, 3B 30 to 44, stage 4 15 to 29, and stage 5 less than 15. This stage 5 is also sometimes called as end stage renal disease. Now the kidney is not functioning. MCQ one-liner, absolute indication for dialysis in CKD. One-liner MCQ, uremic pericarditis. So urea and creatinine is so high, it is causing cardiac toxicity. That is called as uremic pericarditis. Absolute indication to do dialysis in the patient. I told you dialysis is also known as, renal replacement therapy. It is also known as renal replacement therapy. Now, approach to tubular disorders. Now, sometimes question will be asked about tubular disorder. Now, how the examiner will put a question, examiner will say, there is a patient who's having polyuria polydipsia. See, kidney has, the functional unit of kidney is nephron. Nephron has two parts, glomerulus and tubule. What is the function of glomerulus? To filter. What is the function of tubule? To absorb. If tubule is not functioning, what will happen? Absorptive function will go away and there will be large losses of urine. That is called as polyuria polydipsia. Polydipsia is increased thirst to compensate for that. So polyuria polydipsia can occur in diabetes, but examiner will tell you polyuria is there, polydipsia is there, but diabetes mellitus and diabetes insipidus are ruled out. How would you approach? So there is an approach for this. Immediately do ABG in the patient. This scenario will work in some of the tougher questions when you solve them. So when you do ABG, there will be two possibility. Either patient is having metabolic alkalosis or patient is having metabolic acidosis. Metabolic acidosis. If it is metabolic acidosis, there are two possibilities. Either we are dealing with RTA. What is RTA? Renal tubular acidosis. I'm writing in the bracket, renal tubular acidosis. Or there can be a syndrome known as Gordon syndrome. Gordon syndrome patient will always have hypertension. Hypertension will be the clue. If it is metabolic alkalosis, you look at the BP. If there is normal BP versus hypertension. If hypertension is present, it is likely to be a syndrome known as Liddle syndrome. If it is normal BP, you further see. If they say facial abnormalities, so facial dysmorphism is there, sensory neural hearing loss is there, increased prostaglandin levels, PGE2, but not increased PGE2 and increased urine calcium. Increased urine calcium means hypercalciuria. The likely diagnosis in the patient will be Bartter syndrome. Bartter syndrome. Bartter syndrome. And if the patient is having no facial dysmorphism, hypomagnesemia, decreased magnesium level, hypocalciuria, that is decreased urine calcium excretion, and a milder disease, the patient is having a syndrome known as Gittelman syndrome. The diagnosis in the patient will be Gittelman syndrome. Now, exact recall is not there. Many of the students who sat in July exam, if someone has sat, they can tell better. Ki, sir, there was a long question, 4 line long. It had all these features like hypomagnesemia, sensory neural hearing loss, facial abnormality, and polyuria polydipsia mentioned. They were asking the diagnosis. Now, what the question was, I have no idea, but this flowchart works like a charm. There have been questions asked on this in NEET PG. That is about the topic of tubular disorders. Miscellaneous scenario. Similar question asked in January 25 as well as July 25. Examiner will say, post-burn patient, post-electric injury patient, post-trauma patient presents with red-colored urine. What is likely? If post-burn, post-trauma, post-electric injury patient is presenting with red-colored urine, there are two possibilities. Either it is gross hematuria or it is myoglobinuria. Myoglobinuria. Gross hematuria will require supportive therapy, whereas myoglobinuria can cause acute tubular necrosis. They require admission, start IV fluids, and watch for acute kidney injury. And in the MCQ, which was asked in July 25, students said myoglobinuria was in the option. One version of the question says RBCs were negative. If RBC is negative, then you can be sure the answer is always myoglobinuria. Now, as I said, we will be taking up these three segments here. We'll be taking up CVS, neurology, and endocrinology. Hematology, number one, there is a lot of integration with pathology, plus some scenarios are relevant. Okay, so let us start with the discussion. After this initial things, let us start with cardiovascular system. Cardiovascular system is huge, but there are certain trends you can find in cardiovascular system. Close to the exam, areas to focus on in cardiovascular system, you have acute rheumatic fever and rheumatic heart disease, which are important. Particularly, mitral stenosis is one of the favorite of examiners these days. Second is pulmonary embolism, which we have already covered in the pulmo part. Third is ECG findings. They will give an ECG and ask you details related to it. So ECG related diagnosis and next step in management. Fourthly, they will be asking questions on acute coronary syndrome, that is MI, unstable angina, non-ST elevation MI, details of these. They will ask you on questions on JVP, and they will be asking you to distinguish between constrictive pericarditis versus cardiac tamponade. So these are the areas you have to focus on. And if time permits, plus minus, you can have a look at infective endocarditis, you can have a look at cardiomyopathy, and you can have a look at pericarditis. These are plus minus topics. If I am a serious aspirant for cardiology part of medicine, you will find that at least 3 to 4 questions from these topics which I mentioned are bare minimum at least asked. Try to think like this. Entire anesthesia or an entire dermatology gives you 4 to 5 questions. Similar number of questions generally are asked from these particular topics. Again, cardiology is tough. Cardiology is something we cannot do in one day. Even if the entire day is available, still we will try our best to cover the maximum ground possible. And I'm assuming that most of you have done and you are thorough with at least the basics of physiology and basics about the disease already. So let us start. When I said HOC cardiomyopathy, it includes HOCM as well. Okay, so let us start with the discussion. First of all, I'll be starting with acute rheumatic fever. Acute rheumatic fever is a topic which falls between the gap. What is falling between the gap? Pediatricians will think medicine person will teach. Medicine persons will say, we will teach RHD, rheumatic fever to बच्चों में होता है. You must have been taught in pediatrics. This topic gets isolated and then it gets asked in exam. Acute rheumatic fever question asked in FMG July 25. Question asked in NEET PG 24 last year and INI set November 25 this year as well. And there were multiple correct options in the INI set question. What it means is rheumatic fever is on the radar of examiner, something from which is likely to be asked. And because many of you don't read this topic properly, I will go fast, but I will try to cover a lot of ground in this topic. So what is acute rheumatic fever? So let us start with acute rheumatic fever. What is the age in which rheumatic fever is important? First, let me tell you a simple thing. In simple words, then we will write the key points. Normally, suppose I am a child, age 7 or 8 years. I get a streptococcal infection and my body will try to fight against the infection. How? It will form antibodies. These antibodies will bind the antigen of streptococcus and normally they will be removed from my body. The immune cells will take care that they don't circulate. Now imagine they are not getting removed and they are persisting in the body. Now, what will happen is this persistent reaction will lead to autoantibody kind of formation against the native antigens. In other words, there is a protein found in the outer layer of streptococcus called as M protein. Many times, the antibodies which are formed against M protein also, because they are not getting cleared from the body, they will cross react with similar tissues of our own system. In other words, let me make it even more simple. स्ट्रेप्टोकोक हिंदी में बोलता हूं पहले. स्ट्रेप्टोकोकस आया, एंटीबॉडी बनी. एंटीबॉडी ने स्ट्रेप्टोकोकस को तो मारा, लेकिन अगर वो एंटीबॉडी लंबे समय तक परसिस्ट करे तो अपने ही टिश्यू को मारने लग जाती है. उसको कहते हैं मॉलिक्यूलर मिमिक्री मैकेनिज्म. नाउ द इंग्लिश पार्ट. In streptococcal infection, sometimes the antibodies against M protein component of streptococcus, they persist longer and they start damaging the cardiac tissue, the joint tissue, and the skin antigen. The disease so arising because of that is called as rheumatic fever. And this mechanism is called as molecular mimicry. Right? So let us write down. So let us continue with the flow. Acute rheumatic fever. What is the age of the patient? Typically occurs between 5 to 15 years. Which gender is it more common? Which gender is it more common? It is more common in males. It is more common in males compared to females. India lies in high risk population. India lies in high risk areas or high prevalence area for rheumatic fever. What is the most common cause? Sore throat. or throat infection caused by group A beta hemolytic streptococci. Group A beta hemolytic streptococci. And there are specific M strains which are responsible for producing this. What is the name of the mechanism? The mechanism is known as, this is MCQ point. The mechanism is known as molecular mimicry. Molecular mimicry. How do you make the diagnosis? It is always a clinical diagnosis. Diagnosis is made clinically, supported by, I'm writing in brackets, supported by ECG and blood tests. So it is a clinical diagnosis supported by ECG and blood test. What is this mechanism? I'm writing on the side. This mechanism of molecular mimicry is also known as type 2 hypersensitivity reaction. Remember that streptococcal renal involvement. Remember we did the word PSGN. That was type 3 hypersensitivity. This is type 2 hypersensitivity. So you can write in the bracket or on the side that PSGN, post-streptococcal nephritis, is type 3 hypersensitivity reaction, whereas acute rheumatic fever is considered to be type 2 hypersensitivity reaction. For those who do not know or they might have forgotten, there are broadly 4 types of hypersensitivities. Type 1 is immediate. All the allergies, anaphylaxis is type 1. Asthma is type 1. Type 2 is antibody-dependent cellular toxicity. Rheumatic fever is that. Type 3 is immune complex deposition. So PSGN, Henoch-Schönlein purpura, they are all type 3 hypersensitivity. And type 4 is delayed hypersensitivity like you see in granuloma formation, like you see in tuberculosis patients, right? So streptococcus causes both type of reactions. Rheumatic fever is type 2 and renal involvement is type 3. Now, what is the modified Jones criteria, also called as revised Jones criteria? It was originally given in the 1940s and 50s, and it has been revised almost 6 to 7 times. Currently, we follow the 2015 criteria. This criteria says that the criteria remains the same in both low risk population and high risk population. LR population means low risk population. Low risk population. For example, United States of America. But slightly different criteria is used in moderate to high risk population, for example, India. Let us first look at what is happening in the United States. The criteria remains the same. So we have 5 major criteria and 4 minor criteria. Okay, what are the 5 major criteria? First is carditis. Carditis means heart involvement, heart inflammation. It can be symptomatic or it can be asymptomatic, means clinical or subclinical. Second is arthritis. Arthritis means joint swelling, redness, pain, inflammation, etc. That is called as arthritis. I'm highlighting this word. I will summarize in the end so you would understand why am I highlighting this. Polyarthritis only. At least 2 or more joints if they are involved. Only then we call it as a major criteria in low risk population. Third is chorea. What is chorea? Also called as Sydenham's chorea. Chorea is abnormal body movements. It is a CNS manifestation. Fourth is subcutaneous nodule, painless nodules which occur in the patient. So they are painless nodules. And fifth is erythema marginatum, which is a kind of rash. Erythema on the margin, center is clear. We call it as erythema marginatum. These are the 5 major criteria. Let us have a look what happens in high risk population like India. Let us go further. Then we will discuss minor separately. Look at this moderate to high risk population. Carditis was a criteria here. Carditis was a criteria here. Arthritis was a criteria there. Arthritis is a criteria here. But highlight this word. What is the difference? In low risk population like United States, only polyarthritis is considered a major criteria. Here, polyarthritis or monoarthritis or even multiple joints having pain without any inflammation, that is also considered to be major criteria. Chorea is criteria there, chorea is criteria here. Subcutaneous nodule there, subcutaneous nodule here. Erythema marginatum there, erythema marginatum here. So there are 5 major criteria in US also and in India also. What is the difference? In United States, only polyarthritis is considered a major criteria. In India, polyarthritis, monoarthritis or polyarthralgia, all 3 are considered criteria. Please put a Q here. because there are statement-based questions on this in NEET PG exam. How do major criteria differ in high-risk population like India compared to Western population? This is how they ask questions. Once you have understood, you will be able to answer in the exam. Actually, it is not tough. Once you will be doing revision, you will just be, just having a look at this highlighted part. But somebody should have told it to you that this is the way question can be asked in the exam. So I hope this funda is clear in your mind that in US only polyarthritis is a criteria. In India or in high risk population, what are the high risk population areas? The entire Southeast Asia is high risk population, right? So we all have rheumatic fever. So not just India, Sri Lanka, Nepal, Pakistan, Bangladesh, Afghanistan, Myanmar, all the way till Thailand. This is all the belt which we are seeing. This all belt, Cambodia, Laos, they are all high risk population. Okay. Now, what about minor criteria? Let's have a look at the minor. There are four minor. In United States, the first minor criteria is polyarthralgia, that is pain in the joint. But two or more joints should have pain. Highlight this word. Polyarthralgia is a minor criteria in US. Fever is a minor criteria, but what is the degree of fever? Highlighted more than 38.5. So high degree fever. Third is ESR more than 60 or CRP more than 3. Just you can remember the value ESR more than 60, CRP more than 3. Acute phase reactants should be high. Highlight this CRP also 60 is the value in US. And prolonged PR interval when you do ECG in the patient. So prolongation of PR interval. This particular thing was the INI set MCQ asked in November 25 exam. They had asked you to identify the incorrect statement. One of the statement was rheumatic fever patients have short PR interval. Wrong. Rheumatic fever patients have prolonged PR interval, and that was that was the answer. So I said November 25. Okay, so four minor criteria: polyarthralgia, fever, ESR CRP high, and prolonged PR interval. But ESR CRP, the ESR value is more than 60. Let us see what is happening in India in high risk population. In US, polyarthralgia was a minor criteria. Here, monoarthralgia is a minor criteria. So I'm highlighting it. On even a single joint having pain, we will consider as a minor criteria. Here, there is a typing error. There, fever more than 38.5 was the cutoff. Here, fever equal to or more than 38 is the cutoff. Cut this. Equal to more than 38 is the cutoff. And highlight this. During typing, sometimes errors can happen. Third, ESR and CRP was high there, ESR CRP high here. But what was the cutoff for ESR there? It was 60. Here in India, we follow the cutoff as 30. Prolonged PR interval there, prolonged PR interval, right? So this is the criteria. So major 5, minor 4. How do you make the diagnosis? Diagnosis of initial, now come here. Diagnosis of initial rheumatic fever is made if the patient is having two major manifestation or one major plus two minor criteria. And there should always be evidence of preceding group A streptococcal infection. Let us summarize it. What is the meaning? What it means is first episode of acute rheumatic fever is diagnosed if a patient has two major criteria or one major plus two minor criteria. Yes, Aziz, CRP is only 3. It is milligram per deciliter. Many times the values are measured in milligram per liter, then the values change. So it is more than 3 is the cutoff that we take, milligram per deciliter. So first episode ARF, 2 major or 1 major plus 2 minor in the presence of any evidence indicating group A streptococcal infection, that is considered to be acute rheumatic fever. For any relapse, the criteria becomes 2 major or 1 major plus 2 minor or 3 minor alone in the presence of any evidence of group A streptococcal infection, right? There should be past evidence of streptococcal infection. It could be anything. Some blood test, some antigen test, some streptozyme test, some throat swab culture, ASO titer, anything. right? These are the tests that you will be reading in microbiology class. So microbiology educator will be telling you about this. So this is the diagnostic criteria. Did you notice I spent full 8 minutes talking about it? The reason is there is a recent question on this, and fine points related to it are asked in the exam because examiners know people are reading rheumatic fever, but they are coming with a superficial knowledge. Five major, four minor, dekh lenge. They check whether you know the thing to be remembered, different in low risk and different in high risk population. It will require a bit of reading again after the class, but once you read it two times, even a leisurely reading like reading Harry Potter, it should be fine for you, right? I hope you will never get the answer wrong, at least in these rheumatic fever question. Let us move further. Talk about treatment of rheumatic fever. Diagnosis already made. How would you treat? Treatment is different from prophylaxis or prevention. The type of treatment given in these patients is called as immunosuppressive therapy. You are trying to suppress the inflammation. But we don't use the usual immunosuppressive agents. It is also sometimes called as immunosuppressive therapy. First thing you need to remember is duration of therapy is always 12 weeks. You don't give therapy beyond 12 weeks in the patient. Treatment में there is no role of benzathine penicillin G. This is the mistake people make. We don't use antibiotic for treatment. Antibiotics are for prevention. क्योंकि देखो जब तक वो होता है तब तक already infection has been taken care by the body. So you suppress the antibody formation. So duration is 12 weeks. If patient has carditis with congestive cardiac failure, the drug of choice will be prednisolone given for 12 weeks. If it is carditis without CCF, you will be giving prednisolone. But if you feel prednisolone does not work, you can use aspirin also. And it is always a high dose aspirin which is used. It is always high dose aspirin. Low dose aspirin is antiplatelet, antithrombotic. I told you this funda yesterday also. And third, if there is no carditis, other manifestations are there. Others are there. For example, arthritis is there. Then prednisolone is not indicated. You use only and only aspirin. But the duration of therapy will always be 12 weeks. There have been questions asked on this. And people get it wrong because they immediately see benzathine penicillin G market. Read the question. Are they asking treatment or are they asking prevention? Treatment, you give steroids or aspirin. Prevention, you give antibiotics. Right? So prevention is done by antibiotic prophylaxis. Prevention is done by antibiotic prophylaxis. What is the drug of choice? It is injection of benzathine penicillin G. They are given intramuscularly. Doses are there. You can remember the dose if you want, but those doses are not essential. They are given every 3 weeks. If the patient is having penicillin allergy, which is the agent you will be using? Either you can use macrolides like erythromycin, azithromycin, or you can go for sulfonamides. Either of the agents can be used. Right? So treatment के लिए different, prevention के लिए different. And then what is the duration? For how much time you will give prevention in the patient? This table will give you prevention or prophylaxis. So if there was rheumatic fever without carditis, the duration of prophylaxis will be 5 years after the last attack or 21 years of age, whichever is longer. Rheumatic fever with carditis, but no residual valvular disease. There was heart involvement, but no permanent damage to the heart valve happened. You will give for 10 years or till 21 years of age, whichever comes later. And if there is persistent valvular disease, suppose patient has developed mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, echo is abnormal persistently, you will give for 10 years or 40 years of age, whichever is longer. Sometimes lifelong prophylaxis is recommended. They will give a quick case scenario on this. There have been questions asked on this. They will say, a patient got rheumatic fever. This is the current age. This was the feature. Carditis present, carditis absent, whatever they will mention. And they will ask, what shall be the duration of prophylaxis? This is the topic where MCQ solving is paramount important. Because if you don't solve MCQ, you will not get that confidence ki, ha, question came and I was able to answer based upon the table. First thing is ratifying, mugging up the table. Second part is practicing it in MCQ. Anything goes wrong, read the table again, you will never forget. So this is rheumatic fever. I hope this is clear. Okay. So let us come to one-liners now. Let us do a rapid fire one-liner discussion. Most common manifestation in the Western world. In rheumatic fever के questions है. World West में सबसे common क्या है? Arthritis. High risk population इंडिया में सबसे common क्या है? Carditis. देखो 5 क्राइटेरिया है ना, तो इंडिया में सबसे कॉमन इज कार्डाइटिस. यू कैन रिमेंबर लाइक दिस. हम लोग थोड़े इमोशनल होते हैं, तो हार्ट कमजोर होता है, जल्दी इन्फ्लेम होता है. इट्स अ स्टूपिड वे टू रिमेंबर, बट यू कैन रिमेंबर लाइक दिस, दैट कार्डाइटिस इज मोर कॉमन इन इंडियन rheumatic fever. Rare manifestation, erythema marginatum. Because we are brown people, our skin color is brown, and so erythema marginatum is not always visible. Erythema marginatum generally more commonly seen in the fair skin. Even small amount of melanin can sometimes obscure faint erythema marginatum. Late manifestation, which occurs many months after rheumatic fever, is chorea. Sometimes chorea comes by that time already rheumatic fever has been taken care by the body. Type of carditis in rheumatic fever, pancarditis. Pancarditis means all the three types of carditis are seen. There is pericarditis, there is myocarditis, and there is endocarditis. Among them, which is the one which is more severe? Generally, endocarditis is severe involved because endocardium is covering the heart valve, and endocardial involvement will lead to damage to the heart valve also. So all the three can occur. But which is the one which is severe and contributes to long-term morbidity? Endocarditis. And I'm highlighting it here. You can get a MCQ on this particular point. Now, if you do myocarditis, what will you find? On myocarditis, you will find special nodules known as Ashkoff nodules. Ashkoff nodules is a pathology thing. This is already, it is a previous year question in pathology pond that you will see. Murmur in rheumatic fever. There is a murmur known as Carey-Coombs murmur. Carey and Coombs, two people described. Carey-Coombs murmur. It is a diastolic rumbling murmur. It is a diastolic rumbling murmur. Most common valve involved in rheumatic fever is mitral valve. Which valve is never involved? Pulmonary valve is never involved. So you can remember the sequence of valvular involvement like this. The sequence of valvular involvement is mitral, followed by aortic, followed by tricuspid, followed by pulmonary. Remember, in acute rheumatic fever, regurgitation is more common. Whereas in RHD, rheumatic heart disease, once permanent damage has happened, then stenosis is more common. Stenosis is. Let's move to the next thing. Mitral stenosis. Mitral stenosis, as I said, it's a hot topic right now. So narrowing of the mitral valve is mitral stenosis. It can be congenital mitral stenosis, which presents in the first 5 years of life. It can be acquired mitral stenosis. Acquired one generally occurs as a sequence, as a consequence of rheumatic fever and rheumatic heart disease. Now, what is the normal mitral valve diameter? There is a lot of controversy here. So normal mitral valve diameter is between 4 to 6 centimeters square. If it is less than 2 centimeters square, it is called as mitral stenosis. So normal is different and area to decide narrowing is different. If it is less than 1.5 centimeter square, we call it as severe MS. Some people say that it is less than 1 centimeter. That is also mentioned in some few textbooks, but we have to go by what are the current echocardiographic criteria. And these are the values which are given in American Heart Association AHA publication. So we are going with that. If the patient of ASD is having mitral stenosis together, that is called as a syndrome known as Lutum-Bacher syndrome. Lutum-Bacher syndrome. Lutum-Bacher syndrome. Now, what are the findings that you will be see in a patient of mitral stenosis? This is the point on which maximum MCQs have been asked. First of all, when you do auscultation in these patients, see, clinical features are very non-specific. They are very difficult to distinguish. Symptoms are very difficult to distinguish from any other cardiac lesion. They may have features of dyspnea, cyanosis. They may have not cyanosis, sorry, dyspnea, CCF, fatigue. Those kind of symptoms can be there. Many times it is asymptomatic. When you do auscultation, first of all, you will find the first heart sound is loud, also written as accentuated. It is loud or it is accentuated. Second, second heart sound. Second heart sound may be normal or it may have a loud P2 component, either normal or loud P2. But the hallmark of the disease, hallmark means something which is always present, that is abnormal sound present after S2. We call it as opening snap. It resembles S3, but with experience, you will learn that it is a different heart sound, opening snap. It is a high pitched sound which occurs after S2. So, opening snap is also written as OS. And a very, very important point, A2OS gap. A2OS gap means the gap between the second heart sound aortic component and the opening snap. It is inversely proportional to degree of mitral stenosis. Gap increases, MS is mild. Gap decreases, MS is severe. So it is inversely proportional to degree of MS. It is a statement-based question which has been asked in the exam. Opening snap is present. And what is the type of murmur which can be seen? Can a murmur occur? Yes, there can be a low-pitched rumbling diastolic murmur can occur in these patients. Low-pitched rumbling diastolic murmur can occur at the apex. These findings are extremely important. Now, what you will see in chest X-ray features of these patients. Chest X-ray feature, first feature will be left atrial enlargement. So there will be left atrial enlargement. Left atrial enlargement is the characteristic finding which is seen. Left atrial enlargement can lead to straightening of the heart border. It can lead to straightening of the heart border, and sometimes it can produce a sign known as double density sign. Double density sign is the sign which can be produced due to left atrial enlargement. Secondly, these patients can have a prominent main pulmonary artery. PA is pulmonary artery, prominent main pulmonary artery. Third, these patients can have posterior displacement of the esophagus, although it may not be easily appreciated on a PA view of X-ray, posterior displacement of esophagus. And fourthly, in long-standing or severe cases, in severe MS, there will be features of pulmonary hypertension. So pulmonary hypertension features will appear in the patient. So pulmonary hypertension features will appear in the patient. Now, what is the treatment that we are going to do? Treatment part is interesting. If it is mild to moderate MS, then you will give medical therapy, symptomatic therapy for the symptoms will be given. But if it is severe mitral stenosis, the first line therapy these days is a procedure known as PMBV. What is PMBV? Percutaneous mitral balloon valvuloplasty. Basically, we don't do open surgery. So it is a relatively less invasive way. We pass a catheter through a femoral vein or through the subclavian vein, reach till the mitral valve, and we try to dilate using a balloon. We open it, inflate it, and try to dilate the stenosis. That is PMBV. However, PMBV is contraindicated if there is left atrial thrombus or if there is some coexisting abnormality. So if PMBV fails or it is contraindicated due to some other reason, then you have to do mitral valve replacement. Mitral valve replacement. And this particular thing is important NEET PG questions have been asked on the treatment part. So this is mitral stenosis. I've gone slow, but I've tried to cover what the bare minimum important things that you need. Now let us move over to some ECG scenario and related points we will be doing in a rapid fire. Photograph, what is to be seen, what all can be asked, what is the treatment. That is how we will be proceeding. So let us start. Sorry, there is aortic regurgitation also. Then we go for ECG pattern. Really sorry. Aortic regurgitation, what are the signs? Occasionally, the signs are asked in the exam. There was an MCQ asked in the exam where they said, all of the following are signs of aortic regurgitation except. Now, aortic regurgitation again is a feature of RHD. RHD is the common cause which can cause it. Aortic regurgitation, there are some signs. First of all, we have the Corrigan's pulse. What is Corrigan's pulse? There will be rapid and forceful distension of arterial pulse with quick collapse. Hits hard and then goes back fast. That kind of pulse is Corrigan's pulse. What is de Musset sign? We don't call it as de Musset, de Musset sign. If you observe these patients in a large AR, there will be subtle head bobbing happening. That head bobbing is called as de Musset sign. Then Muller sign is you examine the oral cavity with a torch. Ask the patient to open the mouth and look at the uvula. Uvula is present at the back of the throat. There will be pulsations present in the uvula. That is called as Muller sign. Then we have Quincke sign. In Quincke sign, there will be nail bed. When you compress it, you will find that you can do one thing. When you compress your nail bed, the nail bed becomes the distal part becomes white and the proximal part is pink, right? Can you see any vessels? No. But in patients with aortic regurgitation, on the nail bed where this, semilunar thing is there, you will find dilated vessels to be present or pulsations to be present where the skin part is attached. So small pulsations will start happening there. So these capillary pulsations, they are better seen than felt. They are Quincke sign. Then systolic and diastolic pistol short femorals, that is pistol short sound will be heard over femoral artery when you do auscultation, Probe sign. What is Durosia sign? Bruise will be heard over the femoral artery. And finally, Hill sign. You see the gap in the BP between lower limb and upper limb. See, in coarctation of aorta, the upper limb BP is more, lower limb BP is less. Here, reverse happens. The lower limb BP is more, upper limb BP is less. And the difference between them is 60 millimeters of mercury. Remember, the upper limb BP is on the lower side and lower limb BP is on the higher side in these patients in aortic regurgitation. And the difference between them, if it is 60 or more, that sign is known as Hill sign. Right? So these are some of the named signs. This table I've taken directly from a textbook. It is there in the Google images as well. So this is important and they are asked. What are the things on which question has been asked? Hill sign has been asked and Muller sign have been asked. So if nothing else, at least the previous year topic and previous year question one-liner, you have to remember. Now let us start with abnormal ECG. Look at this ECG pattern. They will not give you a random ECG. There will always be a history or something mentioned alongside. Those who have sit in the exam, they know. They mention a one line and then they mention ECG. At least they mention risk factor or age of the patient. Now they will say there is a patient with, look at these patterns. They will say patient with acute kidney injury, yeah, chronic renal disease, chronic kidney disease, or acidosis patient, or tissue injury patient is having ECG abnormality as shown. What is the likely diagnosis? AKI, CKD, acidosis, tissue injury, all four conditions predispose the patient to hyperkalemia. With this in mind, V4, V5, V6 leads we see. What is happening here? This is your P wave. This is your QRS complex. And look at the T wave. The T wave is large. Giant T waves are present. Giant T waves, tall T waves, peaked T waves, if they are present. What is the likely diagnosis? The patient is suffering from. What is the likely diagnosis? The diagnosis is hyperkalemia. Absolutely right, Edwin. Hyperkalemia is the answer. What is hyperkalemia? When the serum potassium becomes greater than 5.5 millicoulomb per liter, that is called as hyperkalemia. What are the signs of hyperkalemia on ECG? I'm writing it here. I'm writing it here in this part because there is no space. Originally I had kept some space. So the ECG findings of hyperkalemia, there will be peak or tall T waves. That is an early sign. Then there will be widening of PR interval as well as widening of the QR interval. And later on, these patients will develop loss of P waves. But loss of P waves generally occurs late or in severe hyperkalemia. This is the sequence which occurs that you need to know. The sequence is also important. It is a NEET PG MCQ. This is the sequence that you are supposed to know. What is the management that you are going to do in the patient? Now, management of hyperkalemia has been asked 4 to 5 times in FMG exam already, and still people get it wrong. Let us do a quick fire management. Patient with hyperkalemia comes to you. What is the first step in management? Hyperkalemia can cause life-threatening arrhythmia. So our first thing is save the life. Potassium value we will manage later. First is save the life. So you stabilize the cardiac membrane so that arrhythmia does not happen. So first step is stabilize the cardiac membrane. And how do you stabilize the cardiac membrane? It is done by IV calcium gluconate. Doses they will not ask. IV calcium gluconate. That is always the first step in management. Good, absolutely right. After taking first step, after giving calcium gluconate, start with the second step. As a second step, you will try to reduce the serum potassium levels. You will reduce the serum potassium levels. How do you reduce serum potassium level? First thing, we start two things together. We do two things together. We start the patient on IV dextrose along with IV insulin infusion. IV dextrose and insulin, not given as bolus, started as infusion, and you need to monitor the blood glucose as well. Simultaneously, you nebulize the patient with salbutamol. Salbutamol is a beta agonist. Due to beta agonist action, it causes inward movement of potassium inside the cell. It also takes care of acidosis because acidosis can worsen the patient. Salbutamol helps indirectly without giving bicarbonate. Some degree of acidosis is also corrected in these patients. So nebulize with salbutamol. Salbutamol is also known as albuterol. If this is not working, as the second step, you will go for sodium bicarbonate. Second step, you will go for sodium bicarbonate. Remember that sodium bicarbonate is never the initial step, and generally the world is moving away from sodium bicarbonate. I'll write like this. Many of you might have forgotten the symbol of sodium. So sodium bicarbonate is given. It is given only in acidosis patient. If acidosis is persisting, that will not allow hyperkalemia to improve. And if still not improving, you can consider loop diuretics or hemodialysis. That is, renal replacement therapy can be tried. This is the management of hyperkalemia. Remember that potassium binding resins do not have a role in acute management. They are useful in CKD patient, but they do not have a role in the acute management of the patient. Right? So, yes, insulin, this insulin, when we say insulin, we are talking about regular insulin. Okay, this is the nomenclature we follow. So regular insulin is the one which we are using. Okay, first topic, identification done. What else can be asked? NEET PG MCQ covered, and management related questions which are asked in FMG covered. Let's go to the second one. There is a patient who has history of starvation, alkalosis. Acidosis causes hyperkalemia. Alkalosis causes hypokalemia. Dehydration and drug intake. Many drugs have a tendency to cause hypokalemia. ECG is as shown. Now in this ECG, what you can see? You will see that the T wave is not tall. T wave is either flat or it has inverted. Here inversion of T wave has happened. And after T wave, an abnormal U wave is happening. Between T and P wave, you have an abnormal wave. We call it as U wave appearing. Either flattening of T wave or inversing of T wave with a U wave in a patient with risk factor. The likely diagnosis in the patient is hypokalemia. So patient is having hypokalemia. What is definition of hypokalemia? Serum potassium less than 3.5 milliequivalent per liter. Serum potassium less than 3.5 milliequivalent per liter. Now, what are the ECG findings that you will see in these patients? So I'm writing on the next page, ECG findings. ECG findings of hypokalemia. ECG findings, early sign will be T wave flattens. First of all, T wave will flatten. Then patient will have T wave inversion. And when T wave inverts, only then patient will have abnormal wave known as U wave appearing. Apart from that, what are the other ECG changes which can happen? These patients can have prolonged PR interval, and they can also have ST segment depression. ST segment depression can also occur in the patient. So these are the other findings. They have not been asked, but because hyperkalemia, other ECG changes have been asked, so we have to remember these changes as well. Now, what is the management? Contrary to popular perception, hypokalemia is always measured more conservatively because giving potassium actually is problematic. Sudden potassium given IV can induce arrhythmias. So we always start with oral potassium supplementation. So oral KCl is always the preferred way, is always the best way. And how much we give? We add to IV. We give the maximum amount of KCl that is given is equal to or less than 200 milliequivalents of KCl of potassium in 24 hours. So the amount of potassium given is equal to or less than 200 milliequivalent of potassium in 24 hours. And we monitor for hypomagnesemia as well, because many patients can have associated hypomagnesemia as well. And there is an indirect MCQ asked on this already. The question is something like this. Listen to the question. It's a pediatric question. There is a severe acute malnourished child who presented with diarrhea. The patient was managed for dehydration, but ECG revealed hypokalemia, which was corrected. However, muscle weakness is persisting in the patient. What other abnormality should be looked out for and corrected in the patient? The options were hyponatremia, hypernatremia. See, they would have already been corrected now because potassium correction we are doing very slowly. So which other thing can mimic and can lead to persistence of symptoms? And you need to watch it out for hypomagnesemia. And that is the answer. So there is an indirect MCQ already asked on this. Mechanisms, again, not needed from exam perspective. There are mechanisms, you can always reach out if you want, but not needed close to the exam. Right? Topic is done. Let's move further. Third scenario. What are you looking at in the third scenario? In the third scenario, there is a abnormal thing happening. There is a, look at this. There is a P wave, there is a QRS complex, and what has happened here? Can you see that there is something wrong? There is something wrong happening here. Some wave is happening close to this wave. What is this wave known as? Yes, this is the wave which is appearing. This wave which is appearing, this T wave is a bit delayed. Any wave which is present just after the QRS complex is over and forming a small, this point is called as the J point. This is also called as a J point wave. This is called as Osborn wave and it is indicative of hypothermia in the patient. So this is a Osborn wave. So label the image Osborn wave. What is Osborn wave? It is a small positive wave which is present at the J point on ECG. What is J point? J point is the point where QRS complex ends and ST segment begins. So that point is called as J point. And what is the most common cause of Osborn wave? It is seen in severe hypothermia. It is seen in severe hypothermia. Can it occur in other conditions? Yes, it can occur in hypocalcemia also. So hypocalcemia can also produce a Osborn wave in the patient. Let's move further. Now, this is a scenario which has been asked 2 times in INI CT also and once in FMG exam as well. So actually, I should be putting 3 questions on this. So there is a patient who presented with palpitation. Palpitation is a symptom. Patient feels, the beat in his chest. There is a, normally your heart is beating, but you don't feel it. When you feel, that is palpitation. And irregular pulse. This is a very, very important clue. There are very few causes of irregularly irregular pulse. When you look at ECG, what is the finding that you are seeing? You will find, first of all, there are narrow complex QRS in the patient. So these are all narrow QRS complexes which are forming. And there is absence of P waves. And there is a baseline which is fibrillating. Can you see this fibrillation of the baseline? And the frequency is variable. This is all fitting into a diagnosis of, absolutely right, atrial fibrillation. So the likely diagnosis in the patient, look at this photograph, we will label it. This is the patient with atrial fibrillation. The diagnosis is atrial fibrillation. Why do I say this is atrial fibrillation? देखो अभी तो आप सुन लोगे. Many of you are young MBBS students who are listening to this for the first time. Many of these things will make sense much later when you read in detail. But why am I saying this is atrial fibrillation? Pehla clue is irregularly irregular pulse. Watch out for this word. Second, in this patient, there is narrow QRS complex. Can you see any P wave? The P waves are hardly visible. So P waves are not clearly seen. And third, there is a undulating baseline. So baseline is showing fibrillations. Baseline is undulating, it is showing fibrillations. That is why we call it as atrial fibrillation. Okay. Now, what is the management that we are going to do? Management is important. Management is divided into two parts. First thing, any atrial fibrillation patient comes to you, two possibilities are there. First possibility, the patient is hemodynamically stable. There is no shock. Many patients present in shock. So hemodynamically stable patient. And the duration of atrial fibrillation is less than 48 hours. It has been recent onset atrial fibrillation. In these patients, the therapy of choice, this is a previous year FMG question already. The therapy of choice will be cardioversion. You will be doing cardioversion. Absolutely right, Edwin Shaju. Cardioversion. Two types of cardioversions you can do. Either you can go for electrical cardioversion. It is also called as DC cardioversion. Or you can go for drug-induced cardioversion. Drug-induced cardioversion, the drug used for this is ibutylide. Ibutylide is the drug which is preferred. It is a class 3 antiarrhythmic agent. Class 3 antiarrhythmic agent. On the other hand, if the patient is hemodynamically, see, this is unstable patient, Hemodynamically unstable, you have to give shock. If the patient is hemodynamically stable, or the patient has already adjusted, he's adapting, the duration of atrial fibrillation is equal to or more than 48 hours. Then there are two problems. First of all, the response to cardioversion may not be adequate. Secondly, you need to provide anticoagulation because they may already have a thrombus formation happening in the atria, and that can cause embolism. So if it is hemodynamically stable or duration more than 48 hours, the first thing to do is do the rate control. Control the rate of the patient. The heart rate is very high, so control the rate. What is the heart rate in these patients? It is quite high. It is somewhere around 160 per minute. So you will control the rate. The drug of choice for these patients is short-acting beta blocker like Asmolol. 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 Okay. And after controlling the rate, if beta blocker is not possible, second possibility, you can go for calcium channel blockers like verapamil as well. After the rate has been controlled, as a second step, you will add anticoagulation in the patient. You will do anticoagulation in the patient. Anticoagulation in the patient. Generally, warfarin is preferred if there is a patient with underlying RHD or MS patient. So any rheumatic heart disease or mitral stenosis patient with atrial fibrillation, warfarin is used. But in the other agents, in the other conditions, you can go for apixaban. Apixaban or dabigatran. Dabigatran in case of other causes or unknown causes of atrial fibrillation. Atrial fibrillation. And lastly, once anticoagulation has been maintained, then you will go for rhythm control. In these patients, as a third step, I'm writing on the next page, there is no space here. So as a third step, you will go for rhythm control. And this rhythm control can be done by either beta blockers or by catheter ablation. So you will ablate the focus from where this fibrillation is arising. I'm zooming out. It's tough, I know, but you have to remember stepwise management. It's a tough topic. It's a topic in which a lot of scenario-based things are asked. So defibrillation, cardioversion, see these terms, again, it's not the place where we should be discussing. If there is defibrillation, cardioversion are basically many times synonymously used, but they are not the same. So cardioversion means you are reverting to normal rhythm, right? So defibrillator is the name of the device through which you can do cardioversion. But the name used in the standard guidelines is cardioversion. So returning to normal rhythm. Okay. So stable patient, you will be going for drugs. Unstable patient, you will be going for either electrical cardioversion, shock to the patient, DC shock, or you will give drug-induced cardioversion. Right? I hope it is clear and you will not get it wrong again. Okay, easy thing. Next question. Look at this. What can you see in this patient? These are the waves. Remember this photograph. These waves are what you call as sawtooth waves. I'm mentioning it here. Sawtooth waves. Examiner will say there is tachycardia. ECG is showing sawtooth waves. What is the likely diagnosis? The sawtooth waves are seen in a patient with atrial flutter. Atrial flutter. Atrial flutter is relatively less common compared to atrial fibrillation. Treatment of atrial flutter, if the patient is hemodynamically unstable, you will again do cardioversion, DC cardioversion. Shock will be given. But if the patient is hemodynamically stable, you will start the patient on IV beta blockers. IV beta blockers will be given. No, adenosine is not the first line therapy. Adenosine is preferred in SVT, that is supraventricular tachycardia, also called as PSVT. So we'll be coming to PSVT, don't worry. In fact, the next topic is PSVT. Look at these images. First of all, these patients are having a narrow QRS complex. Examiner will say there is a patient with palpitations or some risk factor will mention there is narrow QRS complex. There is P wave is not visible. P wave is not visible. There is no P wave visible, and there is no, and the rhythm is regular. It is not irregular. The rhythm is always regular. Because if it is irregular rhythm and undulating baseline, it will go in favor of fibrillation. So narrow-QRS complex, P wave not visible, rhythm is regular. This is fitting into, remember this photograph. Sometimes ST segment depression can occur, although it is not visible in these patients. The likely diagnosis is PSVT, also known as SVT. PSVT, there is sinus rhythm. Yes, it is sinus rhythm. So PSVT, that is paroxysmal supraventricular tachycardia. There is another name of this. It is also known as AV nodal reentrant. AV nodal reentrant tachyarrhythmia. This is the other name. Other name is very important. Many of us have other names. One is our name which is written on our degree. Second is the name by which we are called at home, right? Home name. Third is the name you get in MBBS time. Your friends call you by that name. Fourth name is the name you get in your personal life. I'm quite sure these three milestones you have attained. Fourth milestone you may or may not have been attained, but nobody passes or becomes a professional before going through all these four milestones. So similarly, MCQs questions get repeated. Examiner changes the name of the condition. So PSVT is the same. AV nodal reentrant tachyarrhythmia. This is the technical name of the condition. So PSVT, what is the treatment we are going to do? Treatment of PSVT was asked in FMGE and NEET PG 2023. There was a question on PSVT management. So treatment, again same. If the patient is hemodynamically unstable, you will be doing synchronized DC cardioversion, also written as simply cardioversion. And if the patient is hemodynamically stable, first you will do vagal maneuvers like carotid massage or Valsalva. And then you will arrange and immediately try to give adenosine to the patient. Adenosine is always given by flush method. Adenosine is given by flush method. Adenosine is given. Alternative to adenosine is verapamil. It's very, very important. Please add it to the notes. This is something you have done already. This is something you have already read about. So PSVT is done. All these ECGs are easy to remember. I'm just asking you to have a look, take a pause again. They will say acute kidney injury patient, trauma patient, V5 is showing the following. Now look at P wave. P wave is normal. Is there any tachycardia? No, tachycardia is not visible. QRS looking fine. What about T wave? Where is the T wave going? Tall T wave. This is hyperkalemia. And the options will also have hyperkalemia, hypokalemia, hypomagnesemia, and so on. You understand? Look at this inverted T wave and U wave. They will not give you a very borderline ECG. They will give you such an ECG, provided you are not partially blind and you know what is to be seen. You will reach the correct answer. Third thing, look, they will say there is a patient, who has come from a hiking expedition and his heart is showing waves like this. So there is a J point wave where the ST segment begins. There is a small positive wave happening just close to that, to the QRS complex. Adjacent to that, that is Osborne wave. Look at this. Undulating membrane, irregular pulse, QRS complex. Rhythm is not sinus, atrial fibrillation. Look at this sawtooth wave, very easy to identify. In fact, same photograph I have been seeing since so many years in the exam. And finally, PSVT. Regular rhythm, sinus rhythm, and narrow QRS complex, P wave not visible. And options will have options like adenosine, cardioversion, etc. You will immediately come to know it is PSVT. Let's move further. There is no space, extra space has been given where it was not needed. Look at this photograph. What you can see in this patient. What you can see. Now, this is a patient where delta waves are coming. Normally, what happens is, let me tell you, normally you have P wave, then you have QRS, and then you have T wave, right? In these patients, what happens is there is P wave, then instead of a sharp rise, there will be a gradual rise. There will be a curve like this, and then the QRS complex will come. This elevation which has happened, let me show it like this. Ideally, it should have come to baseline and then it should have gone like this. This elevation which has come here, this angle which has formed is called as delta wave. So this is a patient having delta wave. So I'm labeling it. This is what you call as delta wave. Delta wave on ECG. And delta wave on ECG is characteristic of which condition? It is seen in patients with WPW syndrome. WPW is also known as Wolff Parkinson White syndrome. Wolff Parkinson White syndrome. These are the patients who are having antidromic tachycardia. The mechanism involved is antidromic tachycardia because there is a accessory pathway which is found in these patients. So they have antidromic tachycardia. What is the MCQ point? What is the underlying congenital heart disease? Congenital heart disease with WPW syndrome. It is Epstein's anomaly. It is Epstein's anomaly. Epstein's anomaly. Treatment of the patient. Again, same thing we will remember. If it is an unstable, hemodynamically unstable patient, you will go for cardioversion. And if it is a stable patient, the drug of choice will be procainamide. Intravenously, procainamide will be given to the patient. IV procainamide will be given to the patient. Yes, DC cardioversion or DC shock will be given. WPW syndrome. Close to the exam, keywords are important. Diagnosis बन जाएगा, word miss नहीं होना चाहिए. Next thing, look at this photograph. Examiner will say, now what we are having here is, can you see oscillatory changes in the amplitude of QRS complex? Slow से बड़ा घट गया, went up, came down, went up, came down. And plus, you will find that there is no P wave visible, right? This is a generalized electrical activity. So you would write like this. There is oscillatory amplitude, increasing and decreasing of QRS complexes, and there is no visible P waves or significant T waves. and there is a irregular kind of a rhythm which is happening. This condition is called as torsades de points. Torsades de points. Torsades de points can lead to, yes, polymorphic ventricular tachycardia, and torsades de points can be associated with prolongation of QT interval as well. The drug of choice in torsades de points is magnesium sulfate. This is a previous year question. So drug of choice in torsades de points is magnesium sulfate. Next photograph. What you can see in the next photograph? Can you see that there is tachycardia with very broad QRS complexes and absent P waves? Absent P waves. So this is what you call as, so I'm labeling it broad QRS complex, absent P wave. Remember the photo also, absent P waves. But there is no undulation which is happening. This is a patient with ventricular tachycardia, also called as monomorphic, because the morphology is same throughout. QRS complex is having the same morphology. So monomorphic ventricular tachycardia is there, right? So this is monomorphic ventricular tachycardia. So all examiner will ask you is to make the diagnosis, because VT-VF eventually management we will do in the end. We have to make a small chart out of it. Finally, they have given space where it was not needed. They have not given space where it is needed, but it's okay. We'll manage. Look at this photograph. What is happening here? Chaotic rhythm, chaotic wave, and no P wave, no QRS, no T wave, irregular rhythm, non-specific rhythm. And intermittently, the baseline starts fluctuating as well. So this is ventricular fibrillation. Ventricular fibrillation. In atrial fibrillation, the QRS complex is narrow and QRS complex is still present. Here, no identifiable P or QRS complex is there. So this is ventricular fibrillation. It is the easiest to identify in the exam. If you're not able to identify ventricular fibrillation, something seriously wrong. Remember, photograph like this. The photograph will be something like this. Let me tell you, photo will be something like this. If I have to make, I will be making like this, right? You get photo like this, something which you can make is ventricular fibrillation. But one straight line is cardiac arrest, and second easy line to make is ventricular fibrillation. So ventricular fibrillation, there is chaotic electrical activity, with no pattern. There is chaotic rhythm, chaotic rate. There is no P wave, no QRS, and no identifiable T waves. No identifiable T waves. It is also known as, this is an example of, it is an example of shockable cardiac arrest rhythm. It is an example of shockable cardiac arrest rhythm. How do you treat these patients? Any patient comes to you with, any patient is found unconscious. Any unconscious patient, unresponsive patient is seen. Unresponsive patient is seen. Immediately start CPR. Start CPR. So first thing to do in any unresponsive patient is start CPR. CAB, compression, airway, breathing. That is the sequence to follow. Check the rhythm. Check the rhythm. Check the rhythm. There will be two possibility. It is shockable rhythm. Shockable rhythm will be ventricular fibrillation or pulseless ventricular tachycardia, as it is written as PVT. In shockable rhythm, you will give shock to the patient. Give shock to the patient. And if it is non-shockable rhythm, that is, there is no rhythm at all, asystole is there. Asystole. In these patients, you will give epinephrine. You will give epinephrine and continue CPR. You will continue CPR. There have been 3 MCQs asked on this. 3 MCQs asked on this. It's very, very important. Let me tell you a very interesting fact. Very, very interesting fact. What happened was, like about 2 or 3 years back, if you solve PYQ, you will find a question in FMG exam. The question was, they had given this rhythm. Like, I'm not showing it here. Let me show somewhere. So they had given a rhythm like this. They said there is a person and the patient has a rhythm like this. This is the rhythm. Okay. They said, what is the immediate next step in management? Many people marked DC shock as the answer. When I asked them, ki, sir, why did you give DC shock? Why did you give DC shock? They said, sir, movies mein to yahi dikhaya hai. Have you seen those movies? Not just our Indian movies, but even in Hollywood movies. Cardiac rhythm becomes flat, ECG becomes flat. What people do? Everyone get away. They take those pads of giving cardio of defibrillator and they start giving shock. One shock, two shock, three shock, four shock. Sometimes they keep on giving seven, eight shocks, sad music playing in the background. Then somebody starts praying, or a heroine comes and picks up the hand of the hero. Shock is being given, by the way. And suddenly the rhythm comes back. This is absolute rubbish. This is not the way you treat a patient, right? Everything is wrong with this thing. Actually, what happens is if there is asystole and there is no cardiac rhythm, it is not a shockable rhythm. What you are supposed to do, you are supposed to give CPR and give epinephrine to the patient, and that will be your answer. It's a small thing, but people make this mistake. It's a mistake we all make. So you have to see the rhythm and then decide. And even if the rhythm, you don't have the time, the first thing to do in any unresponsive patient is what? You have to start CPR. Compression airway breathing is what you have to start in the patient, right? Very important. Keep this. You can get a fresh question on this as well. Absolutely right. Let's move further. So where have we reached? We are on to the scenarios now. We are on to the scenarios. So let us look at the first scenario. Examine now these two scenarios which I'm going to discuss. They are very important and they have not been asked in the recent couple of exams. So they are waiting to be asked. It's like a high quality batsman not scoring runs. It's like Virat Kohli not scoring runs. People saying Virat Kohli finished. Then there is a match against Australia or Pakistan. And suddenly he comes back into form. It's like that only, right? So I'm just giving an example. So this topic is like that. So look at the first topic. A patient is being evaluated. The patient is having muffled or absent heart sound on auscultation. There is low BP, that is hypotension, but the JVP was raised. If all the three are present, this is considered to be the classic triad. It is called as Beck's triad in the patient. And if there is Beck's triad present, Beck's triad has been asked 2 times in FMG exam. The likely diagnosis in the patient is cardiac tamponade. Cardiac tamponade. Cardiac tamponade. Now, regarding cardiac tamponade, what is cardiac tamponade? It is not the same as pericardial effusion. Small amount of fluid in the pericardial space is pericardial effusion. Any massive pericardial effusion which does not allow expansion of the chambers interferes with filling of the heart. That is called as cardiac tamponade. Now, cardiac tamponade can have multiple causes. It can be a part of trauma. It can be traumatic. It can be due to tumors. Many times, lung cancers can cause it. Breast cancers can cause it, or metastasis to the heart can cause it. Now, about cardiac tamponade, there are a few one-liner points which are important. First of all, cardiac tamponade patients will be having raised JVP, but it is non-pulsatile. The pulsatile nature of JVP is not there. Second, these patients have low ECG voltage because the cardiac signal will be muffled by all the fluid which is surrounding the heart. So low ECG voltage will be there. Some patients will have alternation of the electrical activity. We call it as electrical alternance. And Kussmaul sign will be absent. Kussmaul sign will be absent. What is Kussmaul sign? Kussmaul sign is normally when you take deep inspiration, there is a fall in BP. If the BP doesn't fall or it paradoxically rises, that is Kussmaul sign. Kussmaul sign is absent. It is used to distinguish cardiac tamponade from similar conditions. And some patients may have pulsus paradoxus. Pulsus paradoxus may be present. And what is the treatment of cardiac tamponade? It is pericardiocentesis. You try to drain the fluid which is there. Pericardiocentesis, right? These are the key points. There are more points, but these are the ones I would make sure to remember, revise before I sit in the exam. Then second point, second group of symptoms, examiner will say congestive cardiac failure is there. So pedal edema, raised JVP, All these features are there. Jugular venous distension. Kussmaul sign is present. If Kussmaul sign is present, it cannot be your cardiac tamponade. And pericardial knock is present. What is pericardial knock? It is a early S3 sound. Early S3 sound, also known as a diastolic sound. It is a loud diastolic sound which is heard in these patients. If you have a presentation like this, the likely diagnosis in the patient, constrictive pericarditis. How do you distinguish between the two conditions? On GVP, I will be coming to that. There is a separate table for this. I know, don't worry. मैंने भूला नहीं हूं मैं, वो लिखा है नीचे, ये देखो टेबल है आगे, आएंगे उसके ऊपर भी. So let's finish the topic first of all. So constrictive pericarditis is the likely possibility. What is the most common cause in India? It is TB pericarditis. Tuberculosis is the most common cause of constrictive pericarditis. And in these patients, you will have sometimes there will be a sign known as broad bent sign. Broad bent sign. Second sign which can occur on echocardiography is a sign known as square root sign. The name of the signs are important. Details you can read from your detailed notes if you have. So echo will show square root sign in these patients. And what is the treatment that we are going to give? In these patients, the treatment will be pericardial resection. So pericardium needs to be removed. It is also known as pericardial peeling or pericardial resection will be needed in constrictive pericarditis. Now, a very interesting thing on which a lot of questions are asked is, how would you distinguish between the two conditions, cardiac tamponade and constrictive pericarditis, based upon jugular venous pressure? JVP is elevated in both. It is always non-pulsatile there. It may or may not be pulsatile here, right? But JVP waves help you in reaching the correct answer. So what do we find in these patients? Look at this table. So we look at the two descents on the JVP wave, X descent and Y descent. In constrictive pericarditis, the X descent is present, it is prominent, and Y descent is also present. So both X and Y descent present is constrictive pericarditis. However, only X descent present and Y descent absent goes in favor of cardiac tamponade. This particular thing again has been asked multiple times. It has been asked multiple times. And you can put a star and write upwards that the rapid X descent, sorry, the rapid Y descent in constrictive pericarditis is also known as Friedrich sign. So Friedrich sign is again present only in constrictive pericarditis and not cardiac tamponade. Right? So this is the difference between the two conditions. So इसीलिए मैंने बोला XY descent हम करेंगे लेकिन end में अलग से करेंगे. Right? So these are some of the ECG scenarios. Next thing, acute coronary syndrome. Now, acute coronary syndrome is a condition in which there is acute interruption of oxygen supply to the cardiac tissue. The syndrome arising because of that is called as acute coronary syndrome. First thing you need to understand that your anginas, MIs, they all come as acute coronary syndrome. But there is another variety known as Prince-Metal angina, which is generally not considered a part of this. Because Prince-Metal angina is more of a vasospasm rather than an obstruction of blood supply and oxygen to the cardiac tissue. Right? So acute coronary syndrome is a general term whenever a patient presents with retrosternal pain with or without associated with radiation of the pain, diaphoresis, that is increased sweating, or any other symptom which can be attributed to cardiac illness. So whenever acute coronary syndrome patient comes to you, how you are going to approach and how you are going to manage the patient. So it's a summary kind of a thing we will be discussing. A lot of scenarios I will be discussing here. Suppose there is a patient who comes to you with retrosternal chest pain. See, the details are there in your existing notes as well. So what I will be doing is retrosternal chest pain. So retrosternal chest pain patient comes to you. What is the first step in the management? The first step in the evaluation will be do ECG. Never do cardiac biomarkers directly. Always do ECG in the patient. Now there will be two possibilities if it is acute coronary syndrome. First possibility, there is no ST segment elevation. And second possibility, there will be ST segment elevation. Whether ST segment elevation is there or not, as a second step, you will be doing. Second step, you will be doing cardio biomarkers. Do cardiac biomarkers. So biomarkers like troponin I. I is better than T, so troponin I will be done, and you will be doing CPKMB. Many times LDH is mentioned in the theory notes, but it is not generally done. If there is no ST segment elevation and you do cardiac biomarkers, there will be two possibilities. So remember the findings here. First step is always ECG. Second step is always cardiac biomarker. When you do cardiac biomarker, there will be two possibilities. The cardiac biomarkers are normal. And second possibility, biomarkers are elevated. The biomarkers are high. If biomarkers are normal, the patient is likely suffering from a disease known as unstable angina. And if the patient is having biomarkers which are high, the patient is likely having non-ST elevation MI. We call it as NSTEMI. Non-ST elevation MI is known as NSTEMI. Okay. If the patient is having ST segment elevation along with biomarkers being high and ST segment elevation is also there, the likely diagnosis in the patient is STEM. That is ST segment elevation MI. So you will have three possibilities: unstable angina, non-ST elevation MI, and ST elevation MI. Remember that unstable angina as well as unstable angina, there is no role of fibrinolysis. There is no role of fibrinolysis. Whereas in patient of ST segment elevation, fibrinolysis is effective. So dissolving the clot is effective in ST segment elevation MI in the patient, right? So this is first how we make the diagnosis, the diagnostic approach to making the diagnosis. Also, whenever you talk about ST segment elevation MI, ST segment elevation, you have to see the type of MI also, where the elevation is happening. If the ST segment elevation occurs, if it occurs in leads V1 to V4 as well as AVL lead, the patient is likely to have anterolateral MI. Anterolateral MI. If the ST segment elevation occurs in leads 2, 3, and AVF, then the patient is having a inferior wall MI. Inferior wall MI. If the patient is having ST segment elevation in V1 to V3, if it is associated with, you would write reciprocal depression. The word is reciprocal depression in leads V1 to V3. Instead of elevation, there is a reciprocal mirror image depression happening. Then you would suspect patient is having posterior wall MI. These terminologies are important, and most of the MCQs which will be asked to you in FMG exam, they will be either anterolateral MI or they will be inferior wall. Posterior wall MI can occur, but generally examiner will mention that it is posterior wall MI, right? Because it is very unlikely that entire detailed, that strip is given to you. Let me tell you why. In the actual exam, the ability to zoom in is not there. Have you noticed those who have given the paper? You cannot zoom in. And so it becomes very difficult to put up multiple images as along with the MCQ. So generally examiner will put questions. This is a technical thing to understand. Generally they will put questions on anterolateral MI or inferior wall MI where you have to make the diagnosis. If they have to make a question on septal MI or posterior wall MI, they will not ask you to make the diagnosis. They will mention that posterior wall MI is there in the patient, right? It's a small hack which you can utilize when you are answering the question. Now the question arises how you are going to actually manage the patient. So management, first of all, initial therapy. So I'm giving the heading. The next page is empty. I'm giving the heading Management of Acute Coronary Syndrome. So any acute coronary syndrome patient comes to you, whether it is MI or non-ST elevation MI, the initial therapy will always be starting the patient on MONA. Starting the patient on MONA. Now, when you start MONA, the conditions include. Now, variations of MONA have been described, but still the traditional teaching has been you talk with MONA and then you add the other drugs. So morphine is given for pain relief. Oxygen will be needed in these patients. Nitrates will be needed in these patients. And antiplatelet agents will be needed in all patients. They had to be started in all of these patients. Antiplatelet agents will be added. Now, what is the best antiplatelet agent? It is not aspirin alone. We always give a combination of aspirin along with another antiplatelet agent, ticagrelor. So you will combine it with ticagrelor. So aspirin with ticagrelor will be used. Sometimes you can substitute with clopidogrel also if it is not available. Now, management of acute coronary syndrome. After this, the management will be different in patients of non-ST elevation MI and ST elevation MI. So unstable angina as well as NSTEMI, the treatment will be different. And if there is a patient with ST segment elevation MI, the treatment will be different. If it is unstable angina or non-ST elevation MI, there is no role of fibrinolytics, no role of fibrinolysis. So what you will be doing, you have already given nitrates and antiplatelet agents. So you will add beta blockers in these patients. Beta blockers will be added. For example, metoprolol will be added. Metoprolol acts by producing relatively bradycardia and reducing the oxygen requirement of the cardiac tissue. So rate is controlled a bit and oxygen requirement of the cardiac tissue is improved if you add a low dose beta blocker in the patient. So metoprolol is the one which is generally recommended. Plus, you will consider adding anticoagulation in the form of low molecular weight heparin. For example, enoxaparin will be added. Enoxaparin will be added in the patient. Right? Then, if the patient is not responding, you will take a clinical decision to add plus minus. You will add tirofiban. You will take a clinical decision to add. There are indications for that, but it is not added in all patients. Those specific indications you need not remember for FMG exam. So plus minus tirofiban, it is a IV antiplatelet agent. So it is IV drug which will be added as an antiplatelet agent in these patients. So this will be the treatment of unstable non-ST elevation MI. When it comes to ST segment elevation MI, the therapy of choice, the initial therapy of choice, the first or ideal therapy will be PCI. What is PCI? Percutaneous coronary intervention. So I'm writing in bracket percutaneous coronary intervention. Percutaneous coronary intervention. In normal language, it is called as percutaneous angioplasty, right? This is the cash cow of cardiologist. So percutaneous coronary intervention and primary PCI has to be done within, ideally it has to be done within 90 minutes. Within 90 minutes. So first medical contact to device time, it is called as first medical contact, FMC to device time. When the first procedure is performed, it should be done within 90 minutes. It's a previous year question also. However, if you anticipate, if the anticipated time needed, anticipated means हमें नहीं पता कि हमें लग रहा है कि ज़्यादा time लग सकता है. We are thinking that more time can be taken. If anticipated time is likely to be more than 120 minutes, if it is likely to be more than 120 minutes, in these patients, you will be doing fibrinolysis. Do fibrinolysis. And fibrinolysis should be done ideally within 30 minutes of arrival. Within 30 minutes of arrival. And see, you need the basic difference is Coronary intervention can be done only by a DM cardio person. But fibrinolysis can be done by MD medicine person also. If you feel that the facility to do within 90 minutes is not possible, it is going to take more than 120 minutes. You patient comes, don't wait for cardiologist. You will give a call, but as a MD medicine person or as a resident, you will do fibrinolysis. Fibrinolysis can be done by residents also, right? So fibrinolysis, when you do, what are the drugs which are useful? The most commonly used agent is alteplase. You can use other agents like streptokinase and reteplase as well. So alteplase, for example, alteplase is to be used in the patient. And the more you delay the patient, the more worse is going to be the outcome in the patient. So this is the stepwise management that we perform related to management of acute coronary syndrome. However, if the examiner says there is a female patient, she has chest pain at rest, not related to exertion, and the chest pain increases more in the cold environment as well as in the morning hours. And there is a history of a Raynaud's phenomenon. Which cardiac condition you will think of? Any possibilities? You will think of a condition known as Prinzmetal angina. You will think of a condition known as Prinzmetal angina. In Prinzmetal angina, remember the cardiac biomarkers are generally normal. Cardiac biomarkers are generally normal. And what is the uh, drug of choice for Prinzmetal angina? You can go for nitrates. Second line drug, you can go for calcium channel blockers also. And these patients will be having angina with ST segment elevation. So remember, Prinzmetal angina has ST segment elevation despite normal cardiac biomarkers. It's a very, very interesting thing, and there is an MCQ on this. So whenever you find ST segment elevation, immediately it comes to your mind, the answer could be STMI. There was a very interesting question asked on this in the old NEET PG exam, but they had mentioned the values of TROP-I and CPK level to be normal. So what was the possibility in the patient? It was a 40-year-old female patient. The answer was Prinzmetal angina, right? So answer will be Prinzmetal angina. This is how questions will be asked to you in the exam. Let us immediately move into the world of neurology. Now, I'm going to take neurology again as scenarios, but I will be making a lot of flowcharts and atypical ways because neurology can be again very vast and overwhelming. So let us start with the first scenario in neurology. Patient presents to you with headache and neck stiffness. Neck stiffness is also sometimes written as nuchal rigidity. So they will not use the word neck stiffness, they will use the word nuchal rigidity. Nuchal rigidity. What is the possibility? Now, two possibilities are there. First possibility, if the fever is present in the patient, the likely diagnosis is going to be meningitis. But if the fever is absent in the patient, plus the patient is having very severe headache, they will say worst headache of my life. It is also called as thunderclap headache. The likely possibility in the patient is going to be SAH, subarachnoid hemorrhage. Dear friends, there is an MCQ on this. There is an MCQ on this. Both scenarios MCQs have been asked. I know it, but you need precision close to the exam. And this is something you need to remember. If the patient presents with headache, neck stiffness, fever, it is meningitis, infection of the CSF and meninges. If it is headache and neck stiffness, but no fever, sudden onset, and very severe headache, they will say worst headache of my life. That is subarachnoid hemorrhage as the possibility. Let us quickly do a recap of what you need to remember from meningitis point of view. In patients of meningitis, there will be a differential diagnosis. What is the investigation of choice in meningitis? It will be lumbar puncture for CSF analysis. But if patient has raised intracranial pressure, lumbar puncture will be contraindicated. So investigation of choice becomes CECT of the brain. It becomes CECT of the brain. This is again a MCQ. How question is asked? A patient has fever, headache, vomiting, photophobia, and neck stiffness. What is the investigation of choice? Lumbar puncture. Second question. Fever, headache, vomiting, photophobia, neck stiffness, papilledema. What is papilledema? Swelling of the optic disc. What does it indicate? Significantly raised intracranial pressure. What is to be done? Lumbar puncture is contraindicated. So CECT, contrast enhanced CT scan of the brain, needs to be done in the patient. Right? Both scenarios, questions can be asked to you in the exam. Now, when you do lumbar puncture, so differential diagnosis of CSF findings. If examiner says there is high fever, if the patient has neutrophilia in the CSF, there is raised protein and low glucose, the patient is likely to have bacterial meningitis, also known as pyogenic meningitis. What is the therapy of choice in bacterial or pyogenic meningitis? The treatment of choice is combination of ceftriaxone along with vancomycin. Single drug is ceftriaxone, but these days combination therapy is used. Ceftriaxone plus vancomycin will be your therapy of choice. If the examiner says there is a patient with moderate grade fever, lymphocytosis, very high protein, and low glucose, the possibility in the patient will be tubercular meningitis. And tubercular meningitis, you have to use, treatment will be anti-tubercular therapy plus dexamethasone will be needed. Steroids are indicated. Dexamethasone is needed. How to find if the patient has ICP? Papilledema will be mentioned. So ICP, write in bracket, you can write, for example, examiner will mention papilledema. Patients who have significantly raised ICP, there is swelling of the optic disc. So when you do fundus examination, papilledema is seen. This papilledema, try to see. If the pressure is high, it will be transferred to optic nerve, and optic nerve opening, which is present in the fundus, that will be inflamed and there will be edema in that region. So they will mention in the question, papilledema is seen. So your answer will become CECT of the brain. Okay. Third possibility, if the examiner is saying patient is having moderate grade fever, lymphocytosis in CSF, raised protein, but normal to high glucose. Glucose is not reduced. What is the possibility? Patient is having aseptic meningitis, also known as viral meningitis. And treatment in these patients is supportive. No specific therapy is available. Some people give acyclovir empirically, but acyclovir is given for herpes. And herpes is not a common cause of aseptic meningitis. It causes encephalitis. And lastly, if the examiner says HIV patient, raised cells, raised protein, normal to increased glucose, and they will say India ink stain is positive. India ink stain is positive for an organism. You will think of cryptococcal meningitis. Cryptococcal meningitis. And in these patients, you need to add HIV, ART, antiretroviral therapy needs to be continued along with amphotericin B will be needed. Amphotericin B will be needed. So what was the first thing that we discussed? That was neck stiffness in the patient. So headache and neck stiffness with fever, that is meningitis. So this is the DD and the one-liners related to meningitis. If the patient says fever with very severe, fever is absent, fever is negative, but very severe headache is there, it is likely to be subarachnoid hemorrhage. Patient will say that is the worst headache of my life and thunderclap headache is seen. When you do non-contrast CT scan, when you do CT scan of the patient, you will find this appearance. What is this appearance? Look at this photograph. You will find blood in the sylvian fissures and blood in basal cistern. It is a spotter image. It is likely to be subarachnoid hemorrhage. So this is a patient with subarachnoid hemorrhage. Regarding subarachnoid hemorrhage, what is the most common cause? Most common cause is trauma. Among non-traumatic causes, it is a rupture of berry aneurysms, also called as saccular aneurysms. Rupture of saccular or berry aneurysms. What is the grading system followed in SAH? There are two grading systems which are followed. Hunt-Hess scale and WFNS scale. WFNS scale. What is the immediate investigation of choice? It is NCCT of the head, non-contrast CT scan of the head. If you do lumbar puncture, and the patient will develop initially bloody CSF, later on 6 to 12 hours later, the patient will develop xanthochromia, yellow colored CSF. So yellow staining of CSF, xanthochromic CSF will be seen. But what is the gold standard investigation? It will be conventional 4-vessel angiography. So conventional 4-vessel angiography will be needed. 4-vessel angiography will be needed. What is the treatment you give in SAH patient? Immediate patiently, we start the patient on nimodipine. It is a calcium channel blocker, which is neuroprotective, and it is a relatively safe in SAH, followed by definite management. So you plan neurosurgery in the patient. You will either put coils or you will put clips during neurosurgery therapy. So neurosurgery details is something you will be reading in surgery class. So this is the first disease and the quick rapid fire review of the topic SAH. So we have done meningitis, we have done SAH, at least the MCQ should not go wrong. Then we have some easy, smaller topics which are mentioned here. Look at the road traffic accident followed by coma. Neuro MRI as well as brain biopsy done post-mortemly found punctate hemorrhages in the brain. What was the cause of death in the patient? The patient developed an injury known as DAI. Yes, absolutely right. DAI is diffuse axonal injury. Punctate hemorrhages scattered throughout the brain is the clue. Diffuse axonal injury. These are the patients who have a very poor outcome. So these patients have a very poor outcome. Yes, absolutely right. Coiling is preferred over clips these days. Coils, endovascular coils are now available. But again, it comes down to the treating surgeon also. It's a surgical decision. But generally, in one liner, if you have to remember, coiling is better than clipping. That's true. Next scenario, examiner will say, there was a patient who had road traffic accident, trauma, or falling from a height. NCCT was done. This is the image. Two types of images can be seen. What is the likely possibility? Either they will show this part or they will show this part. Now, what are you seeing? First of all, can you see this type of swelling? This type of concavo-convex swelling. This concavo-convex swelling is what you call as lemon sign. Lemon sign. Lemon sign. And lemon sign will indicate what? The patient is having extradural hematoma. And what is the second sign showing? Look at this particular thing. Can you see this? This semi-lunar shape, concavo-convex thing, which is forming here. So this type of appearance is what you call as banana sign. Banana sign. And banana sign indicates what? SDH in the patient. Subdural hematoma in the patient. And what is the diagnosis in this patient? The diagnosis in this patient. Triangle is the word we use for diagnosis. Most of you, all of you who will be interns next year, let us think positively. You will be not writing the full form diagnosis. You will be putting triangle. Triangle is the word, is the diagnosis. This is the short term that you use in clinics. So diagnosis in this patient is EDH with SAH. And obviously the outcome in this patient is not going to be good. And is it a acute or is it a subacute bleed? Anything which is white on non-CT scan is always a acute bleed. If it is isodense, it is difficult to identify. That is a subacute bleed. And anything which becomes dark black than the remaining brain tissue, that is a chronic bleed. That is a chronic. Some of you might be thinking कि sir इतना easy चीज क्यों बता रहे हो? अरे easy चीज भी important है. And many times we read hi-fi things and we forget these simple things. Like in this question, examiner will be putting this photograph asking you what is the diagnosis. Four options: EDH, SAH, both A and B, DAI. Now there are no diffuse punctate hemorrhages here. Now generally what happens is we don't mark the option with both of them or none of them. But here the answer will be both EDH and SAH are visible. Okay. So this is the diagnosis. Differentiating between EDH and SDH is very important. This is a very, very useful table, very, very high yielding table. First of all, EDH versus SDH. EDH is unilateral. SDH can be unilateral or it can be bilateral. EDH occurs from artery, SDH occurs from veins. There are exceptions, of course. EDH, the source of bleeding is middle meningeal artery. Middle meningeal artery. What is the source of bleeding in SDH? It is bridging cortical veins. Bridging cortical veins. Bridging cortical veins. What is the presentation? EDH or SDH? Where would lucid interval be present? EDH. So initially there will be trauma, then there will be apparent normal period. So lucid interval will occur. Lucid interval will occur, followed by deterioration. Here there is no lucid interval. There is no lucid interval. There is simply headache followed by progressive deterioration. No lucid interval. There will be progressive deterioration. Which out of them is associated with skull fracture? Which is the one which is superficial, extradural? So association with skull fracture present, and generally it is absent. Which of the one is limited by suture lines? The extradural one is limited by suture lines. SDH is deeper. It is not affected by suture lines. Shape on CT scan. This shows biconvex shape. Biconvex means like a lens. This shows concavo-convex shape, also known as semilunar shape. So this will be something like this. Surgical drainage, ASAP, as soon as possible. SDH may or may not be needed. In fact, many times na SDH patient already comes with a small SDH and it has, already patient has recovered. But when you do CT scan, there will be history of trauma and small black SDH, that is chronic SDH, may be persisting in the patient. But EDH patient will require surgical drainage always. And what is the prognosis? Prognosis is good if small and urgently evacuated. If you are late, obviously the prognosis will become bad. SDH, if it is associated with low GCS, the outcome is always poor, irrespective of evacuation. Whether you have evacuated it or not, if there is low GCS at the time of presentation, the outcome is generally poor. It's a very, very important table. Yes, the surgery done in EDH is burr hole drainage. So it's very, very important. Cerebrovascular disease. Cerebrovascular disease is also known as CVA, that is cerebrovascular accident. Now, cerebrovascular disease is of two types. Sudden interruption of blood supply to the brain causes focal neurological deficits. These are called as cerebrovascular disease. Okay. If these deficits resolve within 24 hours and the CT or MRI is normal, there is no brain infarction, you say TIA, transient ischemic attack. Full form is something you already know. If neurological signs persist for equal to or more than 24 hours, or the symptoms have gone away, but when you do CT MRI, there is brain infarction present anywhere, that is called as stroke. Risk of stroke after TIA. Maximum risk of stroke after TIA is seen within first 48 hours. It is seen within first 48 hours. Now, one patient had TIA. Would stroke happen or not? What is the scoring system for that? So risk of future stroke is predicted by a score known as ABCD2 score. It has been asked 2 times in the FMGE exam. It has been asked 2 times in the FMG exam. Now, what does ABCD2 score looks like? Have a look at this page. ABCD2 means ABCD 2 times. So A is age. 1 point is given if the age is more than 60 years. Remember, yesterday we did pneumonia curve 65 criteria. That was different. There the cutoff was 65. Here the cutoff is 60. Then B stands for BP. 1 point is given if the BP is equal to or more than 140/90. Third is clinical feature. If there is speech disturbance, that is slurring of speech, but no motor weakness, 1 is given. If one side of the body weakness has come, that is, weakness doesn't mean that there should be complete paralysis. Even weakness, plagia is also considered to be a feature. Then duration, you will be giving 1 point for the value between 10 to 59 minutes duration. And if the TIA or the symptoms persisted for equal to more than 60 minutes, you will give 2 points. And finally, if the patient has diabetes mellitus, for diabetes mellitus, single point is given. So then we take out the total score. Total score says if the total score is 0, the 3-month rate of stroke in the next 3 months possibility is 0%. Total score 1, 2%. 2 score, 3%. 3 score, again 3%. 4 score, possibility 8%. 5 score, 12%. 6 and 7 we have very high percentage. Would they be asking this? No. All they will ask is this particular thing. This is the only thing you are supposed to know. The lower table, it is there, but even if you leave it, it's okay. You are not going to be penalized for missing out this particular part, right? So this is ABCD 2 score. Now the interesting thing, the important thing comes, how you are going to manage a patient of stroke. Just like we did for acute coronary syndrome, we will be making a handmade chart here as well. So when would you suspect stroke in the patient? It should be suspected if the patient is having any acute onset neurological deficit. Any acute onset neurological deficit. What are the neurological deficits? So F is face drooping, A is arm weakness, S is speech difficulties. If any of them is present, there is T, that is time to call. It's a medical emergency. You need to treat the patient as soon as possible. So patient with either face drooping or slurring of speech or arm weakness comes to you. What is the first thing that you will do? Any suspected stroke patient, we are not sure. Any suspected stroke patient comes to you, you will do A, B, and C. What is A, B, C? Airway breathing circulation, right? You will do airway breathing circulation and do an urgent NCCT, non-contrast CT scan of the head. Now people will ask, sir, MRI, isn't it more sensitive? Yes, but MRI takes about 30 to 60 minutes. And for those 30-60 minutes, patient is inside, not receiving therapy. Once the patient comes out, photo is good, but patient is dead. So what is the point? So any emergency, we always go for NCCT head. Raised ICP patient, NCCT head. Stroke patient, focal neurological deficit acutely developing, NCCT head. Trauma patient, NCCT head. So urgent NCCT head is done. Now there will be two possibility. It will be inferior to MRI, but it is not that bad also, right? So do an urgent NCCT head. So hemorrhage is present. Two possibilities. You find any evidence of hemorrhage in the brain. And second possibility, there is no hemorrhage detected. No hemorrhage detected. If you are suspecting hemorrhage in the patient, the possibility is hemorrhagic stroke. We call it as hemorrhagic stroke. Hemorrhagic stroke is strongly associated with high BP. And these are the patients in which fibrinolysis or thrombolysis is contraindicated. So thrombolysis will always be contraindicated, right? So what is the most common site of bleed? Most common site of bleed in hemorrhagic stroke? It will be basal ganglia. Particularly in basal ganglia, it will be putamen, which will be the common site where bleeding will occur. So putamen is the site. And the strongest risk factor for hemorrhagic stroke will be high BP. BP equal to or more than 160/100 is considered to be the strongest risk factor in the patient. So what is the management that you are going to do? Treatment in this patient? You will do BP control. You will manage raised intracranial pressure if present, and any hematoma. If hematoma size is very large, if hematoma is more than 3 centimeter, you will plan neurosurgery, neurosurgical evacuation in the patient. Evacuation means you need to remove it. Neurosurgical evacuation will be needed. But if the patient is having no hemorrhage, then stroke is there. It is a non-hemorrhagic stroke. What you will do? In these patients, there will be two possibilities. First possibility, the window period by which the patient presented is small. Window period is less. The patient presented within equal to or less than 4.5 hours. 4.5 hours. You will be doing thrombolysis in these patients. Thrombolysis. See, never try to normalize the BP in these patients. Rapid fall in BP can further compromise. See, there is a auto-regulation of blood supply to the brain. So any rapid fall in BP should be avoided. And generally, we don't use IV agents. We use oral agents if provided the patient can take. Or low-dose IV agent, the same class which the patient is taking, being hypertensive, that can be given. Generally, more than 10%, 10 to 20% fall should be avoided in the systolic BP. There are separate guidelines for that, so that we can discuss separate. So window period is less within 4.45 hours. Thrombolysis has to be done. You will be using alteplase. You will be using alteplase. But if thrombolysis fails, then you have to go in for mechanical thrombectomy. Neurosurgery will be done, so you will do mechanical thrombectomy. Mechanical thrombectomy. We allow some degree of hypertension to occur. Good. Permissive hypertension. Good. Second possibility, if the window period is more than 6 hours, more than 6 hours, in these patients, you will consider endovascular revascularization. And if it fails, take expert opinion. If it fails, take expert opinion. Means let a neurologist handle. You can take neurosurgery opinion as well. So this is the management of, and once upon a time in a FMG exam, they have asked the dose of alteplase also. So remember, the dose of alteplase is 0.9 mg per kg. That is the dose of alteplase. It has been asked once, so we are writing it as a one line. But generally, doses are not to be remembered unless it is a very, very important protocol that we follow. So alteplase dose has been asked once, so we have written it here, right? So this is the stroke management that you will be doing. So if I zoom out, this is very easy to remember and it is very easy to reproduce as well. Now, when you solve MCQ, some occasional point comes in, some additional thing you find in your regular notes, add to this particular thing. Look at this MCQs. Let's solve some MCQs. FMG July 23, 60-year-old man presents with acute right hemiparesis. His BP is 220 by 100 and NCCT head is shown. All should be done except. So acute right-sided hemiparesis, hypertensive patient, and look at the bleeding which is happening in the basal ganglia putamen region. This is the basal ganglia putamen region. All should be done except का मतलब क्या नहीं करना, थ्रोम्बोलाइसिस नहीं करना. देखो बीपी कंट्रोल करना है, सेरेब्रल एडिमा होगा मैनेज करना है, इलेक्टिव हाइपरवेंटिलेशन करना है. क्यों करना है? बिकॉज इफ देयर इज रिस्क ऑफ raised intracranial pressure. Hyperventilation can transiently decrease the ICP. It can transiently decrease the ICP. तो ये करना है. क्या नहीं करना? Thrombolysis कभी भी नहीं करना. Right? So they're asking, don't miss the words except in the MCQ. A patient presented with contralateral face, arm and leg weakness, one-sided hemiplegia, NCCT revealed intracranial hemorrhage. So hemorrhagic stroke has happened. What is the most common location of hemorrhagic stroke? Again, the answer is D, that is basal ganglia. So what is the answer? D is your answer. Let's go further. There are some stroke syndromes. The nomenclature is important. You have to mug up these tables. So you cannot remember every stroke syndrome. There are other rare stroke syndromes as well, but these bare minimum ones you have to remember. If examiner says After stroke, there is same-sided third nerve palsy, that is oculomotor palsy, but cross-sided, opposite side hemiplegia. The patient is having a syndrome known as Weber syndrome. Weber syndrome is a typical brainstem stroke syndrome. Ipsilateral third nerve palsy with contralateral tremors. It is Claude syndrome. Claude syndrome. Yes, doc. ये इसीलिए लगा blank आप इसलिए हुए because that precision is lacking. So limited चाहे आप पढ़ो, लेकिन जो पढ़ा है ऐसा होना चाहिए. It's like there are certain players, they can't play every shot, but they know कि मेरे को मेरे एरिया में बॉल मिल गया तो छोड़ूंगा नहीं. You understand? They actually do better than people जो कि एक डिफ्यूज सी गेम खेलते हैं. You have to be good in whatever you are doing. So accuracy comes into play in these topics. Next question. Next point. Ipsilateral third nerve palsy, contralateral weakness with tremor. तीनों आ गए. So then you will call it as Benedict syndrome. Benedict syndrome. It is not C wala Benedict, K wala Benedict. Benedict syndrome. And ipsilateral facial weakness with contralateral hemiplegia. It's a very important question. 2 times it has been asked. It is what you call as Millard-Gubler syndrome. इनफैक्ट ये चारों के अंदर सबसे कॉमन सिंड्रोम जो है दैट इज मिलार्ड गुबलर सिंड्रोम एंड all the 4 conditions are considered to be brainstem syndromes. Then if there is contralateral palsy with Broca's motor speech area getting affected, the patient is likely to have middle cerebral artery involvement. But which segment of middle cerebral artery? You will write superior division of left middle cerebral artery is affected. If the examiner says contralateral palsy with Wernicke's sensory aphasia, then inferior division of left middle cerebral artery is affected. Remember, right middle cerebral artery does not cause Broca or motor aphasia. And finally, cortical blindness with the lack of awareness. It is called as Anton syndrome. Anton syndrome. It is seen due to bilateral cortical infarcts. Both the cortex are gone. And the interesting thing about it is, patient will be blind, but he will not know that he's blind. He will try to walk and he will stumble and fall. You will tell him ki, dude, you cannot see. He will be like, no, 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 I can see. I can see you. That lack of awareness will go away as a part of stroke syndrome. That is why it is not a normal thing. It is called as stroke syndrome. Anton syndrome will be the answer to this question. Let us have a look at Glasgow Coma Scale. This Glasgow Coma Scale you will be doing in surgery class also. Surgery faculty will be telling 3 components are there. Eye opening, 4 types of scores can be given. Verbal response, 5 types of scores can be given. And best motor response, 6 types of scores can be given. You are supposed to mug it up. There is no rocket science. Minor brain injury is between 13 to 15. 9 to 12 is moderate. And severe brain injury is 3 to 8. Maximum possible score is 15. Least possible score in these patients is still 1 plus 1 plus 1, that is 3. Now, about Glasgow Coma Scale, there is one liner you can write here that any patient with Glasgow Coma Scale, it's an MCQ point, less than 8 requires intubation. To secure the airway, there is a chance of aspiration in the patient. So immediate intubation is needed in the patient, right? So this is a Glasgow Coma Scale, not a Glasgow. It's a misprinting again. Glasgow Coma Scale. Glasgow is a beautiful city in United Kingdom. This is where the coma scale was devised. So we call it as Glasgow Coma Scale. Let's move further. Now we have some scenarios. And in these scenarios, we will be discussing some of the recent MCQs as well. Look at the first scenario. There is a child or adult with dysentery 1 to 3 weeks back. Now he's coming with symmetrical ascending flaccid paralysis. You know that paralysis can be of 2 varieties. See, it should be equal to, at 8 GCS, it is a elective decision. It comes down. Less than 8, absolute indication to intubate the patient. If there is stroke, generally the weakness in the limbs is upper motor neuron type. Upper motor neuron means there is spasticity, there is brisk reflexes, and there is Babinski sign, which is positive. But this patient is having flaccidity. The tone is gone and the reflexes are gone. So acute onset, symmetrical paralysis, both sides. Ascending. Ascending means starts in the lower limb and rises. Weakness increases as the days progress. CSF is giving a clue. Albuminocytological dissociation. Bladder bowel usually spared. What is the likely diagnosis in the patient? The patient is likely suffering from GBS. It is not ALS. ALS is amyotrophic lateral sclerosis. This is GBS, Guillain-Barré syndrome. Sometimes they use the word Landry-Guillain-Barré syndrome. LGBS, they are the same. So the same condition है Landry-Guillain-Barré syndrome or Guillain-Barré syndrome. Now, what is the most common infectious trigger? It is diarrhea or dysentery caused by Campylobacterium jejuni. MCQ. Campylobacterium jejuni. And 1 to 3 weeks later, patient can develop GBS. There are predominantly motor symptoms, but if pain or numbness occurs, can it occur? Yes, it can occur. It is due to demyelination. It is a demyelinating disorder of which fibers? This was the MCQ asked. Medicine Physiology Integration, July 25 FMG exam. It can occur due to involvement of A beta fibers. A beta fibers. This was the MCQ asked this time. It was a tough one, but now it is a previous year question, right? A beta fiber. You need to understand what is happening in GPS. There it is a condition in which there is initial trigger. Either it is a diarrhea, sometimes vaccination, sometimes unknown trigger. It causes antibody formation. These antibodies target the neurons and they target the motor neurons, the myelinated neurons. Two types of neurons are there, myelinated and unmyelinated. They target myelinated neurons and they lead to conduction block. Paralysis happens. That condition is called as GPS. So it is a predominantly motor symptom with demyelination, but if pain occurs, A beta fibers involvement can produce this type of presentation. Now, there are four broad varieties of GBS. We have AIDP, Amann, Empson, and Miller-Fisher syndrome. AIDP, the full form is acute inflammatory demyelinating polyneuropathy. This is the full form. It is a very common variety, AIDP. This is the variety which is more commonly seen in adults. So this is seen in 90% cases. So this is the most common variety. And these patients will be having anti-GM1 anti-GM1 antibody in the blood. Second is MN. What is MN? Acute motor axonal neuropathy. Acute motor axonal neuropathy. This is the variety which is seen generally in younger population. And these patients will have antibody anti-GD1A. Anti-GD1A antibody will be seen. Third is AMSEN. This is acute motor neuropathy, acute motor sensory axonal neuropathy. This is the variety. Again, it occurs in adults, but it is a rare disease and antibodies may or may not be present. So plus minus antibodies. And these patients have incomplete recovery. The response to therapy is also not great. And finally, we have Miller-Fisher syndrome. This is characterized by a triad of three things. Three things occur. They have ophthalmoplegia. They have ataxia, that is unstable gait, and they will have loss of reflexes, that is areflexia. And these are the patients who are having anti-GQ1B antibodies. If you see, all of them are anti-ganglioside antibody, and gangliosides are found in the myelin sheath. That is why they have a tendency to attack and damage the myelin sheath. Myelin sheath damaged, that is a demyelinating disorder. It is considered to be a demyelinating disorder. It's a demyelinating disorder. What is the treatment in these patients? What is the cause of death? These patients can die due to respiratory muscle paralysis. The drug of choice in these patients is IVIG. IVIG is the drug of choice, and alternative second line therapy is plasmapheresis. Plasmapheresis. There is no role of steroids. This is an MCQ, there is no role of steroids in GPS patient. There is no role of steroids in a GPS patient, right? So scenario is done, topic is done. Let us move into the world of DDs of headache disorders. So let us talk about DDs of headache disorders. Now let's talk about differential diagnosis of headache disorders. Three headache disorders we will discuss. There was one question on headache disorder asked this time also in FMG July 25. Let us go one by one. The first scenario, examiner will say there is a young adult patient. There are recurrent attacks of severe pulsatile word is important, and unilateral word is important. And duration is more than 4 hours, aggravated by movement and associated with nausea and photophobia. If somebody has got it, you know what I'm talking about. This is migraine disorder. There are many types of migraine which are described. We have migraine with aura, migraine without aura. There is variant migraine these days, and so on. But the diagnosis in these patients is migraine. If aura is mentioned, then you mention aura, but generally most migraines do not have an aura, right? So migraine is the diagnosis. Now, how you are going to treat the patient? Now, treatment wise, we will not go into details. In pharmacology, you will anyways be reading it. So first of all, when a patient comes to you with acute attack, immediately you will be starting according to the severity in the patient. Suppose it is a mild attack and it is not debilitating. You will be starting non-steroidal anti-inflammatory agents. You can use aspirin or you can use ibuprofen or similar drugs. Some people use diclofenac and naproxen, but aspirin and ibuprofen are generally good enough. And second possibility, you can consider paracetamol, that is acetaminophen. And they can be combined plus minus. If vomiting is present, you can use metoclopramide. This is the first line therapy in mild patient. But if it is moderate to severe attack, and in fact, most of the attacks are moderate to severe. If they don't mention, you have to manage according to moderate to severe. You will be giving triptans in the patient. What are triptans? They are selective 5-HT 1B by 1D receptors. Selective 5-HT 1B by 1D receptor agonists. What are the triptans you will be using? Now, the most commonly used one is sumatriptan. Sumatriptan. But if they say most efficacious is rizatriptan. Riza is also costly. Rizatriptan. And remember that these triptans can aggravate the patient if there is an underlying heart disease. So previous history of congenital heart disease, previous history of MI or stroke, these triptans should be used very carefully. And if they fail, you can go for rimegapant. What is rimegapant? It is a CGRP antagonist, CGRP receptor antagonist. CGRP antagonist. And second part of therapy is starting the patient on prophylaxis. Prophylaxis. For prophylaxis, you have various options available. You can go for beta blockers like propranolol. You can go for flunarizine. You can go for topiramate. You can go for valproate. Some people like to go for amitriptyline. And lastly, some patients can go for venlafaxine. But in clinical practice, it is beta blockers, flunarizine, and topiramate, which are more commonly used. Again, it will come down to the other comorbidities, like some of them will cause weight gain, some of them will cause insomnia, some of them will cause their own side effects. So which prophylactic agent to use? Now it's a pharmacology again, so you have to read it from pharmacology as well. My suggestion, please read the treatment of migraine in details and do it from pharma as well. The mechanism of these drugs, their side effect, where used, where not used. Sometimes it looks like a migraine question, but actually it is a pharma question they are asking you. This is one topic, please, you can write on the side. Also do from pharmacology. It's going to be useful in your exam. Integrated questions. Anyways, pharma is mostly coming integrated these days. Standard standalone pharma is, it is asked, but it is not as much as it used to be before. Second scenario, examiner will say that there is a patient who has episodic or chronic headache. या तो कभी कभी हेडेक होता है या क्रॉनिकली चलता रहता है. दिस वर्ड इज इंपॉर्टेंट. देयर इज अ टाइट बैंड लाइक डिस्कम्फर्ट. ऐसा लगता है किसी ने टाइट बैंड बांध दिया है थ्रू द फोरहेड. इट इज माइल्ड टू सीवियर. इट कैन बी माइल्ड, इट कैन बी मॉडरेट, इट कैन बी सीवियर. But nausea, vomiting, and throbbing are rare to absent. So these are not seen. There is no nausea, no vomiting, no throbbing. If you have a presentation like this, what it is a very, very common headache. I am quite sure many of you would have got it as well. This is tension headache, also known as tension type headache, also known as TTH. TTH stands for tension type headache. Tension type headache. Tension type headache. Now, what is the treatment you are going to do in tension headache patient? Now, the initial for it, because it is not a migraine, so first line therapy is always non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs. Ibuprofen is usually good enough. Books say paracetamol also, but let me tell you, Dolo 650 doesn't work anymore in headache. I'm telling it from a clinician's perspective. Theoretically, yes, we use it, but there has been so much of overuse of paracetamol, crocins, and dolos that it doesn't work anymore, except if there is a very high fever or the patient is having some, you can't use non-steroidal drugs. It doesn't work anymore. Young kids, it works. Adults, headache, at least in me and every single patient I have used in, including my family members, headache does not respond at all to paracetamol. Books do write paracetamol also, but first line therapy for all practical purpose is non-steroidal anti-inflammatory agents. Remember, there is no role of triptans. There is no role of triptans in these patients. And what is if there is a recurrent equal to or more than 15 times per month and it is debilitating, then you can consider low dose amitriptyline as a maintenance therapy. Low dose amitriptyline can be started in the patient. It will be given regularly for about 3 to 6 months and slowly you will try to taper it. The second headache is done. Third headache. Dear friends, this third headache is the one which was asked. So I'm putting it like this. It was asked in July 25 FMGE exam, case scenario MCQ in medicine. So July 25. So they will say there is a young adult male. He has clusters or groups of headache, but periodicity is seen. It comes periodically at a certain pattern. There is severe deep retroorbital pain, and plus there will be watering from the eyes and autonomic dysfunction will be there. Increased or decreased sweating, increased or decreased BP, increased or decreased heart rate, autonomic dysfunction will be there, and patient will be restless and move about. Now, if a person is having headache and he's moving about, people think it is tension headache. No, the patient is restless not because of the headache alone, but also because of he's not feeling well at all, and there is severe pain happening deep in the head, and there is watering from the eyes. If these words are mentioned, these pattern, it will be, patient will be like, you ask the patient, pehle bhi hua hai? The patient will say, yes, it has happened 2 months back, and every 2 to 3 months it happens, and it stays for a few days. This is cluster headache. This is cluster headache. Cluster headache. What is the treatment that you do in cluster headache? The first line therapy in any cluster headache is starting the patient on oxygen. Giving oxygen alone works. If it is not responding to oxygen, you can consider adding triptans to it. This was the MCQ asked. Consider adding triptans to it, and if it is still not responding, you can consider vagal nerve stimulation. You can consider vagal nerve stimulation. It is written as VNS. It is generally done non-visibly. Vagal nerve stimulation, some maneuvers are there. And how can you prevent? Prevention can be done by steroids, low-dose steroids. But steroids have a problem of causing Cushing syndrome. Second possibility, You can go for verapamil. And these days, a lot of people are using melatonin as well. Books will say lithium also, but lithium is generally the new guidelines say lithium should not be used. Side effects outweigh the benefit, right? So melatonin is the one, and melatonin is available easily, and it has lesser side effects as well. So these days, melatonin is being tried before we go for the more sophisticated therapies and the new drugs, right? Cluster headache, important topic. And finally, we come to the miscellaneous CNS disorders. Now, many of the answers you would know already. You have to make the diagnosis and write four or five important points about it. First scenario, middle-aged or young adult, female more common than male. Paroxysmal means intermittent, episodic. Paresthesias are there. Paresthesias are tingling, numbness, etc. Pain is there, weakness is there, and vision loss occurs due to optic neuritis. And many times these patients will have Lermit syndrome, shock-like sensation, particularly when they are taking a bath. And CSF, when it is done, it shows oligoclonal bands. What is the likely possibility the patient is suffering from? Multiple sclerosis. It is not a good thing to be. So multiple sclerosis is the likely possibility. Now, in multiple sclerosis, what are the additional things you should know? Multiple sclerosis has multiple types. The most common variety is uh, the relapsing form, RMS form. RMS means relapsing multiple sclerosis. There is a, when you do MRI in these patients, you find an abnormality known as Dawson's fingers. Dawson's fingers are found. Then these patients will be showing central demyelination. Dawson fingers along with central demyelination. What is the criteria that we use in the diagnosis? There is a criteria known as McDonald's criteria. So you need not remember the details. McDonald's criteria. McDonald's criteria. And what is the first line? What is the therapy? A lot of, yes, finger-like projections occur. So treatment in these patients, the highly effective are first line therapy. Any of the following biological agents can be used. Either you can go in for rituximab. Rituximab, you all know it is anti-CD20 monoclonal antibody, or you can go in for natalizumab. Natalizumab is anti-integrin antibody. It is anti-integrin antibody. And sometimes these days we are using alemtuzumab as well. They are highly efficacious. It is anti-CD52. Anti-CD52 antibody which can be used in these patients. Baki, there is a complete list of drugs, and remember, interferon beta has also been found to be useful. Remember the funda that interferon alpha is useful in viral infection. Interferon beta is useful in demyelinating disorder. Interferon gamma is not used for therapeutic purpose. I repeat, interferon alpha useful in viral infection. For example, SSPE. For example, chronic hepatitis B. For example, chronic hepatitis C. There interferon alpha is used. Interferon beta is useful in certain demyelinating disorder like multiple sclerosis and its variants. And interferon gamma, it is important in the body, but it is not used therapeutically in any common condition. This, I hope you will remember this funda. Let's move further. Now, this is a very, very easy thing. Look at the question and tell me the answer. This scenario is mentioned. Old age, insidious memory loss. Insidious means gradually progressive memory loss. Anomic aphasia, patient cannot take the name. And there are severe visual specific deficits. The answer is Alzheimer's disease. It is the most common dementia occurring in old age. Can you use melatonin for sleep? People do use it, but before you start, always take consultation from a qualified medical professional. You can use low dose, you can start, but again, end of the day, a drug is a drug. So, Alzheimer's disease. So, this is a patient. The words are old age, anomic aphasia, visual specific deficits. Alzheimer disease is having, when you do MRI brain in Alzheimer disease, these patients are having NFT. What is NFT? neurofibrillary tangles. Recent MCQ in NEET PG exam can be repeated. So neurofibrillary tangles and plaques composed of A beta amyloid. A beta amyloid plaques. A beta amyloid plaques will be found. And the most important genetic risk factor, genetic cause of Alzheimer's disease is epsilon 4 allele. It is written as epsilon, right? It is not E, epsilon 4 allele present on ApoE gene on chromosome 19. Another reason is APP gene present on chromosome 21. And that is why Down syndrome has early onset Alzheimer's disease. This is also a MCQ because Down syndrome has 3 copies of the gene which is involved in producing Alzheimer's disease in the patient. Regarding the therapy, not many therapies are currently available. So you use neurotransmitter-based therapies like donepezil, rivastigmine, and memantine. And these days there is a new A beta targeting therapy. The name of the therapy is aducanumab. Aducanumab is the new A beta targeting therapy in the patient. So aducanumab can be added. Finally, we come to this scenario. Mask-like expressionless face, no emotions are coming. Rigidity, tremors, bradykinesia, unstable posture, decreased blinking, drooling of saliva, autonomic disturbance, shuffling gait. 2 or 3 of these, if they mention together, the patient is likely to have the disease known as Parkinson's disease. Parkinson's disease. Parkinson's disease. In short, it is written as PD. Parkinson's disease. Now, Parkinson's disease is a basal ganglia dopamine defect. In these patients, what are the key things you should know? If there is a lack of, progressive lack of dopamine secreting neurons. There is a loss of dopamine secreting neurons. Substantia nigra, pars compacta region of the basal ganglia. This is a very, very important area. Substantia nigra, pars compacta. This is the site where damage maximally happens. These patients will have gene mutations in alpha-synuclein gene mutations. Alpha-synuclein gene mutations can occur. What is the therapy? First line treatment in these patients is levodopa, or you can use dopamine antagonists. Dopamine agonists. For example, ropinirole can be used. See, there are many other things. These are the things which are discussed in details in your medicine as well. It is not a theory class, it's a revision class we are doing. So we are trying to cover the maximum things and focusing on the things you can remember. You need to have a look before you sit in the exam. So dopamine agonists like ropinirole will be used in these patients, and many times you will add COMT inhibitor, which slow down the breakdown of dopamine. So you will add COMT inhibitors in these patients. For example, tolcapone. Tolcapone is added. Tolcapone is added. I have a question to ask. There is a 25. See, Parkinson disease, Alzheimer's disease, these are all diseases of the old age. 25-year-old person, 25-year-old, I will repeat, 25-year-old person presents with rigidity, tremor, bradykinesia, hallucination, shuffling gait, unstable posture. Okay. He also has hepatomegaly and ocular abnormalities. What is the likely diagnosis? What are we dealing with? Wilson disease is what we are dealing with. So remember, early onset Parkinsonism before 30 years. All one differential diagnosis you need to rule out is Wilson disease. What I just told you is a NEET PG MCQ, right? It is not written here. Remember, you can write as a one-liner if you want. I'm not in the mood to write. I have to write more for the next 1.5 hours. So early onset Parkinsonism, liver involvement, eye involvement, strong possibility Wilson disease should be thought of. Okay. Let us start with the endocrinology part. Let us start with endocrinology. So what you can see in the photograph. First of all, examiner will show a picture like this and they will ask you what is the likely hormonal deficiency. What you can see in this patient, there is a single central incisor. Whenever examiner says there is single central incisor, whenever examiner says there is single central incisor or overcrowding of teeth, overcrowding of teeth along with short stature, the likely diagnosis in the patient is growth hormone deficiency. So remember, it's a very, very important funda that you need to know. It is a very important identifying point. The patient is having growth hormone deficiency. If it is a male child, if it is a male child, they will additionally have problems above features. Along with that, they will also have micropenis. Along with that, they will have micropenis as well. What is the type of short stature seen in these children? These patients have proportionate short stature. What is proportionate? The body proportions are otherwise normal. What is the screening test in these patients? The screening test that you can do is serum IGF-1 levels. Serum IGF-1 levels are found to be decreased. They are found to be decreased. But if they say investigation of choice in growth hormone deficiency, it is always growth hormone stimulation test. We never do a standalone blood level of growth hormone. We do a growth hormone stimulation test. If the value of growth hormone, despite stimulation by agents like clonidine, etc., is less than 7 nanograms per ml, it is less than 7 nanograms per ml, it is considered to be diagnostic positive test for growth hormone deficiency. And the treatment in these patients, the only good thing is if you start early, there is a recombinant human growth hormone available. Recombinant growth hormone injections can be given. Dose will not be asked. Just remember the route of giving growth hormone is subcutaneous route. It's an MCQ point as well. You can add it to the notes. It is not acromegaly, dear friends. It is growth hormone deficiency. It is the opposite of acromegaly. So the first disease that we have discussed is growth hormone deficiency. Let us go to the second disease. In the second disease, now you have spade-like broad hands. Normal height is there. It is important. Normal height. They have prognathism. The jaw is protruding forward. Heel pad thickness is increased. And there is tachycardia, arthritis, and galactorrhea from the breast. Even in male patients, the likely diagnosis in the patient is acromegaly. And acromegaly occurs when there is excess growth hormone secretion beyond 16 years of age, because the growth plate has already fused, so patient will have no increased height. The height will be within normal limits, but acromegaly will be produced in the patient. Right now it is acromegaly. Yes. So in acromegaly, what is the most common cause? What is the most common cause of acromegaly? It is generally caused by pituitary microadenoma. In the pituitary, in the brain, there are benign tumors which overproduce growth hormone. So pituitary microadenoma is the most common cause. What is the diagnostic test in these patients? See, the screening, if they ask you screening for acromegaly, for the purpose of screening, you can do serum IGF-1 levels, which will be found to be increased. But if they say diagnostic test, then in these patients, we go for glucose challenge test, also known as growth hormone stimulation test, and it will show very high growth hormone levels. Plus, if they ask you which test is done for evaluating the cause, because the most common cause is brain tumors, pituitary adenoma, then you have to do MRI brain as well. What is the most common cause of death? It's a NEET PG MCQ. It is congestive cardiac failure, which is the most common cause of death. And finally, what is the treatment? See, because tumor is the cause, so you will do neurosurgery, you will do transsphenoidal resection of the tumor. Secondly, you will do drugs. Now, many of the textbooks and many of the places in one online platform also, I saw that drug of choice is pegvisomant. Pegvisomant is the effective drug, but it is not the drug of choice. And this was the MCQ asked in FMG exam as well. According to Harrison 22nd edition, the preferred drug always are long-acting somatostatin receptor ligands, which inhibit the secretion and the action of growth hormone. You can use either depot preparation of lanreotide, it is a long-acting form, or you can go for depot preparation of octreotide. Remember, it is always the first line agent to be started. Only when it is not responding to the usual management, then you will go for growth hormone receptor blockers or growth hormone receptor antagonist like pegvisomant. So pegvisomant is always a reserve drug. It is never a first line drug in the management of acromegaly. Small thing, but you need to remember for exam. Many times octreotide will not be in the option, lanreotide will be in the option. Either of the two will be mentioned and that will be the answer. So short review, short topic, but important. Preferred management of acromegaly in the patient is. Preferred management in acromegaly is. Look at the options. What is the likely diagnosis? It is long-acting form of depot formulation, lanreotide. Many people marked octreotide in the answer. It is the IV octreotide जो है वो तो देखो within 8 to 12 hours it will be metabolized. You need a long acting constant inhibition, and for that you will be going for lanreotide depot formulation in the patient. So B is your correct answer. The mistake many students make is they mark octreotide, don't remember certain important things as one liner. You need to know the context of the topic as well. This is the second disease, that is acromegaly. Let us look at the third disease, the third syndrome. Young adult patient has constipation and renal stone. Whenever there is constipation and renal stone, you will think of more calcium in the body. Investigations revealed hyperparathyroidism causing hypercalcemia. They also have Zollinger-Ellison syndrome, which is a type of gastrin secreting tumor, and they have brain tumor like prolactinoma. So hyperparathyroidism, gastrin secreting tumor, and brain tumor, we are dealing with a syndrome known as Men syndrome. And which Men syndrome are we talking about? We are talking about MEN1 syndrome. MEN stands for multiple endocrine neoplasia. These are the group of disorders in which multiple endocrinological tumors occur in the body. Generally, they are benign, rarely they can be malignant as well. Many varieties have been described. Common varieties are three: MEN1, MEN2A, and MEN2B. Remember, MEN2B is also known as MEN3. So MEN3 is the other name of MEN2B. Due to MEN1 gene mutation present on chromosome 11, whereas MEN2A and 2B, the type of mutation varies, but the gene location is same. On long arm of chromosome 10, you have the RET gene which is implicated. All the three varieties can be sporadic. If they are inherited, they can be autosomal dominant. MEN1 is also known as Wermer syndrome, and MEN2A is known as Sippel syndrome. MEN2B or MEN3 does not have any underlying nickname. So first of all, what is the triad of three things seen in MEN1 syndrome? First thing, these patients have parathyroid adenoma. Adenoma means a benign tumor. This is the most common presentation. And these patients will have hyperparathyroidism, hyper PTH, that is hyperparathyroidism will be produced. Secondly, these patients will have neuroendocrine tumors. They will have gastrinomas. Gastrinoma tends to produce a tumor known as Zollinger-Ellison syndrome. And thirdly, these patients will have pituitary adenomas. Which pituitary adenoma is common? Prolactin secreting tumors known as prolactinomas are important. So this is the classic triad seen in MEN1 syndrome. Remember that in MEN1 syndrome, there is no pheochromocytoma. Presence of pheochromocytoma takes the diagnosis away from MEN1 syndrome. Remember this important funda. What about MEN 2A and MEN 2B? MEN 2A has some features similar, some features different. First of all, these patients will always have thyroid cancer, but we have a thyroid cancer known as medullary carcinoma of thyroid. Medullary carcinoma of thyroid. It is the most common manifestation. It is written as MTC, and this is the most common manifestation of MEN 2A syndrome. Second, they can have pituitary, they can have parathyroid adenoma, so they can have hypercalcemia. And thirdly, these patients will have pheochromocytoma. Pheochromocytoma. What about MEN 2B syndrome? So medullary carcinoma of thyroid will be here as well. So I'm just writing in the short form, medullary thyroid carcinoma will be there. It is again most common manifestation here. Secondly, these patients will have marfanoid habitus. Marfanoid means they have long legs, long arms, and thin extremities. So marfanoid-like features will be there. Thirdly, these patients will have pheochromocytoma. And fourthly, these patients will have mucosal neuromas. What is the treatment? See, it's a genetic condition, it's a syndrome, so there is not much therapy except for, supportive therapy that you can do in these patients. So this is the three syndromes important. You have to revise. It's likely to be asked as a fresh question in the upcoming exam. So first thing is MEN syndrome in this topic. Let's go further and talk about two important syndromes on which questions are very frequently asked: Conn syndrome versus Addison's disease. Now, if you look at the parathyroid, if you look at the adrenal gland, it has two parts. There are two adrenal glands. They're also called suprarenal glands. Two parts are there, cortex and medulla. Medulla produces epinephrine and norepinephrine, and the cortex has three layers: zona glomerulosa, fasciculatus, and reticularis. Right? So, what exactly is Conn syndrome and what is Addison disease? If there is destruction of cortex, the cortex does not function, that causes Addison disease. But if there is a tumor which overproduces aldosterone, that causes Conn syndrome. So one is a excess, one is a deficiency. So Conn syndrome, what is Conn syndrome? Conn syndrome is a condition in which there is a adrenal adenoma. There is a benign adrenal mass. Rarely it can be malignant also, but adrenal adenoma which produces hyperaldosteronism. This is the primary defect. Hyperaldosteronism means the aldosterone levels are very high. It doesn't produce other types of hormones, but generally it produces high aldosterone. On the other hand, Addison disease occurs due to destruction of the adrenal cortex. Most commonly, it occurs due to autoimmune causes. In a country like India, tuberculosis is also a common cause. But overall, most common cause worldwide, it is autoimmune destruction. And so these patients will have decreased adrenal cortical hormones. So they will have decreased cortisol also, they have decreased aldosterone also, and they have decreased sex hormones as well. So DHEA, etc., will also be reduced in such patients. Now, what will ABG show in the patient? When you do ABG, let us first discuss Conn syndrome. What is happening in Conn syndrome is aldosterone is high. Aldosterone will cause increased secretion of hydrogen ion into the urine. And so patient he will have a tendency to develop, two times asked in FMG exam, metabolic alkalosis. So patient will have metabolic alkalosis. Addison disease, if it is mild, it may be normal, but generally, due to the deficiency of aldosterone, they will have features suggesting metabolic acidosis. What will you find in the hormone levels? In Conn syndrome, the serum aldosterone levels, S means serum aldosterone, that will be low. That will be increased because it is hyperaldosteronism, right? So aldosterone will be high. Aldosterone will cause feedback inhibition of renin, and so the renin levels in the patient will be low. And there is a test that we do known as ARR test. ARR test will show increased activity in these patients. What is ARR? We take the ratio of aldosterone divided by renin ratio. Aldosterone by renin ratio. This test will show increased activity in the patient. How will Conn syndrome patients present? Now, these patients have obviously hypertension. So they will present with hypertension. They will have muscle weakness and they will have cramps. These cramps will occur because of the presence of metabolic alkalosis in these patients. Now, try to think what will happen. Aldosterone will cause sodium retention and BP increase, but potassium will decrease. And that is why these patients, the muscle weakness and cramps occurs because of hypokalemia, because these patients have hypokalemia. Remember, hypokalemia is a feature. This is again a MCQ point asked in the exam. So in patients of Conn syndrome, you will have hypokalemia. What happens to BP? BP is increased. It is called as low renin hypertension because the renin levels are low renin hypertension. What is the investigation of choice? There is a test that we do known as saline infusion test. Saline infusion test. You infuse about 2 liters of saline over 4 hours and see if the aldosterone is suppressed or not. If aldosterone continues to be high, it indicates it is autonomous production, and so you need to treat the patient. So what is the therapy of choice? Initially, you can give a trial of spironolactone. Spironolactone is a aldosterone antagonist, but it is only a temporary measure. It works, it has efficacy only in 30 to 50% patients. It is not a very efficacious therapy. It is generally more commonly used as a temporary measure for managing the patient. The definite therapy in the patient will always be adrenalectomy. Adrenalectomy. Many times the adenoma is big and it is located in such a way that only resection of the tumor is not always possible. So we do unilateral adrenalectomy in most of these patients. So one adrenal gland is generally removed. So this is the definite therapy in these patients. It's a very, very important topic. I've gone slow. I've tried to cover a lot of ground. All these points which we are writing, they are very, very important. What happens in the other thing? What happens on the other side? Now, in the other side, you will see that the adrenocortical hormones are not getting produced. So there will be deficiency of all these enzymes. There will be the cortisol levels will be low. Aldosterone levels will be low. Sex hormones levels and their precursors like DHEAS levels will be low. Because cortisol is low, so feedback inhibition is gone. So ACTH levels will be high. So ACTH levels will be increased. And because aldosterone is low, so the feedback inhibition to renin is gone. So renin levels will be high. Renin levels will be high. What about the clinical presentation in these patients? These patients, the clinical presentation is in the form of all these manifestations will occur. Cortisol deficiency, so they have hypoglycemia. Aldosterone deficiency, generally they have normal BP, but postural hypotension will occur. This word is important. Postural hypotension will occur. Fall in BP on erect posture or prolonged standing for some time can occur. These patients can have delayed puberty or absent puberty. Pubertal disorders can occur. And because ACTH levels are high, you know that ACTH क्या करता है? ACTH causes melanocyte stimulation. So it will cause hyperpigmentation in the patient. So hyperpigmentation will also be produced in these patients. Hyperpigmentation will be produced. Now, what will happen to the BP? The BP will be normal to low. So it can be normal, it can be low. And because there is no hypertension, so we have already discussed the renin in these patients is on the higher side. And because aldosterone levels are low, these patients, the potassium levels in the body, they are normal to increased. Remember, they can have normal to increased potassium level. Many times, the total body potassium is on the normal side as well. But serum potassium can sometimes be on the higher side. What is the investigation of choice? Here we do a test known as ACTH stimulation test. So ACTH stimulation test can be performed. Details of the test will not be asked to you in the exam. And finally, what is the treatment? Obviously, you will do hormone replacement. Hormone replacement will be needed. So you need to add hydrocortisone. You need to add fludrocortisone, and you need to add sex hormones as well, plus minus others. And if there is autoimmune cause suspected and there is some residual function, you can give a trial of a drug known as azathioprine in these patients. A trial of azathioprine can be given in these patients. I'm zooming out and see this is, let us solve some MCQ. Look at the first MCQ. A patient presented with hypertension and hypokalemic alkalosis. Hypokalemic alkalosis. CT revealed a small mass in the suprarenal location and there is elevated ARR. What is the best management? You have to make the diagnosis. What is the diagnosis? Cohen syndrome. And what is the best management of Cohen syndrome? It is unilateral adrenalectomy. Now the question looks easy because we have understood it, right? Questions are solvable. These are solvable questions. Next question. All of the following are seen in Cohen syndrome except Cohen syndrome. You know the answer. What happens in Cohen syndrome? These patients have more aldosterone. Aldosterone causes hydrogen loss. So patient tends to develop alkalosis. So what is not seen? A. Next question. Patient presents with hypertension, palpitations, and sweating. Now, palpitations and hypertension can occur in, Cohen syndrome also. It can occur in other conditions also. So we will discuss those other conditions as well. So look at the keywords: hypertension, palpitation, sweating. Potassium is low, aldosterone is high. What is the likely diagnosis? Again, the answer is Cohen syndrome. So it's a very, very easy question. It's a very, very easy question if you just get the hang of it. Same things being asked again and again. The only question is, do you have that? Which of the following is a cause of hypertension with low renin and high aldosterone? The answer will be Cohen syndrome. But there is another syndrome where there is hypertension with low renin and low aldosterone. Low renin, low aldosterone. The disease is Liddle syndrome. Liddle syndrome. Liddle syndrome is there. Yes, hypertension, palpitation, sweating can occur in pheochromocytoma also. But that is why it is not pheochromocytoma, because in pheochromocytoma, the cause is not aldosterone being elevated. If aldosterone is elevated, pheochromocytoma is ruled out. Pheochromocytoma occurs due to catecholamine excess. And these patients will have episodic hypertension. These words will come. I will discuss that scenario also. So it will be very clear in your mind why the answer is not pheochromocytoma. Commonest mistake people make, they mix up Cohen syndrome with pheochromocytoma. We will not mix up after today's session. Let us move to the next one. First, we need to talk about Cushing syndrome. Let us finish adrenal gland, the deficiency and excess part first. So examiner will say there is a patient with moon-like face, Chand sa chehra. Centripetal obesity. It is also called as lemon on stick appearance. So they have central obesity, but the limbs are very thin. They have hypertension, hirsutism, and cataracts. The patient is likely suffering from a disease known as Cushing syndrome. Cushing syndrome, right? So answer is Cushing syndrome. Now, what are the causes of Cushing syndrome? There is a table of Harrison that we need to make, and it's a very important table. Tough questions are also asked. This has been asked once in FMG and has been asked 2 to 3 times in the other exams like NEET PG as well. Let us talk about the causes. Causes of Cushing syndrome can be divided into two parts. Either patient has exogenous Cushing syndrome, also known as iatrogenic Cushing syndrome. Iatrogenic means it is happening because of somebody's taking steroids more. So exogenous or iatrogenic Cushing syndrome is generally due to excess steroid intake. It is seen due to steroid intake. It is seen due to excess steroid intake. For example, there is a patient with frequently relapsing nephrotic syndrome. तो क्या होगा? Patient with SLE क्या होगा? Patient with frequent flares of Sjogren syndrome क्या होगा? Cushing syndrome will occur. On the other hand, second possibility, patient is having endogenous Cushing syndrome. So increased cortisol is there, but this increased cortisol, Cushing syndrome is bracket, you can write increased cortisol levels. This increased cortisol is endogenous. It is forming in your own body. It can be of two varieties. First is ACTH dependent form, which is seen in 90% patients. And second is ACTH independent. ACTH independent form. ACTH dependent form will have increased ACTH in the blood. So basically क्या हो रहा है, ज्यादा ACTH बनने से कुशिंग सिंड्रोम प्रोड्यूस हो रहा है. ACTH इंडिपेंडेंट में क्या होगा? There will be normal to low ACTH. ACTH independent causes. The typical example for ACTH independent is adrenal adenoma and adrenal carcinoma. Adrenal carcinoma. देखो कुछ एड्रिनल एडिनोमा जो होते हैं वो क्या करते हैं, दे प्रोड्यूस एल्डोस्टेरोन, वो करता है कॉन सिंड्रोम. कुछ बनाते हैं डायरेक्टली कॉर्टिसोल, तो वो करते हैं एसीटीएच इंडिपेंडेंट कुशिंग सिंड्रोम. ओके. सेकंड पॉसिबिलिटी इज एसीटीएच डिपेंडेंट, वेयर मोर एसीटीएच इज गेटिंग प्रोड्यूस्ड. अब सवाल ये है कि ये एसीटीएच ज्यादा बन रहा है तो आ कहां से रहा है? टू पॉसिबिलिटी. 75% ऑफ दीज केसेस आर ड्यू टू पिट्यूटरी एडिनोमा. पिट्यूटरी एडिनोमा तो ब्रेन से आ रहा है. इसको कहते हैं कुशिंग डिजीज बिकॉज इट इज सेंट्रल इन नेचर. इसे कुशिंग डिजीज कहते हैं. एंड अबाउट 90% में से 15% कहां से आ रहा है? एक्टोपिक एसीटीएच प्रोडक्शन. Ectopic ACTH production. It is typically being seen in oat cell cancer, also called as small cell cancer of the lungs. I already told you small cell cancer of the lung will have ectopic ACTH production. What about approach to MCQs in Cushing syndrome? Now, there is a very interesting approach that we need to follow. एक क्रॉनिक स्मोकर है, उसमें वेट गेन, हाइपरग्लाइसीमिया, हाइपरपिगमेंटेशन इज देयर, एंड आपने किया हाई डोज डेक्सामेथासोन सप्रेशन, एसीटीएच हाई रहा, तो डायग्नोसिस बताओ. You need to understand two things. There are two types of dexamethasone suppression test which are used in Cushing syndrome. Listen to me carefully. स्क्रीनिंग के लिए हम करते हैं लो डोज डेक्सामेथासोन सप्रेशन टेस्ट. Low dose dexamethasone suppression test tells Cushing is there or not. To find the cause of Cushing, we do high dose dexamethasone suppression. How do you reach the answer? Let us form a generalization. सबसे पहले in suspected Cushing syndrome, suspected patient, you do a low dose dexamethasone suppression test. Low dose dexamethasone suppression test. Low dose कितना होता है? 1 milligram dexamethasone is used. Low dose dexamethasone suppression test. Now, when you do this test, there will be two possibilities. When you give overnight dexamethasone low dose 1 milligram, दो possibility होगी. देने से it is a steroid, so cortisol level will be decreased, या cortisol level will be found to be increased. You try to suppress it. If the cortisol level is decreased, you will say no Cushing syndrome, normal patient. And if cortisol level is increased, then the patient is having Cushing syndrome. तो पहला टेस्ट हम किस लिए करते हैं? कुशिंग सिंड्रोम आइडेंटिफाई करने के लिए. cortisol is increased. If cortisol is increased, the patient has Cushing syndrome. Now, if Cushing syndrome is there, now we do the second test. Second test is called as high dose dexamethasone suppression test. High dose dexamethasone, and high dose कितना होता है? 8 milligram suppression test. Now, when you do this test, you have two further possibility. When you do high dose dexamethasone suppression test and you check the cortisol level, the first possibility, cortisol is decreased. Cortisol is decreased. Cortisol is decreased. If cortisol gets decreased on high dose dexamethasone, it is central cause, also known as Cushing disease. Cushing disease should be suspected. Central cause is suspected. यानी कि the pituitary adenoma is producing more tumor in the patient. But if you find that cortisol continues to be high, you check the blood ACTH levels. If you find that the blood ACTH is low, the patient has adrenal cause of cortisol production. And if the blood ACTH levels are found to be increased with increased cortisol, the possibility is ectopic ACTH production. Let me tell you, this flow chart, if you have not read before, when you read it for the first time, it seems a bit tricky and it is tough. It is tough, let me tell you. But once you get a hang of it, you will find that this is a very, very useful test, very, very useful chart, which will simplify life if you get a tough question on Cushing syndrome. Chronic smoker presented with abnormal weight gain, hyperglycemia, hyperpigmentation. High dose dexamethasone test was done. Before and after test, ACTH was found to be consistently high. It is not getting low. If ACTH is consistently high in a chronic smoker patient, we are probably dealing with ectopic ACTH production. Right? Ectopic ACTH production. ACTH is also high. What is the likely cause? Oat cell cancer or small cell cancer of the lung. So D is your correct answer. D is your correct answer. So this particular page again, apart from the page I showed you, this page is important and this page is very, very important. ट्रीटमेंट ऑफ कुशिंग सिंड्रोम, ट्रीटमेंट सिंपल है. पहला कॉज क्या है? ट्रीट द कॉज. अगर पिट्यूटरी एडिनोमा है तो क्या करेंगे? ऑब्वियसली ट्रांसफिनोइडल रिसेक्शन कर देंगे. एडिनोमा है ना, तो वही ट्रीटमेंट करेंगे, ट्रांसफिनोइडल रिसेक्शन ऑफ द ट्यूमर. और एड्रिनल कॉज है तो एक तरफ की एड्रिनल ग्लैंड इन्वॉल्व होगी तो यू विल डू यूनिलेटरल एड्रिनल एक्टमी. यूनिलेटरल एड्रिनल. लेकिन सेकेंडली अगर नहीं पॉसिबल कभी कभी, सो यू विल यूज ड्रग्स टू अपोज कॉर्टिसोल एक्शन. यू कैन गो फॉर मिटाइरापॉन, ketoconazole, mitotane, and pasireotide. Pasireotide is a somatostatin receptor agonist, and this is particularly useful in severe Cushing's disease. If immediate treatment is not possible, then in severe Cushing's disease, Cushing disease क्या था? यहाँ वाला, pituitary वाला. So that you can use, there you can use pasireotide in the patient. Sudden flushing हो जाता है, लाल हो जाता है face, lasting 5 minutes. Associated with watery diarrhea, asthma-like wheezing, and urinary 5-HIAA and VMA levels are increased. What are we dealing with? We are dealing with a disorder known as carcinoid syndrome. So carcinoid syndrome is your likely possibility, right? What is the metabolite which produces it? It occurs due to increased serotonin production. Serotonin is also written as 5-hydroxytryptamine. So 5-hydroxytryptamine or serotonin production produces it. What is the underlying cause? There is a neuroendocrine tumor which is the cause of this. So there are neuroendocrine tumors in the gut which produce large amounts of serotonin leading to carcinoid syndrome. What is the investigation of choice? Investigation of choice is 24-hour urine for 5-HIAA. 5-HIAA. This will be used to, if it will be increased, that will indicate presence of carcinoid syndrome. However, you need to understand that to locate the site of tumor, पता लग गया carcinoid है, लेकिन cause कहाँ है? For that, you need to do either PET scan or radionuclide gallium scan. Radionuclide gallium scan. Either of the two can be done. Both are equally efficacious. And what is carcinoid heart disease? Certain patients with carcinoid syndrome develop tricuspid regurgitation along with fibrosis of right-sided heart walls. Fibrosis of the right-sided heart walls. And what is the treatment in the patient? Treatment in these patients will be somatostatin analogs, octreotide or lanreotide can be used. They are the therapies useful. Plus minus, you will do resection of the tumor if you can identify and if it is resectable. So resection of the tumor can be tried in the patient. Resection of the tumor can be tried. So which of the following is not correct about carcinoid tumor? Look at the options. TR can occur. Asthma-like symptoms can occur. Flushing can occur. Urinary 5-HIAA, it is not normal. It is increased, and that is the not only screening test, it is also investigation of choice. It is looking like a, such a childish question. It is childish only if you have read the topic recently. Let's go further. there is a differential diagnosis of pancreatic neuroendocrine tumors which are asked in the exam. So what is the DD? If examiner says there is a tumor in the body, pancreatic tumor is there, the tumor is producing peptic ulcers, GERD, that is GERD, and diarrhea, the likely possibility is gastrinoma, also called as Zollinger-Ellison syndrome. Zollinger-Ellison syndrome. Second possibility, if they say pancreatic neuroendocrine tumor, hypoglycemia, weight gain, and confusion is happening. Weight gain because some anabolic hormone is getting produced. So this is a patient with insulinoma. Confusion occurs due to low-grade hypoglycemia, which continues in the patient. Third, dermatitis is there. Which kind of dermatitis? Very important. It's a NEET PG question. Necrolytic migratory erythema. I'm putting a Q on top of it. Affecting the groins and buttocks, the likely diagnosis in the patient is glucagon excretion, which is excess. We call it as glucagonome. Glucagonome. Glucagon-oma. Oma is a tumor. Watery diarrhea with hypokalemia with achlorhydria. Achlorhydria means lack of acid production. The patient is suffering from VIP-oma. VIP secreting tumor, also called as Werner-Morrison syndrome. Werner-Morrison syndrome. Werner-Morrison syndrome. And finally, if the MCQ says that the patient is having diabetes mellitus, steatorrhea, gallbladder disease with diarrhea. Gallbladder disease with diabetes mellitus are the clue. The patient is having somatostatin secreting tumor. Somatostatinoma should be thought of. Somatostatinoma should be thought of. Somatostatinoma should be thought of. So we are done with these pancreatic endocrine tumors. Let us come to the thing you were asking about कि sir pheochromocytoma कब आंसर होगा? यहाँ होगा. Look at the buzzwords, look at the keywords. इसमें कभी भी ना मेंटेन बीपी नहीं रहता. फ्लक्चुएशन इन बीपी आता है. दिस इज इंपॉर्टेंट. सो इंटरमिटेंट, एपिसोडिक और paroxysmal ऐसा वर्ड बोलेगा ऑफ हाइपरटेंशन. Second important clue, whenever they have put question on pheochromocytoma, whether it is FMG, NEET PG or INISET. In fact, I was looking at one of the clinical cases in USMLE also, not in step 1, but the later steps. There also they have used this word, that is profuse sweating, diaphoresis. It is very, very important word. Diaphoresis will be there. Palpitations will occur, anxiety will occur, headache will be there, weight loss will be there. And another clue they may add, urinary VMA is increased and sometimes urinary metanephrines are also increased. If you have a presentation like this, what is the likely diagnosis? Patient is suffering from pheochromocytoma. Pheochromocytoma. Pheochromocytoma is a endocrine tumor. Most common site of pheochromocytoma is adrenal medulla. Adrenal medulla. And it produces your catecholamines. It is a catecholamine producing tumor. Your epinephrine and norepinephrine are more produced. What will microscopy show? See, the name pheochromocytoma means, chroma means black. So there is a black pigmentation when you take out the tumor grossly. But when you do microscopy, you will find files of cells arranged in a pattern. This pattern is called as Zell-Ballan pattern. Zell-Ballan pattern of cells will be there. So there will be files of chief cells. Files of chief cells surrounded by sustentacular cells. And this photograph, it looks the same in all the histopathological images. So this is the typical Zell-Ballan pattern that you will find in patients of pheochromocytoma. If you do CT scan or MRI with contrast, what will you find? CECT or MRI, if you do, you will find a sign known as light bulb sign or light bulb appearance. You will find a light bulb appearance in the patient. Light bulb appearance. Pheochromocytoma also shows rule of 10. What is rule of 10? 10% of these tumors are extraadrenal, outside the adrenal gland. 10% found in childhood. 10% run in the family. 10% can be malignant. 10% are associated with Men's syndrome. And 10% do not have any problem except for occasional mild diaphoresis and mild rise in BP. which cannot be picked. So 10% are incidentally detected in the patient. So blood will show increased catecholamines and urine test will show increased VMA, increased metanephrines and so on. What about the treatment in these patients? Treatment obviously will require surgical resection. So surgery will be needed. But during surgery, we need to do pre-operative alpha plus beta blockade because during handling of the tumor, निकालने के लिए पकड़ना पड़ेगा. When you hold these tumors and cutting them, they can suddenly release epinephrine or epinephrine, which can actually, worsen the patient on table. So pre-operatively, you need to give alpha plus beta blockade. So, dear friends, listen to the words carefully. Hypertension, hypokalemia, alkalosis, raised ARR, low renin. This is Conn syndrome. Hypertension, low renin, low aldosterone, but no mass detected, Liddle syndrome. Episodic hypertension, palpitation, diaphoresis, mass seen in the CT scan or PET scan or MRI, pheochromocyte. I am quite sure if you just remember this and listen to this video probably again in 1.5 or 2x, you will never forget it in the actual exam. Up now, there should be no reason why you should get it wrong. Pheochromocytoma कौन ये गलती होती है बहुत लोग करते हैं. Let's not make this mistake if it gets asked in the exam. Right? We are done. Great. Let's move further. Rule of 10 is, let me tell you, what Sir said is, yes, it is correct. It is historical importance. Why do I say it is historical importance? See here. See here. This 10% childhood thing, this itself has changed. I'm a pediatrician and I train students for super specialty in pediatrics. So in pheochromocytoma, it is seen that 10% rule is never favored and already 10% familial thing has already been disproved. Many of these pheochromocytomas occur as part of other syndromes. We call them as APS syndromes. It is just that we did not know about APS syndromes initially. So because the more and more data is coming, so this rule of 10 is only of historical importance. But at the same time, ask yourself, are historically important things not asked in the exam? If they ask you a question, won't you say, would you say to the examiner, ki, sir, this is of not no longer followed, it is of historical importance? No, you're supposed to answer. And rule of 10 has been asked in exams. So we are supposed to. There is a difference between two things which we sometimes forget. One is clinically treating a patient and talking the right thing. And second is solving an MCQ. Solving an MCQ. Personal anecdote I'm saying, two personal anecdotes important for you to understand. Number one, when I teach for pediatrics, I always tell watery diarrhea in a child, no other symptoms, just give ORS and zinc, don't give antibiotics. That is what you should remember from exam perspective. When you sit in OPD, many times E. coli can have a presentation like this. And if I don't give antibiotic, or if there is a clinical suspicion, I want to get a test done, but parents are not uh, ready to get it done. Would I not add antibiotic? I will add. So what we do versus what you need for the exam, that is different. Probiotics, no role in diarrhea actually. But we have to remember that probiotics are used in practice. Similarly, pheochromocytoma, no longer followed in practice, let me tell you. I agree with Sir what he said, but it is of historical importance and it is asked in the exam, so we are supposed to remember. Okay, let's scenario. A female with tachycardia, palpitations, staring appearance. Staring ka matlab, eyes are like this, staring into your eyes, staring into your soul. And legs are as shown. What are these appearances? These are what you call as pre-tibial myxedema. Pre-tibial myxedema. Okay, pre-tibial myxedema. So tachycardia, palpitation, staring appearance means staring appearance indicates there is lid retraction which is happening. And pre-tibial myxedema, what is the likely diagnosis? The patient is suffering from primary thyrotoxicosis, also called as primary hyperthyroidism. The most common cause of primary thyrotoxicosis is Graves' disease. It is Graves' disease. Yes, it is a shin bone sign. So Graves' disease, right? Graves' disease, what will you find in these patients? What are the things you should know? First of all, it is more common in females compared to males. These patients have thyroid scan. When you do thyroid scan, because the gland is overactive, increased uptake will be seen in the gland. And these pre-tibial mixed edema is always a non-inflamed orange-red plaques, which will give a typical appearance in such patients. What is the therapy that we give in Graves' disease? The first line therapy is always anti-thyroid drug. We start with anti-thyroid drugs. Anti-thyroid drugs. What are the anti-thyroid drugs? Three drugs are available. You have propylthiouracil, propylthiouracil, you have carbimazole, and you have methimazole. Methimazole. Out of them, propylthiouracil is the one which is preferred in pregnancy as well as when the patient presents with thyrotoxic crisis. So propylthiouracil is the one which is used in pregnancy as well as crisis. But the side effect of propylthiouracil, these patients have hepatotoxicity which can occur. Second possibility of therapy is that you can go for ablation therapy. We call it as iodine 131 ablation therapy. Remember that iodine 123 is preferred for scan, but iodine 131 is used for thyroid ablation. And if that also fails, you will go for total thyroidectomy and put the patient on lifelong thyroid supplements. Total thyroidectomy will be needed in the patient. Yes, methimazole is unsafe. Methimazole, in fact, is the most unsafe drug in among the antithyroid drugs in pregnancy. So this is a quick review of the topic of Graves' disease. Now, DD of thyroid scan. What are the one-liners you should know? If you form, examiner says thyroid scan was done, warm nodule was found, it will be a normal test. If they say hot nodule was found, it is generally normal, but watch for future malignancies. Watch for future malignancies. There is a 1 to 2% risk of developing malignancy in later life. Cold nodule. Cold nodule will be seen in thyroid cancer. It will be malignancy, so thyroid cancer. And most commonly, it will be seen in papillary carcinoma of the thyroid. If there is diffusely increased uptake, this is what you call as Graves' disease. If there is mixed hot and cold nodules or asymmetric presentation, the patient is having toxic MNG, that is multinodular goiter. Toxic multinodular goiter. And if there is diffuse decreased uptake, the patient is likely having Hashimoto's thyroiditis, also called as Hashimoto's disease. So Hashimoto thyroiditis or Hashimoto disease, these are the patients who have anti-TPO antibody positive. Anti-TPO positivity is seen. So this is the DD. Some one-liners are related to thyroid cancers. Thyroid cancers are generally covered in surgery, so I'm not going into the details. Next thing, thyroid cancers. What is the sequence of thyroid cancers as per prevalence? What is the most common thyroid cancer? I hope you all know. It is papillary cancer, which is most common, followed by follicular cancer, followed by medullary cancer, medullary thyroid carcinoma, followed by anaplastic. Rarely lymphomas can also occur, but we are not including it. Hashimoto thyroiditis increases the risk of what? It increases the risk of papillary cancer as well as lymphomas in the thyroid. What is the most common thyroid tumor in the iodine sufficient areas? Again, the answer is papillary cancer. Papillary cancer. Orphan aneide nuclei and psammoma bodies are seen in which condition? They are seen in papillary cancer. But iodine deficient area में कौन सा tumor is common? It is follicular cancer. Which tumor is associated with a long-standing goiter? Again, the answer is follicular cancer. So goiter or iodine deficiency, they are associated. So follicular cancer. FNAC is not useful in follicular cancer, that can miss. So you have to do the uh, proper biopsy, and many times, you need to go in for uh, partial thyroidectomy also as a part of diagnostic cum treatment workup. Raised calcitonin with normal calcium level, medullary carcinoma of thyroid. And where is radioactive iodine not useful? Because increased uptake or decreased uptake is not very significant. It is again medullary cancer. Medullary cancer. So simple things, one-liner things you can add through the notes. Let's go further and talk about this table. So we are on to the second last topic, and then last topic will be diabetes. Diabetes, we will discuss some, subtopics. So examiner will ask you questions related to diabetes insipidus versus SIADH. This is a table I always teach. This table is there in my detailed videos also. There is not much to discuss in this table, but it is just that I have put this table and you are supposed to revise this table. Now, posterior pituitary releases two hormone. I'm not saying synthesizing, releases two hormone. One is vasopressin, also called as ADH, antidiuretic hormone. Second is oxytocin. If there is deficiency of vasopressin, it causes diabetes insipidus. If there is excess of vasopressin or ADH, it causes SIADH. Diabetes insipidus can be of two varieties. One variety is true deficiency, where the pituitary is not releasing it. That is central diabetes insipidus. Second is it is there, but receptors are not there. It is not acting on the kidney. That is called as nephrogenic diabetes insipidus. PYQ, lithium is a cause of nephrogenic DI. And another PYQ, thiazide diuretics are useful for treatment of nephrogenic DI. So two different MCQs you have to remember. Now diabetes insipidus में क्या हो रहा है? Because ADH is deficient, so water will not be retained and urine output will be high. ADH is involved in insertion of channels into the distal tubule. And so these channels are not coming, water is not getting reabsorbed, polyuria is happening. Because there is extensive loss happening, so sodium level becomes high, plasma osmolality also becomes high. It is a concentrated, body is losing water and urine is dilute, so urine osmolality falls. On the other hand, SIADH में क्या है? Urine output is normal to decrease because there is excess ADH production. And because water is getting retained, क्योंकि ADH क्या करेगा? Water को retain करेगा. Even if the total body sodium is normal, it will be diluted. So dilutional hyponatremia will be seen. Because water is getting retained, so blood will be diluted, osmolality will be less, but urine will be concentrated. Which of the following is true about all of the following true about DI except all of the following true about SIADH except. This is how MCQs are asked. With a cooled mind, if you just say it out two times, you will not get the answer wrong. Simple questions are asked, but they are still you need to read about them. Finally, we come to diabetes mellitus. Now, diabetes mellitus, India is right now in the middle of a diabetes epidemic. Diabetes mellitus, when do you make the diagnosis? Sign and symptoms of diabetes, polyuria, polydipsia, polyphagia, sudden weight gain, sudden weight loss, etc. With random blood glucose, anytime you check random blood glucose, it is equal to or more than 200 milligram per deciliter. You call it as diabetes mellitus. Now there is a spectrum of diabetes, normal, pre-diabetic and diabetic, and these values are asked. It has been asked two times in exam, once in FMG, once in NEET PG. Now what about fasting plasma glucose? Normal people, the fasting plasma glucose is less than 100 milligram per deciliter. Pre-diabetes, it is between 100 to 125. And diabetes is said to be there where fasting blood glucose is equal to or more than 126 milligram per deciliter. What about the normal HbA1c level? HbA1c tells you the glucose control, glycemic control in the preceding 3 to 4 months. So HbA1c will be less than 5.6% in normal people. In pre-diabetes, it is 5.6 to 6.4%. And any value equal to more than 6.5 is the diabetic range. Third, there is a glucose tolerance test that we do. 2-hour plasma glucose is checked after loading with glucose. How much glucose is used? If you check glucose loading, so you give 75 gram glucose orally and then check the plasma glucose 2 hours later. If the value is still below 140 milligram per deciliter, normal value. If it is 140 to 199, it is pre-diabetes, and equal to or more than 200, it is diabetes in the patient. So this is the spectrum of diabetes mellitus. Simple thing, but still you need to remember it. Now, in treatment of diabetes, obviously, if it is type 1 diabetes, you will be using insulin. It is insulin dependent diabetes. Type 2 diabetes is insulin resistance. And in type 2 variety, oral hypoglycemic agents will be used. Let me tell you, oral hypoglycemic agent, if you spend even half a day, but you can say in the end of half of the day, कि sir, any oral hypoglycemic you ask me, I can tell you the correct answer. If you have that confidence, that is a half day well spent. Would question be asked? As I said, we cannot predict, but oral hypoglycemic very important from pharmacology point of view. Go through the details, right? What about the type 1 diabetes? Type 1, the treatment is insulin. Many types of insulins are there. You have the ultra short acting, you have the short acting, you have regular insulin, and then you have the long acting, glargine, detemir, etc. Now, two types of phenomena are confusing and they are sometimes asked in the exam: Somogyi phenomena and Dawn phenomena. So let us do a quick review of the two phenomena. Let us have a look here. We'll come back to the treatment part because then we have to discuss the treatment for diabetic control. Let us skip one page and first talk about Somogyi versus Dawn phenomena. Now, whenever you have a chart like this and two curves are shown, remember कि डी पहले आता है, एस बाद में आता है अल्फाबेटिकली, तो ऊपर वाला हमेशा डी होता है और नीचे वाला हमेशा एस हो. यू अंडरस्टैंड? इट्स अ स्टूपिड क्रूड वे टू रिमेंबर कि अगर लेबलिंग करने का आ जाए तो ऊपर वाला डी है, नीचे वाला एस है. और इसमें इंपॉर्टेंट चीज ये है कि जो आपका कट ऑफ है, एक यहां पर कट ऑफ दिया जाता है 70 मिलीग्राम पर डेसीलीटर. जो डॉन फिनोमेना है हमेशा 70 के ऊपर रहता है ब्लड ग्लूकोज, इट नेवर फॉल्स बिलो 70. Whereas in Somogyi phenomena, the blood glucose dips below 70, it can reach the hypoglycemic range. So let us try to break it down. What is the meaning of these two conditions? Now, both of the phenomena, एक चीज पहले ये समझनी है कि जब हम अर्ली मॉर्निंग कहते हैं, अर्ली मॉर्निंग, अर्ली मॉर्निंग का मतलब आपके और मेरे लिए क्या होता है? 6 बजे 7 बजे, है ना? लेकिन फ्रॉम मेडिसिन पॉइंट ऑफ व्यू, अर्ली मॉर्निंग इज पीरियड बिटवीन 3 to 4 a.m. That is early morning. It is also called as Brahma Muhurtam in Sanskrit. And what is the pre-breakfast time? Pre-breakfast time is considered to be 7 a.m. Have you seen that most of the breakfast in most hotels that starts from 8 o'clock till 10 or 11 o'clock? So pre-breakfast is 7 a.m. These are the two things that you need to remember. And these will be useful for your later life also. Not in real life, but from when you will be reading in medicine. So सबसे पहले पहला फिनोमेना जो हमें देखने को मिलता है, that is Somogyi phenomena. So I will be writing the first phenomena is Somogyi phenomena. What is Somogyi phenomena? You can remember like this: so much insulin हो गई. If you give more insulin, the side effect, the repercussion of that is called as Somogyi phenomena. So much insulin ho gayi. So more insulin causes this problem. What is the cause of Somogyi phenomena? If you give increased bedtime insulin. If you give increased bedtime insulin, what it will do? It will cause early morning hypoglycemia. It will cause early morning hypoglycemia. Can you see in this photograph as I am writing? 3 AM पे हाइपोग्लाइसीमिया हो गया है. 3 बजे सुबह के अर्ली मॉर्निंग हाइपोग्लाइसीमिया हो गया है. लेकिन बॉडी क्या करेगी? अब बॉडी फाइट बैक करेगी. तो अर्ली मॉर्निंग हाइपोग्लाइसीमिया से क्या होगा? ग्लूकागॉन का रिलीज होगा, बिकॉज बॉडीज काउंटर प्रोडक्टिव हार्मोन विल बिकम एक्टिव. और उससे क्या होगा? जो आपने इंसुलिन दिया था वो उसका कोई मतलब ही नहीं रहेगा. दैट विल नॉट बी एबल टू sustain blood glucose and glucose will start rising and patient will have pre-breakfast hypoglycemia, pre-breakfast hyperglycemia. So can you see at 7 a.m. it is in the hyperglycemic range. So this phenomena is called as Somogyi phenomena. So much insulin ho gayi. 3 a.m. pe hypoglycemia and 7 a.m. pe hyperglycemia. This is Somogyi phenomena. Okay, that is the first thing. Second phenomena is dawn phenomena. Not the DON dawn, dawn phenomena. Dawn is again in the morning time. So dawn phenomena, it is relatively more common. What happens in dawn phenomena is it is more commonly seen. It's more commonly seen compared to smoky phenomena. In these patients, there will be slight in sleep, in normal people, including diabetic people, there will be slight dip in the blood glucose levels. But this slight dip will produce no hypoglycemia. Can you see in this photograph? Look at the blue curve. No hypoglycemia is getting produced. Dip is happening during sleep, but there is no hypoglycemia happening. This slight dip in blood glucose will lead to increased cortisol. Cortisol secretion will start rising. Some amount of growth hormone and glucagon can also be increased, but it is predominantly cortisol mediated. They all will start rising, and they will make insulin receptors. In the effect of these, the insulin receptors become refractory, and that leads to pre-breakfast hyperglycemia. Temporarily, the receptors become refractory, leading to pre-breakfast hyperglycemia. तो दोनों में हो क्या रहा है? 7 AM पे hyperglycemia is happening. But one variety is due to increased bedtime insulin, glucagon is involved, and a dip of hypoglycemia is happening. Dawn phenomena में dip does not happen. Ideally, both should not happen. लेकिन which is more dangerous? Somogy is more dangerous because hypoglycemia, the dip is more. And physiologically, we have seen that rapid fluctuations in blood glucose again is not good for the patient in the long run. Ideally, both should not happen, but somogy is something that we need to target and more aggressively target in the patient. Dawn phenomena to some extent occurs in many diabetic patients as well. So this is somogy versus Dawn's phenomena. So this is your somogy phenomena versus Dawn phenomena. Now talking about diabetic ketoacidosis, it's one of the favorites of examiners these days. A lot of questions are being asked. So we will again be making flowchart. बहुत flowchart बनाए हैं. We'll be ending with flowchart, but it's not random flowcharts. We have understood and made them. So what is diabetic ketoacidosis? You would write it is a complication commonly seen in type 1 diabetes mellitus. It is rare in type 2, but it can occur in type 2 as well. But however, it is more commonly seen in type 1 diabetes. Three parts are there. Diabetic means hyperglycemia. Keto means ketone body formation. Acidosis means acid pH of the blood is falling. So there are three things that you need to watch out for. First diagnostic criteria, any patient having blood glucose equal to or more than 200 milligram per deciliter. That should be there. Generally, इनका blood glucose almost 300-400 होता है, 500 भी हो सकता है, but it is above 200. Second, these patients will have metabolic acidosis. It is always a high anion gap metabolic acidosis. High anion gap. And if you check serum bicarbonate in these patients is less than 15 to 18 millicoulomb per liter. Different guidelines use different cutoffs. Age का भी difference होता है. So 15 to 18 is what you should know. And third, these patients will have ketosis. Either ketone bodies in the blood, we call it as ketonemia, which is more specific. Some patients can have ketonuria as well. So which is the most common antibody which is produced? It is beta hydroxybutyrate. For example, there will be beta hydroxybutyrate. That is the common ketone body which is produced in these patients. Diabetic ketoacidosis is always an emergency because it can cause death. MCQ, what is the cause of death? Diagnostic criteria also an MCQ. Most common cause of death in DKA, it is cerebral edema. Cerebral edema is the cause of death. Now, what happens and how you are going to treat these patients? Let us talk about the management principles. As soon as the patient presents to you, first of all, any emergency, you will check for airway breathing circulation and you will make DKA diagnosis. पहले पता भी चलना चाहिए ना diagnosis है कि नहीं. Patient will not say I am having DKA. You will make the DKA diagnosis. Once the DKA diagnosis has been made, what is the management we do in the first hour? In the first hour, you will be starting the patient on IV fluids. Start the patient on IV fluids. Very, very important. start the patient on IV fluids. Okay. Now, which fluid should be preferred? Normal saline is generally preferred over ringer lactate. Let me tell you, if it is a pediatric patient, ringer lactate is not to be used. In adult patient, ringer lactate can be used. Because we are talking medicine, so we will talk. But normal saline, the latest data, if you go by all the standard guidelines, including the book which is lying on my side, normal saline is the one which is generally preferred in practice. So start IV fluids in the patient. Normal saline is 0.9% normal saline. Right? Start IV fluids. प्लस क्योंकि क्या होता है कि सभी पेशेंट्स ऑफ डायबिटिक कीटोसिडोसिस में देयर इज अ सेल लेवल डिहाइड्रेशन व्हिच इज हैपनिंग इवन इफ देयर इज नो शॉक. नाउ द क्वेश्चन इज कितना फ्लूइड दें. फ्लूइड का टाइप तो पता लग गया. इफ देयर इज माइल्ड डीके, व्हाट इज माइल्ड डीके? whenever the bicarbonate is between 10 to 15, we call it as mild decay. Second, तो आप कितना दोगे? You will be giving 10 ml per kg IV fluid per kg body weight over 30 minutes. Now, adults you use in liter, but ideal way to remember is always in ml per kg. It is always the best way to remember. Second is moderate decay. Moderate decay is said to be there where bicarbonate value is between 5 to 10. You will be giving 20 ml per kg over 30 minutes. And if it is severe decay, the bicarbonate value will be less than 5. You will be giving the same amount, 20 ml per kg, but the time over which you give it is 20 minutes. Generally, shock is rare in these patients and shock management is not needed. कोई भी shock होता है तो what you do, you always start bolus therapy in the patient, right? So bolus will be needed. Now, when you give fluid, after this starting IV fluid, you will shift the patient to maintenance fluids. Shift to maintenance fluids. When you are giving maintenance fluids, you will add KCl to the fluid, even if serum potassium is normal. Maintenance fluid will be added because even if the serum potassium is normal, many of them have low potassium levels in the body. That's a part of the physiology. And secondly, you will start insulin infusion. Adults, sometimes you use bolus, but remember the preferred way of giving insulin, regular insulin is given. It is regular insulin which is used. It is always started as an infusion. We start in a dose of 0.05 to 0.1 unit per kg per hour insulin infusion. And you titrate as per response. You titrate as per response. This is the initial therapy. Subsequent therapy will not be asked to you because that will depend upon the status of the patient, how blood glucose is rising or falling. कभी-कभी क्या होता है, actually blood glucose falls more dramatically. So you have to add glucose into the maintenance fluid also. This is something also you have to do sometimes, right? So this is the initial management and this is what examiner is interested in knowing. Remember, no role of sodium bicarbonate except pH of the blood is less than except pH of the blood is less than 6.7 with cardiac depression. This is the only condition, cardiac dysfunction. This is the only condition where you will be using sodium bicarbonate, but sodium bicarbonate will never be the answer. There is no role of sodium bicarbonate, right? And anytime, absolutely rightly said, if blood glucose falls below 250, you will add dextrose to the maintenance fluid. You will add dextrose to the maintenance fluid. You will add dextrose to the maintenance fluid. Okay, every single MCQ on DKA related to therapy which has been asked, including some tougher ones in INISET and NEET PG, are now in your notes. The only thing is you need to remember it precisely. This also means that we reach the end of the session. Take care. God bless everyone.